शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः।
So good morning to each and everyone, respected dear senior doctors and friends. I am happy to welcome you all to Debate 2026 on the opening day. So to start the proceedings, the first workshop on measuring obesity and its outcomes. So I invite Dr. K. Morgan to moderate the session, and I invite the facilitators, Dr. Aravind Sosle sir, Dr. B.T. Sarun, and Dr. Vijay Bhaskar Reddy to take it forward.
Good morning, everybody. Let me start with thanking the organizers for giving this wonderful opportunity. Wonderful opportunity. We have something called as a Slido, which we can just scan that this thing and answer this question. It will be again at the end of the session. Hopefully, if we have conveyed our message, should be able to get better answers. So there's one more slide. You can go to the next slide. Yeah. So starting with, there was one more slide previously. Can we just go back? Can we just go back? Okay, yeah. To start the proceeding, sir, here's a 45-year-old man who comes to the office for an insurance workup. He is obese by any criteria, but you ask him like how, if he has got any problems, obviously. And so he says he's genetically obese, but he's healthier than anyone. Do you accept this sort of a statement? Why do we need to talk about obesity at all?
I think may I now request whoever is here for this particular workshop, will you kindly come to the front? And I would like to also thank my colleague and my partner Krishna for starting this so very early and choosing 4 of us to be a part of this particular workshop. And this defines the weight itself here. Somebody who is lean, somebody who has a normal weight, somebody who's got an overweight. I'm not going to talk about the moderator. I'm not talking about the moderator at all here. And okay, I just want people to have fun here, because one of the key things today in practice is going to be actually measuring the weight of your patient, and this makes a huge difference in his treatment. Okay, now coming to the question, how are you going to proceed? I think I will ask Reddy to start with this, and then Beatrice can add to that.
Yes, sir. I think this is a common scenario, especially when I used to work in the north. People will tell, "Mota nahi bolna hai, healthy bolna hai." Healthy bolna. So they say that I am healthy. This is my normal weight. Our families have been like this. So why are you making an issue out of it? So I think that is from the initially excess weight, especially the abdominal fat and pot belly used to be considered a sign of prosperity. So you're prospering well, you have a paunch, and people think, okay, this fellow is rich. But now we know that even though they don't have any problem, even though they feel it's normal, this abdominal fat is not just a storehouse of energy. So it is bad. Studies have shown that this can cause inflammation, and this can lead on to various harmful hormones, and in the long run it is bad. So abdominal fat is not or obesity is not a healthy thing. Even if the patient is not symptomatic, the weight has to be reduced in the long run.
How would you convince this patient that he is obese, ma'am? How would you start convincing, like, Would you throw different statistics at him, or how are you going to tell him that he's obese?
So approaching a patient who's obese is an extremely daunting task, I would say, because they usually come to us not for the obesity. They come to us with the complications. Somebody has diabetes uncontrolled, somebody has hypertension, somebody has OSA, all sorts of things, and they want medications for that. But to address obesity and tell them that this is the root cause is going to take some time. So there is actually something called as a motivational interviewing to figure out where the patient stands. Whether the patient is acceptable to the diagnosis of obesity, and you'll have to approach the subject very cautiously, because we'll have to see how accepting the patient is and whether the patient is willing to do something about it. So only then we can give treatment. So throwing statistics at him and saying, all this is because of obesity is not going to work.
That said,
I think she's very right. I mean, even to start a talk on obesity is going to be tough. The first thing I think we need to do is, once the patient is registered, to check for his height, weight, BMI, etc., and have a lot of posters in your clinic which talks about the bad effects of obesity, the metabolic health, etc., so that the patient in their language, which is comfortable, I think have it in 2-3 languages. They start reading this. And you can always say in your posters, please ask the question to the doctors or talk to the dietitians, know your weight. See, when you tell somebody that, okay, you are 85 kgs, you are overweight by so many kgs, it never really gets into their head. Okay, my father, my grandfather, his father, everybody were old, and then I'm also a little healthier, as he said. And then when it comes to ladies, they say, no, not healthy, sir, thoda plump hai. Very typical, the Marwadi, this one, Dr. Saab, thoda plump hai. Okay. So, have a lot of posters which gives the effect of the vision. And that is a very powerful tool today. I think all of us must start doing this, and then start measuring, and then show them that, okay, this is where you stand.
Historically, it was introduced by the insurance system, basically, to categorize people who are at risk. But now we understand that every patient needs to be categorized on the risk, for which, as sir says, unless they are already, as soon, even before they come, they have an idea that obesity is a problem, you may not be able to talk about it. But then, that said, is there a subset called as metabolically healthy obesity? And do they remain healthy?
I think there was this term metabolically healthy obesity and metabolically unhealthy obesity. So just like the patient feels that I am okay and I am not okay. So like that, so metabolically healthy, we say if they don't have any problems at that time, the blood glucose levels are normal, the glucose tolerance test is normal, blood pressure is normal, they don't have any physical effects like osteoarthritis or obstructive sleep apnea, and mentally also they are fresh, they are able to do all their activities, then that is metabolically healthy obesity. But now this terminology is not accepted, because that stage only we have to act. So then only, because this is the stage when everything is going to start setting in insulin resistance and all the pre-diabetes and inflammatory thing, and the seeds for the cardiovascular disease, all of this are set at this time. So this terminology is not accepted. Any obesity is not healthy, so there is no metabolically healthy obesity.
Most probably they are just in a passing phase where they are going to translate from an healthy individual to an unhealthy individual, and they are obese as a first sign.
This is described very well in the Lancet Commission. If you look at it, they have defined something called as a preclinical obesity, which means that somebody is obese, does not have any metabolic complications, but does not mean that they are normal. It is just like how we see somebody with pre-diabetes. Is pre-diabetes normal? No, they are going to progress. Yes. So like sir said, that is exactly the right stage. In fact, much earlier, primordial, but then probably that would be an early stage to intervene.
Yeah, I think I'll just add another thing, because coming from a sports background, earlier most of these obesities were classified based on the BMI, and today we know, I think BMI probably is not the best tool to pick it up. So when you look at only the BMI, there are people whose BMI can be more than 30, and then they don't have any visceral fat. It could be just the muscle fat, because these are absolutely the sportsmen who train a lot, etc. And then they may not have visceral fat, their BMI may be more, it could be just the muscle mass. They are the ones who are metabolically healthy. But as he very rightly said, Reddy said, I think this is the term, it's only for the doctors. I don't think we should confuse our patients at all. See, today the whole intention of this workshop is every doctor today here, sitting here, including me, I think we should be able to learn how to measure our patients the right way and say, look, you got overweight or obesity, etc. Yes. I think that is how we should take it now.
We all understand that there's a lot, huge complex of this thing, outcomes which can occur because of obesity. So, when we talk about measuring obesity, should it be physical parameters or should it be metabolic parameters including inflammatory cytokines? So, how useful are the physical parameters? Where do you place them?
So I think physical parameter is essential because that's how our criteria is to label as obesity, and that's anthropometric. So there are different measures. I think we'll be discussing that. So one is the body weight. So body weight is not only fat actually. Obesity means we're talking about excess adiposity or excess fat. So we want to identify the excess fat. Traditionally we have been using body mass index, but the problem is it does not show only the excess fat. It shows the muscles, it shows the bones. So body fluid, everything is counted in body mass index. So that we will discuss about what parameters to pick up this excess adiposity or excess fat alone. But once we identify by whatever criteria, either by body mass index or by excess abdominal obesity, waist circumference, or whichever or you have a sophisticated measure of a DEXA scan or bioelectrical impedance, we can identify the body fat percentage. Once you identify that there's excess adiposity, that is obesity, then we have to look at the other things also. So the complications have to be assessed. So we can divide the complications into metabolic and mental and mechanical. So all these three parts we have to assess. Some of it is clinical, some of it is investigation wise. So that is essential, and inflammatory mediators also is required. So to assess how much the inflammation is happening in the body. So it's required.
Before going to the assessment proper, what do we call as a lean mass and what is a fat mass? What is the difference?
So fat mass is, of course, you know, the adiposity. Then we have a term called as the fat-free mass. So the fat-free mass is going to include everything: your skeletal muscle, the bones, your organs, the total body water. So everything comes under the fat-free mass. So the lean mass is basically about 50% skeletal muscle, and then you have the organs and all that which comes under that. So this is how briefly we describe the body composition. And this is important for us to know, because nowadays we do have studies which have looked at how much percentage of the fat-free mass is lost, how much of fat mass is lost. So this is very important because we are in the era of pharmacological management of obesity. So when we are actually looking at these things, it's very important because we need to know what the patient is losing. And our focus should be fat-free mass, the fat mass, sorry.
Yes. So, what is the easiest way? Because there was a time when we used to have a weight chart. You just categorize them and call them, place them in different this thing. Why did we move away from this, and what is the best thing as of today that we got as of today?
I think here we should really go to the audience. I think you can start asking the questions to the audience one by one, and then let's see what the answers are going to be.
Yes.
Okay, there are two people here, and then we are not going to ask them because they're the masters in that. But I think in this side, all the clinicians, I think we should ask the question. Mohan, you should really now go to them. And then, can somebody carry the microphones across, please?
Can anybody just pitch in and say, what would you term as the easiest or the best diagnostic way? Best we'll be talking about, at least the easiest, what you use in the clinic. What do you think should be, what is the minus point that you face? Anybody can just pitch in.
I mean, so you're feeling shy? You're not feeling shy, right, sir? Okay, I think I'll come to you. I think ask him the question.
Yeah.
I usually measure the height and the abdominal circumference, and compare with the weight. That's a simple procedure I am doing.
Yes.
Okay, you can write it down. He will check the height, he will take the abdominal measurement. Is there anything else?
That's all.
Okay. I'm not going to ask you. Okay. But I still ask.
Same thing. Waist to height ratio, waist circumference is what it is mostly.
Would you like to add anything to what she has already said? You can add? You can add the neck circumference. Anything else? Yes. Okay, you want the hip measurement to be taken along with the waist measurement. Okay, excellent. Anything else anybody wants to add in your measurements in your clinic? Height, weight, waist measurement, hip measurement has been done. Anything else to be added?
I think the physical appearance itself will show that a person is obese or not.
No, sir, we are talking about the measurements. The physical appearance, yes, I and you, I mean, we actually move into the obesity cadre, but then, would you like to measure something?
The weight.
Okay, you're not been a ladies' tailor. So he said, I'm not a ladies' tailor, I don't think I will measure much. Okay, I think anything else to be added? I think you can continue, Mohan.
See, we all understand there are 4 types of this thing. So anthropometry, density, conductivity, and radiography are not there, are all the different this thing. So we have moved away from just a weight chart to this level, and we have taken this thing that there are so many things that they'll do. Calmness, which we have been talking about. See, we should understand that BMI is one of a very important criteria with its own plus and minus points, where we have seen that studies have all used BMI as a cutoff. So most studies have used BMI as a cutoff. Sir, what is the normal of BMI? How do we measure it? And why is it a normal?
So BMI, we have different cutoffs. Traditional textbook teaching was BMI, that is for Western countries. So BMI more than 18 to 25 is normal, more than 25 is overweight, and more than 30 is obese, and more than 40 is morbidly obese. But what studies have shown that Indians, we have got a genetic predisposition to depositing fat in the abdomen at a lower BMI. So now the BMI cutoffs for Asian Indians and Indians, I think the first MCQ Dr. Mohan had shown. So BMI more than 23 is overweight in the Indian context, more than 25 is obese. So now we need to be more fitter and lower BMIs because we have more fat in the abdomen as compared to the Western countries.
Yeah, I think, I think I'll ask you another question before we take it on. So when it comes to BMI, the Indian cutoffs were brought down. Okay, 18 to 23 normal, 23 to 25 is a little bit overweight, and 27 and above is going to be this one, obesity. Based on what these set points were brought down? Any idea? Because Anup is not here. Or I can ask Dr. Deepak, who is here. Deepak is from IISc, is heading the Longevity India project. Why was the BMI set lower compared to the Western standard for Indians, and what was the parameters on which this was actually brought down? Can somebody give a microphone to him?
Yeah, thanks, Arvind. I think I'll be honest, I don't have a lot of clear answer on that. But the interesting part is based on the visceral adiposity and inflammatory markers based on which people are picking up inflammation, which is systemic in nature. And there's a very nice cohort study which was done in Singapore. They compared Malay, Chinese, and Indian, and they found Indians at a lower BMI were actually having higher inflammation. And it was very clear indication that Indians, because of visceral adiposity, need to be looked at a different lens. And I think you can go with that logic. But also when you talk about measurements, there's a new called body roundness index. And Indians have a much rounder body that way. And that's also a very good indicator that we are picking up more poor metabolic indexes much earlier on. I think going with that standard, visceral adiposity, higher inflammatory markers, and body roundness, I think 23 is a reasonable number to talk about for India.
So can we say based on the visceral mass, the BMI was set lower for Indians? Yeah. Was that the reason?
I would say more like inflammatory index, more like how inflamed you are. I would say DEXA plus inflammatory marker assessment would be one reason why the BMI was brought down.
Okay.
Another one is predisposition to diabetes also. Yes. Starts at that BMI.
Yeah. I think one of the seminal papers on this was Dr. Yajnik's paper, the YY phenotype.
So what are the plus points of BMI? We understand it's easy to use. Many calculators are easily available. That's the plus point. But how specific is it? Because like many studies seem to use it even today.
See, unfortunately, BMI just gives us a figure. It doesn't give us anything about the metabolic parameters, the problem the patient has, how much amount of visceral fat is there, how much amount of non-visceral fat is there. So it's just a number. So it doesn't really give us, because you can still have a very high BMI and normal visceral fat. Okay, so we all have seen the photograph of Yajnik, and she was just mentioning that. And then, thin fat Indian thing. So BMI will not probably give us the true picture of what his metabolic risk is going to be, or inflammatory risk is going to be. I think you need to have BMI, and then you also add one or two other things in your clinical practice to actually see what the metabolic risk is.
BMI is good enough for categorization, but I think for metabolic risk, I think you need to move on. So, what are all the different anthropometric measurements that we have, which can be looked at? When you want to add, as sir was saying, like you want to add other information to BMI.
So in the clinic, these are things that are easily doable. So these are the Asian cutoffs. So we have the waist circumference for Indian cutoff for male more than 90 centimeter, and for females more than 80 centimeter. The waist hip ratio, so that is more than 0.9 in males and more than 0.85 in females. The wrist circumference, again not very extensively done, but yes, it is one of the markers, 16.5 and 15.7 centimeters. Neck circumference again will be important, because the risk of OSA can be predicted with the neck circumference. So it is approximately 35 centimeter in male and 34 centimeters in females. But if you're looking at a grossly obese person, you use the stop bank questionnaire. So that includes a cutoff of more than 40 centimeters. So when the neck circumference cutoff is more than 40 centimeters, there is a very, very high risk of the patient having OSA. And if you look at the body fat percentage, so now we have the bioelectrical impedance, the machines, it's very commonly available. So with that, we can measure the body fat percentage. So the cutoff for males is more than 25%, and for females, it's more than 30%. And the body mass index, of course, as sir has described. So it is not only the BMI, we'll have to look at other parameters as well.
But what do we do that, like as sir was saying, like because of the type of fat that you are looking at, maybe abdominal fat, those sort of things. In that, of this, what is the easiest to do, and what would you do what would you recommend that everybody does in their clinic?
I think the waist to hip ratio is going to be the easiest to do. I mean, it's easy on papers, very tough in the clinical practice. So it's very surprising that I also saw the wrist circumference, and then Reddy had this one, an explanation as to why the wrist circumference actually came into being tested.
Yes.
I think over to you, because you said it's very difficult to measure the hip and the waist in ladies.
I think in some ladies will be hesitant to get, suppose only males are there in the clinic, so difficult to measure the waist and hip circumference. So there are some studies, not too many studies, but that wrist circumference may be a surrogate for abdominal weight, so that is why that value is there. So that is easy to measure, you can measure for anyone, but you are going and measuring the abdominal circumference and waist circumference and hip circumference for ladies, just like your airports. So the ladies are frisked separately. So if your ladies are there, your staff is well prepared, but even then in certain populations they may not be very much. There are obese people who come, but they refuse to get on the weighing machine. I don't want to see my weight.
Yes.
So that also is there. So wrist circumference is just like you're measuring your pulse quickly, you can just see, they will not realize what's up.
So another parameter is the waist height ratio.
And I'll come to that.
Or you're going to be talking
I'll
about
come to that. Of this, what is the easiest to do? Like possibly waist circumference may be the easiest, because like a single factor, followed by wrist circumference would be this thing. The waist hip ratio versus the weight height ratio, why, how does it work?
You're talking about the waist to height?
Yes.
Okay, you said you will be talking about it now.
So the waist to height ratio gives a better predictor of cardiometabolic complications. So in almost uniformly in all studies, the waist height ratio has done very well to predict the cardiometabolic risk. So it's easier to tell the patient, because the cutoff is 0.5. So you tell them, keep the waist half of your or less than half of your height. So it's easier to tell them. Waist hip ratio, again, it has been used and it's used as one of the WHO recommended anthropometric parameters, but the waist height ratio performs better when it comes to predicting the cardiometabolic risk.
why has the skin fold thickness gone off? Vernier calipers looks very, looks like you're doing something, but then it's totally gone off. Why is that?
I think it's mostly a logistic issue, in fact, because it's very difficult to measure. So we have different measures. We have the arm,
Yes.
and then we have the calf muscle. So different measures, and they are not very validated measures, in fact.
And it's not reproducible because each person, amount of force they give us very different and they get very different.
It's like, okay, I'll just go back to my CMC days. One of the things that was always told to us was, if you're asking for a test, make sure that there is something behind it, and then if it comes as abnormal, then you need to have a treatment for that. Okay, that means just unnecessarily do things which you're not going to use. Now, as she very rightly said, you have all the skin fold things, and then it's not a great marker of anything. And then we don't have the Indian standards. Somebody has to really reset the clock and restart doing it. When the waist to hip measurement itself is difficult in day-to-day clinical practice. I mean, even though we know it's so easy to measure, every tailor does that. And when a tailor can do it, why can't the doctors do it? It's easier said than done. And anybody has any other ideas about this in the audience? How easy it is for you people to check the waist and the hip measurement of your lady patients, or for lady doctors, men? Not easy, no?
Waist is okay, hip is difficult.
Yeah, waist is okay, hip is difficult, yeah.
And plus waist plus height is an equally good cardiac risk marker.
No, as she very rightly said, the simplest thing is you can tell the patient, you measure your own waist,
Yes.
and then make sure that it is less than half of your height.
Yes.
You just calculate the height in your inches and then the waist in inches, and then keep it less than half. Otherwise, your cardiometabolic risk is going to increase.
Yes. Would anybody volunteer to have a demonstration? If not, somebody can just get up and tell us like how it would go on. How would you, what is the waist? Because like some people like me don't have a waist to talk about. So like what would you like to say? How do you measure, where do you measure the waist? Anybody can just pitch in. Sir, please.
No, I think you have to draw lots. So somebody will have to now come. Just
Yes.
request somebody. It can be downstairs only.
Yes.
Because the whole idea is, many a times, if we don't know the right method, we can't teach our paramedical staff. And if we don't teach our paramedical staff, or if we are not doing it ourselves, even a simple thing called waist measurements, we can actually make mistakes.
For almost every patient, I measure the almost for every patient, I measure the weight first, then height, then waist circumference.
No, but waist,
This.
what is waist? How do you measure the waist?
Weighing machine.
No, waist.
Waist
Wait,
circumference
wait.
measuring tape.
Circumference, how do you measure?
Centimeter. I mean, each tape,
How do you
the area between the lowest rib and the hip is the middle point.
You have a tape? I have.
Yes, sir. Hip, rib, middle point. And scale should be parallel to the.
So can you just check it and tell everybody it's 31?
Usually, I give the patient
Yeah. You give to the patient.
to
Okay.
take it out. Because ladies will be very advanced.
Yes, sir.
No, it's in between, sir. The lowest point of the rib.
No, theory he has got 100 on 100. Now it's the practical examination. Theory he got 100 on 100. So when it comes to 22, that's my waist, sir.
Sir, no, because of the food.
Sir, you should not take deep breath and hold, sir. Relax.
Right.
Waist is 36.
Yeah, but with the dress, so I can understand. Yes.
It just came as 43. I mean, is the tape okay?
Yes.
Is the tape
No, sir, because of food. Food is too good. Sir, what else, please, sir? What else would you add to that in the sense like,
so
do you
actually
do
it
in
doesn't,
full, inspiration, full
many
inspiration?
people feel it is at the level of umbilicus, whereas it is not. It is a lower midpoint between the lower costal margin and the top of iliac crest, and need not correspond with the umbilical level. Many people measure it at the umbilical level. That's the commonest mistake which I have seen, number one. Number two, feet should be slightly apart with the thin clothing as he breathes normally. At the end, normal inspiration, we should measure, sir.
At the end of expiration.
End of expiration. End of expiration. Expiration, sorry.
Right. So what about neck circumference?
Neck circumference, I have not measured, sir. Collar size is...
No, sir. Neck circumference is, you mark the biggest point. There is the Adam's apple. It is 1 centimeter. Below that, you take the neck circumference.
Thank you.
The easiest would be just below the Adam's apple.
Yes. And no, once again. Below, after that, what is the hip? Hip, how do you measure the hip? Any other thing to be inspiration, anything?
No, it has nothing to do with it. Yeah, legs together, yeah. It is always there, yeah.
So, just to reiterate, the waist circumference is measured at the midpoint between the lowest end of the rib and the iliac crest. The in-between point at that line, horizontally you would measure. This thing, the vertical line, the hip is with your feet together. That is very important because otherwise it will change, and it is measured again horizontally at the highest point. And neck we talked about. Wrist measurement, yes, you look for the bony prominent. Again, 1 centimeter below the bony prominence is where you measure. Right. So we'll move on to the other thing where the composition is measured. So this is more available than DEXA. How useful it is, what does it, how is it done, you know. Many times in between we all felt it was just a farce, it was just thing which we are the thing. Now we understand that it's clinically very relevant. How do you use in bioelectrical impedance analysis? Is it useful?
Thanks for asking this question, Mohan. I think it's been 36 years since I started my practice, but almost 32 years I was not convinced that all these things are really necessary. But then when you talk to a patient and when you tell him that, okay, this is your waist circumference, this is your hip, you're already overweight, you're obese, you know, you'll have more of visceral fat, it never gets into their head. The importance and the dangers never gets into their head. Now, you put them on a BIA kind of a machine, or in-body people, I think they also have a stall here, and then get this done, and then show them something graphically. Look, this is your visceral fat, this is your fat-free mass, this is your body water composition, and this is your BMI, and this is the amount of weight that you have to lose. When they actually start seeing this report in a very graphic manner, people are getting impressed. In fact, VLCC of many of these centers, weight reducing centers and yoga centers, etc., used to have this. And as doctors, we always thought, I mean, why is it necessary? It costs about 2.5 lakhs. Why should I have to invest? Why can't I just have a weighing machine? But now things have changed. I think for the last 1 year, things have changed. Most of the serious peoples are endocrine diabetes centers where you are really practicing obesity. I think this in-body bioimpedance machines have started coming, and now some of the companies are also giving it, I was told. So people are actually doing this. I don't think we should do it only to monetize it. I think we should do it for our own sake because we have a record. Okay, this is the baseline of the patient because it's just the electrical impedance, and then the mechanism, of course, can be explained to the people. I think a little investment goes a long way. You know, it's like foot mapping, right? And unless you do an ABI, people don't realize it. So people started picking up ABI machines, foot mapping machines and things like that. But I think this bioimpedance is something that our doctors should really invest on, so that it gives a feeling to the patient that, okay, now I have been measured, I don't say it's absolutely accurate. Still, the DEXA is going to be the gold standard. I'm sure both of them will talk about DEXA because I have not used DEXA. So, but this bioelectrical impedance analysis may have some shortcomings.
What is the mechanism, sir? How does it work?
It's just the electrical, this one. It's the resistance. When you pass through the electrical impulse, then there are areas of resistance and areas of no resistance, and there are complicated biorhythms, some calculations which are said. I really don't know the exact technical part. If somebody knows the technicality of this particular machine, they are most welcome to talk about it. I'm sure they also have a stall here. People can actually see this. Do you know the exact mechanism of how this works? Or maybe we can ask Deepak to talk about bioelectrical impedance, how exactly it works. And
I think just like the electrical impulses,
Yeah, I
they
know it's
travel through
electrical.
water, fat and bone in
Correct.
different ways, and it gets picked up.
correct, you have resistance
Just like
inside
ultrasound
area.
waves.
It's
how
like
they-
an ultrasound waves. Anything more, Deepak, you would like to add?
Can somebody give me a mic?
So they should be well hydrated when we do this test.
Through the body, the water allows it to flow it better than the fat. Fat acts as a resistor. So wherever there is a flow and there is a fat in the process, it actually breaks the flow of electricity and then record that at various parts of the body.
So the fat does not allow this to pass through. That
Yes, it's a
electrical-
barrier. It's a
Okay.
barrier.
It's a
The
bad
amount of
conductor.
water will
Water is a
dictate-
good conductor.
Water is a good conductor. That simple principle allows you to understand how much is the impedance that is offered by the body.
And obese people seem to be having less amount of water. That
Yes.
has also been shown.
Or more fat, or more fat. Or more fat.
Okay, right.
It's also important in monitoring patients. So when you start a patient on, especially on exercise regimen, the muscle mass increases, whereas the weighing scale will not show a difference. So at least to show to the patient that, the muscle mass has increased, the fat mass has come down, this is very important for monitoring.
Yeah, I think the only shortcomings is, don't do it when they're dehydrated, don't do it when they have a full stomach, kind of wait at least for an hour to two. Simple things, do's and don'ts of this. I think it's an excellent tool right now because you can actually show it to the patients. Look, this is where you are and this is where you should come.
Going on to the DEXA. What is DEXA? How do you interpret it? Because we always looked at DEXA as something which is done in research laboratories. So
So DEXA also works very similar to how we are talking about the bioelectrical impedance. Is going to show us the resistance of the different tissues to the X-ray beam. So we have different types in that, in fact. So here what is showing is, it will show you the differential distribution of fat in the body. So you have the arms, the trunk, the waist, everywhere it shows. And then you have percentiles. So you have the young percentile and the age matched percentile. Just like how we interpret a DEXA of the bone, this also has to be interpreted in the same way. And then whenever you're looking at the body composition results, you have to make sure that the addition of all the fat and the muscle mass, everything comes down to your weight exactly. So that will be checking the veracity of the results that you have. So basically what you're going to look at is the percentiles here. So more than 50th percentile should alert you to the possibility that this patient has an increased adiposity measure.
going on to the next part, where would you put this in a normal everyday scenario? The first patient who came in for just for an insurance checkup, who had come for an insurance checkup, he has this thing. So where would you place DEXA in such a this thing? Is a BMI enough? Do I have to go in for DEXA? Where do I have to go in for DEXA?
Currently, it is more of a research, and if you want to publish papers, yes, you look at that. And of course, for studies on drugs, yes, that will show you, because it is one of the gold standards apart from MRI. It will give you a clear picture of how the fat distribution is and the muscle mass. But otherwise, in the regular clinic setting, we would not advise DEXA for this.
Right. Where exactly would you have a DEXA? Where, in a patient who's otherwise absolutely normal, would you do that for a person who can invest, who doesn't have a constraint on that, but has got no other thing in a so-called metabolically healthy obesity? In such patients, would you do something like this and tell him that this is the fat you have, which needs to be this thing?
I think bioelectrical impedance is good enough. Good enough. Setting DEXA only for research study purpose.
we had other things which are more difficult, which is generally not done, like the hydrostatic weighing, air displacement plethysmography, the pod method and all like, all these are pure research tools, but generally, and they are also less reproducible, it seems. That's why people have moved into DEXA and MRI. So, in the research settings, we always talk about MRI and CT. Okay, one more question I'd like to ask before that is that DEXA is also an X-ray. So, what is the amount of radiation you get in such as this thing?
It's not much. It's not like a CT. Definitely even lesser than an X-ray.
No, because there was a time when we used to say 9 X-rays in your whole life and things like that, because of radiation. So, like, how bad is the radiation?
Not significant, and patient does not have to be worried at all, because we do it regularly in clinical practice. Look at the mainly we do the DEXA for the bones, but even then we will tell them that it is not something to be worried about at all.
Yeah, Mohan, I just ask a question here. Has DEXA and bioimpedance, has they been compared in any of the Indian studies to see what is the correlation between the BIA results and the DEXA? Has it been done anywhere? I know there's a 5% variation.
Yes, there is a 5% variation.
Yeah, bioimpedance.
Yes, there is a 5% variation. What I'm going to, you can go back to the previous slide. No, the one before. The one point I want to make is, I almost never order a DEXA.
Yes.
I think we should be very, very clear about it. It's like measuring insulin. You really don't need this. And in fact, just to explain this one slide, I pass it on to this group because this is coming out as an editorial from our group, Dr. Mohan, myself, Shashank, Manoj Chawla and others, and saying that for India,
you don't need a DEXA.
You don't need anything. The Lancet Commission is an overkill. And for us, because our things are, 23 is where our problems start. And the waist by height greater than 0.5 is where the problems start. For most of us in the clinic, this is a much simpler way of looking at it than doing all that stuff. So please don't waste your time and invest in any of these investigations. It belongs to a very few people like Anne who need to do it in some complex cases, but unless you are planning to just make money out of it, don't waste your time in all of this.
Perfect. That's exactly what was also discussed. I'll ask a very quick question to both my colleagues over here before you actually wind it up. Okay, the percentage of fat for the Western population and the Indians, because normally we say try to keep your fat levels less than 20 or 25. What is an ideal percentage of fat, especially the Indian population?
Males less than 25% and females less than 30%.
Okay, it's not 15% like the Western population. Less than 25 is okay?
For males and less than 30% for females.
Less than 30 for females.
Okay. I think in body if they have, all of you can also check your fat percentage.
No. Yeah, I think...
Can I have a question?
Yeah.
Before you could ask the question, because time is not there. Now that I think we are doing too much of weight reduction programs, I think to great extent we have been trying to be successful in that. Now we are doing so many measurements, and then after the weight reduction, it's something like, we have to follow it up, how they have improved and all. Now there's a component of even the muscle weight loss is as well there. In that case, when you are measuring over the time, like once in 3 months or 6 months, that is the weight. Do we need to do some corrections in all these measurements, or we should not do anything about that?
Corrections? I don't think it's required, sir. Corrections not required.
We are worried about the muscle mass and the percentage of muscle and fat.
No, it will show the test itself will show the percentage.
Vijay, generally it's not about 30% of the muscle loss will be there when you lose weight, and then therefore the resistance training is almost always given to most of the patients. Okay, in all the obesity clinics, resistance training is a part of it, but I don't think there is any readjustment. As long as they do the resistance training, their muscle resistance is fine.
I think MRI remains and research tools, so we'll not be talking about it as of now. Thank you for being an excellent...
One more thing which you can do is we can give a obesity-related health quality of life index. You can give a questionnaire when they're waiting in the outside, so that they can...
in fact, the bank questionnaire itself is a very good idea for everybody.
That is for OSA bank questionnaire.
Yeah.
This is for obesity-related quality of life also there is.
Thank you for being a wonderful thing, and thank you for being a wonderful audience. Thank you all, and
So thank you, Dr. Mogan sir, and all the panelists, Dr. Aravind sir, Dr. BTS, and Vijay Bhaskar. So we'll move on to the next session. It's on a debate. So, should anti-obesity drugs be a lifelong prescription? So, may I invite Dr. Purvi Chawla to speak on the things, and on Dr. Shruti, and to balance and give the expert opinion, may I invite Dr. G. Vijaykumar sir to take it forward.
Good morning, everyone. And great to have this debate at debate. Really, are weight loss drug prescriptions lifelong? And I'm saying yes. Oops, I said it, yes. I think something that we all are really scared to confess. And a very big thank you to Krishna sir for inviting me and also giving me this very thoughtful, incisive topic, but please don't go by how beautiful my contender looks today in her beautiful sari. My bag didn't come, so I had to dress up.
Just one thing, I was told that Vijay Kumar said you should not fight with each other. We are paid only for a fight.
Your money is going down the drain, sir. So no pertinent disclosures. Well, the whole world was asking about this pertinent question, but it's Dr. Krishna sir who has actually nailed it and gotten it here. I was smiling until he asked me that, and ever since he has asked me that question, I've been just thinking about it. I wish life was black and white, but we know there's a whole lot of gray and blue and everything else in between, so much like our topic today. That's what flows in between everything, and that's where the art of practicing medicine actually comes in. So there's science, there's medical evidence, and then the art of dealing with patients. But first things first, obesity, definitely a chronic, complex disease, unarguably, and a relapsing one as that, in which abnormal or excess body fat impairs health, increasing the risk of long-term medical complication, reducing lifespan. Burden is tremendous. I'm not going through the numbers, you already know, but India is number 3 right now, and it's also exploding in this particular aspect, because if you look at the younger generation, the adolescent obesity numbers are also crossing 14%. So this is a very, very important aspect that we need to talk about. And again, the predisposition to numerous chronic diseases, including diabetes, cardiovascular disease, cancer, psychosocial health, intergenerational transmission, everything is very, very important, and this cannot be a more timely discussion with respect to everything else. So the energy balance, and it's very simplified in this cartoon, but it's definitely much more complex, much more interrelated, and very, very fine in its balance and loss of it with respect to the hedonic input as well as the environmental influences and the whole game. So we just cannot undermine this biology. We need to understand it well, because if you're going to address it and make sure it remains addressed, then we need to understand this. So the management options for people with overweight, obesity thus far, and these will continue, there's no doubt about it. Lifestyle modifications with respect to the dietary as well as physical activity, the psychological interventions, Although modest in their results, they are very, very important. But we know that so far we had only bariatric surgery or metabolic surgery and the endoscopic procedures to really bank on to bring about a significant change. 25 to 35% weight loss on an average, and a wide gap between this lifestyle modification group and the bariatric surgery group existed. So a treatment gap for those patients who either did not qualify for surgery, could not afford it, or who did not wish to undergo surgery, and where behavioral and lifestyle interventions were not even working for them. Well, there was a gap, and that gap seems to have been filled up now. But how successful are the lifestyle interventions in chronic weight management? Again, all of you have seen this graph. We know that as long as there is intervention or adherence to all that, it works, and then post-treatment, the maintenance of weight loss is dismal. Most individuals regain more than half of the weight lost within the first 2 years itself, and more than 80% within the next 5 years. I'm not saying there are no benefits, but it is difficult to sustain. Even with modest weight loss, it is very difficult to sustain. And the same data we've seen even with specific meal replacement therapies as well. So this gap that I was talking about between the lifestyle modifications and the dramatic or permanent solution of bariatric surgery, somewhat permanent, it has been filled with the pharmacotherapy, where, and today with the incretin-based drugs, we are able to achieve up to even 25% weight loss. This is definitely very, very clinically significant. But these are prescription drugs, let's not forget that, and they potentially help fill that gap. Why is it so difficult to maintain weight loss once long-term obesity is established? Because of the adaptations that resist weight loss. Whether it's the hormonal changes, where the satiety hormones decrease and the simultaneous increase in the hunger hormones, and the resultant decreased energy expenditure because of decreased fat oxidation, increase in cortisol levels, etc. So all that together gives us weight regain, and these adaptive biological responses lead to persistence of obesity once it's established. So chronic weight management requires interventions that address these metabolic adaptations. Again, even we have seen in smaller and bigger studies that hunger itself, in response to weight loss efforts, itself increases hunger because of these hormonal variations. And the resting metabolic rate, also as seen in various studies, again has been seen to dramatically decrease with weight loss. And the metabolic adaptation, which is defined as the residual resting metabolic rate after adjusting for all the changes in body composition and age, by year 6, as seen in this particular study, it's really reduced. And this is what is responsible for the weight regain and just gives rise to this constant struggle. So despite the patient's best efforts, metabolic changes to weight loss promote weight regain. And this is the reason, in the first place, we need the weight loss drugs. And today with pharmacotherapy, like I said, we are able to achieve up to 20% weight loss or even more. So these new generation of anti-obesity medications maximize the magnitude of weight loss, helping to overcome the compensatory mechanisms inducing weight regain, promoting sustained weight loss. And it's not just about weight, it's also all the complications or comorbidities with weight loss that are also dramatically improved. Particularly the cardiometabolic risk factors, there is definitely improvement in those with the long-term health benefits well established. In comparison with bariatric surgery, which is nearly permanent, we know that there are permanent changes in the hormonal levels as well, and even remission of metabolic conditions, including diabetes, is long-lasting. So weight loss with the newer incretin-based therapies is akin to that. However, we need to take the medications, and those benefits will be seen as long as we take those medications. But there are clinician as well as patient mindset factors as well as attitudes. In terms of clinicians, lack of understanding of the biology itself, the past experiences with other chronic anti-obesity medications that were approved and on the market and then subsequently withdrawn because of unacceptable adverse events, and the bias and stigma itself with this particular condition as well as with the drugs or treatment along with. But the patient who is in the center of all these approaches, there is huge stigma and bias in the mindset of the patients themselves, and obsession with natural products, as there is an inherent bias against anything that is, associated with modern medicine. Relatively newer understanding of disease itself and the need for managing it, because they still look at it as a cosmetic issue, like Dr. Arvind Sosale sir also mentioned in the previous session. Social media self-education and chaos with skepticism is one of the most important factors influencing the mindset of the patient. Lack of education again, and psychosocial as well as economic reasons all influence whether they want to take it or not. Again, the reputation of these drugs precede the over the actual use or discussion with respect to the scientific data. I know all of you want me to talk about this one because this is one of the most recent evidence pool that we have, and this is an important one. This systematic review and meta-analysis published just a few days ago in the BMJ talks about weight regain after cessation of medications for weight management. And in a very, very large pool of patients, they have seen that there is almost instant weight regain, or within a year and a half, there is regain of the weight, as well as reversal of all the cardiometabolic parameters that were benefited with the use of the weight management drugs. So this yo-yo effect in the absence of continuation of anti-obesity medications, something that we refer to as weight cycling or body weight variability, has also been studied as a huge risk factor for increased cardiovascular risk in over and above the baseline risk that exists. So again, that yo-yo effect, or stopping the drugs, restarting, or not having a proper plan in place for these medications is not recommended at all. So again, due considerations, and I'll end here, adopting optimal strategies for long-term use is the key. It's common in chronic conditions like diabetes and cardiovascular disease to continue medication lifelong, and most patients never question why. Obesity is still perceived as a cosmetic issue by most patients, hence the recognition of long-term or lifelong therapy is still a surprise. Besides, when weight loss starts to plateau, patients think there is no further benefit of the drugs and then they want to stop them. Again, there are no guidelines in the world that are currently de-prescribing weight loss medications. Mindful eating has to be a philosophy throughout life, and resistance training or exercise as well. The mantra in life, weight cycling, is an emerging concept and needs to be well understood and studied even in the Indian context. And with respect to the limited drugs that we have for chronic weight management today, additional benefits include the fact that it's going off patent in a few weeks from now, and most of them are once weekly preparations. Patient as well as physician education is a must in understanding the long-term medications as we go. So simply saying yes, lifelong is not the answer. Adopting strategies for long-term use is based on setting patient expectations right and along with a dedicated and structured weight loss and maintenance clinic and supervision, because this is a prescription, mind you, and strong global pharmacovigilance programs. So as of today, we do have the evidence that long-term use, or yes, lifelong use will be necessary for weight loss medications with a prescription implying under supervision. And individualization and continuous assessment of the risk-benefit ratio is the key. So no point in being tight-lipped. We need to really achieve that balance with the perfect use of anti-obesity medications. Thank you.
Thank you, Dr. Puri. I think it's a very extensively, we are, come, take a seat here. And it's very interesting, as even Manoj was suddenly come out of the blue and then was admiring you speaking there actually. Lakshruti?
Yeah. Thank you, Dr. Purvi. Thank you, Krishna, for giving us this opportunity here. Dr. Krishna has given me exactly 7 minutes to say or prove my point of why anti-obesity drugs are not lifelong. So before I start, I have no conflict of interest specific to this debate, but I am a strong user of GLP in practice. I also use, have some experience with Orlistat and not much experience with bupropion, naltrexone or topiramate, which are currently available anti-obesity drugs. So in 7 minutes that is given to me, I'm going to specifically focus only on GLP. I know she has set the stage on obesity, why it is sort of important to have these drugs as lifelong. Whatever Purvi has mentioned in her talk, I am going to show you the evidence as well to say why this cannot be a lifelong therapy. So one lifelong pharmacotherapy in the management of obesity, one currently is not evidence-based, right? None of the guidelines have endorsed a lifelong. The WHO guidelines came out last year, which called these drugs a conditional recommendation. I'll also show that in my presentation. So there are no evidence-based strategy to use these drugs forever. And it is not individualized as well, right? So this is not something that we can do for all our patients. Even though I do understand the use of GLP and how it has sort of bridged this gap between the pharmacotherapy and lifestyle therapy and bariatric surgery, as Purvi mentioned, it cannot be feasible at a population level. We cannot do this for all our patients that we would see in our practice. So the weight loss therapy that we use in our practice should be evidence-based, right? So I think all of you here would agree with that. Time limited. Right, it can be short-term, long-term, depending on the patient or the patients that you see in your practice. It has to be a goal-directed. So when you first meet your patients, it might take 1 or 2 or even 3 visits to sort of understand what your patients actually want out of, the consultation. It's a starting GLP or the weight loss in the management it's not an easy task. So it has to be a goal-directed therapy, and periodically we need to review. What are we doing? What is going wrong? And are we doing the right thing? Is this the right dose? And this has to be the mantra for weight loss therapy, but whatever it is, not the default lifelong pharmacotherapy is my point. And that is exactly what I'm going to show you. So the anti-obesity medications that you have is like a toolbox. Like imagine a toolbox for your cycle kit or whatever you use. It's like one of the tools that you use in your practice, and they are not mandates, right? Because we know obesity is a complex biological heterogeneous disorder, and what we see from one patient is absolutely not the same with the other patient, right? And lifelong prescription assumes irreversible biology, which has not been shown. There are fewer studies where they talk about modulating the neuroplasticity and sort of, make with cognitive behavioral therapy, with the psychiatrist help, to sort of modulate that to see how you can wean these patients off drugs. And everyone differ in the biology and the life course. For example, we have women, especially in my practice, and also men around 40s to 50s, they do gain weight around perimenopause, or if they have a divorce or some family situation, they do gain weight, and that's not the end of the, the consultation. So we see them in follow-up, they do, they get back on track, and they will probably do well over the period of next couple of years. So it is not, the life course of our patients differ. They all do not need to be on a drug forever. And the environment, the society, the side effects, of course, we will talk in brief about these drugs, all of those will change and it differs. So it is not something that we should consider lifelong is my point for my argument. And you may stay for this ever. So the first consultation when we see patients, when we put them on GLP-1, doc, how long should I be on this drug? Is the first question that we ask, in addition to the cost and the other things that we also discuss. You must stay on this drug forever. It's not something that I would say to my patients at the first consultation, because it is, at the end of the day, it is an internalized stigma and a sense of personalized failure, right? So this is something that I wouldn't say. Maybe some of our patients would require for a longer time, no doubt, but this is a sense of personal failure. So consider anti-obesity medications are one of the tools in your obesity practice, and not as a mandate for all your patients to be on lifelong therapy. And what is the current therapy shows? You know, we also showed evidences with semaglutide about the therapies. Most of these current the trials that we have, be it SURMOUNT trial or the STEP trial with semaglutide or tirzepatide, or the future trials that we have with the triple agonist, most of them would span for 1 to 2 years, say max 4 years for the SELECT trial. Right? That is the maximum data that we have. Well, in real life trial with SCOPE trial with semaglutide, that again is not a long-term trial. It's a short-term. We can't really, you know, how long of an evidence do we have? You know, that's the question that we need to, you know, think about when we, you know, consider these for long term. And WHO obesity recommendation guidelines, which came out last year, also call these as a conditional recommendation, because long-term efficacy and safety data with these drugs for the anti-obesity management is not really known. And many of us who use GLP here would know some of our patients do not respond to GLP, right? There are non-responders. What are we going to do with those patients? We know about the gut-brain axis, we know how it modulates and etc. What do we do for non-responders, right? So we need to think about that. And Purvi clearly showed this slide of what happens when you stop the therapy, and that is what that was done with tirzepatide and semaglutide in STEP 4 and SURMOUNT 4 trial as well, where they stop the therapy and patients do gain weight. And what do we do with those subset of patients? I know that doesn't equal to a lifelong therapy. I'll show you a point for that in my next slide. So the dependency of effect does not equal lifelong necessity. Sir, I'll take 3 more minutes, sir. So obesity, and I know this is an NCD, we talk about obesity as a non-chronic, disease where, it's a relapsing disease. That's how most of the definitions have been put forth by the ESI or the RSSTI guidelines. But we cannot really equate this to the other, NCDs like diabetes or hypertension, because this is a behavior biology feedback loop, which sometimes, not in all, can be modulated with a partial reversibility, unlike the other NCDs that we talk in terms of diabetes and hypertension. Because the food noises, with the so-called food noises that we talk about, the orexogenic pathway and how people eat and this constant feeling of hunger, the gut-brain axis, so it's pretty complex, this obesity thing. Can this be modulated? Yes. There are some smaller studies which show understanding this orexogenic pathway. Had we known this, probably would have not needed the GLP-1 agonist to begin with. I think a lot of people could argue it that way as well. But if you think about this, what have been shown in these smaller studies of how to modulate these food noises is, one, to have a stable circadian rhythm. Have a proper chronobiology, go to bed early, wake up early, give your time, to talk about melatonin is there, all those other things. CBT with a trained psychiatrist or a therapist absolutely works. Sometimes we just ignore that in our practice. That is important. Exercise and movement, regular weight training exercise, having a routine, working out 3 to 4 times a week sort of modulates this neuroplasticity and the eating behavior. It has also shown in smaller studies. Having a high protein diet, if I have to have a buffet breakfast today here or a buffet lunch, I usually have a 25 to 30 grams of protein before I come in, so that I don't overeat on the carbs. So you have your protein. You prioritize your protein and good fat so that your carb content comes down. Changing the house environment. Do not buy stuff. Do not have food lying everywhere. And having this Instagram and constantly scrolling this, cooking videos and these, all these things have also shown to, cutting down on that has shown to change this eating behavior and neuroplasticity. We can do this. This takes incredible amount of time. In a private practice, you are tired talking to your patients, but at the end of the day, this works. And from my personal experience, I can tell you this 100% works without the GLP-1 or any other anti-obesity drugs that you have to use in your practice. And long-term safety does not mean lifelong use. We do not have long-term safety with these data. What happens to the lean mass? I'm not going to here talk about the GI side effects or retinopathy or NAION. I'm not going to talk about that because I also use GLP in my practice and I know how to use it and how to sort of wean off and stop it and how to reconsider my prescription. But prolonged use, what about the lean mass? What about the micronutrients? Are we looking into this? Do we have data? Absolutely not. No data for decades of use, maximum 4 years. Now in India, it's been from March of last year. So how long is too long? We don't know. And safety does not mean it is necessity, right? So long-term safety does not equal. So we have to ask all these questions before, we prescribe or continue to use these drugs in our practice. So this is my last slide, sir. I think this sort of summarizes whatever we went through right now. The future model of obesity care is not GLP-1 receptor. It's, as I told you, it's one tool in your practice. Using this for lifelong is absolutely not evidence-based, not individualized, not feasible at a population level, and dependency does not mean lifelong necessity. You can talk about the orexogenic, modulate it, include protein in your diet, move, sleep properly, do all the right things. Weight loss is not about doing the most complicated things. Weight loss is about doing the most mundane things again and again, right? That's exactly what, how we actually sort of lose weight and maintain the weight loss. Anti-obesity drugs are tools, not mandates. The future model of obesity would be a more personalized and de-escalating way. So it's an evidence-based, time-limited, goal-directed management that has to be personalized, for each and every of our patients differently. You have to periodically reassess, thoughtfully de-escalate. I don't have time to show. There are very small studies which have done what they call quote unquote as microdosing. So this is not approved in the guidelines yet, but the guidelines are evolving, right? How SGLT2 and GLP has come in the guidelines now. So guidelines will evolve. There are microdosing study where they use a small dose of GLP every 2 weeks when the patients come off of therapy. They don't stop it cold turkey. When somebody has lost weight, most of the trials, the step 4 and the sermon 4, just stop them cold turkey for half their patients. We don't do that in practice. In practice, they say you can de-escalate the dose, do microdosing of GLP-1 receptor agonist, and probably have a different way of stopping it, allowing all the other things that we talk about, the protein, the movement, the sleep, etc., also to sort of work parallelly. And you can de-escalate GLP-1 receptor agonist every 2 weeks maintenance therapy that came out in 2025. So there's a comprehensive support, includes a therapist, a CBT, exercise, sleep, environmental changes, social media. A lot of things play a very important role. Obesity needs a lot of patience to manage. It is just not drugs, and drugs are not lifelong. Drugs can be used for your patients, but we really need to know how to sort of de-escalate and take them off the medications at the time that is appropriate. With this, I finish and I hand over to Dr. GVK, sir. Thank you.
Thank you, Dr. Shruti. Very nice. Okay, now before going into discussion with the audience and finally giving 2 to 3 minutes I will take to give the balanced view, suppose you are asked to speak what Purvi has spoken. Do you think that, you also confess that you do use GLP-1 receptor analogs for obesity management. So now, as far as this orlistat and other things are concerned, I don't think they are very useful in our country. That's what I personally felt. The weight reduction is hardly anything. Now, which are the patients which you would like to have a long-term, I don't say lifelong, long-term usage of anti-obesity drugs?
So, if I have to speak in place of Purvi, I would certainly debate, I know it's not about which speaker wins, it's about the science. I know it's not between Purvi and me. I would still say there are evidence for 3 to 4 years, and we need to, at appropriate time, we need to sort of think about this and sort of de-escalate for our patient. I would still because I'm not saying don't use GLP, I say use GLP, but see when you can stop them and how you can also sort of look into the other pathways which would interact. So I would still stick to my points and show you the science, because at the end of the day, what matters is the science has to win, not the speaker.
Just briefly, who are the patients do you think that you will not use drugs for therapy? Just very brief.
Definitely somebody who has gained weight in the recent past and is very highly motivated to follow lifestyle changes, and has a lot of focus on exercise, because eventually for weight maintenance only exercise and resistance training is really going to work long term and help you stick to a good diet as well. So all those points are very important, but I think we just cannot shy away from the fact that there is a huge role for drug therapy. I think where we are faulting is that along with drug therapy, we are not emphasizing on the lifestyle changes, and that's where we are failing. So I think drug therapy is here to stay, but definitely in addition to that, it's not a magic pill that you're just going to get the results just by taking the drug or staying on it lifelong.
I think with the paucity of that time, I think I would like to appreciate both of them. In fact, there's a so-called debate. It's not exactly debate, and I thought they're complementing each other. So that's a way of looking into that. Now, Dr. Purvi has given a very good way of looking into obesity management. There is a treatment gap between 5% of lifestyle modification and 35% of the bariatric surgery, and in between the gap, the pharmacotherapy. It's a very nice way of looking into that. But one of the slides that Dr. Purvi has shown is very impressively that at the end of 5 years, there is an 80% regain of the weight. But mind you, this study is a very blotched study, actually, because there are a lot of withdrawals, and there are a lot of people gone into pharmacotherapy in between. Those things were not recorded. That particular slide that you have shown has a lot of issues in that particular data that has been presented. The reason why I am telling is that if you look into the look ahead trial, and as well as if you look into the direct trial, it's not very bad actually. At the end of 3 years, it's not very bad at all. Actually, if you look into the look ahead, at the end of 5 years, only 9% of the people got more weight than the baseline weight. But they were able to maintain to a certain extent the weight loss in look ahead. And direct trial at the end of 3 years, still that remission, whatever the study has been done, the 10% of the weight loss has been maintained even after 3 years. I mean, it's not said that lifestyle modification has got no role at all, but there is a role for even the pharmacotherapy. I'm not trying to say that I mean, as both of you use, I'm also using pharmacotherapy for many patients actually. Now, as far as the stigma is concerned, that Dr. Purvi has spoken about the stigma, rather both of you have spoken about that. Stigma is an issue in our country. I think stigma is there, but it's a different issue. So some good weight loss is there. People come and ask us, the people around them are telling what has happened to you, you're losing weight, you're not looking better now. So people used to come and say that, okay, please stop the drug, I want to put on weight also. So it's a different way of looking into that. But ultimately we need to convince them to say that no, this is a very good thing to do, go ahead and all. Okay, now, I mean, Dr. Shruti has put a very important question. What do you mean by lifelong? That's a very important question actually. Really we don't know actually what do you mean by that lifelong medication to be stopped. And I think it's a very important what you have shown in the WHO guidelines. It's only 3 to 4 years of data that we have, though we have been using the GLP and receptor analogs for more than 20 years, but the recent ones have been most effective, the 2 drugs that we have been using in the last few years. And then I think the safety data has not been there. Maybe there is a safety, but we don't know. And that may not be the only reason why we should say that we have to stop the drug as well. That's just not because. I think we need to look into in a different way actually. It's not very easy to answer these questions actually. And as far as the appetite modulation is concerned, it's another important aspect what you have said. appetite modulation, but it is, I mean, you need to have a lot of motivation for that. It's not easy. If you ask me to, for example, if you ask me to go and say that don't eat idli, and then or dosa, you go only for these things, maybe I'll not be doing it. Because it is, it's not just, we can cut down number of idlis or dosas, but you cannot say that I don't take this, don't take that, because our integral part. After all, in life, two things what you need, some amount of good food and a good sleep. These are the two things that we need in our life. I think we need to balance these things, and cutting down the calories is the most important, I think. 25% of what you're eating, you cut down. That's more than enough. Dr. Sanji Pimos used to say that, cut 20%, cut 20%, cut 20%. Very simple way of looking into that. That itself may improve that actually. And you can see that there is so much of change in the lifestyle that has been happening over what about 40 years ago, 30 years ago, and now. There's so much of difference is there. I think we have to go back to our old traditions. Probably we may, dependence on the drugs may also will come down. So I think it's I would rather like to congratulate both the, I don't say debaters, it's Jugalbandi rather, I would say Jugalbandi, complementing each other, and thank you very much. Dr. A.K. would like to add something for this? No, okay. Shanmugam, okay. Thank you. Thank you for, or anybody would like to have some, any clarifications from the audience point of view? No, thank you.
Good morning. Sir, obesity is itself a risk factor for MACE outcomes. What about stopping GLP-1s? Will it cause any increased risk, or the risk will be stable, or it will be reduced?
That's I mean, that the whole thing is that, the risk factor is basically because of the obesity. The moment you stop the drug, the weight regain is going to be there. Okay, not only that, even for lifestyle modification, the metabolic modulation that happens, what Dr. Puri was talking about, will make you put on weight. Definitely, the metabolic risk, what you had with weight reduction, when you regain, you'll get back. That's very sure.
Thank you, sir. Thank you.
So, thank you, sir. So, thank you, Dr. Vijay Kumar, sir, and Dr. Shruti and Dr. Purvi, ma'am, for the wonderful debate. So, moving on from workshop and debate to the main keynote addresses. So, may I invite Dr. Professor N. Rajendran, sir, who has been teacher of many diabetologists and a well-known person, so to chair this wonderful session. And we have three eminent speakers to deliberately give their beautiful keynote addresses. And the first speaker will be Dr. Abraham Omnan, sir. Over to you, sir.
So with your permission, can I start?
1 minute, sir. Hello. Good morning to everybody. My dear faculties, distinguished speakers, dear colleagues and friends. It gives me the great pleasure to welcome you all for the scientific sessions of debate, focusing as one of the most complex and rapidly evolving challenges in contemporary medicines, obesity and its cardiovascular complications. As you know, for many years, obesity was regarded primarily as a lifestyle issue or at best a risk factor. Today, there is no doubt that obesity is a chronic, relapsing, multi-system disease influencing not only metabolism, but also cardiovascular structure, function, and long-term outcomes. What makes obesity particularly challenging is that its cardiovascular impact often extends beyond traditional risk factors. So, this session will progress in 3 steps. The first step is the relationship between the heart and obesity, the known and the unknown, about which my colleague at Apollo Hospital, Dr. Abraham Woman, is a well-known speaker. He is going to talk on this topic. Dr. Woman.
Thank you, sir.
Can I have the slides? The topic given to me is the heart and obesity, known and unknown. Dr. Krishna is famous for his philosophical bent. So I thought I'd start with a quote from Aristotle, relevant to this talk. Aristotle said, the more you know that you don't know. So, more you know about obesity and heart, you know that you don't know much about that. Then for the young people who have seen Game of Thrones, there is a very famous quote there. You know nothing, Jon Snow. That means we may think that we know, but we know nothing. And finally, I go to Don Rumsfeld in 2002, who said this in a defense briefing. So I will not be talking only about knowns and unknowns, but they are subdivided into known knowns that are facts, known unknowns that are questions, unknown knowns are intuition, and unknown unknown are discovery. So I got 20 minutes, so let's go dive into known knowns, facts. So what is known about obesity and heart? We know that 2/3 of the excess obesity related death, yet now talking about death, is attributed to cardiovascular disease. So it reduces lifespan, and the reduction of lifespan is predominantly due to cardiovascular disease. How much is the reduction in lifespan? If the BMI is more than 40, you lose about 9 years in a man and about 8 years, 7.7 years in women. So that much years of life is lost, and predominantly due to cardiovascular disease. Now moving on to MI, we think of cardiovascular disease as only as myocardial infarction. That is no longer true. The mortality in acute MI, the West is less than 1%, and mortality with heart failure, hospitalized with heart failure, it's still around 10% in the West. Whereas in India, mortality with acute MI is about 3 to 5%, and heart failure is 10 to 20%. So you have the big three there: smoking, diabetes, hypertension. Look at the odds ratio, 2.87, 2.37, etc. Obesity, odds ratio is 1.62. But you mix obesity to diabetes and hypertension, the odds ratio increases tremendously. Where have we seen an odds ratio of 21? This is in the heart. So that much is the increased risk of MI. I moved from mortality to MI, and it's provided by obesity. Now to heart failure. This Milton Packer's slide, and see, obesity, he has simplified it into expansion and biological transformation of visceral fat. So it is just not some numbers, but and I believe it is, because it is just not the numbers. There is a saying that the higher the weight, the chance of you dying, especially in HFrEF, is less. That means big ships do not sink. It's the smaller ships that sink. But obesity is essentially expansion and biological transformation of visceral fat. There is altered synthesis of adipocytokines. There is pro-inflammatory effects, fibrosis, and leading into HFpEF. So this is the CT picture of a patient, and you can see the heart covered with fat. This is huge amount of fat, even in thin people. Even the thinnest of the BMI may be 23. I've got patients with BMI 23, but with significant pericardial fat. Moving on quickly, these are all the known knowns. The cardiac arrhythmias. So obesity increases cardiac arrhythmias, both ventricular as well as atrial. Then it produces QRS fragmentation. One simple thing in ECG, now this is going to come, if at all it's come, the AI red ECGs, they can pick up the QRS fragmentation. If you see a fragmented QRS, just the QRS is fragmented, then they are at very high risk of sudden death, if no obesity or sarcod, whatever. So that's a marker of fibrosis. And there is decreased connection proteins. There is this associated with epicardial adipose tissue. VT and VF is increased and sudden cardiac death is increased. And again, for atrial arrhythmias, atrial fibrillation increases, and there is atrial remodeling, the tissue around the left atrium, again, fat around the left atrium is metabolically very active. What about pulmonary hypertension? We think obesity, pulmonary hypertension, okay, everybody is having OSA, that may be the reason, so lung related. But no, directly, even the 79% of the class 3 obesity patients have pulmonary hypertension. So, dividing known knowns in the pathogenesis and progression of heart failure with preserved ejection fraction, which I got a passion about. So, the primary means of identification in the clinical setting, it is waist height. I love waist height ratio. I am not a fan of BMI. I am not a fan of others because simple things. And waist measurement, ladies with the hip measurement where the ladies have some problems, and then the waist height ratio more than 0.5. If it's more than 0.6, your chance of, if you have HFpEF, your mortality increases. That was shown in Paragon. Association with heart failure epidemiological studies is more with HFpEF than HFrEF. Associated with experimental studies only with HFpEF. These are all known knowns. Association with hemodynamic and clinical severity of HFpEF, definitely yes. The predicts heart failure events in patients with established HFpEF, yes, again known. Treatment before the onset of HFpEF reduces the risk of HFpEF. Again, there are observational studies and also studies on bariatric surgery. And after the onset of HFpEF treatment, it reduces risk of heart failure events, yes. So these may be the known knowns in the pathogenesis and progression of heart failure. So again, I have 10 lessons on predominantly on heart failure, but on obesity and heart. Obesity is more than a comorbidity. It is not a lifestyle. It is a disease, period. You have to know that it's a disease. It's a disease like heart attack, MI, or non-communicable disease, any of these. Visceral obesity is present in more than 90% of HFpEF patients. GLP-1 receptor agonists have distinct mechanisms of actions which we can debate for hours. There is huge overlap in the cardio-kidney metabolic obesity in heart failure. GLP-1 receptor agonists reduce cardiovascular and heart failure events. Quality of life. This is something which we have to understand, because if you ask the patient what do you want, they'll say I want to live better. Very few people will say I want to live till 100 or 90 or 1,000 full moons and etc. etc. But they want to live well. And the quality of life, the best was with GLP-1 receptor agonists by weight reduction and maybe other mechanisms. And the disease modifying role more than weight loss. Decongestive properties in heart failure. This is something which is not being talked about because decongestion means diuretics. But there's been shown that GLP-1 receptor agonists reduce congestion head to head or almost the same as that, even maybe better than diuretics, including spironolactone. And the magnitude of weight loss with drugs is similar to bariatric surgery. And again, tread with caution in some situations, including HFrEF. I was fortunate to be part of this global guideline called iCardio Alliance. This alliance of people all over the country, all the world, and obesity is published in 2025. And again, the last knowns are, it is universally endorsed by all major guidelines to mitigate cardiovascular disease. Now we come to known unknowns, that is the questions. You see here, the questions and answers may not be in the same direction. So the first question is that why Indians are different? Is it because of central obesity, thin fat Indians, high insulin resistance? Is it because LDL is high? It's because triglyceride is high, HDL is low. We know that Indians have all these, but we do not know exactly how they factor into excess cardiovascular problems. Next is the obesity survival paradox. It was thought that big ships do not sink. If you're obese, especially if you have heart failure with reduced ejection fraction, your mortality is less. But this does not hold true with heart failure with preserved ejection fraction. And when the waist height ratio rather than BMI was taken into, especially in HFpEF, this paradox became less evident. Location of your fat matters, but where? Now we know that it's not a subcutaneous fat, but fat at the back is different from the tummy fat. Fat in front of the gluteus is different. It's that we know that location of fat matters, which except for a cardiac point of view, it is the epicardial fat and pericoronary fat. So coming to pericoronary fat. So there is fat around our coronaries. We are moving away from a stenosis or blocks associated cardiovascular risk stratification or event prediction. We know that people with less blocks can have more MIs, critical calcified blocks may not have MIs. So what happens is the fat around the coronaries, and they talk to each other. So they are not passive. They talk to each other, and it can get inflamed. There's something called fat attenuation index. So we can measure. Now that CT has come to India, it's not there everywhere. You can actually measure the fat attenuation and inflammation of pericoronary fat. And the study called Orphan study, which is a big study, and which showed that the degree of inflamed fat around the coronaries is the single most important driver for cardiac events. It is not even triple ulcer disease. So they looked at people with triple ulcer disease and no the inflamed fat around it. And they looked at people with no critical blocks but inflamed fat around it. And people without critical blocks but inflamed fat around the coronaries, they had more events. So that can be called that obesity of the coronaries. Now again, another known unknown. When you combine SGLT2 with GLP-1, will the cardiorenal effects, I'm not talking about the weight here because my topic is obesity and heart. So in flow, what they've found was that if you give a patient is already on SGLT2, the effect of GLP-1 was little mitigated. Flow was a renal trial, but flow, even though obesity was not a criteria, the mean BMI in flow was 31. So this is another known unknown. Then comes the interesting known unknown. GLP-1 receptor agonist in reduced ejection fraction. We know that GLP-1 receptor agonists act in the brain through the vagus predominantly. It is not directly crossing the blood-brain barrier, etc. And we do not know what exactly it does in the vagus. We talk about agonist, partial agonist, antagonist, biased agonist, so many things. So if this vagal stimulation should reduce heart rate. But here, paradoxically, and this is one of my, as a cardiologist, my favorite grouse with GLP-1 receptor agonist. It increases the heart rate. You can see here to your left the heart rate. And look at the difference. It is almost more than 10. Mean difference of heart rate was 7. That is not good at all, especially in HFrEF. And this was published in 2025. What they found was that these are all patients with HFrEF on an ICD. We know exactly what is going on. Ventricular arrhythmias increased and shocks increased. AF reduced, but they with GLP-1 receptor agonist. So this is a very great known unknown. It acts through vagus, but what does it do to vagus? Whether it produces the vagus stimulation, parasympatholysis, or parasympathetic, we do not know. It may be, so these are known unknowns. Another, this was just now published, and we do not have trials on HFrEF. So we need more trials in patients with reduced ejection fraction. We know that good number of HFrEF patients are also obese. Now coming to the greatest the discussion part, skeletal muscle. We know that, okay, the fat-free mass, and you can see the fat mass reduction, 39% with semaglutide, 25% with tirzepatide. So we all know resistance training is advisable, and there can be what is called as sarcopenic obesity, which is bad. So now let's look at the summit result. LV mass reduced by 8%. That is not very great number. But paracardiac adipose tissue reduced significantly. The epicardial fat or the extra cardiac fat or the the reduced, but that's not that significant, but there's significant reduction. Look at the stroke volume, reduced by 11%. This is in HFpEF patients, not HFrEF patients. So HFpEF patients are generally thicker ventricles. They may tolerate cardiac mass loss better. But again, the known unknown. There are 10% patients in Summit with more than 20% LV mass loss. So that is something which should be, we do not know and we have to worry about. What about stopping therapy? Again, this has been told again and again. We gain weight and we gain fat, not muscle. So 5 key points here are skeletal cardiac muscle loss with GLP-1 is a reality. Its impact may be slightly overrated in general. It is that not too bad, but it's slightly overrated. It's like neon, or it's not exactly like neon, but maybe overrated. But in elderly and heart failure where sarcopenia is a problem, this has to be considered. Heart rate issues has to be considered. And uncertainty over the previous debate was on that, over debate or body and cardiac composition on stopping. Now the unknown knowns, that is intuition. Classical is the adipokine hypothesis of Dr. Milton Parker. He said there are 3 domains and domain 1 is protective and domain 2 and 3 are bad. When there is visceral adiposity, domain 1 adiponectin reduces and leptins increase. In very simple words, that's what he said. And incretin receptor agonists improve the domain 1 adipokines. Adiposity as a driver of cardiovascular aging. We have heard about chronological age and biological age. Now we are talking about chronological age and biological age of the heart. And majority of us are going to die of heart-related issues. So we have to know the biological age of the heart. And adiposity is a driver for cardiovascular aging. What about coronary flow reserve with skeletal muscle adiposity? We do not know if it's a risk marker, treatment target, or bystander. Now in the last 2.5 minutes, the unknown unknowns. That is the discovery. So we know that there are GIPs, GIP antagonists, GIP agonists, there are GLP-1s, PYY, amylins, glucagon, and I'm not going into the depth of each, but I'm interested in the bone part where the GIPs and amylin, they may be useful. But they remain in the realm of discovery. Still they are unknown unknowns. Then so many trials are going on, retatrutide, survodutide, and you have movement all on heart-related and maritide. But the cardiovascular, that is the holy grail. The most of these initially looked at just weight reduction. But is that enough? Is again an unknown. The method of delivery, peptide agonist, peptide multi-agonist, oral peptide, oral small molecules, antibodies, cell-based therapy, gene editing, still the ones onto your right are still getting in the realms of discovery. And finally, people talk about the skeletal muscle fat getting resolved. But some people say that may be protective. GLP-1 receptor agonist is a protector to skeletal muscle. Again, what happens is there is SIRT1 activation. Dr. Krishna is very, very fond of SIRT1 and mTORs. And there is SIRT1 activation and mitochondrial activation by GLP-1. And one of the mechanisms are by reducing the fat in the muscle. And the muscle anabolics, bimagrumab, enobosarm, and many. And Lilly has spent crores, billions on acquiring this company for bimagrumab, and the studies are ongoing. But still, it is an unknown. So, concluding, 2/3 of obesity-related excess mortality is due to cardiovascular disease. Obesity is a disease, and which perpetuates cardiovascular disease. People with similar BMI can have different metabolic profiles. BMI may not be the key. Obesity is a major modifiable risk factor. I would change that. It's a modifiable disease for cardiovascular disease. and strategies to tackle obesity can reduce the cardiovascular disease burden globally. I conclude with 3 seconds to spare, quoting Jocelyn, with an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Thank you very much for patient hearing.
Thank you, Dr. Oman, for that comprehensive and elegant presentations. What clearly emerges is that obesity is not a passive load on the heart, like it aggravates that myocardial infarctions, cardiac failures, arrhythmias, and so on and so forth, but an active pathophysiological driver influencing myocardial structure, function, and long-term outcomes. Your emphasis on early, often silent cardiac involvement is particularly relevant for preventive cardiology and metabolic practice. Thank you. I think that we will have the questions at the end of this sessions. Now I may call upon Dr. Avidesh Kumar Singh, who is going to talk on cardiovascular outcome trials in obesity, a deep dive. As we move from mechanisms to outcomes, the next critical question is, do interventions in obesity actually translate in cardiovascular benefit? Cardiovascular outcome trials have fundamentally changed how we practice medicine, first in diabetes, now increasing in obesity. Dr. Singh is widely recognized for his expertise in analyzing and interpreting COT data. In this talk, he will take us through the key cardiovascular outcome trials in obesity, helping us understand not only what the trials show, but also their limitations and real-world applicability. Dr. Singh, we look forward to your deep dive.
Thank you. Thank you, Chairman, sir, for the kind word. Thank you, organizers, Dr. Krishna, entire team of debate. So in next 19 minutes or so, I am going to take you through a deeper dive into cardiovascular outcome trial exclusively conducted in people with obesity, with or without diabetes. So this is not a diabetes cardiovascular outcome trial. I am just focusing on cardiovascular outcome trial exclusively done in people with obesity. They may or may not have diabetes. Dr. Abraham spoke so elegantly on cardiovascular manifestations of obesity, knowns and unknowns. The one thing which we know is that if you are obese, you are going to die with a heart disease. That is a clearly known fact, and there is no debate about that. The second thing which we exactly know, that as we shifted our gears from numerical values of diabetes to cardiorenal benefit, so we no longer look at the glucose value. Even if your patient is well controlled with blood glucose, if you have not used the tools to prevent cardio and renal disease, there is no point treating diabetes just by looking at the number. Similarly, if you are using a tools to reduce body weight, this is just, your look. If you can't reduce the ultimate cause of death, which is heart related in people with obesity, there is no point reducing body weight just for a cosmetic value. So the moral of the story, that we are shifting our gears from cosmetic numbers to finally prolong life. And in pursuit to find and to reduce cardiovascular death, we started conducting the trials with the drug which has a potential to reduce cardiovascular event. Dr. Abraham talked about this, so he did my job very easy now. So I will directly shift to the tools and the trials which looked at the cardiovascular outcome in people with obesity. Okay, so let us start with the lifestyle modification. When anybody comes to your clinic, our job is not to just you write one drug. The first time the patients meet you, our job is to speak about lifestyle modification. That is the integral part of treating diabetes and obesity. There is no point using a fancy medicines which has a lot of money involved without simply advising your patient that you need to change your lifestyle. You need to cut down your calorie, you need to do exercise, you have to stop smoking, you have to minimize or stop alcohol. This is an integral part of. And if you are motivated one, you can go for intensive exercise. Look at this study called Look Ahead trial. What you can see that Look Ahead trial did show a significant reduction in body weight on people who actually maintained the intensive lifestyle modification. However, when it comes to look at whether reducing body weight by intensive lifestyle modification translated into cardiovascular benefit, the answer was big no. That's an unfortunate part of the story, that when you say that people with obesity die of diabetes, once even if you reduces the body weight, you do not reduces the cardiovascular risk. That's a little bit a sad part of the story, that despite an intensive weight loss in the Look Ahead trial, there was no reduction in the cardiovascular outcome. Therefore, tools is important. Not controlling diabetes is important. The controlling or preventing future cardiovascular and renal disease is the important. So Look Ahead though reduces body weight significantly. There was no reduction in cardiovascular event in the Look Ahead trial. Now let's go to the extreme. Bariatric surgery. You know, the bariatric surgery give you a largest weight reduction, compared to any tools which we have. Although with modern tools we are nearly challenging the bariatric surgery, but if you look at the invasive bariatric surgery, still none of the anti-obesity drug can match the weight loss which the bariatric surgery actually showed. So this is a SOS trial, Swedish obese subject called SOS trial. This trial was a trial conducted in people with obesity who has undergone bariatric surgery. And if you look at what happens to the cardiovascular outcome, including the mortality, you can see in the SOS trial there was a significant reduction in the mortality outcome in people who undergone bariatric surgery. However, this looks absolutely fabulous, but their statistical interference is little weak, because if you look at the p-value, it just achieved statistical significance. But I would not say that it is not statistically significant. This amount of weight loss which happened in SOS trial ultimately lead to a significant reduction, as you can see in the 3-point MES by 33% and 24% reduction in all-cause mortality. So although lifestyle modification failed in Look Ahead trial, the extreme one bariatric surgery did a significant reduction. What about the newer anti-obesity drug? Not only lifestyle, not only bariatric surgery, what about the medium classes drug? So let me start with the first drug, which has a historical perspective. You know that the fenfluramine was the first anti-obesity drug that was approved for very short-term use, not more than 3 months. And this fenfluramine, phentermine, undergone several trials. And unfortunately, we learned that this medications has a potential to involve cardiac valves. And there was a significant increase in valvulopathy and pulmonary hypertension. So therefore, this drug was kept for not using more than 3 months, although people misuse these medications for a longer period of time in absence of any better tool for the treatment of obesity. The next one, very popular drug, many of us used rimonabant. Rimonabant was a wonderful oral anti-obesity drug with a quite reduction in body weight. The rimonabant undergone a cardiovascular outcome trial called Crescendo trial compared to placebo. This trial has to stop prematurely because of increased in neuropsychiatric side effect. There was a significant increase in suicide and attempt to suicide, and therefore this trial was stopped prematurely, and you can see there was no benefit at the end of the trial when the trial was withdrawn. So these medications were banned later on, and therefore no point of discussing the cardiovascular outcome trials with rimonabant. Many of us use sibutramine. Remember, sibutramine was very frequently used in people with obesity. This is a trial, CB outcome trial called a Scott study. This trial was conducted in more than 10,700 patients in people with obesity who had established cardiovascular disease with or without diabetes. They were randomized to sibutramine versus placebo at a median 3.4 years. There was increase in composite of MES events. There was, you can see there is 16% increase in the composite of 3P MES. And because of this particular trial, sibutramine was banned for clinical use in people with obesity. This drug was not seen the light in Indian context. Naltrexone was one of the very popular drug in United States, was approved for obesity treatment. This has undergone also a cardiovascular outcome trial called the LIGHT trial, randomized in nearly 9,000 patients. This trial was also stopped prematurely, because of neuropsychiatric side effect. And if you look at the cardiovascular outcome, it didn't achieve the statistical significance in the LIGHT study. The fifth one was, remember this Camellia trial, many of you used lorcaserin. This was one of the largest cardiovascular outcome trial with anti-obesity drug, nearly randomized 12,000 patients to lorcaserin. And if you look at this trial, successfully undergone, the full interim analysis, and there was no difference in the cardiovascular events, so it was a basically neutral trial. But lorcaserin was withdrawn not due to the cardiovascular event, but there was increase in breast cancer, which was later on analyzed. Remember, lorcaserin was approved by the US FDA in initial part, but later on withdrawn when a reanalysis did find that there is a signal of increase in malignancy, in particular the breast carcinoma. So lorcaserin was withdrawn. Many of us used for quite some time. Unfortunately, this medicine also could not be used for a longer period of time. But the CV outcome was neutral. And finally, then we entered into the GLP-1 space. This is the only trial conducted with a GLP-1 receptor agonist approved in obesity, that is semaglutide 2.4 milligram, popularly known as Wegovy. The SELECT trial was, at the moment, is the largest trial in the planet conducted with any drug. It crossed even the DECLARE-TIMI trial by 64% higher. And before to the SELECT trial, the DECLARE-TIMI was the largest trial. The SELECT trial today is the largest cardiovascular outcome trial conducted ever with any pharmaceutical agent. This trial in people with obesity with established cardiovascular disease involving nearly 17.5 thousand patients, either randomized to semaglutide 2.4 milligram once weekly against placebo. And you can see this trial conducted for nearly 4.5 years with a good safety margin. And interesting, in this double-blind randomized controlled trial, there was a significant reduction in the composite of 3P MES by 20%. So if you look at the composite of 3P MES, which was MI, stroke and cardiovascular death, there was 20% relative risk reduction. And primarily this reduction was involved due to reduction in myocardial infarction. So that's the first anti-obesity tools which we have that suggested that there is a significant reduction, not only in terms of body weight, but here you have got a drug that will ultimately provide you the benefit which we actually looked at in people with obesity. And if you look at this NEGM publication, this was primarily derived due to reduction in myocardial infarction by 28%. Remember, semaglutide 1 milligram, which was approved for diabetes, undergone also a cardiovascular outcome trial called SUSTAIN-6 in 2016, 10 years back. And there was a significant reduction in 3P MES earlier in people with type 2 diabetes by 26%. And that was primarily due to reduction in a stroke by 39%. So semaglutide 1 milligram, so younger brother of semaglutide 2.4 milligram, already has established cardiovascular benefit data in people with type 2 diabetes, and that too with a 39% reduction in a stroke. Now this time semaglutide, the elder brother 2.4 milligram in obesity, came with a 28% reduction in myocardial infarction. And their other step brother, oral semaglutide, as you all know, in SOUL trial, also significantly reduced the composite of 3P MES by 14%, again due to primarily reduction in myocardial infarction with oral semaglutide. So now we have got only 3 agents at the moment in GLP-1 space that actually reduce myocardial infarction. The first one to show was LB-glutide in the Harmony outcome trial, but LB-glutide is nowhere available for commercial use. That was one GLP-1. Although the weaker GLP-1 In Harmony trial, there was nearly no weight reduction. The weight reduction happened by less than 1 kg, and yet there was a significant reduction in MI by 26%. This speaks volume that GLP-1 receptor agonist cardiovascular risk reduction is not mediated solely through the body weight reduction. And the best example to learn was the LB-glutide trial, where the weight reduction was only 700 grams with LB-glutide, and yet there was a 26% reduction in myocardial infarction. But what was surprising that, in other two drugs, here semaglutide 2.4 milligram in obesity and oral semaglutide 14 milligram in diabetes in SOUL trial, they also reduce a significant reduction in myocardial infarction. But what was interesting to note, and this slide perhaps is very relevant to me. We all know, and we learned from the SUSTAIN trial on previous 10 cardiovascular outcome trial, that the benefit of GLP-1 receptor agonist in terms of reducing cardiovascular event is due to a slow regression of atherosclerotic cardiovascular event. And in none of the trial cardiovascular benefit was seen 1 year prior to when the drug was started. But what was surprising to note in the SELECT trial, semaglutide 2.4 milligram started showing benefit as early as 20 days. So this is after the completion of the dose modification. Once we have reached to 2.4 milligram, so starting from to 5, to 0.5, to 1, to 1.7, to 2.4 at the 5-month duration, and now you have continued with the trial. Within 20 days, you see started change in the Kaplan-Meier curve, and this persisted. The statistical significance persisted within 3 months. It was never replicated in the previous cardiovascular outcome trial conducted with any GLP-1. So we were astonished that how could so early the benefit in the 3P miss event. And also surprising to note, the similar thing was noted with the oral semaglutide in the SOUL trial. The cardiovascular benefit started within 3 months, even with the oral semaglutide 14 milligram in the SOUL trial. So these are the two trials done with semaglutide, suggesting a very quick reduction in cardiovascular event as early as within 3 months. And that was a very surprising finding in the SELECT trial compared to the previous trial. Now people also started looking whether these benefit was related to the body weight reduction, and you would be surprised to see, so this is the event and the urgency as to how the cardiovascular benefit started in the SELECT outcome trial. Now people started looking whether this is attributed to the body weight reduction, and as I alluded to, the best example to learn whether GLP-1 exerts their cardiovascular benefit due to the weight reduction, the best example to learn is the Harmony outcome trial, where there was despite that less than 1 kg weight reduction, there was a significant 26% reduction in MI. In the SELECT trial, naturally, you would expect there will be a significant lowering of the body weight. But when I say that the benefit started within 3 months, you don't expect that the weight loss was the reason. Because within 3 months, you don't expect that weight loss will happen to the peak. And yet there was a significant reduction in the composite of 3P MES. This suggests that weight loss may be one of the contributing factor, but it is not the only contributing factor. Perhaps the GLP-1 cardiorenal benefit is partly mediated by weight loss. It is perhaps mediated mainly by their pleiotropic benefit, in particular reduction in the pro-inflammatory cytokines. And ladies and gentlemen, many of you might be surprised to know that the statin, which you use every day in your clinical practice, if you compare the high sensitivity CRP reduction with any cardiovascular protective drug, the GLP-1 tops the list in terms of reducing high sensitivity CRP. And so remember that Jupiter trial with rosuvastatin. And GLP-1 showed even a larger reduction of hsCRP, thereby suggesting that this molecule is working in some different direction, perhaps majorly due to reduction in inflammation component related to the atherosclerotic cardiovascular disease. No reason why all the guidelines in the world, starting from FDA to EMA, and the guidelines in the world has given semaglutide a permission to use as a level indicate to reduce cardiovascular event in people with obesity. So is by the Indian regulators. As you can see by DCGI, semaglutide has been given a level update to reduce risk of major adverse cardiovascular event. Now, second part I will quickly take you into heart failure. Dr. Abraham alluded to the Summit heart failure trial. The GLP-1 has undergone a dedicated cardiovascular outcome trial in people with preserved ejection fraction. Dr. Abraham was one of the investigators in this trial. So there are two trials conducted with semaglutide. As you all know, STEP heart failure with preserved ejection fraction in people with diabetes and in people with obesity without diabetes. But their endpoints were very soft endpoint. As you can see, this was 6-minute walk or KCCQ scoring. And it did reduce significantly the KCCQ score and improved the 6-minute walk test. But however, when the people looked at the hard clinical endpoint, which is composite of cardiovascular death and heart failure across the semaglutide trials, so this is the two trials of in patients with heart failure with preserved ejection fraction, in people with diabetes or in people with obesity. But when they pulled the data with semaglutide across all the trials, as you can see here 4 trials pulled together, there was a significant 31% reduction in the hard clinical endpoint, which is composite of CV death and heart failure hospitalization. So this data do suggest that here we have got a drug that has the ability to reduce the cardiovascular composite in people with heart failure with preserved ejection fraction. And this is their, evidence with first heart failure hospitalization. There was no significant reduction in the cardiovascular death, but the first heart failure and the recurrent heart failure hospitalization was significantly less with semaglutide. The same was replicated in other trials with tirzepatide called Summit heart failure with preserved ejection fraction trial, which Dr. Abraham was alluding to. In this trial, the hard endpoint CV death and heart failure was the composite, and you can clearly see there was a 48% reduction in composite of CV death and heart failure. The another drug with a GIP, GLP-1 that reduced the composite of CV death and heart failure happened. Unfortunately, there was some signals of increase in CB death and all-cause death was noted numerically, but this looks to be more of, a chance, finding rather than of any statistical importance. Finally, I will quickly pass on SURPASS cardiovascular outcome trial, although it was done in people with diabetes, so it is not, important in people with obesity. But just to quickly tell you that the tirzepatide was compared with the dulaglutide, and it was found to be similar compared to dulaglutide. So, tirzepatide did not, cut the cake by getting a superiority with dulaglutide. But this suggested that dulaglutide has already got a positive cardiovascular outcome trial against placebo. But when you look comparing at the placebo, there was a significant reduction, as you can see in different cardiovascular events, and in particular the all-cause deaths. So, ladies and gentlemen, let me quickly summarize the story. So far, if you look at anti-obesity drug and cardiovascular space, none of the molecule till, semaglutide cut the cake of the cardiovascular space. Tirzepatide is currently undergoing their dedicated cardiovascular outcome trial, which will be only published in 2027. So, we have to wait for tirzepatide obesity trial called SURMOUNT-MMO. And there are many other drugs in pipeline. These drugs are very new drug, which next speaker, my friend John Matthew, is going to talk. And they are also undergoing a dedicated cardiovascular outcome trial like CagriSema's called Redefine, which is ongoing. Or Orforglipron is also undergoing a dedicated CB outcome trial called Achieve-4. Survodutide is a GLP glucagon coagonist. They are also undergoing trial called Synchronize. We are expecting this trial result very soon now in 2026. And retatrutide, which is a triple GLP-1, GIP and glucagon receptor agonist, they are also coming with their CB outcome trial called Triumph-3 in this year. So 2 trials we all are waiting for survodutide and retatrutide in this year. This is very interesting part in the space of obesity. Thank you very much for your patience hearing.
Thank you, Dr. Singh, for that clear and data-rich presentations. And thank you for you are giving much importance to that today. Lifestyle modifications in the management of obesity, though there are more number of drugs currently available in the market. Nicely told the fate of that anti-obesity drugs that have been used in the past and why they have been banned or not being used in the practice. And finally, nicely you touched upon that semaglutide, and you have not even given a clear vote even for that molecule, including that the tirzepatide, and you are asking to the audience to wait for quite some time. And what is particularly striking is the transition from the COOT being merely safely oriented to now demonstrating meaningful cardiovascular benefit in obesity. Your insights into patient selection, endpoints, and duration of therapy are extremely valuable when translating trial evidence into daily clinical practice. Thank you once again, sir. Now let us move on to the last session of the last topic of these sessions. That is, are the off-target benefits of nutrient-stimulated hormone therapies a class effect or dose dependent? For this, Dr. Matthew John is here, and he is going to ideally placed to address this complex issue, integrating mechanistic understanding and clinical trial evidence and bedside relevance. Dr. John, please take us through this fascinating topic.
Okay, thank you, sir. Thank you for the introduction, and I'll jump into the topic right away. So these are my conflicts of interest. There is no conflict of interest related to this talk. And now, what are the NUSH hormones? Just for common understanding, these are hormones which are secreted by the cells of the gastrointestinal tract and pancreas in response to nutrients via oral intake, which can regulate nutrient and energy fluxes. And we have a list of drugs that fit into the criteria of NUSH hormones, but generally we look at GIP, GLP-1, glucagon, amylin, and PYY. And you know that these drugs have variable effects in terms of controlling appetite, in terms of glucagon and insulin secretion, in terms of weight loss, gastric emptying, etc. So these are the sort of areas which we are trying to look at. Now, therapies are also there. Dr. Singh has already shown you the therapies. Various therapies are already approved, like the semaglutide, drugs like tirzepatide, which are approved. Some are in the marketing stage, some are in the sort of development stage, some are in advanced clinical trials, and we look forward to all this data which Dr. Singh showed. Now, if you look at what are the target and the off-target effect of these therapies, so this is what I've been asked to talk. So I asked Krishna, what are the target therapies which I should not cover? These are glucose lowering and weight lowering. And others are the off-target therapies, which are cardiovascular, including HFpEF, MASLD, renal, things like obstructive sleep apnea, osteoarthritis, effect on the central nervous system, and problems like skeletal muscle issues, ocular issues, pancreatic and gastrointestinal issues. So this being a very long thing, I'm trying to confine myself to cardiovascular, including HFpEF, MASLD, and renal. And I think a significant part of my discussion has been taken over by Dr. Abraham and Dr. Singh, so I'll concentrate on the rest. Now, we know certain things that GLP-1 does reduce blood glucose levels by action on different areas, which include alpha, beta, and delta cells. And we look at whether these molecules really differ from each other in terms of these outcomes. Instead of going to individual level data, I'll just try to put a meta-analysis here. These are 76 trials which involve 15 GLP-1 RA drugs and combination therapies, involving 39,000 patients. And you can see that from a glycemic control perspective, certain molecules stand out, like tirzepatide, cagrisima, on top of semaglutide and albiglutide, etc., etc. So here it seems that at the maximum tolerated doses used in these studies for type 2 diabetes, certain drugs seems to be having an effect in terms of better glycemic control compared to others. These are the weight loss mechanisms which these drugs can cause, mechanisms. And when it comes to the same data, which I'm again going back to in terms of weight loss, you can see that again certain drugs like tirzepatide and cagrisima outperform other drugs like semaglutide. This is a very dynamic area. I'm sure that the triple agonists now have got trials much bigger than this. This is looking at a meta-analysis. This is just to show that there is a differentiation between molecules, at least in terms of glycemic control and weight loss, when it comes to individual molecules used at the maximum tolerated doses in these particular studies. Now coming to, does dose differ in terms of glucose control? Again, I'm going back to the sustained data of semaglutide, where they have tried to look at 0.5 milligram and 1 milligram semaglutide in comparison to different molecules. The first upper part is looking at the glycemic control and the lower part is looking at the weight. The lighter things are the 0.5 milligram and the darker blue lines are the 1 milligram. And you can see that distinctly at higher doses, semaglutide seems to be work better both in terms of glycemic lowering and weight reduction. Tirzepatide trials also show a very similar picture, where you would see that the 15 milligram seems to be working better than the 10 milligram, which seems to be working better than the 5 milligram, mostly as a trend, both in terms of weight loss and in terms of glucose lowering. So the target effects of these niche hormones, whatever we have with us, seems to be sort of dose dependent and seems to be partly from overall whatever is known seems to be molecule dependent. Now what about the off-target effects? Now to look at the cardiovascular thing, I'm not going to the mechanistic area here, which Dr. Uman has already covered, but to look at this data, I'll try to fall back on the series of cardiovascular outcome trials in people with type 2 diabetes that we have, starting from the leader till the SURPASS CVOT, which Singh has just explained. So we look at these trials and we look at, again at meta-analysis so that we can get everything together on the same page. So the primary outcome of almost all the CVOT trials have been the 3-point MACE. And this has been the primary outcome. So it is good to start there. So you could see that the hazard ratios for the 3-point MACE seems to be differing among these trials. Sort of showing out, sort of trying to point, again I'm looking at it from a much easier perspective, that is the percentage risk reduction. Again, seeming to be like in an amplitude O, like 35% risk reduction, to Excel, which is around 9%, which is not significant. So you see a series of risk reduction with different molecules which have undergone cardiovascular outcome trials. Now, when you take CV death, you can see this again, as a group they seem to be performing better. But if you mark out molecules which have achieved a level of significance in terms of CV death, you can see certain trials standing out like the leader, Pioneer 6 and the FLOW trial. And if you look at fatal or non-fatal MI, you can see the harmony outcomes and the SOUL standing out there in terms of benefits in terms of cardiovascular, fatal or non-fatal myocardial infarction. Stroke you would look at and you would see certain trials like REWIND starting out in terms of the stroke improvement. Now, are these really so different are these molecules so different that they stand out in terms of certain outcomes, but other molecules don't stand out there? Now let us look at the baseline characteristics of these trials. You would see that again, they are not really the same group of trials in the same group of people. If you look at female people included in the trial, you would see that SOUL had included around 30%, whereas REWIND had close to 50% of women. If you look at the diabetes duration in these trials, put everything together, you see that certain trials like REWIND had around 10 years diabetes duration, certain things like FLOW had around 17 years duration. Look at the baseline A1C, which is a major determinant of, one of the major determinants of cardiovascular outcomes. You would see that again, baseline A1C did differ among trials. If you look at cardiovascular and renal characteristics of patients who have been enrolled in this trial, if you look at established CVD, which is the most important factor for getting into a cardiovascular outcome trial, you can see that trials like Harmony Outcomes had around 100% of patients who had established cardiovascular disease by their definition, and REWIND had only around 31%. If you look at heart failure as one of the not the inclusion criteria, the baseline criteria for this trial, the investigator defined heart failure, you would see that SUSTAIN had around 24, whereas REWIND had only around 9%. EGFR differs across trials, standing out in the FLOW, which is a renal outcome trial, which is less than 60. And you can see the baseline LDL also different. If you look at the baseline drugs used in these trials, again, you can see these are also again different. Some trials had an excess of insulin use. If you look at SGLT inhibitor use, very important criteria, you can see that new trials like SOUL and FLOW are having significant SGLT inhibitor use. Again, statin use, antiplatelet use, antihypertensive use. These are not exactly the same across various trials. Now coming to the duration of these trials and whether they were non-inferiority or superiority based trials, the number of patients who have been enrolled into these trials, again you can see these are all different. Pioneer was a 1.3 year duration trial, whereas Rewind is 5.4 years duration trial with larger number of patients. And when you look at the most important criteria, the definition of established coronary artery disease or established CVD, this is one of the most important inclusion criteria into the trial. So whatever is marked in green is something which has been part of the trial, and whatever marked in red is not been part of the trial. So if you look at a trial like say Excel, you would see that more than 50% stenosis of coronary, carotid or lower extremity arteries was not an inclusion criteria there, but it was an inclusion criteria in leader. So basically to tell you that if you look at this picture, it's so heterogeneous in terms of people who have been included in the trials. So there are really different group of patients being studied in all these trials, although we put them under a common basket of established cardiovascular disease. Now, how do we really look at these trials? If you look at the event rate in the placebo group, you can see that certain trials like ELIXA, I didn't put ELIXA in any of those trials because that's something we don't talk about anymore. If a trial, ELIXA did include patients within 180 days of a cardiovascular event. You can see the MACE events are very high in ELIXA. So if you can look at different trials, you would see the event rates are a bit different between the trials. So what do we understand from all this sort of confusing data that I put across? Trials do differ in terms of definition of established CVD. They differ in terms of number of subjects enrolled with established CVD. They differ in terms of their baseline medications. They differ in terms of their duration. So many sort of factors which sort of interfere in these trials, which actually make them really not very similar to compare these drugs. Now, if you look at whether doses differ in these trials, like whether semaglutide at a lesser dose did better than the semaglutide at a higher dose, in most of these trials, all these trials, the doses of drugs were adjusted, titrated up to the maximum dose. So only a very small proportion of patients really remained at lower dose, unlike the EMBARAGE outcome where you could compare between 10 and 25. Here you could not compare between because you had only a small number of patients with suboptimal doses. And so dose dependency on CV outcomes, very difficult to sort of say yes or no from this data. Although we know that dose dependency does exist for blood pressure, lipids, waist circumference, weight, etc. SURPASS CVOT, I'm not going into SURPASS CVOT. Dr. Singh has again covered that, but this stands out as a trial which tried to compare, instead of a placebo-controlled method, they looked at dulaglutide versus tirzepatide, which gives you some idea at available doses, which gives you some idea in terms of the hazard ratio for 3-point MACE, which is non-inferior, and CV that seems to be doing better in terms of for tirzepatide, although that's not a primary outcome. So I'm not going into details of this, but some comparison is allowed with this particular study. Now coming to the renal part of it, are again renal mechanisms. I think this will be covered again in other talks. Renal flow trial stands out as the renal outcome trial of GLP-1 RAs, and there are various mechanisms by which GLP-1 RAs improve renal outcomes. Now coming back to the renal outcomes in other CVOT trials. So various, again, definitions do differ, like composite kidney outcome is one of the major definitions. This in fact differed between trials in terms of the EGFR decline, which was proposed as a criteria for composite outcome. Again, you can see that certain trials stand out in terms of their renal outcome, in terms of composite kidney outcomes. Definition of kidney failure also differed between trials. Again, you can see that overall as a group, they seem to be doing good. And when it comes to worsening kidney function, again, you can see that certain trials did in fact show a benefit where certain trials did not. Now, FLOW trial, again, committed renal outcome trial in which semaglutide showed, 1 milligram semaglutide showed benefit for people with type 2 diabetes and CKD in terms of major kidney events reduction and death from any cause. And renal outcomes in SELECT, again, small number of patients, so rather small number of events which is accrued in this for the renal outcomes. Tirzepatide does not have a renal outcome trial, but this is data from the SURPASS-4 looking at patients, because SURPASS-4 is one of those trials of tirzepatide which had some patients with renal problems. That means around 18% of patients had EGFR less than 60 and around 36% had USCR more than 30. So again, you can see that tirzepatide seems to be better than placebo in terms of renal outcomes. So what can we take home from this renal data? The renal data generally seems to be seen across various GLP-1 arrays. The varying magnitude of benefit may be related to trial characteristics, number of subjects, baseline renal risk, and the duration of study. Except for flow, all the studies use renal outcomes as a secondary endpoint or as post-hoc analysis as an exploratory endpoint. Specific molecule or dose-related benefits cannot be asserted from these trial formats, and renal benefits seems to be seen also in obesity, although the event numbers are small. Coming to hepatic, these are the mechanism of hepatic benefits, again, as area which has been hotly debated. Now, coming to renal benefits, are they different? Hepatic benefits, are they different between the hormone? If you look at GLP-1 arrays, the earlier ones like exenatide, dulaglutide, liraglutide, etc., had some data, mostly in terms of fat reduction. Liraglutide, the lean trial looked at MASH reduction, whereas you had a reduction in inflammation but no change in fibrosis, 39% in the liraglutide arm versus 9%. Semaglutide 4 milligram daily injectable did show a reduction in both MASH, and this was a phase 2 trial. And then you had the semaglutide 2.4 in cirrhosis, showing that there is no benefit in terms of outcome. This is the dose ranging study, I'm not going to that. Now this is just to show that, just one detail of this is that in this particular data, they used once daily subcutaneous semaglutide at dose of 0.1, 0.2, 0.4, and they looked at histology, 320 patients. And you can see the data here, there was no comparison between the doses of semaglutide versus individual doses of semaglutide, but at higher dose of semaglutide, there seems to be sort of benefits in terms of both resolution of NASH and also in terms of fibrosis reduction, or rather in terms of all doses. Now coming to the ESSENCE trial, again, we know the outcomes of ESSENCE trial, both resolution of steatohepatitis with no worsening of fibrosis and reduction of liver fibrosis with no worsening of steatohepatitis happened in 2.4 milligram of semaglutide once weekly. But again here, 88% of these patients were on 2.4 milligrams, so you cannot really get a sort of dose dependency of benefits from these studies. Synergy NASH, again, coming to the individual dosing here, one good thing is that they looked at 5 milligram, 10 milligram, and 15 milligrams separate and compared with placebo. Again, there was I could not find any sort of statistical comparisons between the doses, but only with each dose and the placebo where it achieved significance. Now again, to conclude here, there is evidence for MASH resolution and fibrosis resolution with both semaglutide and tirzepatide. And higher dose of semaglutide and tirzepatide seems to be having better improvements in these studies and also in terms of weight, HbA1c, and transaminase level reduction. Now coming to HFpEF, again, this has been covered in reasonable detail. Just to show this picture that certain studies like the SELECT, HFpEF, STEP HFpEF, and FLOW were looking at outcomes which are different from the SUMMIT, which looked at a hard outcome. So just to summarize this, which will probably give you more confusion, that various benefits of GLP-1 arrays like glycemic control, weight reduction, triglyceride reduction, blood pressure reduction seems to be related to the dose of the drug and may be molecule specific. Molecule specificity may be conferred by molecular structure which is different between these molecules. The DPP-4 resistance, like example, the semaglutide seems to be more DPP-4 resistant than liraglutide. Longer duration of action, because none of the short duration molecules like exenatide did show these sort of benefits, but the longer molecules like starting from lira seems to be showing. Brain penetration and GLP-1 receptor potency may be a factor. We still don't have clinical evidence to support it. The off-target effects may be related to the molecule or due to the methodological difference in clinical trials. These are still unknowns, just like Dr. Abraham told. Renal MASLD and HFpEF actions, evidence is limited to paucity of trials in specific areas comparing molecules or doses. Thank you.
Thank you, Dr. John, for a very thoughtful, provoking presentations. And your talk highlights the importance of understanding why these benefits occur, whether through receptor biology, central mechanisms, downstream metabolic effects, rather than merely observing that they occur. The significant implications for drug selection, dosing strategies, and long-term management of obesity. And now we have to conclude this session. I would like to give some few key messages stand out clearly. First, obesity must be viewed as a cardiovascular disease modifier, not merely a cosmetic or lifestyle concern. Second, cardiac involvement in obesity is multifactorial, progressive, and often clinically silent. Third, cardiovascular outcome trials have moved obesity management from surrogate markers to hard clinical endpoints. Finally, the newer hormone-based therapies offer tremendous promise, but they must be used with the scientific clarity, patient-specific judgment, and long-term visions. Managing obesity today requires a cardiologist's insight, a diabetologist's precision, and a chronic disease management mindset. So, because paucity of the time, on behalf of the organizers, we are concluding these sessions without any questions. If you have any questions, kindly feel free to ask the speakers during the lunch time. I sincerely thank all our speakers for their outstanding contributions and audience for their attentive participations. I am confident these sessions will meaningfully influence how we think, how we debate, and how we practice obesity medicine. Thank you very much.
Thank you so much, all the three speakers and chairperson, for the insightful session. So with this, we'll move on to the next session. To chair the next session will be on muscle and its dysfunction in metabolic disease. So once again, thank you. So the next session will be on muscle and its dysfunction in metabolic disease. And to chair the session, may I call upon Dr. Anbuchelvan Thirumarban, consultant diabetologist from Kanjipuram. Over to you, Dr. Anbuchelvan.
Thank you, Dr. Rajesh, and thank you to N. Rajendra sir and team for giving an excellent discussion. And next I would like to start the session on muscle and its dysfunction in metabolic disease. It's less focused side about muscle, and a lot of insights are there about muscle and metabolic diseases. First I would like to call Dr. Kumaravel Velayudham to talk about the meat and muscle and its role in metabolic diseases.
Respected chairperson, co-speakers, senior doctors, and my dear friends, and many thanks to the debate organizers and Krishna sir for this opportunity. And the topic which I am going to discuss today is the meat about, basically it is about muscles and its role in a metabolic disease. So skeletal muscle is not just a motor for movement, but it is a pivotal metabolic organ that dictates whole body insulin sensitivity. So in this context, let's try to discuss, and the agenda of my talk would be, I would try to basically cover the metabolic functions of the skeletal muscles, the muscle metabolism, how is that muscle insulin resistance plays a pathogenic role in the metabolic complication, especially diabetes and dyslipidemia. We will try to discuss about myokines and various interventions which should improve the muscle metabolism, thereby which would help to reduce your metabolic complications, and a concluding remark. The core metabolic functions of a muscle includes, or it plays a very important role in glucose disposal. The primary site, so muscle is the primary site, it plays site for postprandial glucose uptake. We know there are various GLUT receptors, and GLUT4 receptor is a predominant receptor which is responsible for the glucose disposal. And muscle also has some role in glycogen synthesis. And lipid oxidation, muscle oxidizes fatty acids at rest and during prolonged exercise, and it is a key determinant of lipid flux. It plays an important role in lactate shuttle. It produces lactate during high intensity efforts. And muscle also plays an important role in endocrine signaling and it secretes myokines, it secretes interleukin-6, it secretes irisin, it secretes myosin, and they basically communicate with liver, adipose, and other brain organs. So 80% of the insulin-stimulated glucose disposal occurs in skeletal muscle, making it a critical for glycemic control. So these are core metabolic functions of the muscle, and the systemic effect or the clinical linkage to this metabolic disease includes, it plays an important role in glucose homeostasis. Your muscle insulin resistance is a primary defect in type 2 diabetes, and we know type 2 diabetes, insulin resistance is a key event, and as long as your beta cell functions are normal or your beta cell function is able to compensate for the degree of insulin resistance, you don't develop hyperglycemia. Probably you might have hyperinsulinemia but not hyperglycemia. And this muscle insulin resistance is a primary defect, and it often precedes hyperglycemia by decades. And it plays an important role in lipid partitioning, where it balances fatty acid uptake versus oxidation, and the imbalance leads to intramyocellular lipids, and this intramyocellular lipid accumulation and lipotoxicity plays an important role in various other metabolic complications. The organ crosstalk, the signal muscle secretes various substances which signal the liver to regulate VLDL secretion and gluconeogenesis. It modulates adipocyte lipolysis and thermogenesis. Low muscle mass, especially sarcopenia and sarcopenic obesity, exacerbates the cardiovascular disease risk and the metabolic syndrome severity. So these are the systemic impact or the clinical linkage to metabolic disease for the muscles. Now, it is very important for us to understand your normal muscle metabolism. So unless we understand the normal muscle metabolism, it is very difficult for us to understand how this muscle is responsible for various metabolic complications. So during feeding, what happens is you have a glucose which is secreted, and with the effect of the insulin, it acts on the IRS, that is insulin receptor substrate, which has a downstream signal PA3 kinase. Then it acts on your AKT and various substances, and ultimately it causes translocation for the GLUT4 receptors. And once when the GLUT4 receptors are translocated to the cell membrane, your glucose starts entering into the cell, and this glucose can undergo glycolysis for energy production, or it can be stored. What happens in exercise is that your glucose supply is less, so you are more on the insulin independent mechanism for your energy. So what happens is in exercise and fasting, you have AMP kinase upregulation, which again you have various downstream signals which are responsible for your lipid flux, which in turn gives you energy. So in feeding, your glucose forms a major energy source. In your fasting and your exercise source, your fat forms a major energy source. So the key control points, you have various control points in handling both these glucose and your lipid, is that you have a plasma non-esterified fatty acids which acts on acyl-CoA, which undergoes a beta oxidation and ultimate in the ATP production. So there's two sources of energy production for the muscle. One is your glucose, and another is a lipid flux. Now in this context, your lipid handling is very, very important, and the ectopic fat in your muscle has always been seen to be a detrimental. But the catch here is that what you call Satellite's paradox is that high intramyocellular thyroglobulin stores coupled with high oxidative capacity. So whenever your oxidative capacity is high, your lipid turnover is high, and most of your lipids are oxidized for fuel. So what determines your metabolic complication is that more than the intramyocellular triglyceride or intramuscular fat, what determines is your oxidative capacity. If your muscle has a very good oxidative capacity, it can burn all your substrate for your energy. And another thing is a lipotoxicity. High lipid supply exceeds a low oxidative capacity. Most of your muscle gets accumulated, and it's not only the muscle, it leads to DAG and ceramides, which interfere with your insulin signaling. So your mismatch between your oxidative stress and your intramyocellular triglyceride are the one which is responsible for various metabolic complications. And what you see the bar chart there is that the endurance athletes, basically they have lipid delivery or lipid storage is high, but in spite of that, their oxidative capacity is very, very high, so the toxic intermediates are low. On contrary, sedentary people or obese people, they have your lipid delivery or storage is high, but the oxidative stress or the oxidative capacity of muscle is low, which in turn leads to various intermediate toxic metabolites, which in turn plays a very important role in insulin resistance, plays a very important role in MAFLD and various other complications. So your clinical goal is to improve your mitochondrial oxidation rather than merely lowering your total lipid stores. So it is a mitochondrial oxidation which plays a very important role in preventing your metabolic complications. And again, this hormonal modulation of the muscle, it plays a differential role in females and males. For example, when you try to look at the baseline muscle phenotype in females, generally you have more and more of higher type 1 fibers are there. They have a generally greater oxidative capacity and they in turn improve your insulin sensitivity relative to your total mass. So they have an enhanced capacity for fat oxidation. So this is with the routine females. On contrary, males, they have a greater total mass, but when you try to compare the oxidative capacity to the female, they have higher peak power but lower fat oxidation capacity at the matched intensity when you compare to the females. When you try to look at lipid handling and oxidation, estrogen effects in females, they promote mitochondrial efficiency and lipid utilization. Substrate partitioning happens in males, where males have a greater tendency for greater visceral fat deposition, and this muscle lipid accumulation more strongly correlates with insulin resistance than in females. Life stage transition risk, menopause, we know there's a sharp decline in estrogen which leads to a rapid shift in increased visceral fat to the intramyocellular triglycerides or intramuscular fat. So this in turn leads to increased sensitivity and accelerated sarcopenia, so where you have a metabolic inflexibility at the onset. Andropause, what happens is there's a gradual decline in testosterone compared to the menopause. Lower testosterone is strongly associated with central obesity, low muscle mass and development of various metabolic syndrome. The clinical implication of your muscle and hormones in females is that your HRT may mitigate metabolic decline if started early. So there's a window of opportunity where your hormonal replacement therapy would be able to preserve your insulin sensitivity by its action through your muscle, and resistance training is critical to counteract sarcopenic obesity in a postmenopausal female. In males, testosterone replacement therapy in hypogonadal men can improve your insulin sensitivity and body composition, but lifestyle like weight loss or exercise forms the basic thing. So now, how does muscle insulin resistance contribute to your diabetes mellitus or various metabolic complications? For that, it is very important for us to understand how does the insulin signaling process happen. So you can see the diagram before. Insulin acts on insulin receptor in the cell, and once when the insulin binds to the insulin receptor downstream signaling, it can undergo various phosphorylation, and this acts on your IRS1 where tyrosine kinase gets activated, and tyrosine kinase phosphorylation activates the downstream signal. On contrary, when it phosphorylates your serine or a threonine enzyme, your downstream signal gets blocked. So it is very important for your phosphorylation of the tyrosine kinase, where your IRS1 gets activated, then your downstream signal PA3 kinase, then AKT. Once when your AKT is activated, your GLUT4 receptor from cytoplasm gets translocated to the cell membrane. Unless you have a GLUT4 receptor which is coming to a cell membrane, your glucose cannot enter into your muscle. So that is how your insulin binding to your insulin receptor helps in your glucose entering into your muscle. Now what happens in your muscle insulin resistance? First and foremost, instead of tyrosine kinase phosphorylation, there is a serine phosphorylation in your IRS1 receptor. So this sends the inhibitory phosphorylation, so your downstream signaling is reduced. Next, you have a blunted PA3 kinase or AKT axis, then you have a impaired GLUT4 trafficking, and you also have a microvascular dysfunction in muscle where your insulin fails to recruit more and more of muscle capillaries, reducing the substrate delivery surface area, so it can also cause a hemodynamic resistance. So your muscle insulin resistance is an early defect that precedes hyperglycemia in type 2 diabetes at least by 5 to 10 years. Not only with this core concept, there are various other upstream signal drivers which also drives your muscle to become insulin resistant. One is a lipotoxicity, as I said. When your muscles oxidative capacity is less compared to the nutrient delivery, there is more and more of toxic metabolites which are getting accumulated. One is the DAGs and ceramides. This accumulation of lipid intermediate activates directly other serine residue phosphorylation, whereby it can aggravate your insulin resistance. Other inflammatory signaling activation like JNK and other TNF-alpha also can aggravate insulin resistance. And reactive oxygen species production and unfolded protein response, they basically worsen your mitochondrial endoplasmic reticulum function by increasing the stress. And physical inactivity causes rapid downregulation of insulin signaling proteins, and it is a first break before obesity sets in. The genetics and epigenetics behind this muscle insulin resistance, we have various genetic components, but what I would try to highlight here is more than genetic component, it is the environmental epigenetic influence which has a major impact in your muscle insulin resistance. So it could be inactivity, which could be high fat diet or various forms. So epigenetic is nothing but many times you may not be able to change your genes, but your epigenetic mechanism can either switch on your gene or switch off your gene. So how does it happen? It basically happens through a DNA methylation or histone acetylation or microRNAs. These are the three epigenetic modifications by which you can alter the expression of your gene. You may not be able to alter your gene, but your gene expression could be altered, whereby your GLUT4 trafficking proteins could be reduced, your mitochondrial genes could be altered, and ultimately this can lead to insulin resistance phenotype where there's impaired glucose uptake and metabolic flexibility. So these epigenetic markers are not permanent, and exercise can remodel your DNA methylation patterns in skeletal muscle within a week. That's the reason exercise plays an important role, and this maternal overnutrition can program offspring muscle metabolism via this epigenetic pathway. So exercising in mother is also very, very important for your healthy baby. And again, this mechanism of your muscle response is totally different in your acute exercise response and your chronic metabolic inflammation. For example, acute exercise response, your muscles secrete more and more of interleukin-6, but they do not secrete much and much of TNF-alpha. So this has an anti-inflammatory effect. On contrary, in chronic metabolic inflammation, there's an increase in TNF-alpha along with interleukin-6, where it causes a pro-inflammatory effect. Oxidative signals, the muscle in acute exercise, there's an adaptive signal for the oxidation, but in chronic metabolic inflammation, there's a sustained oxidative stress which basically destroys your defense mechanism or damages your protein, and it causes mitochondrial and endoplasmic reticulum dysfunction. Acute exercise response improves your insulin sensitivity by secreting or recruiting more and more of GLUT4 receptors. Chronic metabolic inflammation causes a desensitizing effect. And more importantly, muscle communicates with various other organs, what you call as organ crosstalk by the muscle and various organs by the effect of myokines. So muscle secretes various substances, what you can see from FCF21, interleukin-6, myostatin, irisin and VEGF. The two important thing which is secreted by muscle is myostatin, which is called as a muscle brake. More your myostatin, you may not develop more and more of muscle. One reason for sarcopenic obesity is as you age, your myostatin increases, so whereby your muscle mass building would be difficult. So nowadays we have various myostatin inhibitor drugs which are on trial to improve your muscle mass. If you have a congenital genetic mutation in your myostatin receptor, normally you are born like a Hercules baby. So you have more and more of muscle mass. Irisin again is a very positive hormone which is secreted during exercise, which has a various beneficial effect. So by this various myokines, muscle interacts with your pancreas and your immune system to increase your insulin secretion and decrease your chronic inflammation. It interacts with your liver to decrease your gluconeogenesis and liver steatosis. It interacts with the adipose tissue to cause lipolysis, and it is very, very important for beiging or to make your white adipose tissue to brown or beiging adipose tissue is predominantly due to irisin, which is secreted during your exercise. And it also interacts with your vasculature to increase your nitrous oxide bioavailability, and it improves your nutrient delivery. So muscle liver interface in NASH, basically the clinical evidence when you look at it, sarcopenia predicts the severity, low skeletal muscle and strength are independent predictors for NAFLD or NASH. when you try to compare exercise and weight loss, structured exercise reduces intrahepatic triglycerides even in absence of significant weight loss. So when you do exercise, it's not necessary you have to lose weight for your metabolic benefit. Even a minimal loss of your intrahepatic triglyceride can have a beneficial effect. And sarcopenic obesity confers the highest risk for adverse hepatic outcomes and metabolic mortality. So more than obesity, obesity coupled with sarcopenia has a very important effect. So this muscle-liver axis is a bidirectional way where treating muscle insulin resistance can also help to prevent or happen as a therapy for NAFLD. So this is a very important slide where you try to look at your sarcopenic obesity and aging. What you can see is a graph where your peak muscle mass comes down and your intramuscular fat liposity increases. So the only catch here is that resistance training can definitely improve your muscle mass, and it can also improve your positive myokines which is secreted by your muscles. And how do you assess sarcopenia? The easiest test is a chair raise test where you can do in your OP itself. So in a given chair, if you are able to fold your arm over the chest, if you are able to sit and get up in the chair 5 times within 10 seconds, you have a very good physical endurance. Your muscle mass is very good. If suppose more than 50 seconds, it takes time for you to have 5 repetitions of sitting and standing, which means you have some kind of sarcopenia or physical inability. Again, you can look at gait speed, you can look at grip strength, and you can look at body composition, various other things could be seen. But primary intervention which improves your sarcopenia is your resistance training, protein dosing, and active living, which means you reduce your sedentary time, simple steps which preserve your insulin sensitivity. You have various other ways to improve your muscle endurances. One, you have muscle sensitivity improving by endurance exercises where 150 to 300 minutes per week at a moderate intensity or steady state. We can go for high intensity intermediate training where you have 4 to 10 bouts of at least 80 to 100% of VO2 max short duration exercises. We can undergo resistance exercise also. But what is important is the frequency matters. Acute exercise enhances insulin sensitivity for at least 1 to 2 days. Various pharmacological interventions and nutritional application, energy deficit and ectopic fat can be reduced by calorie restriction. Protein targets could be reduced by adequate protein. Carbohydrate quality, fat, inflammation, and nutrient training is very important. Pharmacological interventions like metformin improves your hepatic output, thiazolidinediones helps in lipid partitioning in your muscle, GLP-1 receptor agonist helps in weight loss and improves your functioning, SGLT2 inhibitors helps in substrate shifting from your carbs to your ketones. So myostatin inhibitor are emerging drugs to improve your muscle function. So just a final stage, key takeaways. Muscle is a metabolic gatekeeper. Skeletal muscle is the principal regulator of postprandial glucose and gatekeeper for lipid flux. It forms a root cause in muscle insulin resistance, which arises from lipid intermediates, inflammation, mitochondrial vascular defects. It has a crosstalk with signaling with various myokines, potent therapy like exercises, and holistic approach always combine training with nutrition and pharmacotherapy when appropriate. Prioritize muscle mass and function strategies to prevent and treat type 2 diabetes, NAFLD, and cardiometabolic shift, and always shift your focus from weight loss alone to metabolic quality. And thank you so much.
Thank you, Dr. Kumarvel sir. And we will have the discussion at the end of the session. Please come and sit up. And we have had very excellent talk, and it supports our concept of lifestyle modification, particularly exercise and other things, and supplements with a lot of scientific inputs on that. For next talk about protein and muscle myth and evidences, I would like to call Dr. Anand Kumar Annamalai.
So good afternoon. Thank you very much for inviting me. I'm very grateful to Krishna sir for actually giving me this very challenging topic. So proteins and muscle, specifically with relevance to its myths and evidence. So no conflicts of interest for this talk. So why all the fuss? What about protein and muscle? So Dr. Kumarvel was just talking to us about the skeletal muscle and the plasticity. So as bone, muscle has a constant turnover, and there's a remodeling of muscle proteins. So if you look at it in a very basic way, you have a muscle protein synthesis, or MPS, and a muscle protein breakdown, as you have in the bone. Now, MPS actually occurs at a very fast rate in the early stages of life, and it actually slows down significantly after the age of 20. It's not like bone. For someone who's active and who's healthy, you would expect that the turnover of muscle is approximately 1.2% per day, and this exhibits a dynamic equilibrium in between the muscle protein synthesis and the muscle protein breakdown. So as we looked at the mechanistics with what Dr. Kumaravel said, you have a lot of combination factors which actually regulates this. You have obviously genetics, but it's important to understand that resistance exercise, diet, and also nutritional supplementation would actually induce the muscle protein synthesis and also regulate the muscle protein breakdown. So if you look at the protein intake, you have 20 amino acids, out of which 11 are essential. So that means we need to eat it, so we need to consume it. That gets degraded in terms of the gut, and then it enters the circulation. And after the circulation, the liver extracts the majority of it. So liver is very hungry for these proteins. And it releases only 30% for it to go into the muscle. And by doing so, you have the regulation of the muscle protein synthesis, and then you have the muscle protein breakdown. If you look at it at a cellular level, so you have these amino acids, and very specifically these branch chain amino acids, specifically the valine, isoleucine, and leucine, and amongst this leucine being very, very critical in terms of augmenting muscle protein synthesis and actually preventing muscle protein breakdown. So you would need this essentially for basically the contractile proteins to actually exhibit an improvement and actually in terms of structure, and also prevent the breakdown. So in someone who's fasting, in a fasted state, the muscle protein breakdown is actually greater than the muscle protein synthesis. And the muscle is in a catabolic stage of negative net protein balance. However, if you would exercise, and specifically if you were to have an endurance or a resistance training, and compounded this with a net protein intake, you would actually increase the muscle protein synthesis. And also, you would inhibit the muscle protein breakdown, and actually this would lead to a positive net protein balance. So you could manipulate this by, timing, the dose regulation of the protein, and also in terms of what kind of physical activity you would do to actually, regulate the anabolic response. So as we mentioned, it's important to understand that the muscle protein synthesis actually augments, and it's pretty early in life. And generally, if you were to look at the muscle protein synthesis, you would require approximately 20 to 25 grams of high-quality protein to induce it from a protein point of view. And this particularly, if this is around a period of exercise, and particularly resistance exercise, this is augmented. And it's important to know that muscles are actually sensitized to the ingestion of protein around the period of actually, some form of exercise. So it is not pre, post, or during, or basically immediately. We'll talk about those myths later. But it's important to understand if you were to exercise, that would augment the response to the protein intake, and that would actually augment the muscle protein synthesis, and thereby also prevent the muscle protein breakdown. So the total protein intake is rather important rather than the exact time at which the protein is consumed. And this surrounds the period of exercise, and this has the greatest impact on protein synthesis. So if you were to look at this graph, this would tell you the muscle protein synthesis, and as you can see, the muscle protein synthesis is lowest basically when you're doing nothing, when you're idle. And that means it's important that you need to be active. Now, if you were active, that would increase the muscle protein synthesis. And if this was increased and augmented with appropriate high-quality protein, you would actually augment this further. So the balance between muscle protein synthesis and actually muscle protein breakdown, so if you have protein, and if you actually have exercise, specifically resistance exercise, if you were to increase your high-quality protein daily, and also if you were to evenly distribute it across the meals, and that's important, the distribution across the meals, and protein even prior to sleep, and particularly if you were to focus on amino acids like leucine, a leucine-rich diet, that would actually increase it. And Kumaravel was just talking to us about insulin, and the insulin in terms of regulation of this, in terms of muscle protein breakdown, that would actually slow down the muscle protein breakdown if it's the appropriate insulin. So sarcopenia, so we talk about osteopenia and osteoporosis. It basically is present in actually 27% of adults over the age of 60 years. And muscle mass loss is 0.4 to 0.5 after 60, and it accelerates close to 1% after 75. And the muscle strength loss at 60 is close to 3 to 4%, and this basically augments it further greater than 75. So it is known that adults with low muscle mass and strength tend to consume less protein compared with people with a normal muscle status. So if you were to treat sarcopenia, it's important that we have an adequate dietary protein. And when we say adequate, that includes 1 to 1.5 grams per kilogram of body weight per day. And this must be protein rich, and this must be compounded with resistance training. So if you were to look at, what is basically an important aspect of protein which is required for, good muscle mass, evidence states the range ranges between 1.4 to 2 gram protein per kilogram body weight per day. If you were to look at the RDAs based on the various guidelines, general healthy, it's not restrictive at 0.8, you could go up to 1 to 1.2. And if you were to look at physically active, this has to increase to 1.4 to 2. Athletes would go up further. And particularly with metabolic dysfunction, with obesity and type 2, the recommendation is 1.6 to 2 grams per kilogram per day. And again, if you're vegan or vegetarian, this would actually increase. In menopause and perimenopause, again, the requirement is high. And with pregnancy too, depending on the trimester, this actually increases. So if you were to look at, would you keep increasing the protein? Would you actually increase the muscle protein synthesis? The answer is no. You would not actually augment it further than 2.2 grams per kilogram per day. So the key takeaway from that part of the talk is it is important to understand that the muscle protein synthesis has to be augmented. And this has to be augmented, as I mentioned, with resistance training and appropriate protein intake. And a daily protein intake of approximately 1.6 gram per kilogram per day is what you would call as appropriate. And you could actually go up further, but beyond 2.2 gram per kilogram per protein per day would not help maximum muscle. So, where would you get all of this in terms of evidence? This is from the BMJ, which looks at a meta-analysis and a systematic review, looking at why this particular, figure came through. Now, what it showed was a dietary supplementation of approximately 1.6 gram per kilogram per day basically is what you would get in terms of maximal gains, and that is why actually the guidelines actually recommend that particular level. There are a lot of misconceptions, wrong questions, and basically there's a lot of things which are wrong, which is available on the internet. And if we were to look at science as to answer certain common questions, these were basically the international guidelines called by the International Society of Sports Nutrition and the position stand on protein and exercise and muscle. So myth number 1, high protein diets can damage your kidneys. This is a common aspect. The simple answer, evidence is no. Increased protein consumption is said to increase glomerular filtration and actually hyperfiltration. But basically, scientific studies actually show that it doesn't happen. In CKD, a red meat consumption over years may increase this risk, whereas white meat consumption and dairy proteins actually do not, and fruit and vegetable proteins may actually be protective. And if you look at Institute of Medicine and the World Health Organization, if you look at guidelines from basically various societies, there's no renal adverse outcome with high protein diets in someone who basically is healthy. People have looked at very high diets, even up to 3.2 to 4.4 grams per kilogram per day, and they've looked at even up to 2 years, and they found that this basically was not there. And even in metabolic dysfunction, especially with people with type 2 diabetes, dyslipidemia, and obesity, higher protein diets actually promote fat loss without kidney damage. So if you were to summarize from that myth, in summary, individuals engaged in exercise training and who are otherwise healthy can consume protein up to 4 to 5 times the RDA without experiencing adverse effects. And remember, these are normal individuals. Then the question comes about animal and plant protein. There's a common misconception saying that vegetarians would not augment muscle with what they're eating. Now, when you look at protein sources, this is soy, tofu, and legumes. It's important to understand we were talking about essential amino acids, branched-chain amino acids, specifically leucine, and this is particularly low in vegetarian diet. So do we have evidence that vegans and vegetarians cannot consume enough protein compared to animal protein? The evidence says no. Studies actually indicate that basically they need to consume 20 to 40% more plant protein than animal-based protein to actually account for that loss which they're losing without taking, meat. And plant proteins, whatever you're taking, you need a minimum of 6 grams of essential amino acids and 2 grams of leucine. And that's the requirement. And the requirement goes to 1.4 to 2 grams per kilogram per day in terms of protein. And if you look at whey protein, you look at soy protein, you look at rice protein, you can see the content of essential amino acids and leucine. It is pretty high. So actually, it is actually a fallacy that, it's only non-vegetarians who actually can build muscle. And the scientific evidence says that vegans can build muscle when optimized. So it's important to understand that they will need to optimize it and also, again, go with the training or, the exercising, which we're talking about. And this is with soy versus wheat or rice, habitual vegans. Everyone have shown that basically there's no much difference. If you were to compare, what would be ideal, and this is just comparison between animal and plant proteins. As you can see, for example, 100 grams of a chicken breast would equate to 32 grams of protein, whereas a lentil, 100 grams, would equate to 8 to 9 grams. It looks pretty poor, but however, if you were to increase this consumption, and if you were to target 20 to 40 grams per meal, per meal per day, that would actually, give you that amount of protein that you would recover for what you're losing from not taking animal protein. Now you look at skim or low-fat milk, you get 8 to 9 grams protein. You look at Greek yogurt, our grandma is saying take milk and yogurt at night. Basically it says high leucine, it's very helpful post-exercise and at night. So there's some scientific evidence behind it. And remember, as I said, 20 to 40 grams per protein per meal. And specifically looking at dals, looking at basically, tofu, you can see tofu basically 100 grams gives 10 to 11 grams. So approximately 10% of that basically comes in terms of protein from a vegetarian meal. So if you look at evidence again, this is plant versus animals. Again, this was basically from nutrition reviews, looking at the meta-analyses. The conclusion was there is little evidence for protein source playing a role in the muscle health of individuals and specifically elderly individuals. The trends initially, if you look at it from a superficial point of view, it looks like it favors animal protein. However, if you look at studies with soy protein, you can see basically that vegetarians do pretty well. Myth number 3. Excess protein intake causes increased fat mass. The evidence is no. In exercise-trained individuals, high protein intake either has a neutral effect or promotes fat loss. And this is particularly so as basically proteins increase energy expenditure, lean body mass, and satiety. And protein do not increase body fat mass. So evidence clearly says no. Under caloric restriction, if you're hypercaloric, problem a lot of people say is, you lose a lot of muscle. High protein attenuates lean mass and increases fat loss. During caloric excess, if you're taking a lot of protein, a higher protein would promote a greater lean mass versus fat mass gains. And higher protein correlates with decreased consumption of refined grains and sugary foods, which actually is obesogenic. So clearly there is evidence. Myth number 4, high protein harms bone health. Again, the evidence is no. The acid-ash hypothesis saying that basically high protein would increase the urinary calcium is not supported because basically high protein diets increase calcium absorption from the food. And it's important to understand, like, bone has 50% protein by weight and 33% by mass, and adequate protein is critical for the muscle-bone axis, in fact, what Kumaril was talking about. And meta-analyses said that a higher protein intake is associated with a higher bone mineral density and a reduced risk in terms of hip fracture. The other question is high protein or protein is important for muscles only for basically, people who are training and not for people who are sedentary or regular people. The answer again is no. The current RDA of 0.8 is actually very, very insufficient. You need at least 1.6 to 2 if you're an endurance athlete. You look at protein, it matters not just for muscle, we've talked about, it's for bone, it's for immune health, it's satiety, it's thermogenesis, it's glycemic regulation, it's cell signaling, enzymatic factions, and there are at least 50,000 proteins in the human body. So clearly it's important. So special population, older adults have something called as anabolic resistance. So they have a blunted response to dietary protein. So it's important that they consume more to have good amount of muscle. If you go to a gym, they will talk to you about taking a protein meal after an activity. They'd say take it after an hour. So is timing critical, 1 hour post-exercise? The answer is no. The total daily protein intake is what matters. Protein consumed 1 to 3 hours after exercise or even 24 hours remains anabolic. From my initial slides, the muscle basically is very sensitive to proteins around the period of exercise for 24 to 48 hours. So it's important that we actually take the protein and not really time it. It doesn't really have evidence. So adequate total protein would mean 1.4 to 2 grams per kilogram per day if you're training, and this distributed throughout the day combined with resistance training is very important. So this anabolic window basically has no evidence. The question about pre-exercise protein or post-exercise protein doesn't exist. Pre-exercise protein is equally effective based on studies, and as I mentioned, even 24 to 27 hours after an exercise, it actually has a lot of evidence. And there's a lot of science behind this, and this basically is based on isotope studies stating that actually it is pretty much effective. So the post-resistance training, you can see that the myofibrillar protein synthesis basically is accelerated and augmented throughout, whether you're doing resistance training or an endurance training. And the timing doesn't really matter. So the high protein diet basically enhances muscle performance, and this is not particularly related to any particular time. And if you were to look at performance here, these are skeletal muscle masses, the leg presses, the chest presses, and the inverted row physical activities. Whatever you do, basically, you take it, that's important, it's enough. A very important question which a lot of patients ask is, are protein powders ideal to meet daily requirements? The evidence is no. You get it basically from your whole foods protein sources, whether it's animal like chicken, fish, milk, or eggs, or basically we're talking about vegetarian. So, however, certain protein powders could be convenient, but the problem in our country is this is not regulated, and we have true protein powders. It's a lot of carbohydrate with a little bit of protein. So you could choose it as a combination, but basically if you were to take it naturally, that would be the best. So if you were basically looking at per meal, protein per meal is not significant, is that the question? So it's important to understand that if you take at least 20 grams of protein per meal, and if that basically is high protein, that would stimulate the muscle protein synthesis. If you're training, you need to go to 20 to 40 grams. If you are under metabolic stress, let's say you have fever, let's say you basically are dehydrated, let's say you have some form of catabolism post-surgery, the protein content has to go up 40 to 100 grams for a proper anabolic effect. And what do you have an upper limit? You could go even up to 100 grams during a particular meal. So if it's an exercise, you need more stimulus. That means, you go more than the recommended 20 grams per meal, you go up to 40 grams. If it's a metabolic stress stage, again, greater stress, you have basically a caloric deficit, and greater than 40 grams is beneficial. And again, if you were to look at what kind of protein, you use good protein quality. So if you're using, plant-based or whey, it's very fast. It basically has high essential amino acids and high leucine. So if I were to look at all these questions and put up a summary slide, this is the summary slide and takeaway for all of you. So I asked a lot of myth questions, and I gave you some scientific answers. Question number 1, is there any harm to the kidney? No. There's no evidence in terms of healthy individuals, and you could go up to 4 to 5 times the RDA. What about fat gain? No, this relates to the excess carbs in the meal and not the protein. And so you could go with the 1.4 to 2 gram per kilogram per day for for an active person. Bone health, this is actually beneficial. Remember, the mass of the bone is determined by the protein, and higher protein would protect and actually also prevent fractures. Vegan, vegetarian, is it a problem? No, you need not convert yourself to non-vegetarian. It's important that you have a strategic planning and you actually augment your protein content with a high quality content. So meat safety, yes, it's an important thing. I didn't cover it because of lack of time. It's important that, processed meat is a problem. Unprocessed is safe. Sedentary, it's important that it's very essential that you increase the protein. Timing is not critical. The total daily count is important. Endurance athletes, we spoke about the higher content. Do you need a protein powder? Not really. And do you have a pre-ceiling limit? It's got 100 grams, it's fine. So to conclude, protein is essential for all healthy adults, not just athletes. An adequate intake between 1 to 2 grams per kilogram per day prevents age-related muscle mass and supports metabolic health. High intakes are safe, and the RDA of 0.8 is not really, it's very insufficient. Total daily intake matters more than timing. Distribute throughout the day for convenience. The quality matters. Prioritize high-quality animal protein or high-quality plant protein with adequate essential amino acids and leucine. And individual factors guide dosing, especially age, metabolic status, training stimulus, metabolic stress, etc. For your endocrine practice, or specifically if you're looking at just your medical practice, adequate protein improves insulin sensitivity, supports metabolic adaptation during weight loss, and improves body composition. So I thank you for that, and close there.
Thank you so much, Dr. Anand Kumar. Please take your seat. A lot of insightful messages we got, and the science is always about learn, unlearn and relearn. We'll relearn many things about protein, amount of protein to be taken per day. Thank you so much for that. And for the next talk, I'd like to call Preserving Muscle Mass While Losing Fat, a primer. To talk about that, I call Dr. Beatrice Hani to the stage.
A very good morning to all. Thank you, Krishna sir, for the invitation and the hospitality. So my talk is going to be a summary of what you have heard in the last two talks, except that I'm going to be scaring you a little bit more about incretin-based therapies, and my slides are going to be a little more colorful because everybody was talking about AI, so I thought I'll introduce some AI into my slides as well. So let me start with definitions of body composition terms. So when we look at body mass, this is going to be fat mass and fat-free mass. And fat-free mass, again, includes lean soft tissue and the bone mineral. And our focus is on the lean soft tissue. The lean soft tissue includes the muscle and the organs as well. So the muscle is going to take up about 50% of the lean soft tissue, and our target of interest is going to be this lean soft tissue. So what is the problem with rapid weight loss? Because clinical trials have shown that while the total weight drops, there is a massive proportion of muscle mass that is lost. So we have alarming stats from the global trials. The lean mass here loss in step 1 trial with semaglutide has shown almost a 40% reduction in the lean mass. The total weight loss was about 17.3 kgs. And this is about almost all of the other trials have shown a minimum of about 10% loss in the muscle mass when we lose weight. And if you look at the step 1, there's about a 6.92 kgs weight loss in lean mass. And the surmount one, again, a 10.9% of total lean mass which has been lost. And this is with the fact that an estimated 15.9% of the US adult population with obesity and has a low muscle mass. And if you look at it, we lose muscle about 3 to 5% in 10 years. So taking that calculation, we are losing about 10% of lean mass or muscle mass when we start somebody on a weight loss drug, which means that 1 year on the drug is equal to 20 years of aging. So when we start therapy, keep this in mind. So is it only with the drugs? No. With the bariatric surgery, you have again about 20 to 70% weight loss, and the lean mass lost is about 18 to 44%. And it's not only the muscle that you're worried about. Look at the fracture risk. It's also the bone which is getting affected. It's about a 3 times increase in the fracture risk. And if you look at semaglutide, again about 16% weight loss, about 13% is lean mass loss, and there is also a decreased BMD. We do not have fracture data here. Tirzepatide, again about 21% weight loss, and a lean mass loss about 25%, and we do not have data on fracture risk or BMD with tirzepatide. So it is not only the bone, not only the muscle. While the metabolic health improves, energy restriction is going to accelerate the musculoskeletal decline if we do not have proper interventions. So it is not only with weight loss drugs, with bariatric surgery, even energy restriction. Even a simple diet can lead to about 10 to 58% of weight loss can be fat-free mass, that is muscle. And if you look at the BMD loss, it's about 2% for every 10% reduction in the body weight. And what are the mechanisms here? There is going to be a reduction in the mechanical loading. So when you lose weight, there is going to be a reduction in the mechanical loading on the bone, especially the weight-bearing areas. And there is going to be a reduction in the bone mass as well. So there is also going to be metabolic adaptations when we have muscle depletion. So there is going to be a reduced basal metabolic rate due to a lower muscle mass, and the body tries to conserve energy. There's going to be improved muscle efficiency, and it reduces the energy expenditure, which again makes it difficult for us to maintain the weight loss. And when the patient is on let's say a nutritional deficit or on drugs which can cause a loss of appetite, nutritional deficiency, there's going to be inadequate protein intake again to support the synthesis of muscle fibers, and it is also associated with micronutrient deficiencies. So these are the 4 key drivers why muscle fades. So the calorie restriction, so the appetite suppression is going to trigger the muscle catabolism to meet energy needs. There are going to be nutritional deficits, both macro as well as micro, and there are going to be metabolic shifts. And the other important and very interesting phenomenon is this myosteatosis, which is basically deposition of fat in the muscle, in between the muscle fibers. So intramuscular as well as intermuscular fat. So if you take a deeper dive, look at the metabolic consequences, loss of muscle is just not a cosmetic issue. It is also going to affect our physiology and recovery. So what happens when we lose muscle mass? Remember that muscle is metabolically more active than adipose tissue. So when you lose muscle mass, there is going to be a reduction in the BMR, a reduction in the resting energy expenditure, which makes it difficult for us to maintain the weight loss. And when we regain, so somebody has lost weight and has regained weight, there is more regain of fat and less of muscle. So this weight cycling, again, is going to be harmful because we have somebody to start with obesity, and then because of this repeated weight cycling, where there's every time there is a weight loss and weight gain, and there is going to be more of fat addition rather than muscle, this again is going to be detrimental. And functional strength also comes down. And myostatosis is not benign. So this is a mortality predictor. It's about a 50% increased mortality risk with a high intramuscular adipose tissue independent of the hand grip strength. So if you're going to add low muscle volume to it, it's about 2 times increased mortality. If you're also going to add a poor function to it, there's going to be a 6 times increase in the mortality. So an ideal obesity treatment strategy with incretin mimetic drugs, it is not only about reducing obesity, it is not about reducing obesity-related complications, but remember this, preserve the muscle mass, either with nutritional therapy and education plus physical activity. So when we start with an incretin mimetic therapy, let's say semaglutide or tirzepatide for weight reduction, you also need to remember nutritional therapy, resistance training, and continuous monitoring. All of this has to be done together. Otherwise, this is like a poorly arranged Jenga. You remove one block, everything comes tumbling down. So you start with protein intake. Already the previous speaker has highlighted about the importance of protein intake. It starts with about 1.2 to 1.6 gram per kg per day to attenuate the lean muscle mass. Meal distribution, about 20 to 30 grams of protein per meal, and consume it about 3 to 4 times per day. And don't forget the bone, because vitamin D and calcium also have to be supplemented to meet the guidelines. So the target protein intake, it may be a little difficult to start off with 1.5 or 2 grams. Start with at least 1 gram per kg of adjusted body weight. So how do you calculate the protein intake? So the Jocelyn Diabetes Center guidelines gives us the ideal versus excess body weight calculations for protein intake. So you take 1 to 1.5 grams or per kg of the ideal body weight plus 0.25 into the excess body weight. So this will give you an approximate number, the number of grams of proteins per day that has to be taken. And especially concentrate on good quality proteins, especially containing leucine, because that is very important. At least 2 to 3 grams of leucine is important for muscle metabolism. So this is not a one-size-fits-all rule, because we have to look specifically for older adults as well. So in patients over 65, when they have a BMI of about 25 to 30, weight loss is not recommended. Rather look for maintenance and metabolic improvements. The BMI is more than 30, you can give a maximum calorie deficit about 500, and very low calorie diets like less than 1,200 kilocalories per day or less than 800 kilocalories per day. So these are not recommended for older adults. And older adults also require more proteins. This is because the anabolic effect of proteins on the muscle comes down when we age. And even the anti-catabolic effect of insulin is also going to come down when we age. And that is the reason why we need higher protein intake for elderly. So exercise is the cornerstone of preservation of muscle mass. It has to be function and balance. You look at aerobic activity as well as resistance training. So how do you give an exercise prescription to somebody who you have started on a weight loss drug? So start with resistance training. This is muscle strengthening activities on 2 or more days per week, and focus on the major muscle groups, that is the legs, the hips, the back and the chest, and add on the aerobic conditioning. So to lose weight, you have about 200 minutes of moderate intensity exercise weekly. But to maintain that weight loss, you need a higher value, about 300 minutes of moderate intensity exercise weekly. So this is to improve the lipid and the glucose metabolism. So it is resistance training first, and then the aerobic maintenance also has to be started. So this is the therapeutic synergy that you see when you combine both. So how do you give a resistance training prescription guide? Start with at least 2 weekly sessions, improve to 3, 4, increase the number of sessions. And we have something called as the rating of perceived exertion. So this is just to tell you how tired the patient is going to feel after a session. So there are different scoring systems for this. We start with the least score, that is 4, and slowly increase the intensity so that the patient can reach up to a score of 8 or even more, and increase the number of sets. So you start with, let's say you're going to take a 1 kg weight and do the exercises. So you start with about 10 repetitions, and then you start with 2 sets, and then increase it. Make it 3 sets, and the number of repetitions goes up to 15. So you keep increasing like this, and the kg also should go up. So it is from 1, 1.5, 2.5, 5 kg. So you can keep increasing like this. So this is important because systematic increases in stress are required to induce this training adaptation. So you increase the frequency of resistance training and increase the complexity again. Start from single joint to multi-joint compound exercises, and the number of sets can be increased, the number of repetitions can be increased, and increase the load as well. So from 1 to 1.5 to 2.5 kgs and so on. Now let's say you want to combine it with somebody who's on a intermittent fast. So somebody is on a 5:2 fast, so 2 days they're going to take very low calories and 5 days of normal diet. So the 2 days you give them the balance exercises so that you don't exert too much. On the 5 days where the patient is eating well, give them the resistance and the aerobic training. So this is going to be a multimodal clinical workflow. So you start with the pre-therapy screening. So when we give an incretin-based therapy, it is just not giving a prescription and sending the patient away. We have to do a pre-therapy screening, assess the muscle mass and function, which again has been described so well by Dr. Kumaravel sir. And then after that, you introduce the dietitian also, get the dietitian into the picture and assess how much protein the patient is taking and increase the protein intake. And exercise prescription, like mentioned, start with resistance training, add the aerobic, either brisk walking, jogging, cycling, swimming, that also has to be added. And most important is serial monitoring. So we need to see whether this particular patient is responding or not, whether there is an increase in the muscle mass and a decrease in the fat mass. Apart from this, we also do have pharmacological agents for muscle preservation, which are in studies right now. So again, this was already discussed, the myostatin activin axis. So the myostatin activin, simple terms, they are going to down-regulate the skeletal growth. So these are actually negative for the muscle growth. So we need to go and block this axis. So there is bimagrumab, which is an activin type 2 receptor blocker. So this is basically both myostatin and activin will act through the activin type 2 receptors. So this receptor is blocked by this antibody, that is bimagrumab. And then we can also inhibit the pathways. Either you directly block the myostatin or directly block the activin. And this leads to protein accrual. There is going to be muscle preservation when you add these drugs. So we look at this, bimagrumab is the activin type 2 receptor blocker. Then we have trevogrumab, which is a myostatin inhibitor. And then we have a garetosmab, which is an activin inhibitor. So all of these have shown in earlier studies that the lean soft tissue loss is attenuated by about 60 to 80% with bimagrumab and 42 to the tune of 40 to 70% in the other compounds. So here we are trying to lose more of the fat and less of the muscle when we add these drugs. But we do have certain knowledge gaps. So what are the functional and metabolic outcomes of adding these drugs to the existing weight loss therapies, and how long do we give? And what are the kind of population we have to select for this. And apart from looking at the myostatin pathways, we can also look at non-myostatin pathways. So you can look at selective androgen receptor modulators like enobosarm, which is basically, it has the effect of androgen but does not have the side effects of testosterone. And we have multi-agonists. So agonists which also act on the glucagon receptors, they show a little less lean mass loss. So we can add agents like pemvidutide, which again basically in studies. So this also can maintain a favorable LST loss ratio. And we have selective inhibitors of these myostatin pathway as well. So we can see in the clinical trials so far that these agents have given up to a 69% reduction in the muscle mass loss. But these agents are not without side effects. The major one is muscle spasm, But we do have a lot of discontinuation rates because of this, and there's also some signal regarding liver safety liver safety concerns. So even if these drugs are studied, if they come into the market, is it for everybody? No. We'll have to look at specific patient population who would benefit from this combination therapy. So the demographic factors like age more than 60 years, and if they have age-related sarcopenia, where they're going to be resistant to muscle building. So those are the kind of patient who would benefit from these kind of drugs, and patients with pre-existing type 2 diabetes, again with sarcopenia. And there could be patients with who are not able to perform resistance exercise, and patients with severe sarcopenic obesity. So to summarize everything, weight loss is not equal to fat loss unless muscle is actively protected. And adequate protein here is non-negotiable. A target of about 1.2 to 1.6 gram per kg per day is required, and especially leucine-rich sources. And resistance training is the most effective anti-sarcopenia drug. So start with 2 times, increase it to 3 times, and go more if required. And monitor the body composition. Probably now we all have access to the bioelectrical impedance machines. So that again can tell us how much muscle is gained and how much fat is lost, because when we start resistance training, aerobic exercises, sometimes the weight remains the same, but there is a change in the body composition. So this is also reassuring for the patient when we do this kind of monitoring. Probably not a DEXA in every sitting, but at least a bioelectrical impedance, at least to see how the patient is progressing. And individualized obesity treatment, because it is not the same for every age group, especially in older adults and high-risk groups, we need to concentrate a little more, and there should be a change in the way we treat these kind of patients as well. So thank you all for patient listening.
Thank you so much, Dr. Debate-2026. Excellent talk about all these things. And to start with, Velayudham sir told about the importance of keep your muscles active and how much protein he has to supplement, Anand Kumar sir, and how you are going to keep your muscles fit and exercise, all those things. I used to tell my patients 30-20-10 formula. 30 minutes of walking, 20 minutes of strengthening exercise every day, and 10 minutes of breathing exercise and meditation. So let us start with this, and we have to follow the instruction given by our honorable speakers. And most of the time our patients will not listen to us. They need always something. Or chart kudunga sir. Powder sir. They will not go for animal protein or plant protein. Sir, protein powder sir. And we have to protect them from the protein powders with unauthorized fortification of anabolic steroids. That is a cause for all this sudden cardiac death in the gyms and all. So it is our duty to sit with the patient and explain what is animal protein, what is plant protein, how much you have to take. The counseling time is very much important, but the mounting pressure outside the consultation room, most of the time, we are not getting sufficient time to talk with the patients. At least once in their, in a year they are coming for 5 or 6 consultation, at least once we can sit with them and talk. And the floor is open for discussion. Kindly ask your questions.
So what are your thoughts about this creatine supplementation that people come and ask about, especially the ones working out?
So as mentioned, I think unfortunately in our country this is an unregulated space. So if you look at evidence, there is no evidence for any of that in terms of an adequate thing. If you look at the guidelines, especially if you look at the international sports guidelines or everything, looking at this particular aspect, it states very clearly that the dietary protein supersedes all of this. There are certain supplements which are available with some studies, not in India though, but basically which has evidence. So if someone comes and asks me, I generally ask them to come and show me what they're having. And as sir mentioned, a lot of times they are unregulated. There are a lot of issues with contaminants, especially anabolics and other aspects to it. So I don't recommend that. And definitely, I think, a lot of times you have this creatine and also the HMB based, powders, which basically are recommended. And a lot of gyms are the ones which actually, delve in this. So I think bottom line, with our country, stick with basically, basic dietary.
I have a doubt, sir. So while taking protein supplementation, sometimes there are a lot of people who tell that if you take protein supplements and you do not exercise, the protein is not going to get absorbed into the muscle. What is your take on it?
So as I mentioned in my talk, I think it is important that we combine both. So it is not just enough if someone just supplements the protein or takes the protein adequately. The resistance training or any form of exercise basically would be important for that to augment the muscle protein synthesis and to prevent the muscle protein breakdown.
And
so it's a combination of both which are required.
Again, there is a say that there are controversial thoughts about it. Actually, you have to take the protein powder after doing your exercise within half an hour. Is it true like that? Or you can take it any random time?
Again, I think I addressed that in one of the myths which I spoke about. So that is a myth. The scientific evidence states that basically around the period of time of physical activity, between 24 to 27 hours as the peak and up to even 48 hours, intake of high quality protein around that period of time, whether it is pre, whether it is post, whether it is 1 hour post, or whether it is many hours post, it is ultimately the total protein intake per kilogram per day, which is the most important aspect.
Yeah, so because it's very difficult for a vegetarian diet for us to get adequate amount of proteins without supplementation.
Again, I addressed that in one of these slides in the myths, basically. You're right in stating that the vegetarian and the vegan basically have less amount, but basically you would need to augment that number. So the essential amino acids and the leucine content basically is generally lower, and also there is something called as the digestible score, which means that the proteins, the plant proteins basically digestion is pretty slow compared to the animal proteins in terms of rapidity of absorption. However, basically if you were to augment it with the appropriate thing, which I again showed, whether you use rice protein, whether you use soy protein, whether you use whey protein, you have adequate amount of leucine and also essential amino acids. It's important that basically, that is augmented and actually increased. I think that is the basic thing. And it's important also to understand that we actually increase that with carbohydrates, then that becomes a problem. So that is the education which we have to tell people. If you augment it, you augment the protein content alone and not the carbohydrate or the fat content. And that is a problem with our country.
Lean body mass, you got lipomass. Sir, come. When need arises, they don't use the lipomass part of the body. What is the reason for this?
Sorry, sir, I didn't get that question. So the question was lipoma?
I have seen some people with the lipoma and the neck, big lipoma, huge.
Lipomas, okay.
It's a brain condition, no doubt. But when they are in need of energy, they don't utilize it. Otherwise, the body does not promote use of this lipoma. How? How do you explain it?
So lipoma, as far as my understanding, is a benign tumor which would not actually, regulate any metabolic aspect of the body. So that would have no link with this because that is actually a benign tumor which has a separate pathogenesis. So that would not regulate the protein. So it's not that because there's a lot of lipoma, there's a lot of fat, and that basically would add up to the metabolism. That particularly is a benign tumor.
Does it contribute to sarcopenia?
No, sir.
Exactly.
One small, not small, as I was listening to the various talks by experts in the last 1 hour, my thoughts go into too many controversial and paradoxical things which we are discussing to my understanding. For example, Dr. Umman's talk in the previous session, on one side, definitely we all agree that these newer drugs are going to cause significant muscle mass loss. That was put up repeatedly in the last 1 hour. In that muscle loss, I asked Dr. Umman in the previous talk, we were part of it in another meeting, skeletal muscle, heart is also skeletal muscle. Today in his last slide, he showed very clearly that heart muscle is also lost. That's what he put it very clearly. If that muscle is lost, then my thoughts went into, if you say exercise as a way of preventing muscle loss, heart is continuously exercising, but why is it getting lost? That means these GLP-1 and other things have effects which are beyond our current understanding, and I am not too sure whether, and in this era of, and in this whole thing, this whole GLP, the GI effects of GLP are in contrast to what you discussed in the last 1 hour. And my understanding is, if you eat, you have to have good absorption, good appetite, good thing. You protein எப்படி நல்லா சாப்பிடுவீங்க, உங்களுக்கு appetite இருக்காது. Protein சாப்பிட்டா acid வரும். நம்மூர்ல இப்போ universal omeprazolization of the entire mass, and in achlorhydric environment, protein absorption is going to be abysmally low. I'm getting worried about all this. Thank you.
Slightly away from the topic to fill the time. And one book I studied about at least 10 whites, egg whites we can take per day. How many egg yellows we can take? Because whenever I advise my patients to take at least 2 eggs per day, the first time the day, the protein and fat will suppress your appetite to some extent, and when you reduce your carbohydrate intake, the postprandial sugar will be coming down. And the people are not satisfied with my suggestion that not supposed to take egg yellow. So what is your opinion on that, sir?
So I think that's not the number of egg white or egg yellow. It is a total calorie what they have consumed. I think basically when they ask such question, I tell them what is that you consume the whole day. So it is all, suppose their requirement is 2000 kilocalories and we say 20% could be fat. And if they have consumed reasonable fat with this has to be come down. So everything revolves on the whole thing what they take. So ideally we cannot really fix on the egg white or egg yellow based on that. That's what I personally.
One small comment on that question is, one thing I think from basic our undergraduate teaching, egg contains a lot of cholesterol, the yellow part. Today I think we have a dyslipidemia session also, so that is one thing we should discourage excessive yolk intake. Direct cholesterol intake is only in animal fat, and that is egg to be relatively less. White, we assume that they are highly biological, easily by high biological value protein is in the egg white. So that is definitely indicated, but that should not exceed whatever limits they are saying, I suppose. That's a probable answer. This cholesterol is not in this excess in any of the other food items. That we have to remember. Exogenous cholesterol pathway and LDL definitely is related to the excessive egg intake, yolk intake. And today I thank Dr. my friend Anand Kumar that being a vegetarian myself, vegan and vegetarian, we can get adequate proteins from, vegetarian food also was emphasized clearly.
A quick question. So to Dr. Beatrice, one of the slides you mentioned about the non-fat lean muscle loss, and you showed a comparative data between bariatric surgery, semaglutide and tirzepatide. I didn't see a reference for that, Dr. Beatrice. You mentioned 39% lean muscle loss for semaglutide and 25% for tirzepatide.
Step 1 and surmount 1.
So it's shown 39% muscle loss.
Up to 40%.
Muscle loss for semaglutide usage.
Lean mass.
Yeah.
Yes.
Thank you so much for the expert on the stage and off the stage. We had very nice session and nice discussion. I'm concluding the session. I'm asking still we have time? Right. Any more questions we can take up? 2 or 3 questions we can take up.
Thank you. Thank you for the sessions, and it was very interesting to hear your take on the diet and the vegan diet as well. That being said, just to allude to one of the points that was being addressed about the protein and the lean mass loss that comes invariably with GLP-1 use, there is something called the SEMA-Lean trial, which I was just discussing with Dr. Manoj as well, in which what they've actually shown is there is in fact improvement with lean mass with use with semaglutide. More interestingly, improvement in grip strength. And I think we all know that grip strength is something that has been shown to improve longevity as actually a marker of longevity. So on a positive note, we may not actually have to worry so much about the protein and the muscle loss. Maybe there is some data to also point towards improvement in strengthening as well.
You're right in saying that it has increased the muscle, the hand grip strength, it has improved. But there was a lean mass loss of about 3 kgs at 7 months. And it sort of maintained. So there was no actually increase in the lean mass. There was actually a reduction. Yeah. But yes, like you said, there was an increase in the hand grip strength. So we do not know the background resistance training. We do not know what sort of exercise prescription was given for these patients.
Correct. So that being said, I think it goes without saying that whether on GLP-1 or not, we should be advising strength training to our patients. I think that is the moral
As we age, it's so important.
Absolutely.
There's a point that I was hoping one of you would touch, and that is the role of the gut microbiome in muscle mass. Is there any data to support that some of this is gut dysbiosis mediated? This is the first question I want to ask. The second thing is, we were talking about GLP-1 RAs. Is it possible that there are differential effects in the young versus the old? For example, in animal studies, and I'll talk about it tomorrow, that when you give a GLP-1 RA to an older rat, its hand grip strength actually increases, the strength increases. Whether the muscle increases or not, the strength increases, the function increases. There is no such effect in the younger person. So, the younger rat, right? So, I was wondering if you can comment, any of you can comment on these two parts. One is there a role of the gut microbiota in muscle preservation? And should we look at this as another point of view of looking at it? The second thing, of course, is do you think there are differential effects in younger versus older populations?
I'll answer the second question, sir. So there is a differential effect. Like Dr. Nandita had mentioned about the Semaline study. Even in that, they found that there was a gender difference and there was an age difference as well. So women tend to lose more fat, and the older individuals lost more of the lean mass. So this is again known, and the reason for that is the anabolic effects of protein and the anti-catabolic effects of insulin. So all of this is actually lowered when we age. So that is probably one of the reasons why elderly could be having more muscle mass. First question, I'm not aware of any studies.
Can I have one small comment in not related but indirectly related? This is a basic, the way the body handles fat and protein, we are all taught in the critical care medicine. See, when you fast healthily, voluntarily, our fasting induces fat metabolism to be, once your carbohydrate, liver glycogen goes low, your body fat is starting to get used up. This is well documented, we all know that. However, when you become sicker, like a typical sick patient in a ward or something, muscle actually is broken down. So, with all this discussion, I'm just wondering, the body, there is some, grade where it goes into that sick state now. This GLP is causing that. The body is sensing something sick. That's why protein is going along with the fat. Maybe those hormones are probably indirectly activated. Is that so? I'm just wondering, as you are discussing, why should muscle go when this is really to do with fat? I'm confusing, I know, but these are all, the more I listen to talks, I'm getting more, I'm openly, there are many people who may have this in their thoughts. I'm just thinking aloud and vocalizing so that we have more, at the end of the day, kutte kalakinaadam konjamaadu theliyunu paathen.
So I think it boils down to calorie restriction. So whenever there is calorie restriction, there's going to be loss of both muscle and fat. So that differential loss is not seen when there is calorie restriction. That is my idea.
I think to answer Dr. Krishna sir's question, gut microbiota and muscle mass preservation. I think there have been some data on gut muscle axis. So what they say is gut microbiota, they help to improve the oxidative effect of your skeletal muscle. So they help to preserve your oxidative effect, so that even if you have a intramuscular triglyceride fat, it may not have a detrimental effect. So it helps in efficiently improving your muscle functioning.
Thank you so much, the experts, and Krishna sir and Sriram Agadevan sir for the session. So we can have the discussion later, sir.
So thank you.
Many pharmaceutical concerns promote protein products as the main way of improving muscle mass. They don't show any concern for the other methods of muscle mass improvement. They don't promote even muscle exercise. Do you think is the correct method of approach in the management of muscle mass production?
I think we've addressed that already. So we don't recommend protein powders as a way of replacement. Nothing equates to the natural way, whether it is animal protein or basically plant protein. So no, the answer is no.
Thank you so much for the organizers, and I'm handing over the mic to Dr. Rajesh. Thank you so much.
So thank you so much, all the three speakers as well as the chairperson, for such an insightful, informative and an interactive session. So with this VT Symposia, and to chair the session, may I call upon Dr. Nandita, consultant physician and diabetologist from Chennai. So over to you, Dr. Nandita. The next 45 minutes is yours.
Good afternoon. Always a pleasure to take the stage at this prestigious conference, which is organized by my teacher. Krishna sir has been my teacher during the undergrad and postgrad days, and I always tell him that we remember the first day of MBBS when he walked in munching on one apple, and all of us were in awe because he put up this Greek mythology was his first slide, and the impact that he left on all of us was fantastic. Always admired you, sir. So this session is going to be, as the name indicates, it's a Lilly Symposium, and it's sponsored by Lilly. I have the pleasure of moderating the session and setting the context before we move on to the speakers. But I would like to invite, would you like to come to the stage initially or come one by one? Okay, great. So before we move on to the sessions, just to sort of set the context as to why are we all talking so much about obesity. I don't know how many of us have recognized, and I'm sure we all have recognized the shift that has actually been taking place in the context of most of these meetings, most conferences, most meetings, most gatherings. There is a shift from talking about just diabetes and its complications to the so-called obesity or diabesity, to the so-called CKM, CRM, and all these newer terms that we are hearing. Is this because, now there's two ways, in fact we were just discussing this yesterday in another meeting, but there's two ways of sort of questioning this. Well, I have two thoughts on this. Is this driven, number one, by the fact that it was always there? We always knew that obesity is a cardiovascular risk, and we always knew that obesity is a risk that increases your metabolic burden. We knew all this, but did we not have the tools to address it? Was that the reason? And is there a lot of noise being made now recently because you know, there is a growing burden? Or is it because now there actually is a growing burden of obesity in our part of the world? And I think I'll answer that question very quickly before we move on to the sessions. I wish I had the data here to show you, but we have actually shown that, yes, in fact, there is a growing burden of obesity. So we used to believe that obesity earlier was a problem of the West. We always believed that as Indians or as Asians, we are not obese. Obesity was always under, thought of as not really a big problem in our part. However, we have now got data to show that yes, there are growing rates of obesity, not just in the urban areas, but also in the rural areas, more so not just in men, but also in women. And what is even more worrisome is the fact that it is not just generalized obesity, but also abdominal obesity that is growing, and this in turn is contributing to your cardiovascular risk, which is why this shift is happening. Yes, there is an urgency to wake up to the fact that obesity is growing as a burden in our part of the world, and we do need to address it, and now we are equipped with the tools to address this burden as well. That being said, obesity, which was believed to be a risk factor in all our textbooks, earlier we used to read obesity used to be one of the risk factors. Now it has moved towards an entity or a disease that itself needs to be targeted or treated separately. So with that as a context, we'll now move on to the first speaker, who is Dr. Chitra Selvan, who has come here from Bangalore. No, that's not you, that's me. This is our disclaimer for the session. That is also not you, Chitra. That is you. So Chitra is a very good friend, and please come. She's joining us from Bangalore. Chitra works at, and she's from our own Chennai. She's finished her MBBS and MD at MMC. If I'm not mistaken. Doesn't say in the slide, but we're proud to say that she's our own MMC's graduate, and she's now Associate Professor from Department of Endocrinology, MS Ramaiah, Bengaluru. Over to you. Professor and Head. And Professor and Head. Okay, that should be corrected by Lily.
Thank you, Dr. Nandita. Won't you be joining us on stage? Okay, the view is better. Anevarukkum vanakkam. Thank you, organizing team, for having us over. We'll be spending the next few minutes, incidentally happens to be the pre-lunch session, talking about obesity, the what, why, and the how. This is the slide Nanita was looking for, I think. So the disclosure that this is a session which is sponsored by Eli Lilly. Okay, so I'm going to dive right in, okay? So the National Family Health Survey is a nationwide survey which happens every 5 years. And they've been publishing multiple aspects of health of people living in the country. One of the things that have been tracking, apart from the nutrition status, is prevalence of obesity. And if you can see, from 2005 onwards, over the next maybe 15 years or so, the prevalence of obesity has increased a little more than 50% or doubled in the last 15 years. So in early 2000s, the prevalence was hovering at about 10%. But if you take a look at the last one, which was published in 2021, the prevalence is ranging at about 22% in men and 24% in women, based on the BMI criteria. If you're trying to understand where your state lands in this whole place, if you want to draw your eye to the map, if it is dark orange, it means the prevalence is greater than 50%. It's in the pale orange, it's high, but between 25 to 50%. So you do see that the south and the belt in the north are having a very high prevalence of obesity per se. But we do know that in our country, BMI is an inadequate tool of assessing prevalence of obesity per se. So if you look at waist circumference-based abdominal obesity prevalence, the numbers go much higher, 40% in women, around 12% in men. In Karnataka, the urban-rural divide literally vanishes when it looks at abdominal obesity, and women seem to be touching close to 45%, which essentially means that roughly 1 in 2 women, at least in India, in Karnataka, do have abdominal obesity, which we all know significantly increases our risk of cardiovascular disease and all the metabolic conditions. But probably the most concerning bit of information from this survey is the prevalence of overweight children under 5. Right, and that's moved up from 1.9 to 4%. We are now in 2026. We should be expecting the latest census data anytime soon, but those numbers are scary. If you're having children less than 5 years, having a prevalence of close to 5%, we have to maybe have a national policy which is taking this quite seriously. And in the last few years, as Dr. Nandita has pointed out, we are beginning to talk about obesity primarily because one major shift happened about obesity per se. From beginning to think about whether this was something which came because of a lack of willpower, or whether this was an entity, should you even call it a disease condition, we now have reached a consensus with the WHO recognizing obesity as a chronic multifactorial disease. The CDC also now calls it a chronic multifactorial disease. Now, it is a condition which occurs due to numerous environmental, epigenetic factors in genetically predisposed individuals. If you're going to zoom in a little bit about the definition of obesity by all the various professional bodies out there treating obesity per se, you can see that excess adiposity is a commonality between all of their definitions, but the South Asian Federation of Endocrine Societies goes on to declare obesity as a chronic, relapsing, multifaceted, multisystemic disease, which essentially means that you can do something about it, but it is very likely to come back, right? And if you take a look at the Endocrine Society of India, it calls it a progressive disease, very much like maybe type 2 diabetes, right? It is going to probably get more difficult as we age to keep the weight under control or in the range. And if you're wondering why they are calling it chronic, progressive, relapsing, that's primarily because evolutionarily we were never going to see a day where literally everybody on earth, or maybe half people on the earth, are trying to lose weight. We were always supposed to be in an environment where there was a lack of nutrients, a lack of nutrition. So all of our physiology evolutionarily is poised towards weight gain. So when you are implementing weight loss by whatever means or methods, that physiology works against it to make sure that the weight regain happens to reach that hypothalamic set point which we were at before the weight loss began. And this happens due to numerous mechanisms, and we will touch upon some of them related to hormones, some of them related to neuroendocrinology per se. Now, if you're trying to understand what changed that caused the obesity prevalence to increase, did our biology change significantly, or did the environment change, what exactly happened? So essentially, if you take a look at the homeostatic eating, so we all know people in our lives who, irrespective of the ups and downs in life, maintain roughly the same amount of weight, right? In them, the homeostatic model of eating is very strong and present, meaning you maybe gain a couple of kilos, probably because of stressor, probably because of eating outside due to work and pressure, but then you kind of come back to your set point and you keep that loop going, and that's homeostasis. That's a feedback loop, right? But there are other forms of eating which could be stronger in certain individuals, and that is referred to as the hedonic eating, mediated through the mesolimbic system. Here, what happens is the eating is primarily driven by taste or liking and wanting or craving. So in this situation, the drive is not negative and loop back. It's actually feed forward, and it can actually get amplified with time. Something similar to what happens maybe with substance abuse. You begin with a few cigarettes or drinks, and then it doesn't do it for you anymore, and then you increase the number. In fact, food addiction is now a recognized entity which requires or which could warrant medical attention per se. Of course, we all have a thinking brain inside us in the prefrontal cortex, which can regulate some amount of this eating. But if your mesolimbic system is in overdrive, and it can go into overdrive when you are stressed out, when you are sleep deprived, when you are exhausted, it becomes very difficult for the prefrontal cortex to kind of keep that eating under check. And this is a story which we do here in our clinical practice. I'm doing all right most of the times when I'm at work, but when there is a stressor, I gain some weight. When my mother-in-law visits, I gain some weight. So that's when your prefrontal cortex is unable to modulate this particular eating per se. When there is weight gain, what essentially happens is the adipocyte expands, because of which the blood flow does get altered, leading to hypoxia within the adipose tissue, which leads to recruitment of inflammatory cells inside and the local inflammation in the adipocyte. So much of the pathology related to adiposity is primarily related to this. Macrophages, which are there in adipose tissue of obese individuals, are overactive in secreting more inflammatory cytokines. The second point of problem is the fact that when the adipose cell has expanded and cannot accommodate any more fat, there is deposition of fat in other areas, which is ectopic locations like the liver, pancreas, and we know that these areas could potentially increase our risk for MASLD or type 2 diabetes per se. There's also visceral fat deposition. We do know that visceral fat is metabolically more active and tends to increase our risk of metabolic conditions significantly. So with each of these changes which happen, obesity increases our risk of diabetes, cardiovascular disease, blood pressure, sleep apnea, and even malignancies. So why should we even give it a name? Should we even diagnose and give a label? Could we just not be addressing the treatment and management? I'll draw your eyes to the box in the red there. This is information to suggest that if you have an official diagnosis which is made, it tended to trigger certain changes in their regular lifestyle, which translated into weight loss to the tune of about 20%. Had a weight loss of about 5%, and about 7% lost about 10%, which is clinically very meaningful. A 5% loss of weight could potentially improve your blood sugar levels and triglyceride. A 10% weight loss could also alter your HDL levels, improve your incontinence, HDL levels, also reduce your health costs. But if you are able to effect maybe greater weight loss to the tune of 10 to 15%, you get more benefits. And if you're losing maybe more than 15% weight loss, you could be looking at type 2 diabetes remission. This is data from the DIRECT study. You could also be reducing cardiovascular disease and also cardiovascular mortality, and also the odds of having heart failure with a preserved ejection fraction. But maintaining weight loss has been a challenge, irrespective of what method has been implemented to effect that weight loss. And some of the reasons why that happens is that there are compensatory adaptive changes which happen in our body, which brings down our basal metabolic rate or the resting energy expenditure. What this essentially means is that you lose weight, then you stop expending energy adequately, so it is now going to make sure that you regain the weight back. Does this happen when you lose weight by lifestyle intervention? Yes. This is data from the Look Ahead study, which was published for the first time in 2014, and then they do have follow-up data which is happening. You can see this is individuals with type 2 diabetes who went on intensive lifestyle changes. At the end of a year, they all dropped weight, about 10 kilos. That is significant. But you can see that over the years, almost 50% of them gained about 50% of the weight back. Even a similar change seen there with the waist circumference being regained back after the cessation of those lifestyle changes, adding to the fact that this is a chronic condition which requires chronic attention. What are the adaptations which make sure you regain weight back? These are all hypotheses, okay? It is said that when the adipose mass comes down, maybe leptin concentration comes down. The point against this being the major mechanism is the fact that leptin levels are very high in obese individuals. Resistance to the leptin receptor at the level of the hypothalamus is what is usually noted, and that is exactly that. Deterioration of the activity, so maybe the resistance worsens to maybe same or lower levels of leptin which is secreted by the adipose tissue. Could there be a change in the way the brain responds to the hormones which are being secreted, or is this any other hormonal adaptation related to weight loss per se? But despite all of these mechanisms, we do know that while weight loss is a challenge, probably the second phase of it, which is maintaining that weight loss, is a significantly important challenge as well, because irrespective of what method you use to lose the weight, if whatever intervention you implemented is interrupted, the weight does come back. This is similar information from individuals who underwent bariatric surgery. The drop in weight is significant, but they do gain weight after weight loss. We have many studies to look at this. We have the Swiss study, the Stampede study. All of them do show that there is weight regain which is happening. So this is again to show that apart from the decreased energy expenditure, there's also an increased hunger which happens, which drives up the need for them to eat a little more to kind of adapt and regain the weight back. If you're taking a look at pharmacotherapy for obesity management and what has changed, Dr. Manoj will be here to take us through this. But what is approved and is available for use in India are 3 molecules. Orlistat is an oral agent, which is a lipase inhibitor available in doses of 60 to 120 milligrams, approved for use 3 times a day. It decreases the absorption of fat from the food in your intestine. Its most common side effect is related to the stomach. Many individuals are able to tolerate it without too much of discomfort, but some others might have some GI disturbances related to the molecule. It could cause a weight loss to the tune of about 3 to 5%, roughly 4 kilos from baseline. Long-term data for years together is unavailable for this molecule per se. It's also not managed to document evidence to suggest that it can cause a reduction in CV disease or mortality. The other 2 molecules which are available is semaglutide, which is injectable once weekly, the dose to the tune of 0.25 to 2.4. It's a GLP-1 receptor agonist, which affected weight loss to the tune of 19 to 15%, and tirzepatide, which is again a once weekly injection, available at doses from 2.5 to 15 milligrams as the maximum dose, which is a dual GIP and GLP receptor agonist, which is shown to reduce weight to the tune of 16 to 21.4% with doses of 5 and 10 milligram, and weight loss to the tune of 22.5% at doses of 15 milligrams. So while we do have agents which can cause significant amount of weight loss, which can significantly alter the burden of diseases which come with obesity, we also have to understand that irrespective of what molecule you use, there's always weight regain after interruption, even the new molecules which are available in clinical practice today. So quickly to summarize, and I'll hand over to Dr. Manoj, obesity is now a chronic, relapsing, progressive condition with prevalence which is soaring and seeping beyond 30 to 50%, even in a country like India, which is traditionally a low and middle income country. It has numerous manifestations in the country which can affect our CV mortality risk. Of course, public policies for the management of obesity should be of national importance, but while that is being addressed, what can we do as physicians to address this? And with this, I hand back over to our moderator.
Thank you, Dr. Chitra. And with this, I would like to move on to the next session, and we'll take questions at the end. I have the pleasure of introducing someone who does not need an introduction. I'm sure many of us are familiar with the name Dr. Manoj Chawla. But for the formality of having to introduce you, sir, today, sir is from Mumbai. Sorry? Yeah, from Mumbai, and he is from consultant diabetologist at St. Raheja Fortis, and also have their own center called the Lina Diabetes Center, along with his better half, if I may, Dr. Purvi. So over to you, Dr. Manoj. The slides are pointing here, but not there.
Afternoon, everyone, and thank you, Dr. Krishna, for having me here. Somebody from the AV team, can you give me the full slide here? I struggle to see even with the specs on. So both Dr. Nandita in her introduction and Dr. Chitra have clearly highlighted the problem that we are dealing with. Chitra pointed out some of the solutions that we have, and I'm going to, over the next 15 minutes, talk a little more about the solution at hand. Give me the full slide. Okay, thank you. So, well, this is the disclosure for this conversation. Now, talking about solutions, let me deep dive into GIP and GLP receptor agonists and their potential mechanism of action. So over the last several months, we've become more aware of how these two hormones are actually working. GLP has suggested direct actions at the level of the central nervous system, the islets, and the stomach. GIP has shown potential actions in research at the CNS level in the preclinical studies at the fat, at the adipose tissue, and at the level of the islets. So this single molecule, which is GIP-GLP receptor agonist, may enable therapeutic actions that are improved over the sum of both GIP and GLP single receptor agonism. So we see their multiple effect, whether it's reduction in food intake, improved insulin secretion, reduction in glucagon secretion, which I often say has been ignored, especially in type 2 diabetes, the role of overactive alpha cells, and the help that it brings about by delayed gastric emptying. So what is tirzepatide? Well, tirzepatide is a molecule which is largely based on the GIP backbone, and to the right you see the structure of tirzepatide, a multifunctional peptide based on the native GIP peptide sequence, a 39 amino acid sequence which you can see along with a C20 fatty diacid moiety, mean half-life of about 5 days, which is what gives it the once a week dosing, and its plasma concentrations in people with renal and hepatic impairment do not differ than those from healthy people. The potential actions of GIP and GLP based on the clinical and the preclinical data that we have. So on the left, you will see the effects of GLP, and again, to quickly take you through that, at the level of the brain, you have increase in satiety, reduction in food intake, somewhat increase in nausea, and reduction in body weight. At the level of the pancreas through the beta cells, it's going to increase insulin. Through the alpha cell antagonism, it's going to reduce your glucagon output, reduced gastric emptying. As a result, you get reduction in hyperglycemia and other benefits seen at some of the peripheral tissues, including the liver, improved insulin sensitivity, reduced hepatic glucose production, and importantly, reduced ectopic fat accumulation, whether it's level of the liver or pancreas and so on. The GIP agonism has its own advantages. At the level of the central nervous system, it's going to again reduce the food intake, but importantly reduce nausea and balance out this impact, cause a reduction in body weight, again improve insulin, but at the same time GIP is the one which is your safety mechanism which improves glucagon in event of hypoglycemia. At the level of the subcutaneous adipose tissue, there is again improved insulin sensitivity, reduction in hyperglycemia and dietary triglycerides, and its benefit at the level of muscle by improving insulin sensitivity, metabolic flexibility, and reduction again in ectopic lipid accumulation. Now, tirzepatide exerts its action via both GIP and GLP receptors in human islets, and through multiple studies it has shown, if you look at the insulin secretion area under the curve in red, this is what is the impact of tirzepatide. And then you're seeing the impact of GLP antagonism, which alone fails to reduce the insulin secretions. You can see some difference, but not to the extent that one may have thought earlier. Whereas GIP receptor antagonism alone reduced insulin secretion significantly, is what you see in the third bar there. And GIP and GLP antagonism is working similarly. So tirzepatide essentially acts through both these mechanisms, with GIP being a little more predominant as the whole molecule is based on the GIP backbone. So when you talk about targeting the metabolic matrix, you will see the impact of tirzepatide on better glycemic control, on weight reduction, on improved lipids, and overall cardiovascular effects, and some of these I will highlight in the slides to come. So let's start with glycemic control. How is it really improving the overall glycemic control? And I go to the data about tirzepatide reducing A1C from baseline, findings from across the SURPASS clinical trial phase 3 program in people with diabetes. So you look at the data for SURPASS 1, which is the 3 doses of tirzepatide as compared to placebo, and you see a reduction of A1C to the tune of 1.8 to 2%. In SURPASS 2, this is a direct comparison between tirzepatide and semaglutide up to 1 milligram, because that's the approved dose of semaglutide for diabetes management. And tirzepatide you have up to 5, 10, and 15 as approved doses for diabetes management. So a clear comparison between both these doses, and you see up to 2.46 reduction in A1C for tirzepatide 15 milligram. In fact, all the 3 doses of tirzepatide scoring a bit over semaglutide in its 1.86 A1C reduction. SURPASS 3 was comparison with against insulin degludec, add-on to metformin or metformin and SGLT2 inhibitor, and again you see all the 3 arms of tirzepatide causing significant A1C reduction way beyond what degludec does, up to 1.34. In SURPASS 4, this is insulin glargine, comparing to glargine as add-on to metformin, SGLT2 or even sulfonylureas, and again up to a 2.5 reduction for tirzepatide as compared to 1.44 for the glargine arm. And SURPASS 5, a 40-week trial where you are comparing for patients who are already on insulin, glargine and metformin, and addition of tirzepatide as compared to placebo, you're seeing up to a 2.59% further reduction to patients already who are on insulin by tirzepatide various doses. Also seen has been that tirzepatide improved beta cell function compared to placebo or semaglutide in participants with type 2 diabetes. The findings from the GPGT study through a hyperglycemic clamp data, you're looking at the first phase insulin release, and as compared to placebo, you see some improvement for semaglutide, but significantly higher first phase insulin release for tirzepatide. You also look at the second phase where there is better second phase release for tirzepatide usage as compared to semaglutide and placebo. It also showed improved insulin sensitivity. So you're looking at the hyperinsulinic euglycemic clamp data, and you're looking at the whole body insulin sensitivity index measured by the M value. Again, you can appreciate tirzepatide outscoring semaglutide and of course placebo in improving the insulin sensitivity. Tirzepatide also showed changes in insulin and the glucagon area under the curve. So you can again appreciate as compared to baseline and up to week 28 as compared to placebo, you can see the total insulin area under the curve much lesser for tirzepatide, so lesser load and impact on the pancreas, and you see similar effects on glucagon. But having said that, though there is glucagon reduction for tirzepatide, it has not lost its impact in event of hypoglycemia. So tirzepatide still shows intact glucagon response to induce hypoglycemia with participants with type 2 diabetes as seen in the GPHG study, and that's important. For incretins, we've always, from the time we learned a little about incretins earlier with DPP-4s, we always maintain its glucose-dependent action, which is extremely important in terms of hypoglycemia and safety, and that's good to see again that tirzepatide retains the intact glucagon response in event of hypoglycemia. So to summarize on the initial aspect, in participants with type 2 diabetes, tirzepatide improved beta cell function and insulin sensitivity with a weight-independent component compared to placebo or semaglutide, demonstrated a greater reduction in glucagon area under the curve than semaglutide, and demonstrated the intact glucagon response to induced hypoglycemia. Let me move to the second aspect about weight reduction and cover some of the important points there. So tirzepatide reduced body weight compared to placebo in participants with obesity or overweight, so the SURMOUNT-1 trial, and you can clearly see that as compared to placebo in the three arms of tirzepatide, 5, 10, and 15, you got a 16%, a 21.4, and a 22.5% weight reduction at the end of the trial, which was 72 weeks. It also showed change in body composition, and just prior to this session, we've had a lot of conversation on fat mass, lean mass, and so on. So looking at the DEXA data compared to placebo in participants with obesity or overweight, you can see reduction in total fat mass for the tirzepatide arm, largely by the visceral fat mass, and then you're seeing some reduction in total lean mass, which is expected. But when you compare the overall composition as compared to the fat loss, the muscle loss is much lesser, and which is why the argument that you do not get much increased muscle loss or lean mass loss with the use of these drugs. Tirzepatide also lowered the overall appetite compared to placebo in participants with obesity, and you're looking at the hunger visual analog scores, and you can see reduction in the hunger score. Importantly, it also reduces the prospective food consumption score. So it's not only your immediate hunger, but in general, your appetite, your desire to eat the next meal, how we think about it, is there is a reduction in that desire as well. There is improved satiety and fullness, which tirzepatide brings about. And you can see the overall appetite scores during the standardized mixed meal test as well. There has been decreased food cravings from baseline compared to placebo in participants with obesity. And what they found when they tried different aspects, different kind of food aspects, which was high fat food, sweets, starches and carbohydrates, fast food and fruits and vegetables, you see reduction for a desire for fast food fats, which is significant, for sweets, which is significant. However, the food craving for sweets, carbohydrates, starches, and fast foods was reduced, but not for the high fat and the fruits and vegetables. So comparatively, that reduction is not there, and which is what in clinical practice you will see today, your patients using tirzepatide, what kind of preferential change do they have for the food that they are eating, and you may notice similar changes in them. Tirzepatide showed greater body weight reduction compared to semaglutide, mainly driven by the fat mass loss in participants with type 2 diabetes. So you're looking again at the secondary analysis of the GPGT study. So as compared to semaglutide, you see much better fat mass reduction. There is going to be fat-free mass reduction as well, but comparatively, as you see, the fat mass loss is much better in tirzepatide, and you look at change from baseline in body weight over time, that's placebo, that's semaglutide, and that's tirzepatide for you. So summarizing the overall weight benefits for tirzepatide, in participants with obesity, tirzepatide showed greater body weight reduction and significant changes in the body composition. You're looking at total fat mass loss, total lean mass loss, and the visceral fat mass, which was largely contributory to the fat reduction as compared to placebo. Reduction ad libitum for the food intake, overall appetite going down, and food cravings preferentially going down for certain food aspects. No reduction in the sedentary energy expenditure compared to placebo. In participants with type 2 diabetes, tirzepatide shows greater body weight reduction, reduced appetite, and greater reduction in the liver fat content compared to insulin degludec. Let us look at some of the other benefits, pleiotropic benefits, or important systemic benefits, I would call them, on lipids and blood pressure with tirzepatide. So you're looking at the data, there was always concern about GLPs and pulse increase or increase in heart rate. And you look at the data here, so there is about 2 to 2.4 beats per minute increase for all the GLPs, which kind of plateaus, and then you start seeing over weeks this coming down again. So no real difference between tirzepatide arms and semaglutide on the pulse rate. Overall mean systolic blood reduction, tirzepatide 15 milligram, 10 milligram, 5 milligrams, so up to 5 millimeters of mercury reduction in systolic blood pressure, and about 2.5 to 3 millimeter reduction in diastolic. So you are again seeing benefits of tirzepatide, and these have clinical implications when you use these drugs, who may already be on other antihypertensives, and let's say they have borderline uncontrolled hypertension. It makes your decision easier whether I should step up on an antihypertensive, or if I'm starting tirzepatide, shall I wait and watch, because these drugs will also have that benefit of up to 5 millimeter systolic and up to 2 to 3 reduction in diastolic. It does not increase risk of MACE in participants. So this is, you're looking at the SURPASS 1 to 5 trials, and the data from there. There was no increased risk of major adverse cardiovascular events across these trials. Also, people with obesity taking tirzepatide experienced improvements in their cardiometabolic parameters at 72 weeks. So to summarize the entire benefit of tirzepatide, you're looking at 7 to 8 millimeter reduction in systolic blood pressure, 4.5 to 5.5 diastolic blood pressure, improvement in triglycerides, some increase in HDL cholesterol, and about 6% reduction in LDL cholesterol as well. So key takeaways about tirzepatide: to summarize its role in management of the metabolic matrix, improvement in CNS in terms of reduced appetite, changed feeding patterns, reduction in liver and in general ectopic fat content, improved pancreatic function, increasing insulin, reducing or controlling glucagon regulation, cardiovascular benefits through lipid regulation and lowering of blood pressure, and delayed gastric emptying. Well, also showing some improved insulin sensitivity as shown to you through the data presented. So with that, I hand it back to Dr. Nandita for taking it ahead and taking any of the questions from you. Thank you.
Thank you, Dr. Manoj. The floor is open for questions. I'd invite Dr. Chitra to the stage as well.
Dr. Manoj, is this trial is a multi-centric trial, or usually done in one center for over a period of long time?
Which trial, sir?
This one, which you have shown.
So I showed data from multiple different trials. I showed the SURPASS data. I showed
undertaken in our country abroad.
So most of these are multi-centric, multinational trials, as this was part of the phase 3 program, and there were sites from the Asian continent as well as India as well in some of these trials. So all the data that is shown are multi-centric trial data.
Dr. Chitra, one question to you. You mentioned about biological adaptations, which is responsible for chronic weight gain in the long run. Is there anything to do with the genetic makeup of individuals? Because I have two brothers, one losing weight, but the other is gaining weight simultaneously. Both are diabetic.
Yes.
How do you explain it?
That's a good question, sir. So, if you are trying to give weightage as to what is contributing more, whether it's genetics or whether it's environment, maybe it is tipping towards genetic predisposition only for the general population. It is said that maybe 80% of whether you're going to gain weight or not is genetically predisposed. But that being said, the environmental, behavioral influences are huge and significant. Like, for example, if you can look at the Scandinavian countries who have made sustainability and living well, or even the blue zones of the world, like Singapore, or Japan for that matter, where you're focusing on longevity and things like that, the environment is designed such that there is no signal for junk food coming in anywhere. Walking is made easier, parks are available, healthier food is accessible and available and affordable, and you do see that people do remain in normal age. So if you take twins and maybe separate them and put in separate individuals, separate environments, even a genetically predisposed person could potentially maintain a lower weight. Of course, in our society, it's so easy to gain weight, right? Unless you are actively trying in a genetically predisposed individual, it is the default setting is to gain weight.
Will there be any difference in the insulin sensitivity of individuals concerned?
Do you want to add to that, Dr. Nandita?
Well, that's interesting that you mentioned this case. It's just that I believe there won't be too many such cases. What the data has also shown for tirzepatide across the SURMOUNT trials is at least 90% of the patients are doing 5% weight loss. Now 5% today, we may wonder, what's the big deal? But the 5% used to be the cutoff, and as a significant weight loss for any drug to be considered even an anti-obesity medication. And the data is clear that 90% are showing 5. Of course, today we are ambitious and we are looking at 15%, 20% and more, and seeing how many patients are getting to that. So this case about 2 brothers and one responding, one not, I believe has more other factors, largely environmental, even beyond just the genetic factor.
I don't think they were on medications. I think they were just 2.
Oh, you're just talking about, okay.
They were not on medication.
Identical twins. They may differ in insulin sensitivity, am I right? Will they differ in insulin sensitivity?
So you're saying identical twins, but one is gaining weight and one is not. We'll have to go back to their pregnancy time and see who was the higher one and who was really feeding more at that time, and what their birth weight was, and whether there is any kind of link to that, but it's interesting.
One more question to you. I have seen most of the patients who are on depression treatment, anti-depression treatment, they quickly gain weight within a short period of 3 or 4 months. Will there be use of tirzepatide or semaglutide, or bariatric surgery is the only option in this case? How do you explain? This is the same question raised to psychiatrists. The response is not satisfactory.
No, that's a perfect observation, and I think that continues to be a challenge. Patients who are on antidepressants or various or psychiatric medications
the problem is they are not voracious. They do not consume food voraciously, but they develop quick increase in weight.
So there are some of the psychiatric medications which may be obesogenic in nature, and even if they don't have a voracious appetite, it may be reduced physical activity and probably a change in their hormones, which is leading to more appetite. Even if it is not voracious appetite, it could be change or preference for the kind of energy dense foods that they are having. But clearly, patients who have that underlying depression and then on some of these medications, we do find it challenging for them to lose weight.
If they stop antidepressant medicines, their weight is not that much reduced considerably.
So that continues to be a clinical challenge, and one of the solutions for them probably could be the newer anti-obesity medications, but to be under supervision and monitoring given the potential of side effects in these patients.
Hardly 1 or 2% of them develop diabetes. The rest of them are almost normal. How do you explain it? The depressed patients who have been for a longer period of time. Barely 1 or 2 people develop diabetes in the long run, but the rest of them is almost normal.
That might not be true, sir. There is a higher prevalence of diabetes, especially with some of the atypical antipsychotics which are being used. We do see diabetes onset also occurring much higher in this vulnerable group of people.
The only thing is, maybe these individuals who already are depressed and all, they're not seeking help and not coming ahead. So to believe only 1 or 2% of them are developing diabetes or a problem may not be true. I'm sure a larger number there have it. They may not be seeking help and coming ahead for more reasons than one.
I have a question. The role of testosterone and obesity. Role of testosterone and obesity. Because it improves the weight mass and decreases your fat. What else you need? You exercise, testosterone, everything is done.
So the premise is that hypogonadism untreated does come with greater fat mass and lesser muscle mass. But in general population where the testosterone levels are normal and the person is eugonadal, additional supplementation of testosterone, be it in the form of oral agents which are milder or injectable or testosterone preparations or gels, have not documented to lead to an increase in fat loss. Of course, it can cause muscle mass loss, but it is not approved for use in eugonadal individuals. So unless we've documented hypogonadism, it is not recommended. This question is off topic for this session, so maybe we can meet over lunch and speak.
Thank you very much. If there are any more burning questions that need to be addressed, like Chitra said, the speakers are available for discussion over lunch. And thank you all. I think half the audience is already at the lunch venue. So thank you, Lily, for arranging this meeting. And everybody is in hypoglycemia, yes. Let's move on to lunch. Thank you.
So thank you, Dr. Nandita, as well as the two speakers for the fantastic session. So we'll quickly break for lunch and we'll reassemble here sharply at 2:15 p.m. for the subsequent session. Thank you.
So good afternoon to all. So let's start the post-lunch session. So it's a therapy symposium. To set the context setting and moderate this session, may I invite Dr. Sailaja Kale, Madam, who has been the director of Dr. Sailaja Kale's Diabetes and Specialty Center and is an associate professor of KM Hospital, Pune, to take it forward this particular session. Thank you.
So, good afternoon everyone, and we will be having a very interesting discussion. So, I just want to say that we have this extremely interesting molecule, a combination of GIP and GLP tirzepatide for our use in day-to-day practice for all our patients with type 2 diabetes. So, we'll see how important and how we can use it more for more benefits in our patients. So, before we start the discussion, I request so we'll have some initial discussion of type 2 diabetes management and importance of early and aggressive control, mainly when we look at the patients in India, what we see every day. So I request Dr. Muthukumaran Jayapal to have his opinions about how this early holistic management can be done. And then the next will be Dr. Annie. She will be dealing with SURPASS-2, some scientific evidence with the tirzepatide in type 2 diabetic, and then of course we'll have questions and discussions. So Dr. Muthukumaran.
I'm here. Right, okay. Good afternoon everyone. Can I have the slides please? Thanks. Good afternoon, everyone. It's a pleasure to be here. Thanks for the debate team for the invitation. My task for this afternoon is to give you a broad overview of type 2 diabetes management, and following which you will hear about tirzepatide. And basically, it's always been a big question about type 2 diabetes management. whether it's going to be a whole long journey or whether it's short spurts of energy you boost up with, and when you reach the destination, what happens. So, as you're aware, this session is sponsored by Eli Lilly, and I do not have any conflicts of interest on this presentation. So, when we look at patient care in diabetes, we look at patient-centered care. That has been the notion for the last 10 years. And we always think whether it's medicines first or patients first, it's always patients who come first, and the patients, you need to find the best treatment for the patient who's sitting in front of you. And most of our patients suffer from multiple chronic conditions, which includes diabetes as a part of it. So as providers, we need to find empathetic care, and it should be surrounded with the patient in mind. So when we plan this kind of treatment, we look at lots of social behaviors of the patient, personal preferences of the patient come first, and you put that in the biomedical context. And the new notion is you believe in the patient's values and you work with it. So that is what, so if somebody says, I believe in natural and Ayurvedic treatments, then it's not to discount that. You probably ought to believe in it and work with them, explain to them why things are needed on top of it as diabetes progresses, and they might need diabetes management as their diabetes disease progression happens. So things have to be explained so that the benefits and harm of the treatment could be explained to these patients. So we follow certain decision cycles for patient-centered care in glycemic management, and whichever organization you look at, this is what, the diagrams might be different, but patient-centered care revolves around certain key characteristics. So personal characteristics of the patient come first. So you look at key person characteristics. You look at specific characteristics or factors which impact the choice of treatment. And then you come to a shared decision making, agree with the patient about the management plan, and then implement it, and depending on what the results are, you plan, move forward, and replan again. So it's a cycle which goes on forever, and you go through this with the patient putting together as patient first. So when we look at patient-specific factors, what key person characteristics, what we look at is, we look at the patient as an individual, we look at his priority. When a patient walks into your clinic, you ask them what their first priority. It might just not be the sugar control which is priority. He might be looking to fix a denture or do a hair transplant or whatever it is. That might be his first priority, and that might be the reason why he is walking into your clinic. So then you look at his current lifestyle and health behaviors. You look at comorbidities or whether he's a newly diagnosed patient, his current clinical characteristics, and issues with his motivation or mental status. So all these factors become very important when you look at it and make a plan for a specific patient. We also look at the 24-hour physical behaviors of patient, with more and more people opting for work from home, prolonged periods of inactivity, working on a PC for 12 to 14 hours a day. This has become very, very important. And it's just not that 45 minutes of activity might not be sufficient. It might be sufficient for a retired individual going for a morning walk every day, but it might not be sufficient for anybody who is working on prolonged periods of inactivity. The type of exercise also matters, followed by sleep, his exercise, and how much activity he does. In general, we have encouraged people to do 150 minutes of activity per week, which are involving his large muscle group, just like brisk walking, walking on a treadmill, cycling, and so on. But what is not recommended is prolonged periods of inactivity, like leaving a break for 2 or 3 days in the middle and letting it off. We are all aware that the phenotype, diabetic phenotype, is a special metabolic phenotype where it primarily shows preliminary aging process, and people call it even as a Alzheimer's as type 3 diabetes. So that's how premature aging happens in diabetes. So there is loss of muscle, there is loss of premature muscle loss is quite a common problem in diabetes, so you need to work on improving this as well. Sleep has become more and more important in diabetes management in today's world, and we recommend around 7 to 8 hours of activity, and that should also be together with the circadian cycle of patients. So preferably sleeping with the circadian clock and not delaying it too much and not interrupted as well. So although people are very proud that they call themselves as night owls, waking up, keeping up all along the night and then sleeping through the day, there are certain factors which are more important to your glycemic control than not more than sleep. So you need to tackle this effectively. If somebody has got poor sleep patterns, that has to be evolved. Sleep apnea has to be excluded, and things like restless leg syndrome should also be treated. What about other factors? How do we utilize the decision-making plan? You educate the patient, you educate what is necessary for him to change his diabetes. You can also involve other people in the clinic, like your diabetes educator. You can educate the caregiver as well, and explore the personal preferences of these patients. If the patient is not able to understand your language, which might be probably English, preferably in the local language, and probably we have to do more adaptive interviewing on the initial basis of cognitive behavior therapy should be adapted positively to do this interviewing model. So preferably, it's a natural way of doing things, but it takes time. So these are all, as I said earlier, whether you look at the ADA or the EASD, most of these perspectives are very similar, but the language might be different. And when it comes to a holistic approach, it's just not medicines which are components of care. There are other things. Glycemic management might be the first thought in our mind, but there are other important things. But still, it remains to be seen whether metformin or other agents might be the first agent. Weight management has been critical in managing patients. There's no point giving somebody insulin, making them gain 5 to 8 kg in the next year, and then their diabetic ticking clock will be faster than ever. So weight management as a part of glycemic status becomes important, and selecting the choice of drugs which will advocate that in an individual patient becomes critical. Once we've looked at glycemic and weight, we also look at the cardiovascular risk in our patients, because cardiovascular risk is what kills our patient. Diabetic patients are at an increased risk of cardiovascular death, about 3 to 5-fold more than any other patient. The only patients who are more at risk are our renal failure patients, who are more at a higher risk than type 2 diabetic patients. So we would like to address the cardiorenal protection with our glucose lowering medications, and we need to participate in this actively. So when we talk about holistic person-centered care in diabetes management, we talk about preferably the first agent, metformin or an SGLT2, but we also look at cardiovascular risk of the patient. We look at cardiovascular risk of the patient and assess them whether they'll be fit enough for an SGLT2 molecule or a GLP-1RA molecule. If there are additional risk factors, you might have to address them as well. You can use an ASVD calculator to address other parameters. And if predominantly if the patient suffers from heart failure, agents which are helping heart failure would help. Or if weight is a predominant problem, you can go for weight management as well. So it depends on individual patients, and that is what we emphasize on early intensive glycemic management. And this is kind of, as I said, it is a long journey, and the journey matters rather than what you want to end up with. It's, in other words, what I mean by is you don't want to get your patient into a HbA1c of 5.5 in the first 3 months, and then they get into a 10.2, at the end of first year. So this is a process and it has to be educated. But early intervention does matter in our, particularly in our early young patients with type 2 diabetes. Why does it matter? It matters because it reduces cardiovascular risk, it reduces mortality, it reduces all complications of diabetes. This is the UKPDS data. I'm sure most of you have seen this 100 times, but this study forms the basis of current type 2 diabetes management, which first told us good diabetes management helps most of our type 2 patients. And most of our microvascular complications are reduced by 20 to 30%. What the disappointing thing was, we couldn't achieve the same amount of reduction in macrovascular disease. Probably the reason is your macrovascular disease is already established and it might need a longer duration of treatment to address that. So if you look at anything, this is UKPDS 35. If you look at microvascular endpoints, even with cataracts, your levels were decreased, and each reduction of 1% reduction of HbA1c led to 30% reduction in microvascular endpoints. So whether it's retinopathy, nephropathy, you got significant improvements. Does intensive control improves? Yes, it does improve. Whether it is myocardial infarction, stroke, or all-cause mortality, it improves. But the disappointing thing was it didn't achieve statistical significance when looked at as the larger whole study population. So that's why it's not been portrayed. But if you look at individual data, all the relevant macrovascular complications was related directly to your HbA1c levels. Why is early glycemic control very important? That is because what we call as the legacy effect. And what we call as the legacy effect is if you do have good glycemic control for a period of time, between 5 to 10 years, you achieve a legacy which is the metabolic memory. In other words, you achieve this legacy which would continue to protect your patient from all complications, both microvascular and macrovascular complications, and any benefit you choose to get in the initial days or initial years of therapy will continue to last. And this is not only in the UKPDS, that's been various studies suggesting this, and even there is data to show that patients who are having 2 or 3 pregnancies who have had achieved good control continue to show good reduction of complications in the long run. So if you've got a period of good glycemic control, it will stand good for many years, and that is important for most of us. And this study particularly showed the data vice versa. What if you don't do good control in the short period and leave for patients to carry on, do their own thing, and come back to it? So if you look at patients with the HbA1c of greater than 7, not receiving intensive treatment, at 5 years, these patients are at a very high risk of myocardial infarction or a stroke or heart failure compared to somebody who has had intensive control with the HbA1c of less than 7. So this is a huge difference, and this has been again proven in multiple studies. So our greater focus becomes weight management in type 2 diabetes, because weight management has been noted to suggest that progression of diabetes has been lesser in patients who have managed their weight very well. If you've lost 5 to 10 to 55 or 10% of your weight, primary weight, then you do really well with your metabolic control as well as the progression of diabetes over a period of time. So weight loss benefits exceed more than the glycemic control and in easier management of metabolic cardiovascular disease as well. So in a nutshell, we try to achieve good glycemic control with adequate weight management goals, general lifestyle advice on top of educating the patient. Choosing them with your patient in agreement becomes a mandatory, as we all know that this becomes important in your every clinical consultation as well. So this is just one couple of last 2 slides to show you that reduction in weight is correlated with lower HbA1c. So as The more weight you lose, the more HbA1c reduction and more sustained your HbA1c reduction will be, and you have reduction of type 2 diabetes risk factors significantly, which is including your blood pressure and sugars, triglycerides, and HDL cholesterol, which continues to improve. So I'll leave this to my next speaker to follow this through. Thank you so much.
Dr. Muthugam, please join here on the stage, sir. Please come here. So I request Dr. Annie for the next her talk about introducing tirzepatide use in type 2 diabetes. Dr. Annie, endocrinologist. She is from Hyderabad, and we will have discussion, all of us, after her views on tirzepatide.
Thank you, ma'am. A very good afternoon to all of you, and welcome to the post-lunch session on tirzepatide, where we will be focusing about tirzepatide as an anti-diabetic molecule. So as we all know, tirzepatide is a single molecule that is going to activate both the receptors, the GIP and the GLP-1 receptors. So both the GIP and GLP-1, you all know, are incretin hormones, and together they account for the incretin effect. But GIP is responsible for approximately 2/3 of the incretin effect in healthy individuals without type 2 diabetes. And as we all know, again, people living with type 2 diabetes, the incretin effect is diminished. So this is the next. We'll talk about SURPASS-2 trial, which has looked at tirzepatide as a molecule, as an anti-diabetic molecule, and we will see how it compares to semaglutide. So I've already talked about the incretin effect, and you all know about it. GIP initially had garnered a lot of interest before this, but it soon became the forgotten hormone. But we all know that it accounts for almost 2/3 of the incretin activity. And if you look at the GLP-1 activity, so it has receptors, and yesterday we had a wonderful talk about how the GLP-1 does not really cross the blood-brain barrier, and it has a lot of effect through the vagal pathway. But the ultimate effect of GLP-1 stimulation would be a reduced food intake, an increase in the satiety, an increase in the nausea as well, because we have the nucleus tractus solitarius where it acts, which is very close to the emesis, center for emesis, and thereby there is an increased incidence of nausea. And in the pancreas is going to increase the insulin secretion and reduce the glucagon secretion, and in the stomach there's going to be delayed gastric emptying. And GIP activity, so the molecule in question, that is tirzepatide, so it has both GLP-1 and GIP. Semaglutide is only going to have GLP-1 activity. So whatever I've talked about till now will be applicable to semaglutide, but now let's look at tirzepatide, which has both the receptor stimulation. So what does GIP stimulation do? It is also going to reduce the food intake, but it is also going to have direct effects on the center for emesis, and it also decreases the nausea. In pancreas, it is going to increase the insulin secretion, and it is going to increase the glucagon in a glucose dependent way. Now this has again been a lot of contention saying how can hypergluconemia be beneficial, but there is a particular glucose level, so around 90 to 108 is what has been shown in experimental studies, where below this there is an increase in the glucagon by the GIP stimulation. But otherwise, in normoglycemic individuals, it does not really increase the glucagon levels. And in adipose tissue, again GIP receptors are present in the adipose tissue, whereas GLP-1 does not have receptors in the adipose tissue, rather acts through the activation of the sympathetic pathway. So direct activation of this GIP receptors in the adipose tissue is going to increase the insulin sensitivity, increase the lipid buffering capacity. Again, the action, the combined action of GLP-1, that is through the sympathetic pathway, and the GIP directly through its receptors, is going to have or keep the adipose tissue healthy. So this is going to in fact increase the adiponectin levels when there is a combined action of both of these. And it's going to increase the storage capacity, and it's going to reduce the pro-inflammatory immune cell infiltration, and one of the mechanism is by increase in the adiponectin. So there is, of course, we'll reinforce the unique actions of GIP at the pancreas, that there is going to be a good stimulatory effect on the pancreatic beta cells. So the endogenous GIP, it generates a more significant effect on the insulin-mediated glucose clearance compared with the endogenous GLP-1. And in the adipose tissue, as I had mentioned earlier, GIP has been shown to increase the adipose tissue blood flow. It also increases the glucose uptake, and it increases the activity of the lipoprotein lipase, and it also stores or promotes healthy storage of fat in the adipose tissue. And high fat diet, which leads to an increase in the K cells, thereby enhancing the GIP secretion as well. So when the glucose levels are low, so the cutoff is about 90 to 108, so GIP is going to promote the glucagon secretion from the alpha cells. But when the glucose cells levels are high, GIP stimulation promotes insulin secretion. So now let's look at the molecule in question, that is tirzepatide. So this is based on the native GIP sequence, and it is going to act on the GIP receptor and the activity similar to the native GIP hormone. Whereas if you look at the GLP-1 receptor action, it is lower compared to the native GLP-1 hormone. And the half-life is about 5 days, so it enables us for a once weekly dosing. And of course, there's no dose adjustment required for patients with renal or hepatic impairment. And what is the mechanism of action of tirzepatide? We've already seen it. It's going to act both on the GLP-1 RAs as well as the GIP. So ultimately, these are going to be the effects. There's going to be reduction in the appetite, reduction in the food intake, especially craving for high-calorie food that comes down. And there is a decrease in the liver fat content, which again has been shown in the Synergy MASH phase 2 trial. And pancreas, again, there is an improvement in the beta cell glucose sensitivity. It increases the insulin secretion, and at certain levels of glucose, it's going to reduce the glucagon secretion. And when a patient is on tirzepatide, the glucagon response to hypoglycemia is not lost. So that is again an important finding here. It reduces the gastric emptying, but again, this is a effect with tachyphylaxis. It does not stay for a very long time. And there is an increase in the insulin sensitivity. And tirzepatide has been extensively studied in the SURPASS clinical trial program. And now let's look at the SURPASS 2 specifically. How is tirzepatide superior to GLP-1 RAs? So this was what was studied in the SURPASS 2. Tirzepatide 5, 10 and 15 milligram. So this versus semaglutide 1 milligram. So we had 4 arms. So one arm received semaglutide up to a dose of 1 mg. Then there were 3 other arms, different doses of tirzepatide. So 5, 10 and 15 mg. And they were followed up, and they were seen, the primary endpoint was basically a mean HbA1c change from baseline. And the average HbA1c in these patients were 8.3% to start with. And they had about 8.6 years duration of diabetes already. And the baseline BMI was about 34 kilogram per meter square. So we see here that the primary endpoint, that is the HbA1c reduction, was superior to semaglutide 1 mg in all the doses of tirzepatide. So you look at it here, even the minimum dose of tirzepatide, that is 5 mg, gave a better HbA1c reduction compared to 1 milligram of semaglutide. So it's about 2.1 for 5 mg, 2.4% reduction and 2.5% reduction for 10 and 15 respectively, compared to semaglutide, which was 1.9%. And the sustained HbA1c reduction was also seen at every dose through week 10. And the HbA1c came down as early as 4 weeks. And more number of patients, so these were the secondary endpoints, more number of patients received HbA1c targets across all the doses of tirzepatide here. You can see HbA1c less than 7%, almost 86%. With even 5 mg of tirzepatide, they were able to achieve this HbA1c of less than 7% as compared to 81% of semaglutide 1 mg. And very similarly, we see the findings even here with the HbA1c of less than 6.5 and even less than 5.7. And looking at the weight again weight was a secondary outcome. They found that there was significant weight reductions even with 5 mg. So 5 mg gave about 7.8 kg mean weight reduction compared to about 6.2 with semaglutide 1 mg. And this weight reduction was dose dependent. So about 12.4 kg with a 15 mg dose of tirzepatide. And again, this is how it was maintained as well. And more number of patients, of course, achieved the composite endpoint with tirzepatide versus the injection semaglutide. So composite endpoints were HbA1c of less than 6.5%, weight loss of more than 10%, and they do not have clinically significant or severe hypoglycemia. So all of these endpoints were achieved more in the tirzepatide group compared to semaglutide. And coming to the adverse effects, very similar as we see even in clinical practice, mostly gastrointestinal nausea, vomiting, and this was a usual side effect, and it is also a little bit of dose dependent effect. And incidence of hypoglycemia was not different in both the groups. It's very similar. So to summarize this, tirzepatide Mounjaro is the first and only approved single molecule GIP/GLP-1 receptor agonist. And from the SURPASS-2 trial, we know that there is superior HbA1c reduction with all 3 doses studied versus injection semaglutide 1 mg. And we also have seen superior weight reduction as well with all 3 doses versus injection semaglutide 1 mg of up to even 13.6 kg. And safety profile, again, very similar to the GLP-1 RA. In fact, the incidence of nausea we see is little lesser even with tirzepatide. So that's it from my side. Thank you.
Yes, Dr. Annie, please join here. So I think how many of, everyone is using tirzepatide in their clinical practice who are here? Yes, so I think it happens that drug is launched, and when we see an obese person comes for weight loss, first thing comes to our mind is tirzepatide. That's what's happening. But we are forgetting that it's a wonderful anti-diabetic drug. And as Dr. Muthukumar initially said, that early aggressive control from day 1 is essential for preventing complications. Another, type 2 diabetes in India, what we see, almost 50 to 60% patients are young. They are very insulin deficient. So the hallmark of type 2 diabetes in our population is insulin deficiency. And that's why metformin alone is never sufficient. If you see metformin type 2 diabetes in India, the response is much less. We need second drug very early. So we need combinations maybe right from day 1, and we need something insulinotropic, like either a small DPP-4 inhibitor or early sulfonylureas, and we need insulin very early in our patients for that magic number of 6.5 to 7. So my question is, if we are talking such kind of population, do you think that drug like tirzepatide will have such a wonderful A1C reduction? Can we use it right with metformin or after metformin, like quite early when we say, nowadays there is nothing like 1 by 1. We are like putting all together according to the indication, but just purely to achieve that magic A1C.
So we need to know the subtype of diabetes that you are dealing with. So we know the clustering of type 2 diabetes. Now if it is somebody who has severe insulin resistance, so those are the kind of patients who would benefit really from tirzepatide, rather than somebody who is insulin deficient. So those may not be the patients typical for tirzepatide. So we are looking at somebody with obesity, even if it is central obesity, visceral obesity, even that. And that is the sort of patients that we're seeing often now. So it is more of a diabesity population that we're handling. So like you said, there is not going to be a first line or second line. But look at the entire, holistic view of the patient as such. So what are the risk factors that this patient has? And of course, if the patient has obesity, tirzepatide comes like, top on the list. So if the patient has obesity, patient has ASCVD, all of these risk factors put together, and in the Indian setting, the affordability is also important. So all of this has to be considered before you choose tirzepatide as a drug along with metformin.
So we just don't look at BMI, and there's enough evidence that 27 and more BMI with diabetes or comorbidities, it's a wonderful drug. Are you aware of any other studies whether lesser BMI with tirzepatide? I think there was one ethnic study in Chinese population where it was used even with the lower BMI. So it works in Asian population. So though there are cutoffs, we know, as you said, Annie, that distribution of fat is very important. It's not only weight loss, or it's not only obesity. So these drugs, GLP-1 based, they will redistribute the fat, and the maximum benefit which comes, like epicardial fat is gone, central adiposity is reduced, like waist circumference is reduced by 18 centimeters in some trials compared to 3 centimeters with placebo. That gives a major benefit. So Dr. Muthuk, will you like to add this drug earlier?
I think as Dr. Annie was saying, it's a very good drug. There is no doubt about it. Most GLP-1s are pretty good drugs, very well tolerated. But coming back to the pathophysiology of type 2 diabetes in an Indian setting, we are all lean and mean, but we have a big tummy. So that's where the insulin resistance starts off with it. Even in lean patients, we have significant insulin resistance. So metformin is helpful, certainly in most 80 to 90% of individuals. Following which you've got abdominal obesity. So most of the pathogenetic factors of type 2 diabetes will be addressed by your GLP-1s or other newer medications. So they will address your insulin secretion, they will regulate your alpha cell, they will regulate your weight loss, sympathetic reduction, all sorts of pathophysiological factors on top of weight loss will help your type 2 diabetes patient. So the earlier on is good. Affordability, yes, it's a big question in our population, but people are using it and gaining the benefit.
That is the problem, I think. Affordability becomes, if it is like, we will use it much more as an anti-diabetic drug, if the cost, because the patients want immediate results. So then it goes more towards, that's what everyone is, yes, please add.
I think here we need to explain to the patient about the cost-benefit ratio. You know, you're going to have so many beneficial effects with this drug that you're actually saving up on the amount which is going to be spent on complications later. So that has to be explained to the patient. They may not or may not agree to it, but at least we can explain it.
Yes, one more thing that, of course, people come with, they read everything about the drug and they know all about the names and drugs nowadays when they come to us. And then, so how you will increase, decrease the dose, taking care of these nausea, vomiting, constipation, loose motions. So are there practical tips for everyone that we may not escalate the dose as it is seen in clinical trials, or we may not stop immediately with simple side effects? Can you have your words of wisdom?
Yeah, so before starting the drug, we can always sort of tell them what are the expected side effects, that it may not be there in everybody. So we start with a lower dose, like what has been in their insert, so 2.5 mg, keep increasing by 2.5 mg till you reach a dose of 15 mg. But then it is not going to be, sort of one roll is not going to fit everybody. So it's not like every month you have to increase it. It depends on the patient's tolerability. So if somebody is feeling a little queasy with, let's say, 5 or 7.5, I would take it slow. I would probably give for another 2 or 3 months of the same dose till they get used to the dose, and then slowly up titrate it. And of course, nausea and vomiting could be a potential side effect. But then we do tell them, some dietary tips, avoid, you eat only 80% as much as you're full. Don't stuff yourself, and so your appetite is going to go down. So if the patient has eaten 1 plate of rice maybe before the drug, they should not expect to be eating the same amount. So the quantity, there's going to be a lot of energy restriction. So definitely the quantity of food consumed is going to come down. So that has to be emphasized to the patient. So they eat only when they are hungry, and they stop when they are 80% full. And do not lie down immediately after having a meal. Again, it causes reflux. And avoid these carbonated drinks, avoid fatty food. So these are like small tips that we can give. And some of my patients who have complained, so what I do tell them is I do give them a PPI or an antiemetic on the day of the injections and 1 or 2 days after that, and then they are a little comfortable.
Yeah, so first 3 days they need some support, and that is true, and then we can play with the dose because we are doing clinical practice here. It's not a compulsory research kind of a project, and there is no need to stop suddenly. Definitely de-escalate, treat, and this. Dr. Muthukumaran, what is your thing about diabetes remission with these drugs?
Right. Currently, we are only into 6 months into this molecule, but we are having very good results with weight loss. But we a lot of the times forget that these molecules were made for diabetes, and they are fantastic drugs for glucose lowering as well. So with these new drugs, we should be aiming for a good HbA1c reduction. And what we need to be aware is we need to, before we talk about reduction, when you put patients on molecules in addition to sulfonylureas or insulin, fast reduction of the other agent should be a priority first before we think about HbA1c reduction. So that's one thing. You need to reduce your insulin dosage or your other medications which can potentially cause hypoglycemia, and then think about achieving lower HbA1c levels with the growing weight reduction. So weight reduction is a priority, but you need to look at the patient as a whole and look at long term rather than short term.
Anyone who is interested to ask anything, please come in front of the mic. This will go on, but whatever your questions or thoughts or comments, please be here with the mic. So this is a discussion session, we are not talking. So one more thing, as you said, reducing, just one point I am finishing. Intensive control, we always talk. in type 2 diabetes with multiple drugs, and we want that 6.5. We always say it is good without two enemies, hypoglycemia and weight gain, which I think with these incretin-based therapies are already taken care of, and definitely we can achieve these magic. As we saw with SGLT2 inhibitors, now even with these drugs we will start seeing that good A1C and can happen without hypo. Yes, sir, please.
If the patient is already on 3 or 4 drugs, oral hypoglycemic agents, can we stop and start as a monotherapy of this?
I think it depends on the patient's HbA1c where we are starting from. If somebody is on a very high HbA1c, you don't need to. You add as another agent, take off the gliptin, add this agent together, and as the sugar comes down to normal levels, then you can think about which molecule to cut back. Initially, if the patient is on high dose insulin, you might want to reduce the insulin. Later on, if it's a sulfonylurea-like molecule, you might want to do that next. And weight neutral agents or zero hypoglycemia agents, you can keep it to the last. So that's how I would work. And once the earlier on you cut these agents, the patient will not start eating for low sugar. So if you leave it too late and they are nearing lunchtime, they are forced to eat at 12 o'clock or 12:30, then you are missing the cycle. So proactively doing the titration is clearly important in such molecules when the glycemic status improves. So the patient might not be aware of it. You might want to ask for hypoglycemia, increased appetite prior to the normal meal times, or excessive weight gain in a patient might also be an indicator that they have started eating back again.
Yes, I completely agree. Never stop suddenly everything. It's a very gentle addition of tirzepatide, and then reduce SUs, reduce insulin, and slowly by titrating you can take out a lot of anti-diabetic drugs. Yes. So one more thing, patients come with their data when you start prescribing tirzepatide, and they will ask you about all the questions. I'm taking this question particularly because I face it every day in my clinic, that it associated with psychological issues. So I think the standard questions, how long I have to take it, and that you must have discussed in the earlier session. But about can you just throw a light about this in the real, what evidence we have about tirzepatide?
So I totally agree with you, ma'am, because I've been getting WhatsApp forwards of the Australian government imposing those black box warnings regarding GLP-1 based therapies, where there was an increase in the suicidal ideations. But the recent report is that there's been a separate adjudication committee by the US FDA, and they've looked at all of these studies that we have till now, the data, and there is no increased risk of suicidal ideation or psychiatric conditions because of a GLP-1 GIP based therapy. So that is a sort of reassuring, I would say. And actually when you look at it, when you start a patient who is obese on tirzepatide, when they lose weight, in fact, they're happy. So they come to us, in fact, with an improved mood. They're able to move around better, exercise. So they're sort of happy. I'm not seeing depression or anything. But then we do have the other class of patients who have depression, who are on antidepressants, who are obese, and where you want to start tirzepatide. So that is a class of people where you will have to be a little cautious, involve the psychiatrist, and monitor. So that probably requires a little more caution.
Absolutely right. So one should be vigilant about these things, and obesity, some obesity itself comes with some psychological issues. So a treating clinician should be vigilant, but per se this drug, actually there is an improvement in the mood disorder, mental function. There are a lot of things, good things happen with weight loss. We can say that. You want to add something?
I just want to be a little bit, yes, we are taking food off people's plates off. So anybody suffering from active depression, their medications are being titrated, you want to be more careful. Stable phase depression, already on established treatment for 6 months, we are happy to try if they want to lose weight. Patients who have had previous depression, they are doing well, they are stable, yes, go ahead. But anybody who is just on the initial phase of depression, or they've undergone a recent bereavement and you're throwing them on something like this, you need to be really a bit cautious.
Yes, so thank you so much. Just a quick advice from you for your routine things to avoid less in lean body mass, when patient is on tirzepatide with type 2 diabetes. So clinically what should they do? Like other than exercise training exercises?
Oh, I just had a talk before this.
Oh, okay,
About
perfect. So
half
you
an hour
have
I
already
talked
finished. So
about
I am very happy the time is off. So thank you so much, Dr. Annie and Muthukumaran, and thanks the debate conference. So.
Thank you so much, all the three speakers, for the wonderful session we had. Moving on to the next session. The next session is on Translational Research Symposia. And to chair the session, may I call upon a senior endocrinologist, Dr. S. Murthy, to come to the stage. Over to you, sir, and the next 40 minutes is yours.
Sorry, I was chairing the session in the other hall. Sorry for the delay. We now go on to Translational Research Symposium, and it's a question and answer session on bedside questions, bench answers in beta cell biology. Two eminent speakers, and the first talk will be by Dr. Nikhil R. Gandasi. He's an assistant professor, Department of Development Biology and Genetics, Bengaluru. Research interests: membrane trafficking, pancreatic islets, vesicle exocytosis, cell biology, and diabetes. Over to you, Dr. Nikhil Gandasi.
Hello, can you hear me? So the session was supposed to be together, I guess, me and Professor Rohit Kulkarni.
Yeah. So you call both Rohit and him onto the stage, or both can be there together.
Yes. Okay. I'm told it's a duologue, so I request Dr. Rohit Kulkarni also to join us on stage. And he's Professor of Medicine and co-head of the section on islet cell and regenerative biology, Director of the PNF program, DRC at Joslin Diabetic Center, Harvard Medical School, Principal Faculty at Harvard Stem Cell Institute, and Associate Member of the Broad Institute, Harvard Medical School. So over to both of you.
Thank you very much to the organizers and to the chair. I just wanted to give you a little bit of an overview of what we're going to do, because it's slightly unusual. This is going to be like an interactive session, as was mentioned in the context of translational medicine. So me and my colleague, Dr. Nikhil, will take turns to put up slides for you to get a little bit of the background, a little bit of the flavor of what we wanted to discuss. And then we'll open it up for discussion on 3 topics. And then we'll follow each one of those with an MCQ, giving you the options, and then we can discuss the right or wrong answer. So I'm going to start off by this initial explanation of what we want to do, then followed by Dr. Gansi. So these are the training, the 3 learning objectives. We hope that at the end of this session you would be able to understand the concept of insulin signaling and resistance in the beta cell, regulation of crosstalk between 2 chief components of the pancreatic islets, namely alpha and beta cells. And then finally, we also want to give you a little bit of a flavor of the most recent ideas about GLP-1 and insulin itself for beta cell targeted therapies. And here I'm talking about how exogenous insulin can also benefit the beta cell as opposed to hepatocytes, adipose, and skeletal muscle. So the first one I want to set the stage for is, do beta cells have insulin receptors? I'm sure all of you from your medical training and all the other types of lectures you go to, you always think about insulin signaling in peripheral tissues. And the peripheral tissues that come to mind are the hepatocyte or the liver, the adipose, and the skeletal muscle. But what is missing in this entire concept is, what about the beta cell? Does it have insulin receptors? So I wanted to make sure that we understand that the beta cells also have insulin receptors, in fact at the same density or higher density than the other tissues. And so how come we are neglecting insulin action in the beta cell, but we only talk about insulin action in the peripheral tissues, which are the tissues that take up glucose? So the concept of insulin resistance and also the concept of granule biology in the beta cell. And so this regulation of glucose homeostasis, I'm sure you guys don't need a lot of discussion about, but just to make the point that, let me see here, I go back. Just to make the point that that insulin, which is secreted by the beta cell, and according to my own personal view, the beta cell is the most important cell in the entire body. I'm sure a lot of other endocrinologists are here, but we can have an argument another day. Beta cell produces insulin. It has an effect on the liver. It also has effects on muscle and fat. But what about insulin having an effect on the islet itself? So an effect mediated by insulin in the circulation or in the ambient ambient islet environment, having an impact on pancreatic islets in the individual cell types. So hypothetical model here in the context of this approach that we and others have proposed is that initially you have insulin resistance which develops very early on, much before hyperglycemia, and that can be related to some components of insulin resistance in the beta cell itself, that you have hyperproinsulinemia. There are components of proinsulin which are being secreted in the circulation, and this has been shown in clinical studies, and that has been taken off as just insulin, but potentially it is hyperproinsulinemia, and that is because of a dysfunction of the beta cell. And that can in turn lead to go back to the beta cell to cause ER stress, which then leads to this vicious cycle of hyperinsulinemia. And that, when it fails, the beta cell fails, it leads to hyperglycemia. So with that in mind, again, considering this short format, I want to mention that me and others have spent the last 2.5 decades to understand insulin signaling in the beta cell. So shown here is a cartoon which gives you all the different components of the beta cell signaling pathways, and chief among those are the insulin and IGF-1 receptor. And number of these components in the downstream of these signaling pathways can modulate the function and growth of these beta cells. So I won't go into great detail, but I would recommend that you go through the PubMed or the other literature, but I'm happy to pick up any questions that you might have. But let's, for the sake of the argument, show that the beta cell is as sensitive to insulin as the hepatocyte or the adipocyte or the skeletal muscle. So we want to extend that argument that the insulin resistance in the beta cell is among the chief early defects which leads to a series of steps which progresses to beta cell failure. And so that is something I wanted to propose, suggesting again that the beta cell produces insulin and has an effect on itself. So I want to let my colleague Dr. Nikhil go on to give you the second part of the discussion of this part of the session, and then we can open up one question.
Thank you, Dr. Rohit. I think it's very nicely introduced what beta cell does to itself and what beta cells does in general. So I'm just going to put this picture back in saying what beta cell is all about. And when you think of a beta cell, you do see many clusters of cells in the islet, and this is one of the cells that is being depicted there. So for insulin secretion to happen, there's uptake of glucose, which is the first step that is there, which you see on top there. And then there is, of course, glycolysis and things like that, leading to ADP increase and then increase in calcium. And this is what leads the insulin-loaded granules, which are there, which are those granules that you see there. Those are the ones which fuse to the plasma membrane to release insulin. And this is something which leads to biphasic pattern of secretion that we see here. So surprisingly enough, when you look at biphasic pattern, normally you see all the pattern that you see in the peripheral blood. This is what you see with the pattern when you try to do the sort of OGTT or something like that, right? So this is in the peripheral blood. But if you think about the whole pancreas, there as well you do see a very nice synchrony that is developed. And when you look at, this is the whole islet, and you take islets and you try to stimulate them with glucose in the lab setting, then also you do see a very nice biphasic response. But also when you look at single cells, you isolate these green cells from them, and then you stimulate with glucose, you do see a very nice synchronous response in the non-diabetic individuals. So this is data from isolated cadaver transplanted individuals there. You do see with type 2 diabetic individuals, there is very less first phase, and almost second phase also is very little that you see there. So trying to put this into context, you see biphasic response from single cells, from whole islets, from the whole pancreas, and also what you see in the peripheral blood, which you might be very well aware of. So now going next, what comes up next is the questionnaire that we have. So this is the format where we have where we try to explain the concept and then try to derive from it. So you think about it and then you answer. That's the idea there. So the question in this case is, so type 2 diabetes is characterized by insulin resistance in only one place, which is the liver or the adipose tissue, skeletal muscle, or it includes resistance from all the tissues. I think Rohit you want to take the mic? So if someone can circulate the mic, or I don't know if this can be done on the poll.
Yeah, as I presume it's going to be done on the poll, but I guess we also wanted the audience to come up and challenge these concepts so that we are sure that you realize that there are differences in the way that we are understanding the concept of insulin resistance. So I'm sure there are many clinicians who focus mostly on peripheral tissues such as liver, adipose, and skeletal muscle. So feel free to come up so that we can substantiate what we're trying to suggest here in the context of insulin resistance in the beta cell. So I don't know whether the chair has any comments or perhaps yeah. So it looks like we have convinced the entire audience here that the beta cell is insulin resistant. And so I think then it opens up the question about, maybe that's the third session that we wanted to talk about, but it also questions the approaches for therapy. So when you go to the clinic, when you see patients with type 2 diabetes, all of you are saying that the beta cell has insulin resistance, and yet the therapies that are chosen are targeting only skeletal muscle, adipose, and the liver. So there seems to be a disconnect here from what I'm seeing here and what is likely being done in the clinic. So I want the clinicians to step up and tell me what exactly you guys do when you see the patient with type 2 diabetes. What is the first line of therapy that you propose, and what is the rationale for that?
So we can circulate the mic, I guess.
Would it be a combination therapy of addressing both the defective secretion as well as resistance?
Absolutely, that's a good point. So I think that perhaps again there is a little bit of background here. You know, you have the Caucasian population where insulin resistance is likely a predominant feature because individuals in the Caucasian population have a higher BMI, but one would argue that India is catching up in terms of higher BMI. But historically speaking, 50 years ago, you would see that the obesity epidemic hit the Western population at a higher level, and they instituted a number of therapies to address specifically obesity-initiated insulin resistance. But the eastern side of the world, which includes India, China, and Japan, I'm sure all of you are realizing that the BMI is a little bit low. BMI is high in many individuals, but even individuals with a low BMI, with 20 to 24, will manifest beta cell deficiency or insulin resistance. And the argument now is that there are different subtypes of diabetes, which I'll get into a little bit later on, that the concept that insulin resistance is the only feature of type 2 is being replaced, I think, relatively quickly into different subtypes of type 2. So when someone walks into the clinic, if he's obese and he's 50 to 70 years old, one could argue that insulin resistance would be a feature. But let's look at somebody who is about 30 or 40 years old, who's very lean and still has an HbA1c about 6 to 7, then the diagnosis, I think, would be still type 2, but the subset of type 2 would be different from the other individual. So the therapies for these two subtypes of type 2 would be different. And as the chair pointed out, perhaps putting a beta cell therapy initially along with the insulin resistance therapy would be preferable as opposed to just hammering away at insulin resistance, because this individual is not going to respond. So I think that was the message that we wanted to convey here, that insulin resistance in the beta cell has an amount of data that is accumulated. Many of these studies have been done in humans. I didn't have the time to show that, but my colleague and I, Dr. Alison Goldfein, undertook a series of experiments to inject exogenous insulin in individuals, in normal individuals and insulin-resistant individuals, and we could show that exogenous insulin is able to enhance glucose-stimulated secretion in the normal individual, suggesting that exogenous insulin has a positive effect in the healthy individual. And this effect of enhancing glucose-stimulated secretion is blunted in individuals with insulin resistance or type 2 diabetes. Very clear demonstration that exogenous insulin fails to have an effect on type 2 individuals as opposed to normal individuals. So the concept of insulin resistance in the beta cell, which needs to be considered in therapy. So I'm still seeing no people walking up here, but I'm sure you're going back to the clinic and you likely go back to doing the same thing. So I would urge you to think carefully next time when you have a patient walking in and consider the possibility that beta cell therapy is equally important as opposed to just addressing insulin resistance.
Just some underlying questions that we were discussing today morning with Dr. Arvind when we were making these slides when it came up. So in fact, these beta cells secrete insulin, but they also have an autoinhibitory loop where there is an autocrine effect that comes into play, right? So they can also auto-inhibit themselves. But then they are there in a pool of cells. There are many beta cells in an islet. So these are all together. So there's also a paracrine loop that is coming up. So there is this concept of leader cells and hub cells that comes into picture. So there is one cell which carries the load and then takes things further, and then the other cells follow suit. So we have been speaking for a few months now with Dr. Arvind regarding beta cell mass, how can we measure it and things like that. So today also with Dr. Rohit on board, we did speak about it. So one of the things to think about is when you do your OGTTs, so what is the area under the curve with respect to glucose stimulation and also with respect to insulin secretion. Maybe that will define the cell mass that is there and how is the response to these kind of things. Arvind has a question, I think.
Yeah, please.
Ask a question at this time. Okay. I'm going to ask a question like a physician. Okay. I'm a doctor. I'm not a scientist now. I see a patient walking into my hospital with a blood sugar of 300, HbA1c of 9. I have no idea about insulin resistance, insulin deficiency or anything. Nor can I measure how much of insulin can actually come out if I give a sulfonylurea or a non-sulfonylurea. Can I manage him with metformin? Because there are no drugs for beta cell resistance. We know the theory. Now what can I do as a physician now? What do I treat this patient with? That was the question, because it's excellent when we hear the scientists. Now I don't have a drug for beta cell resistance. I have a drug, pioglitazone, for insulin resistance. But can I start with an insulin resistance drug? Can I start with the pioglitazone? These are my questions. And how do we measure? I mean, apart from C-peptide and basal insulin levels, I don't have anything to measure this particular resistance.
Yeah, no, that's a good point, Dr. Arvind. I think we kept the third session focused on GLP-1 and beta cell targeted therapies, so we could come back to that. But just as a short answer to your question, there are now algorithms which have been put forth by Dr. Elquist and others from Sweden and also from the Broad Institute in the US, and I'm sure Dr. Mohan also has these algorithms here, that you can quickly calculate whether this individual, based on BMI, age, lean body mass, and perhaps insulin and glucose as well, whether he or she will fit into one of the subtypes of these type 2 diabetes categories. That could be the first step, that you say, okay, based on these algorithms, which are based on scientific data, has been confirmed by multiple ethnic populations in Sweden, in the US, and in Singapore, in China, and in India. The algorithm allows you to push these individuals into one of the 5 subtypes. That, I think, is fair enough. So first step would be to put them into those subtypes and then begin to consider what are the options. And perhaps when we come to the options, we'll come back to the third part of the talk.
Sure. With this, I think if there are no questions, we go ahead.
Right, we'll go on to the next part of the talk.
So these are the 3 learning objectives which was picturized to start with. The first one is what we covered up regarding the concept of insulin signaling and resistance in beta cells. So we go on to regulation of crosstalk between alpha and beta cells. So how do they talk to each other is the next thing. So when you go into this, I would again hand over the mic back to Dr. Rohit there.
Yeah, so extending the discussion again, this is an islet session, so we wanted to talk not only about the beta cell, but also the alpha cell. Now, we talk about insulin resistance in the alpha cell. What about insulin resistance or effects of insulin on the alpha cell itself, which can then regulate glucagon secretion, right? We all know that glucagon is critical. When you're fasting, the glucagon has to activate your liver to make sure that your glucose levels are maintained in a normal, healthy state. And individuals with type 2 diabetes, this goes awry and the glucose continues to be increased because the glucagon effects on the liver are compromised. So how does the alpha cell fail to detect this? And that also, in type 1 diabetes, also has effects in the context of hypoglycemia. So both of these led us to propose an experiment many years ago to show that, first of all, insulin receptors are expressed on the alpha cell, which has already been shown. And the second is, how can we begin to show how insulin acts on the alpha cell and regulates glucagon? So we did a series of experiments in cell lines and also in human alpha cells, which are available with great difficulty. But then we had to do a model, a mammalian model. And obviously we can't do a human model, so we had to do a mouse model. So in the mouse model, we decided to remove the alpha cell insulin receptor, right? To genetically engineer the model so that you can take away the alpha cell insulin receptor and then see how the mouse behaves in the context of glucose tolerance, or you put them on prolonged fasting, how do they handle hypoglycemia. And as I mentioned, when you put them on prolonged fasting, glucagon levels should go up and then increase the amount of glucose from the liver. And so in this model, I won't go into great detail because of lack of time, we reported that insulin signaling is able to modulate glucagon secretion in vivo. So this would suggest that in the normal situation, in all of us, in healthy individuals, insulin signaling is intact in the alpha cell. So there is circulating insulin, and that is able to regulate glucagon secretion from the alpha cell in states of hyperglycemia and hypoglycemia. When I say hyperglycemia, I'm saying postprandial in a healthy individual, and fasting after you sleep and you wake up, the glucose levels are maintained. And all this is dependent upon healthy action of insulin on the alpha cell. When there is insulin resistance on the alpha cell, so for example, when you have a genetically engineered model, or in humans with insulin resistance, either with type 2 diabetes, prolonged type 2 diabetes, or patients with type 1 who have been injected with insulin repeatedly over many years, that would lead to insulin resistance. Those individuals fail to enhance glucagon secretion during hypoglycemia, and that would worsen the scenario. So this is very clear from this particular study that we reported. And without going into too much detail again, but I just wanted to emphasize a series of papers that we and our colleagues have shown that the effect of insulin shown here has a relationship between the amount of insulin that is secreted, the amount of glucagon that is secreted, the observed glucagon and observed insulin secretion, and what happens when you have insulin or no insulin in the circulation. So I hope I've made made some, provided some clarity that in addition to the beta cell, in addition to the hepatocyte, the adipocyte, and skeletal muscle, the alpha cell also has insulin signaling pathways, and that insulin resistance in the alpha cell contributes to poor responses to hypoglycemia in individuals advanced type 2 diabetes or advanced type 1 diabetes on continuous insulin therapy. So I'll stop there, and I'll request my colleague here to give you the second part of it in terms of the molecular pathways.
So thank you, Dr. Rohit. Just continuing on the same lines, what we did was we first started looking at single cells, single alpha cells again in this case. So it's a big challenge to try to dissect, let's say, single alpha cells either in the human or in the mouse. Because if it's a transgenic mouse, it's all the more easy, no problem at all. But if you are thinking of cadaver islets that you get, and then you want to label only alpha cells, then you're completely dependent on a promoter, which is the glucagon promoter. So in this case, what we successfully did was, based on the glucagon promoter, we could only label the cells, the alpha cells, which would turn green then. That's the one that you see in the upper panel there, which is all green there, you see there. So this is what is, it also shows that with an antibody, which is anti-glucagon, it only labels alpha cells. And surprisingly, we were of the opinion that, well, these donors are all healthy, so they would have similar levels of glucagon secretion as the type 2s. Surprisingly, it was not the case, it was lower. So this is quite a contradiction, because there's also studies in the mouse which says that there is more glucagon secretion when there is type 2 diabetic animal models and things like that. So it was in contradiction to that, in fact. But when we went on and tried to see this in the individuals, we do see that the glucagon excitosis, which is plotted on the y-axis there, and the HbA1c, which is plotted on the x-axis here, you see these red dots there, those are the diabetic individuals, and all of them have less of glucagon excitosis that you see there. And that goes very well with these dots here, which are the glucagon granules that are present, and all of them do have less of glucagon granules present in them. Just goes to show that there is less glucagon secretion in this, in terms of diabetes. How does this make sense? This makes sense because, as Dr. Rohit rightly pointed out, there is glucagon insulin receptors that are present. So this is an alpha cell, and you do see a beta cell. All of these also react to GLP-1, which we'll go to later. But then the biggest thing is that with respect to these alpha cells, the glucagon granules are also compromised in case of type 2 diabetes. That's the message that I wanted to put up here. And there's a huge crosstalk in the sense that beta cells are doing something which leads to less of insulin secretion, and alpha cells are doing their thing, which also means less of glucagon secretion. They are talking to each other, and both are compromised in that case. Normally you would think that one is compromised and the other is not. In this case, we do see both are compromised. So, which lays the question, which is this one here, is paracrine crosstalk relevant for GLP-1 based therapies for type 2 diabetes? Is paracrine effects with alpha cells and beta cells important to take into consideration when therapies are designed, is the question there. So you can take the poll.
So just want to point out there are 4 options here. One is that you have paracrine crosstalk is between alpha and beta cells, or is it only in the beta cell? I also want to emphasize that there is different subtypes of beta cells, so there could be paracrine regulation among different subtypes. There are 6 subtypes that have been shown. 2 of those subtypes in patients with type 2 are compromised. So is it only the paracrine regulation between the beta cells? Third one, the option is crosstalk among all cell types. Islets have 5 different cell types, right? Alpha, beta, delta, somatostatin producing cell, and the epsilon producing cell, which secretes ghrelin. So is there a paracrine dysregulation among all the subtypes? And I'm particularly looking at relevant for GLP-1 based therapies for type 2. So, or none of the above. And again, please feel free to walk up to the mic to open the discussion, or challenge the areas of work. So it looks like many people are suggesting it's it's all islet cell types, and then you have between alpha and beta would be 30%, and among the beta cells, heterogeneous subtypes would be 20. Of course, we didn't talk too much about the other cell types, but one could argue that the delta cell is also playing a role. Somatostatin producing cells are also playing a role because they have inhibitory effects on the alpha cell and the beta cell, and that could be compromised in the context of regulation.
Could you elaborate on the role of somatostatin in this, because it's not talked about at all?
So the question was, can you elaborate on the somatostatin producing cell, because it's not discussed at length. Do you want to take that, Dr. Nikhil?
Yeah, sure. So delta cells have a particular role here. The number of delta cells are too few in an islet, but then somatostatin that they secrete has receptors both in beta cells and in alpha cells. So somatostatin's effect on alpha cells has been very well established. They play a very big inhibitory role. On beta cells as well, they have a very regulatory role to play. But on the other hand, when you think of somatostatin, you're always thinking of controlling the alpha cells. That is the primary target that is thought of. But on the beta cells, not much is thought of. So there is an idea that is again with the hub cells that came into effect, that is it delta cells which in fact drive the beta cells to secrete more and more insulin? Is the delta cells secreting sort of somatostatin so that can be sensed by beta cells, which can take over much later? So that could be one of the things that can follow up, but we don't know exactly the evidence to say that those are the hub cells which are driving the beta cells yet, I think.
Yeah, so I think just to add to the point that Dr. Nikhil mentioned, so there is evidence that the delta cell can also contribute to the paracrine regulation of the alpha and the beta, and since insulin receptors are expressed on the alpha and the beta, one could argue that all islet cell types are part of this paradigm, which can be affected by insulin resistance. So it could be the top answer. I think we have a question here. Yeah.
I'm Dr. Sriram. I recollect reading during our training regarding the way the cells are arranged in the islets. The blood flow is from beta to alpha and that used to be an anatomical histological reason for why the beta cell has an effect on alpha cells. Like once the food comes and the insulin comes, it suppresses the alpha cell, used to be our standard way of explaining. So that's why in pancreatic diabetes, where both cells can get affected, and we explain why certain diabetic subtypes don't go into DKA, ketoacidosis, based on this beta alpha getting affected together, or one below, one after the other, or whatever.
Yeah.
So is these, is this still holding good, or this is now more hormonal?
No, I think you're right. I think the concept still holds. So what Dr. Sriram was mentioning was the blood flow is within outwards. So the blood flow is called BAD. BAD means it starts at the beta cell, and the blood collects the insulin, output from the beta cell goes downstream to the alpha cell and then to the delta cell. So it's BAD, bad circulation in the normal scenario. And then when there are effects of insulin resistance, the effect of the beta cell on the alpha cell, normally it's suppression, that is lost. That leads to more glucagon being produced. And then the dysfunction between the beta and the alpha would then have an implication for the delta cell, because delta cell usually inhibits both the beta and the alpha cell. And when the initial circulation is compromised because of the insulin resistance on the alpha and the beta cell, it also impacts the delta cell. So that concept still holds. Obviously, it's very difficult to design experiments in humans within the islet architecture, like in our islet architecture, right, in vivo. So all this has to be done ex vivo, but this concept still holds.
If I understood correctly, you are trying to say that this insulin resistance at the alpha level, which is causing the hyperglucagonemia.
Right.
And from the context of GLP, obviously, it has nowadays we are having now one molecule having effect on all the cells now. So I'm sure the answer for this question is more complex than
it is. So we'll come back to that in the third part of the final part of the session. Yeah.
Great. With that, I will just go to the next slide then.
Yeah. Any other questions? Okay. Yeah. So the last one would be the relevance of GLP-1 insulin, and I think we touched upon the therapies. We just want to open this up because this is where I guess the clinicians would be wanting to get more information or in the context of discussion, because we all want to talk about therapies. So this is what I alluded to, that in the 20th century, the type 2 diabetes was considered as predominantly targeted by insulin resistance. And this is what my mentor and I had a debate about. But we know when you come to the 21st century, we now know there are different subtypes of type 2 diabetes. And that's why the argument that perhaps when a patient comes into the clinic, you could use the algorithm to get a vague idea as to which category this would be involved in, and based on the availability of resources to do additional experiments or additional tests to categorize this individual. You have a predominant beta cell deficiency. Are they defects in proinsulin? So they would all go into the category of beta cell defects, right? These two would be about 40% of patients. Or the other fraction would be those individuals with obesity. And those individuals would have predominantly insulin resistance. But one could argue that even the obese individual with insulin resistance could have beta cell defects, because I just showed you that insulin resistance occurs also in the beta cell. So we would argue that these three categories of type 2 all have beta cell deficiency. And so the beta cell therapy should be targeted in these individuals. And then you would have these individuals with lipodystrophy or liver lipid defects, which are predominantly related to insulin resistance. So with this background, then we did an experiment to begin to look at the therapies that Dr. Arvind mentioned, and also the interest in how we want to address this. So we know that GLP-1 receptor agonists and all these GLP-1 based approaches target the beta cell as well. Apart from growth effects, which has not been shown, they don't push the beta cell growth, but they push secretion. And they also preserve the beta cell. So I have anti-apoptosis effects on the beta cell. So overall, I think everyone, the scientific community and the clinical community agree that GLP-1 based therapies are good for the individual, targeting the beta cell, and also now multiple other tissues. I mean, now it's exploding to affect everything. But I want to focus on the beta cell with this concept. So we asked, with this background, can we create a model where the insulin resistance is there in the beta cell and then push them with GLP-1 therapies? So we did one experiment in a model that I mentioned to you early on, which is called the BERCO, which is insulin resistance in the beta cell. So we knocked out the insulin receptor only in the beta cell to create a model. So this model is diabetic because of the insulin resistance in the beta cell. And so we treated this particular model with this particular compound, vildeliptin, which is a DPP-4 inhibitor. And now we have done other experiments with other GLP-1 receptor agonists to understand how this can affect the glucose homeostasis in a model with beta cell insulin resistance. And I think, did we miss a slide here? Yeah, so it looks like one slide is missing here. But just to give you the outcome of this study was to showed that GLP-1 based therapies are still able to enhance insulin secretion even when there is insulin resistance in the beta cell. So we think that GLP-1 based therapies would be an ideal approach for those individuals who are showing beta cell deficiency, especially in the Indian subcontinent or the eastern part of the hemisphere, as opposed to overt insulin resistance. And so the argument that perhaps in those individuals who are reporting to the clinic and can be classified into those three categories, whether it's beta cell deficiency, might benefit very early on with GLP-1 based therapies. There's also an argument that perhaps we can also put them in short-term insulin therapy. There are studies carried out in the 90s and 80s by Tim Garvey and others. I just wanted to make one brief point that individuals, when they're initially diagnosed with diabetes, if they go on short-term intensive insulin therapy, right, 4 weeks, 6 weeks, it has been shown in these individuals they're able to preserve their beta cells. And this is based on the data that I showed you, that insulin is having a protective effect on the beta cell. It has the effect on the adipose, liver, and skeletal muscle, but the effect on the beta cell is to preserve it. And so this intensive insulin therapy in these individuals is able to make them insulin independent over a period of time. So these are the two paradigms, I think, based on the discussion that we have today. Is the GLP-1 based therapies works in beta cell insulin resistant individuals. Short-term insulin therapy promotes beta cell preservation and beta cell health. So I think I'll stop there and give Dr. Gansi a...
Thank you, Dr. Rohit. I think I'll just continue the same thing with a little bit of a twist there, just not focusing only on GLP-1, but also other modulators of beta cells. So what else can you use to modulate beta cells? So one of the things that comes up is glucose transporters themselves. So glucose transporters themselves, so these are labeled here, as you can see. So these transporters are the ones which take up glucose to start with, and our recent studies showed that the number of transporters that you see on the membrane of the type 2 diabetic individuals, they are fewer compared to non-diabetic individuals where there are more transporters, meaning to say that there is less of glucose uptake that happens in the beta cells of these individuals. So how can we solve that? So in this case, if you try to expand it a little bit, there are so many SGLT inhibitors, and also there are so many glucose transporter inhibitors that are used in the clinic. Glutar and all of these are examples of it. But that works very well in terms of peripheral tissues. But when you think of beta cell itself, you want the GLU2, which is the primary transporter, to take up more and more glucose, so it can secrete insulin. Sort of a counterintuitive effect, so that there is more secretion that happens. So with this interest, we did screen a lot of small molecules, and we hit upon one of the small molecules, which is furforbidae here, which helps take up more of glucose into the single beta cells. But this has to be tested. This is only in animal models that we have seen until now. We have not tested anything in the human setting or anything like that, so we don't know really how it works. But this is one of the sort of creating hope is what I would call it as. But how would you make it work specifically for beta cells? That's a different challenge altogether, because if you give something, then all the other cells also take it up, which is not a good thing in this scenario. Just with this sort of, maybe not questions but answers to a problem, I'll just leave you with these questions. Are the current advances in treating insulin-resistant beta cells good enough? What are the different advances? So primarily it is GLP-1, and then there's exogenous insulin that comes into picture, and then I did tell you about glucose transporters which is being given. All of these in combination is the other option. So you can take the poll.
Could you extrapolate all this information into how some individuals go into remission?
So I guess the chairman is referring specifically to the short-term intensive insulin therapy. Yeah, so I didn't show the data here, but we have done experiments to show that when you increase exogenous insulin by infusing insulin in healthy humans, that leads to enhancing glucose-stimulated secretion. So in healthy individuals, just increasing from the baseline to potentially postprandial levels for just 2 or 2.5 hours will lead to increased glucose-stimulated insulin secretion. So that would be a beneficial effect of increasing insulin. So that would argue that just a short-term insulin therapy for a period of days or period of weeks in individuals with very early diagnosed type 2 diabetes would be beneficial for the beta cell, because it would enhance the anti-apoptotic and health of the beta cell. And we have shown that when you do this in individuals with very advanced type 2, this does not work so well. So the beneficial effects would argue for early diagnosis of patients with type 2 diabetes.
I have a question. Why have we not included sulfonylureas in this, considering that they also help produce insulin, because that's also standard of care?
Yeah, we excluded sulfonylurea because this is current advances. So sulfonylurea has been there for years and years.
But so have DPP-4s and insulin.
Right. But conceptually, I still think that the exogenous insulin short-term therapy is still based on data that we are providing in terms of how insulin has an effect on the beta cell itself. But yes, sulfonylureas could be one of the categories to enhance secretion, but we also know of sulfonylurea failure, right? So we know that potentially over a period of time, they might fail, and the question is, are we okay with providing that as a therapy for those individuals, as opposed to these, where short-term insulin therapy potentially does not have an effect of failure, at least in scientifically speaking. But yeah, sulfonylureas are potentially as well. I know we are right on time, but I hope this was instructive and useful, and I'm sure the discussions will continue. But I hope that I responded to some of the questions that came up, and obviously we are going to be around to answer any of the questions that might come up. But is there anything else, Dr. Gansi?
So I think in the interest of time, we can probably close the session, but
I'll leave it back to the chair to manage.
Thank you very much, Dr. Nikhil Gandhari and Dr. Rohit Kulkarni for that very interesting session. Just like most of you or all of you, I have also learnt a lot. I think it's been a learning experience for all of us. And most important, you have managed to stimulate the gray cells in the postprandial period. So I think we have all woken up. Thank you both so much for this very interesting dialogue.
So thank you both the speakers as well as the chairperson for such an insightful and informative session. So with this, we'll move on to the next session. The next session is going to be about clinical case study, and we are going to have an interesting discussion here. So to moderate this session, may I call upon Dr. Vijay Bhaskar Reddy, a senior consultant endocrinologist from Pondicherry. Over to you, sir. And the next 40 minutes is yours.
Good afternoon to all. Next we'll be moving on to an important clinical case scenario, clinical case seminar in our clinical practice. So we know that diabetes is in explosive proportions in India, and as compared to Western countries, we find that our patients are developing diabetes a decade or two earlier than our Western counterparts. So we are going to discuss the approach to new onset diabetes in the young adult. So we have a esteemed list of experienced panelists here. So Dr. Ranjit Unnikrishnan, who is consultant diabetologist at Mohan's Diabetes Center. Dr. Shruti Chandrasekharan, Senior Consultant Endocrinologist, Rela Hospital and Gleneagles Global Hospital, Chennai. Then we have Dr. Kumaravel, who is Director and Consultant Endocrinologist, Alpha Hospital and Research Center, Madurai. And Dr. Sriram Mahadevan, who is Professor and Head, SRMC, Sri Ramchandra Medical College, Chennai. Okay, so as I told, the topic will be on approach to new onset diabetes in the young adult. So I would just start off with a clinical case which I saw last week in my outpatient clinic. So 24-year-old girl, she's studying MBBS, an internship actually in Chennai. She was feeling dizzy while on duty, and they just checked glucose by glucometer. It was 520 milligram per deciliter. And on questioning, she had polyuria for 1 week duration. So in this regard, I will just ask you to join this Slido quiz and answer this question. Just scan the QR code from your mobile and answer the question. So what is the age range to define young adult in relation to new onset diabetes? So because we're going to discuss about the new onset diabetes in young adults, so how will you define young adult? 18 to 25 years, 18 to 30 years, 18 to 35 years, and 18 to 40 years. Okay. think it's just changing. Good. I think so most of you feel 25 and 30 years. Some of you think it's changing again. Okay, so we have a variable response. So I think young and old defining is a bit difficult. That is why you find the variable response. And as we age, we feel that even 65 is young. So people can feel 45 is young, 65 is young. So we'll see at what definition we'll see, but you can see the majority feel 18 to 25 years and some of you feel 18 to 30 years. And maybe in the Western countries, it may be 45 years also. So we'll come back to this at the end of the discussion. So next question. So this girl presented to us with polyuria of 1 week and glucose levels was 520 milligram per deciliter. We can do a lot of approach and management. So what is the next best initial investigation? So would you call the next day to a fasting and postprandial glucose? Would you do a HbA1c? If the choices are changing, it's very labile. Okay. So would you do a C-peptide or would you do a urine or blood ketones, whichever is available? Okay, so most of you have chosen urine or blood ketones, and some of you have chosen C-peptide and HbA1c, and we'll come back to the answer at the end of the discussion, but anyone that's symptomatic with very high glucose levels, you don't need to repeat a glucose level the next day, or you can just start treating if they're symptomatic hyperglycemia. So with this, I'd start off the discussion with the first question. Dr. Ranjit Unnikrishnan, who is consultant diabetologist at Dr. Mohan's Diabetes Center, Chennai. So what did you take as the rough age range to define young onset?
See, I think there is no controversy as to what the lower limit is, because now the cutoff for pediatrics has moved from 13 as it was in our days to 18 as it is in the rest of the world. So there is no question regarding the lower limit. The upper limit depends on the average age of onset of type 2 diabetes in the population. For a population like Indians, where type 2 diabetes occurs at younger age, we tend to take a lower upper range for young onset diabetes. So as per the ICMR, Indian Council of Medical Research, who have set up what is known as a young diabetic registry, the upper age of cutoff for saying young onset diabetes is 25 years. I agree, before this YDR came on, we have used the cutoff of 30 for so many of our studies, but now the consensus is towards keeping the upper limit at 25, which by the way is also the cutoff given by Tattersall and Fahans in the definition of maturity onset diabetes of the young. So 18 to 25 seems to be the most appropriate. You wouldn't be far wrong if you said 18 to 30 also.
Any of the other panelists have got any difference in opinion? Sriram?
I mean, you can be young at heart, you can be metabolically young but chronologically old. All these are, I fully agree, based on this study, physically and by definition of diabetes, that's a very logical scientific way of looking at it. I remember our MD days when hypertension in young, stroke in young and all, we used to define by 40. And diabetes that time was 35, if I'm not, or less than 30, means type 1, more than 30. All are becoming blurred now. Age is no more.
Yes, Dr. Rohit.
So I had a question for the panel, because I think, in India, I don't know how different it is, but at least in the US and the Western hemisphere, you have individuals very young showing type 2 diabetes. So Hispanics, like 8, 10
You'll
years
hear
old.
more of that now.
So what do you guys think is in that context, what is the lower limit of the age which begins, because type 2 diabetes, we're all taught in medical school to be, typically 40-year-old individual, walks in with tiredness and so on. But now it's 10, 12 years old. So where's the concept of that in India?
It's probably between 20 and 25, and I'm sorry. It's probably between 20 and 30 or 25 and 30 that the prevalence of type 2 diabetes starts exceeding that of the less common forms. So that's where the controversy rises. Is it 25 or is it 30? But I'm sure as time goes by, what has happened in the West is also going to happen in India. The youngest patient with phenotypic and proven type 2 diabetes whom I have is around 7 years old. But it's rare in that age group. Generally, it's not very common in that age group at all.
that would come more in the pediatric, so in that age, but he's right, we see very young 7-8-year-old with type 2, it's very similar to the Western data. That's where Sriram said age is just getting blurred right now because it's no longer.
I think what we are discussing is young adults, so 18 to above, so we're discussing the upper limit cutoff, so we're not going to the lower limit cutoff today. So Dr. Shruti, what percentage of diabetes patients in your practice would you think they fit into the young adult age at onset? Do you think the percentage is increasing and any specific reasons?
Somewhere around, I would say somewhere around 30 to 60%. I think majority of my practice would also involve this fertility age group. I think a lot of women with polycystic ovarian syndrome, insulin resistance, planning fertility, a lot of type 2 diabetes as well, and maturity onset diabetes in selective few. So I would say, I think because of that, I think somewhere around 30 to 50%, I would say certainly, somewhere around that age group. Yeah.
Okay.
I think because
less than
of
25 years age?
Yeah. Because I think mostly because of the fertility context.
Yes.
I think that would differ from one practice to the other. I don't think we can generalize this number.
No, people are getting married after quite late, no? You are getting less than 25.
No,
so.
I think, a controversy like it, I can't answer this, but I think.
No, generally around, she said, wherever you practice, what is the kind of patients you get? And cutting across anywhere in India, you are getting almost at least 1/4 to 1/3 or.
I think when you try to look at the onset of diabetes, below 25 years, it would be 10 to 20. We may be seeing them at 30 years or 40 years more, but when you try to look at onset less than 25, it would be roughly 10 to 20%.
It's around quarter of our patients probably.
Employment checkup, they do, no? First employment.
And even now they do college checkup also, so there's a more probability of picking them much earlier.
There is this study published by RSSDA from a retrospective analysis of nationwide screening camp of nearly more than 2 lakh patients. They took age less than 35 years as young in this, and they found a prevalence of around 18%. And if the family history was there, the prevalence was as high as 40%. So they find that this is on the other side. So they recommend that in Indians we should start screening from 18 years of age itself, especially in those with the family history of diabetes. So at present, as per the ICMR INDIAB study, the overall national prevalence was around 12%, and maybe in urban areas was 16%. So the prevalence is quite high in this population age than 35 years. So we should start screening from 18 years of age itself. Sriram.
Interesting. Whenever this family history comes, no, today morning the other panel also I was commenting, so half the people they won't check, they won't know. That's another problem. So we should ask. In India, it's very high risk, and everybody should be universally screened if you plan to screen. The family history of diabetes, I'm sure all of us, most of the families here will have at least. Then how do you define family in Kepping problem? Joint family, nuclear family problem.
Not just diabetes, I was pre-diabetes is also very high. A lot of people work with pre-diabetic range as well. So,
Dr. Ranjit, do you think can we get off with doing this MDRF diabetes risk score without doing a blood test?
Definitely yes, but remember the risk score was devised around 20 years ago, at which time we didn't have these many young people coming. One of the major components of the IDRs is the age of the patient. So if you're finding more and more people getting diabetes at the age of 30, it's time to recalibrate the risk score so that a younger age can be given higher score. But like sir was saying, the most important risk factor to look for is a family history. And we see that all the time because the people who come to us for screening with diabetes are the relatives of my existing patients. So father and mother both have diabetes. The fellow wants to find out if he is also going down the same road, and he gets a test and is positive. So we say out of all the GTTs we do, 90% are positive. That only means that we are looking at a selected population, that's all. Youngsters. Both type 1 and type 2, that's the interesting thing. Both have increased.
Yes, post-COVID, I think it exposed a lot of patients, and we had a lot of steroid-induced diabetes and a lot of reasons whether even COVID-induced diabetes also was there. So what is the big deal? So why should we discuss young onset, old onset? Can we just put them as a type 2 diabetes and just treat them? So why are we talking so much about why should you differentiate young onset and adult onset, or that is young adult or usual adult onset? So Dr. Kumaravel, do you think it makes any difference in managing, diagnosis, management and prognosis?
So I think in any diabetes, first defining the type of diabetes is very important, because as there is at least 10% of diabetes which could be secondary form of diabetes, which has to be definitely differentiated. So whether it is type 1, type 2, secondary, or pancreatic diabetes, MODI, so knowing the type of diabetes definitely helps. So in adult onset diabetes, there's a large overlap of these secondary onset diabetes or other types of diabetes. On contrary, if you try to look at less than 18 years, initially it was predominantly type 1, now we see more of type 2 also. And when it is more than 40, 45 years, it was predominantly type 2. So this young onset age group between 18 to 25 or 30, whatever you define, is an area where you have prevalence of all diabetes is more. You have more prevalence of type 2, you have some type 1 also, secondary and pancreatic diabetes. So the charm of diagnosing secondary diabetes is that it is curable if you are able to identify the cause, if it's a Cushing's or whatever it is. So diagnosing the type of diabetes is very important to decide the modality of treatment. So we know type 1 it is different, type 2 is different, MODI is different. Many times they present with glucotoxicity. So your diagnosis blood sugar could be 300 or 400, then rapidly the course changes. So making a diagnosis is very, very important to decide on management also. But in general, young onset diabetes, they have a more fulminant complications, micro and macrovascular complications are more, especially when they have associated dyslipidemia, obesity or other metabolic complications. So your prognosis depends on all these factors also.
So today actually, if I may add one thing, I know we all learn something from one another. I mean, I learned a lot from Sri Ram, so today I came to know when we were actually discussing about this during our lunch break. This is very important because I learned from Sri Ram that in mitochondrial diabetes, you cannot use imiglim or metformin. So, you know, it is important, as he said, at different phases, because that was a new point for me, which I learned today. So I'm also, you know, I'll give it to Sri Ram, he can add on.
Thank you, Shruti, for this positive comment. See, the interesting thing is, one, the run-of-the-mill type 2, I think most of the conferences and the pharma, everybody focuses on type 2, except the insulin part, which is for type 1. But the important is to pick up those atypical features. What are the clinical or other clues which, out of some 50 patients, you will randomly, continuously see in an OP. You should not miss that one Cushing, that one acro, or one pancreatic fellow, or one, when do you suspect? What is the threshold at which you suspect? That will come by training and other practice, but it's largely clinical. That's what I mean to say. It's not, I hope this whole discussion will throw more light on all this. But once you develop that, then that patient, it will be life-changing for them. It will not be just routinely prescribing, semaglutide kudukalama vendama and discuss pannakudadu anga poi. You should know that this is a total contraindicated condition will be there. That's the whole idea of having a holistic view of the patient.
So we always say for certain form of diabetes may be there only in 1% of the population. For that particular patient, it is 100%.
Yes.
So I think that's the way we have to look at it. Don't think just because it's uncommon, it's not important for that particular patient. So that's the way in which we should approach these cases.
Yes, Dr. Ravi.
Yeah, I just wanted to bring up another point that we have been discussing before, especially in the context of this young versus usual age. Because if you look at, going back to the beta cell, and I didn't hear anybody talk about C-peptide levels or the dynamic response to a C-peptide level, right? So you need to get a baseline level and then a stimulated C-peptide. Does that differentiate in your experience between the young and the usual age? Because we typically think that those individuals who are younger would have a higher C-peptide response, would argue for more beta cells to be still there, and that would argue for more, either an intensive short-term therapy to enhance the health of the beta cell, or GLP-1 based therapies to preserve the health of the beta cell. So I just want to bring it up because...
yes, sir, we are having questions on C-peptide in follow-up slide. So I think most often clinical practice, what I do and most of us do, for us diabetes is type 2 diabetes. So we always write reflexly type 2 diabetes. So we don't try to differentiate type 1 or other types of diabetes. So I find FCPD, MODI, all of them get labeled as type 2 diabetes. So the importance is anything less than 25 or 30 years, just keep in your back of mind that other possibilities are there. And once you diagnose, the treatment totally changes. If you think it's type 1, they'll end up on insulin. If it is MODY, then you can take off insulin and give low dose sulfonylurea. So if it's FCPD, then we have to give insulin. So if you diagnose endocrine diabetes, then the disease has to be treated. So young patients, be aware that you need to think about other causes. Don't label everyone as type 2 diabetes.
Even if they have come to you for diabetes, you need not label them on the first day.
Yes, we don't need.
You just put diabetes, and on that day you treat the hyperglycemia, and as you...
Later on you can give the diagnosis. So they can put diabetes in the young, and you can give type to be decided on follow-up. Like that also you can do. And as Dr. Shruti told, so we are getting younger patients. So anyone in the reproductive age group, always ask the question, are you planning for pregnancy? Reflexly we are writing gliptins, glitazones, SGLT inhibitors. So if they're going to plan for pregnancy, and most often we find it's an accidental event in the Indian context. So whenever we see these young patients, we should always ask them the question, are you having any plans of pregnancy? Then I need to change the treatment and give you some safe medicines. Often we find they say they are pregnant and they are on gliptins, they are on SGLT2 inhibitors. It becomes a difficult scenario for us. So pregnancy should always be a planned event in young diabetes. So coming back to this case, this girl, she's doing MBBS internship and glucose was 520 milligram per deciliter. I asked one question about what the next best test.
MBBS level stress.
I don't know, she came from Chennai. She came from Chennai to Pondicherry to ask me how to manage this case. So Dr. Ranjit, what will be your next clinical approach in this case?
See, as far as the history is concerned, I'm sure there are slides coming in ahead of us regarding the family history and other things. So the onset, is it an abrupt onset or has she been having symptoms over a long period of time? That might differentiate between type 1 and the other forms of diabetes. Although it should be remembered that even type 2 diabetes, if kept undiagnosed for a long time, can have severe osmotic symptoms. And obviously we have to ask for a family history. I think that's coming later on in the talk. And in the history, obviously, like Sir was mentioning regarding the thing about getting pregnant, are you pregnant now? That is also an important thing to be asked, because remember she's 23. Anybody in the reproductive age group can get pregnant. Any female in the reproductive age group can get pregnant. So sometimes we feel very delicate to ask these questions, but we should be asking these questions. Then the other thing to be asked is any history that is suggestive of secondary forms of diabetes. For example, features of malabsorption, which may throw light on the fact that they are having exocrine pancreatic insufficiency, other symptoms suggestive of other endocrinopathies. All these things can be asked. Now, in the examination, we should look at whether the patient is having any features of insulin resistance. And like acanthosis nigricans, skin tags, anthropometrics, very important, waist circumference. Although when somebody has such a profound level of hyperglycemia, they might have lost a considerable amount of weight and they may not be obese at the time of first presentation. But look for the stigmata of insulin resistance. So these are some of the things we should look for. But basically, I don't think there is too much of doubt in the diagnosis because the symptoms are there and the sugar is also profoundly elevated.
Yes, I think, thank you, Dr. Ranjit. I think a quick history just to see, because the patient is symptomatic, having high glucose levels, we should get on with the treatment. But certain pointers like family history, presence of acanthosis, abruptness of onset, all this will give certain clues. So the lab work, this I asked in the Slido questionnaire, what is the next best initial investigations? I think most of them had chosen urine or blood ketones and some had chosen HbA1c and C-peptide. Dr. Shruti, what will be your immediate test to do in this patient?
So the immediate test would be, I agree with the poll results of urine or blood ketones. That would probably, the others can also be done, but the others can wait.
Yes.
You know, there is no urgency to do all the investigations that don't go. If I have to pick one, then it will be urine or blood ketones. Between the two,
lab glucose panna vendama. Because osmotic symptoms are there, you go clinically here, no? Because this is GMR is
glucometry.
Lab glucose.
I still feel that it might be worthwhile at least doing one
lab
lab glucose, isn't it?
Sure.
Don't have to wait for fasting postponement because somebody's random is so high. Anytime you check your lab, it will only take half an hour, not more than that. You'll get the report.
Well, that is not there in the,
It's there. It's a fasting TP, we not have to wait till the next day to do it.
I agree with that point, and then that's a valid point. And a urine and a blood ketone is probably what I would
Which do you do in your practice, urine or blood, and which is preferred?
I usually do the urine, but the most of the guidelines would recommend blood ketones. Urine ketones usually lag behind, it's usually 1 to 2 hours. There is a lag in the urine ketones, and it usually stays false positive also even after the symptoms of acidosis resolves. But practically, urine ketones are simple, easy, quick, cheap, effective to sort of do it. And that would probably be the first thing that I would do.
So,
urine ketone, strips. Blood ketone strips are also there, but usually between the two, actually guidelines recommend, most of the guidelines, be the ISPAD guidelines or the other guidelines, recommend blood ketones. But practically, that's why he has this slash.
I will add one interesting point there that the blood ketone strip and the urine ketone strips are same, except that you centrifuge and you do it in the supernatant. So the principle is the same and it will give you the same answer. And if you have that, thankfully I have that smell of ketones. If 20% of the population cannot smell ketones. Otherwise, you could have, by the time the patient walks in, you can diagnose that this is wrong, this ketose.
The patient, madam?
Sorry, ma'am, you had. We can do all those things, but it was not there in that. So, adala we picked up.
So, Dr. Shruti, if the patient had urine ketones 3+ or 4+,
yeah.
Blood ketone strips are not the same, sir. Abbott has got.
That is, I forgot to mention. Beta hydroxybutyrate specifically you want to add, that is a different strip. But the blood ketone strip routinely available is the same as the urine ketone strip.
So, Gauri, you prefer doing blood ketones, is it? I mean, I don't think there is. I just.
Shruti, if you get urine ketones 3+, so what are the most likely diagnosis and which is less likely? And if urine ketones is nil, what is more likely and what is less likely? How do you help?
See, actually, urine ketones, if it's positive with symptoms, polyuria and everything, I would definitely consider insulin deficient diabetes. Treat her with insulin. Priority is to, give her IV fluids, stabilizer, that would be the first route. So if I see ketones with the symptoms, I think before the labs, I think the symptoms and signs are more important.
So you think in terms of type 1 and
insulin deficient diabetes and then treat her
ketones was totally negative in this case with 500 glucose. What will you think?
I would still keep, because not all type 1s, it's to answer your question, does ketones are seen in all type 1 patients? No. Can ketosis occur in patients with diabetes, type 2 diabetes? Yes. So we have seen at least 10 to 15% of our type 2 patients presenting with complete insulin deficiency with ketosis. So I think here again, I would still do the same treatment. Treatment would be to treat her with insulin, stabilizer, hydrator, etc. But, to answer your questions, you can have either or.
Dr. Ranjit, with such high glucose levels and no ketones, what do you think is more?
One situation where this can happen, although it is becoming very rare nowadays, is pancreatic diabetes.
Yeah, absolutely.
Yeah. Because what we should realize is that the amount of insulin which is needed to prevent lipolysis is much lower than the amount of insulin that is needed to maintain euglycemia. And people with fibrocalculous pancreatic diabetes or other types of pancreatic diabetes tend to have some amount of C-peptide left. So they won't be having absolute zero C. That's probably enough to prevent lipolysis and ketogenesis, but it's not enough to maintain euglycemia. Second reason for that being that many of these people also have deficiency of counterregulatory hormones, especially glucagon. The third reason being that they don't have too much of subcutaneous fat or visceral fat because they are malnourished people. So they don't have the substrate for ketogenesis. And the fourth reason that has been suggested is that there is a deficiency of carnitine, which is required for transporting the fatty acids from the cytoplasm into the mitochondria for beta oxidation. So these are some of the reasons given. But if somebody comes to you with profound hyperglycemia with no ketosis, you should think about fibrocalculous pancreas. It's rare, but it's still not totally gone from our population.
What about MODI? Do you think it's possible?
MODI generally, again I'm talking about generally they do not come with this high level of glucose. I agree that the level of hyperglycemia need not necessarily be a guide to the type of diabetes, but generally monogenic diabetes MODI comes with less severe hyperglycemia because they are not totally beta cell deficient. And what is interesting is that even though the initial classification, the criteria by Tattersall and Fahans had absence of ketosis as one of the criteria, there have been a couple of case reports of MODI 1 and MODI 3 going into ketosis because it's a progressive disease. In due course of time, they become beta cell deficient and they can get ketosis. But the fact that it's been reported as a case report in diabetic medicine tells you that it is very rare.
Okay, so with very high glucose levels, if there is no ketones at all, then we should think of FCPD, fibro-calcific pancreatic diabetes. So, Dr. Kumaravel, back to you. So, this case came with high glucose levels. Urine ketones was 3+. So, what will be your immediate next best management?
So I think when you have a hyperglycemia with ketone positive symptomatic, insulin would definitely, whatever may be the type of diabetes, it could be type 1 or type 2, symptomatic ketones, insulin would be the first choice. But what we have seen in many a times, when the patient is not acidosis, ketones, we see many type 2 with ketones of 3+, 4+, though we insist on insulin, 50% of them they go by oral antibiotic drug. They say we will take oral OAD for 2 weeks. If it does not come down, why not we change to insulin? And many times within a week the ketones become negative, they respond very well. So even those things. So I think whenever you have a hyperglycemia and a ketone positive, next thing your clinical examination, look at the hydration and acidosis. That makes a best choice to decide what could be the best for this patient. So, but as a thumb rule, symptomatic, ketone positive, and hyperglycemia, it is insulin, whatever may be the type of diabetes.
I don't know the second statement what Kumaravel said, I don't know what he was trying to mean. The OHA, I think everybody should go with the one home message. Everybody should be agreeing that there should be only insulin if there is ketosis. And Dr. Rohit sir was mentioning about how this insulin can save the beta cell and tomorrow he will be off insulin. That also can be told to the type 2. Young, lean, 23-year-old girl, I don't know whether she may be type 1 for all I know, but...
would you admit this patient and give intravenous fluids, or would you manage this patient as outpatient if there is no acidosis?
You are asking me?
Yes.
I am thankfully in an institute running a department, so I have the privilege of taking patients in. But if I was in a typical private setup OP, if she can come for regular follow-up and her hydration is good, and if I can counsel her for extra 10-15 minutes about hydration, start insulin straight away. But everything that's an issue. It's better to admit for all logistic reasons. These patients.
Dr. Ranjit, in your setup? Dr. Ranjit, in your setup?
I think the most important thing to find out is this patient able to consume and retain oral fluids? Patient is not able to do that, then there is no question you have to hospitalize and give parenteral fluids. Otherwise, there is still a chance. There is something known as ambulant ketosis. You must have heard of that. Ambulant ketosis, where the patient comes walking into the clinic, sugar 500, ketones 3+. We are surprised, they are also surprised that they have got ketosis, and most definitely they will not agree for hospitalization, because unlike you sir, I am in a private center where people have to pay for it, so I know, but at least you have a big department in a college, so it's difficult to convince people.
Yes, ma'am.
Outpatient.
Safest parliamentary answer is whichever is patient is affording, available, insulin should go in. And it should always contain a long acting, intermediate acting. In the insulin or regular NPH. The patient will respond very well. None of the newer insulins have any advantage in the management of DKA.
Okay, so we have completed the initial management and initial test. Insulin has been started, patient has been advised hydration. So now the question will come how to classify the type of diabetes and what all parameters you would use to classify. So, Dr. Kumaravel, would you, what important parameters would you use to classify type of diabetes, clinical parameters and lab parameters?
I think apart from clinical parameters like looking at the BMI and looking at whether the patient has signs of insulin resistance in terms of acanthosis, and many of even diabetes at 18, 19 years, they have severe acanthosis, skin tags, history of polycystic ovaries in females, and history of drug intake, steroids,
family history.
And family history. So apart from these clinical parameters, which I'm sure every one of us would be asking, and they would have a own way of getting the clinical assessment, one important thing is look for signs of insulin resistance, look for signs of secondary diabetes, look for whether they can have pancreatic diabetes or not. And apart from what...
If I can add one more small thing to that list is look for other autoimmunity. Thyromegaly, history of alopecia areata, some vitiligo somewhere, previous B12 deficiency, and it will go more towards type 1. That's the indirect clue rather than GAD65 can be, your threshold for sending. And thyromegaly will be an important clue for underlying autoimmune?
I think basically the history and evaluation would be based on to brand our patient in any of these categories, usually whether it's type 1, type 2, monogenic, gestational diabetes, secondary, in terms of FCPD or other endocrinopathy like Cushing's or drug-induced diabetes.
So we have to keep all this differential diagnosis in young diabetes and just not label them as type 1 or type 2. So we need to keep an open eye. So as already told, presence of ketosis, family history, body mass index, insulin resistance signs, and C-peptide response and autoimmunity to pancreatic islets, all of this will give important clue. I think family history already we have seen. So Dr. Ranjit, do you draw a detailed pedigree chart?
I think this is very
how many
important.
generations do you
At
go?
At least 3 generations. This is something which costs nothing. It will take you all of 10 minutes to draw if you are somebody who is able to talk to the patient in their own language. At least 3 generations you have to see. And the importance being that to get diabetes at a young age, that is type 2 diabetes at a young age, generally you need to have such a strong family history or you really need to have abused yourself that badly. Otherwise, it's very difficult to get type 2 diabetes at this sort of age. Type 1 in general, again, it's a rule of thumb, general, there won't be any family history, although we do have cases where multiple siblings have developed type 1 diabetes in the same family. Monogenic diabetes, MODY, by definition is autosomal dominant. It comes in each generation, does not skip any generations, and will be generally on one side of the family. Fibrocalculous pancreatic diabetes, like for type 1, generally no family history, also some genetic susceptibilities have been identified. Again, there may be a few families in which multiple members are got, but in general, it doesn't run in families. So all these you can get from pedigree chart. But like Dr. Sriram sir was saying, many a time people may not have tested for diabetes. See, somebody is 23. How old will the parents be? Mother will be 46, father will be 50. How many of our patients ever test for diabetes by the age of 50? Women might have tested during pregnancy, but men never do. So the question to ask is, if you don't have a family history, is it because you have never tested for diabetes or it's actually a negative family history? So that point has to be clarified.
Yes, so I think we need to do a detailed family history and draw a good pedigree chart, which will give an important clue. Both parents have diabetes, likely to be type 2. One parent is one side, 3 generations, only maternal or only one side autosomal dominant. We should think of MODY.
Actually,
Yes.
that's a very good point. The family not tested, you know, in this stage. A lot of people don't get tested. Very common in India. So, yeah.
Sorry, I'm the only one asking questions. I hope I'm not taking advantage here. But what about type 5? You know, the new lean diabetes that has come up. So you're missing that on the list.
Yeah, it will be.
It's only an anthropometric diagnosis, basically. So lean diabetes doesn't fit into any of these. So whether it's a subtype of type 2 or a different type of diabetes altogether remains to be clarified.
Dr. Nihal Thomas has done a lot of work from CMC Vellore on, it's really impressive data on type 5
It's
diabetes.
impressive because if we can find out what causes it, because there is no reason these guys should get diabetes, isn't it? Why do they have beta cell deficiency? Why do they? Is it malnutrition or something else? And if it's malnutrition, why haven't we recognized it all these years when malnutrition was even more rife in this country? So I think these are the questions we need to answer.
So obesity and acanthosis in BMI more point towards type 2 diabetes, but some of the type 1 also can be obese, so does not rule out absolutely. Lean patients points towards type 1 or MODY.
Lipodystrophic diabetes can
Yes,
also have
lipodystrophy.
acanthosis.
So coming back to C-peptide, Dr. Rohit was asking, Dr. Shruti, would you do fasting, postprandial or both? What are the fallacies? Do you do when the sugar is 500 or when do you want to wait? What will be the approximate cost in your setting?
I would not do in an acute setting. I would probably treat the hyperglycemia and do it. I usually prefer the fasting C-peptide, but I would say I would leave this question to Dr. Kumaravel because he's done a lot of research on this, so I would get his expertise on this, but not in an acute setting. There is no urgency to do a C-peptide in her at this point of time. Perhaps definitely will give me the beta cell reserve when I do see her in follow-ups. Dr. Kumaravel, do you have anything to add?
I think as rightly said by Shruti, in acute setting, whenever you have hyperglycemia, glucotoxicity, your C-peptide could be falsely low initially also. So there are various ways to do C-peptide. You can have fasting postprandial, you can have a glucagon stimulated, you can have OGTT based C-peptide. So your fasting C-peptide might give you a clue on your basic beta cell reserve. And when you do a C-peptide with OGTT, it is just a glucose stimulated C-peptide. And glucagon again is a different thing. So if we have postprandial something like mixed meal kind of C-peptide where you have various stimulants to do it. So if you are just looking at a basic beta cell reserve, I think fasting C-peptide alone should be okay. But out of these two, which is, I personally feel postprandial C-peptide, when it is there, we are just looking at whether your beta cell is able to function. Sometimes in fasting, your beta cells may not be able to function adequately, but when you give a stimulus in terms of glucose or protein, it might be able to function.
So you would wait, after giving insulin, you would wait for the glucose levels
after
to come
achieving
down?
euglycemia. Ideally, achieving euglycemia, it is better. But many times, as when the patient is admitted, even before discharge, the patient would want to know what exactly is happening. So such times, we might be able to see peptide. It can give you a clue, or it has to be repeated after some time. And another, yeah, you can go.
Yeah, no, I was just curious about the thoughts of the panel, because I think the baseline C-peptide level will give you some measurement, right? So the same patient who's coming back after 1 or 2 years, let's say you get the same 1.2, 1.3, 1.2. But if you do a dynamic response, let's example after a mixed meal tolerance test, and you calculate the delta change from the baseline to the stimulated, year 1, year 2, and year 3, that will vary. So I don't see any reason of just doing the baseline, because the baseline does not give you any measure of the dynamic response to the beta cell. There may be some of them will be sleeping during a basal response. The dynamic change during a stimulation is critical. So I'm just puzzled as to, I was talking to Dr. Arvind, why do we do basal? If the patient comes back after 1 year, just do the basal again. After 4 years, just do the basal. The basal will be the same, but the dynamic response, I can assure you, will be different. And I think we're missing a point here, because we are failing to look at the dynamic change of the functional beta cells.
So I think the point towards this case is whether to establish as type 1 or type 2.
Yeah, no,
so in other scenario, I think when you have a reasonable beta cell function in type 2 or whatever it is, this stimulated C-peptide, as you say, when you look at area under curve, it could give a clue. So in this scenario, probably when we see a basal C-peptide, which is less than 0.3, patient has a ketosis, thin build, and your blood sugar is 530, we are able to fix up a diagnosis of type 1 and counsel the patients or family regarding this thing. Other scenarios, I'm sure your point would be definitely considered.
Yeah.
I think Sir's point is more towards type 2 in its evolution, where the first phase insulin response is definitely defective, so your stimulated beta cell response will be less than the basal beta cell. That's a valid point in type 2. But to differentiate between types of diabetes, basal will, if the basal is more than 1.5, I will be more comfortable diagnosing that there is reserve, some reserve is there. We do this in other endocrine hormones also. And, like classic example is adrenal, where we do a baseline cortisol. If the baseline itself is in double digit, more than 15, we usually say the adrenal reserve is good. Every time we don't do ACTH.
Yes, madam. Rajesh, we're having a hot discussion, so just give us a couple of minutes more.
After the patient stabilizes in terms of euglycemia. In that case, if the patient is started on sulfonylureas, will that interfere in the original C-peptide assay? Because sulfonylurea tend to increase the insulin production.
Yes, it will.
So
you should actually,
you
should not be on sulfonylurea.
It should not use that.
Or it should be the last dose, the previous night dose, you should skip.
1 day is enough?
One night also enough, because the previous morning only you would have given, no?
Yes.
Insulin also, that's what we do. We give NPH kind of insulin. Baseline, basal insulin patient can be there. Only that day morning or that stimulated insulin, that short acting only we avoid.
A word on 1.5 diabetes, how do you differentiate?
1.5. See, there are a lot of entities called 1.5 diabetes. I don't know which 1.5 you're talking about. But I think what you mean is the slowly progressing autoimmune diabetes of adults, which used to be much more conveniently called LADA until 3 years ago. Why they changed the name, we don't know. Now, these do not apply to young people. These are relatively older individuals. At an age at which you expect type 2 diabetes, they come like a type 2 diabetes, they manage with OHAs, but you find that they rapidly become insulin requiring. And then when you evaluate, you find that they do not have enough C-peptide, their autoantibodies may be positive. And then when you look back, you find that they have never been obese, they don't have a family history. So this is just a type 1 which is presenting later in life. Slow type, slowly progressing.
Actually, age should be more than 30 years for diagnosis of LADA, where that is beyond this. So another important point is many of the places will not be able to do a C-peptide. You will be transporting to another place. So cold chain maintenance is important. It's temperature sensitive. So we should ensure that the transport on dry ice. Approximate cost will be around 2,000 rupees to do 2 samples C-peptide. And genetic testing, Dr. Ranjit, you do genetic testing for all and
ideal world we would do for everyone, right? But we are not living in an ideal world, so we have to select our patients. So basically, initially you had clinical criteria like family history, no ketosis, blah, 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 but they are no longer valid. And what we found in some of our studies on these young patients is that again tallies with what Sir was talking about. It is the stimulated C-peptide that best distinguishes people from type 1 diabetes versus type 2 diabetes versus MODY. So and we have defined cutoffs also, but of course they are only valid for our lab. What I generally do is that I try to ask myself, is a diagnosis of monogenic diabetes going to change the treatment in this particular patient? So who are these people? These are people who have developed diabetes in the first year of life, obviously not in this category. But remember, even somebody who is a young adult now was a neonate once. So the first question to ask is, when did you get diabetes? If you have gotten diabetes in the first year of life or 6 months of life, genetic testing is mandatory. The second sort of patient is that somebody who has been labeled as a type 1 but doesn't look like a type 1 in the sense that there's never been any ketosis. There's been a family history of multiple members of the family having onset of diabetes, some of whom were treated on tablets, and the requirement of insulin is very small. The third group of individuals is people who have got persistent high fasting glucose, non-progressive. That is usually due to mutations in glucokinase. And the fourth phenotype is those with syndromic forms of diabetes. So these are the 4 categories in whom I would consider a testing, monogenic diabetes testing. But of course, if the patient is affordable, you can do it because remember, it's only once in your lifetime. And it costs around 13,000 rupees to do the entire panel, which is around 78 genes, all of whom, which we know now, are causes of monogenic diabetes. So 78 genes are there. Some of them are associated only with diabetes, some of them are associated with certain syndromes also.
Dr. Shruti, just a quick word about beta cell antibody estimation. So would you do all the antibodies or you do one?
I usually do the anti-GAD, that is the most common antibody that I do, 60 to 80% sensitivity. Combining with zinc transporter, maybe the sensitivity would go high. It costs roughly about 6,000 to 8,000 rupees. But in this patient, it's definitely warranted to do an antibody to see where she is. So definitely that's what I would be doing.
So with the beta cell function with C-peptide and autoimmunity, you can come to some ideal conclusion most of the patients. Finally, coming to the algorithm, Dr. Ranjit is the author for the algorithm. Just can you just summarize this?
So this is basically meant for people in primary care to decide whom to refer and whom to evaluate further. Like I said, the first thing to look at is family history. Of course, with the caveat that many of them may not have even tested. If family history is NEC positive, then there are 2 possibilities. One is early onset type 2 diabetes and the other is MODY. And you can differentiate these by the fact that majority of type 2s will be obese. They will have much stronger family history than those with MODY, and they will have features of insulin resistance, whereas those with MODY will not have any of these. And the differentiation can be made only on the basis of genetic testing. C-peptide and all overlaps quite a lot, even though we have defined cutoffs. But remember that misdiagnosing MODY 1 and MODY 3 for type 2 diabetes does not generally harm the patient, at least in India, because the treatment for MODY 1 and MODY 3 is sulfonylurea. In India, if somebody is on metformin and does not come under control, most of the time we give sulfonylurea. So they end up getting the right treatment for the wrong reason. Although things are changing now with all the other newer molecules coming. So I am not too worried about that category of patient. What I am worried about is a category on the right who does not have a family history. That is where we need to differentiate from monogenic diabetes. We don't have a family history. It can either be a type 1 diabetes or it can be a fibrocalculous pancreatic diabetes or any other form of secondary diabetes like you were mentioning. And that we have to evaluate further by the specific test. For example, for FCPD, the test would be imaging, pancreatic imaging. A plain abdominal X-ray is often enough. You may not have to go for ultrasound or CT or MRI. C-peptide, as I mentioned earlier, is generally absent in type 1, although it may be present in the initial few years. Up to 5 years of diagnosis, you may have detectable C-peptide. After that, it is present, you will have to reconsider the diagnosis. So this is in a nutshell the algorithm for young diabetes.
Thank you. I thank all the panelists and Dr. Rohit for his inputs. I think we had an excellent discussion. I think we had more slides, but due to lack of time, we have to close the session. All the panelists are available, and I am also available. If you have any specific queries, you can ask us. Thank you.
So thank you so much for all the panelists.
If you have any questions, find Sriram and ask. I'm just kidding.
So thank you so much. Let's move on to the next session. We are already 15 minutes delayed. So by the time they take the photograph, the next session, we're going to have debate. So may I call upon Dr. Jayashree Gopal Madam, a senior consultant endocrinologist, to take over the session.
So, good evening. Without further ado, let's get on to the discussion. This came up when we were talking about the remarkable ability of the newer agents, the GLP-1 analogs, in reducing the HbA1c. So, Krishna and I were having an informal discussion, and we were saying, what is the HbA1c we're going to be targeting? And we were saying 6.5 or 5.6, and then that became a debate, and I'm put in charge of the debate. And I think really we should be looking at so-called reversal. We'll talk about that. Is that a reality? Definitely for type 2 diabetes, yes. Sustainability, we don't know. We don't know because obviously it's very difficult to maintain those lifestyle changes that are necessary to reverse the diabetes. Let me first call upon, I think Anand is going to be talking for the motion that we should be aiming for a HbA1c of 5.6, and over to you, Anand.
Thank you, ma'am. Thank you very much. So I'm going to move the motion saying that HbA1c 5.6 is the new 6.5. You know, my conflicts of interest is I owe my livelihood and thanks to all that my patients eat. And that's my first conflict of interest. And my second conflict of interest is what Dr. Ameya, my good friend, is going to say. So the core argument of my summary is going to revolve around this. I think we have to shift from a diagnosis-driven HbA1c. So I'm not going to just talk about therapeutics. I'm going to talk about why this 5.6 is important. So we should not be waiting for 6.5. We have to be moving towards a risk-driven endocrinology. We need to act early, specifically with the HbA1cs of 5.5 to 5.9 zone, where subclinical atherosclerosis is actually emerging. If you're looking at diabetes conversion, basically this starts early. So there's 3 to 5-fold increase at 5.6. And obviously lifestyle interventions and cardiovascular disease prevention with selective pharmacotherapy, with now the SGLT2s, GLPs, GLP-GIPs, you know, you could actually achieve this. There's a very high return of investment with this 5.6. And my core argument number 2 is this HbA1c and this cardiovascular disease relationship is continuous, and this is not stepwise. There is no biological threshold at 6.5. To be honest, 6.5 was chosen because basically retinopathy onset basically was detected at that. And this is not the earliest point at which there's cardiovascular or diabetes risk. And when you plot A1C versus CV events, because that's what you're really looking at in terms of macrovascular disease, you see a smooth rising curve, not a cliff. Now, if you look at epidemiology in terms of diabetes conversion risk by A1C band, the scientific foundations, if you're between 5 to 5.5, 5.5 to 6, or 6 to 6.4, there's a 5-fold higher diabetes risk with 5.5 to 6. So this has really very important implications. So someone at 5.6 is 3 to 5 times more likely to develop type 2 diabetes very soon. And this alone justifies elevated monitoring and lifestyle intervention. I'm not talking about insulinization or actually putting them on drugs, but this is basically being careful. And this came out in Diabetes Care. This was basically a review and a commentary, and this basically stated that, HbA1cs between 5.5 and 6.5 were associated with a substantially increased risk of developing diabetes. And if you look at this curve, this is what I was talking about. This HbA1c risk is continuous, and this is not stepwise. And the risk curve is already peaking and going steep at 5.5 to 5.6. Obviously, if you go higher, it goes higher, but the annual incidence of diabetes is like 2.5 at 5.5, 5.6. So from, let's say, from a conservative point of view, yes, But, if you really want, it's someone you know, you want this early. Cardiovascular disease and macrovascular risk with a high HbA1c of 5.5 to 5.9. Now, there's a huge recent cohort analysis with 6 lakh people looking at HbA1c 5.5 to 5.9 versus 5 to 5.4. And what they found was in men, there was a 12% higher CVD hospitalization risk despite being the so-called non-diabetic in comparison to the HbA1c of 5.5 to 5.4. So this was in Journal of American Association of Heart Association, which is pretty robust. These people were followed for 5 years, and as you can see here, the cardiovascular disease hospitalization and the cardiovascular death was pretty high, both in men and women, basically with that amount of HbA1c. So what does this tell us? What are the clinical implications? The implications are the CVD association with HbA1c is independent of the traditional risk factors, and you could use this as a marker of making sure that you actually start with lifestyle and diet. Remember, I'm not saying put them on a I'm not saying put them on a GLP-1, put them on an SGLT2 inhibitor. I'm talking about making sure that they identify risk. So this is important, and this is new. This definitely is new, and this is changing practice because this is telling us that you need to start early. What about HbA1c categories and all-cause and cardiovascular mortality? Now again, look at this particular study, 20,000 non-diabetic adults followed for 16 odd years. And what they found was between HbA1c of 5.5 and 5.9 versus 5 to 5.4, the ASCVD risk was 17% higher, and the mortality risk was 14% higher. And even in those with a 0 CV risk factor, that's non-smokers, non-hypertensive, and dyslipidemia, the hazard ratio was 1.26 for ASCVD. Why this matters? The association is independent of traditional cardiovascular risk factors, so A1C per se as a marker could contribute important to this risk. And this is this particular study which concluded saying even among individuals without diabetes and ASCVD, elevated HbA1c levels are associated with higher risks of ASCVD and mortality. So it's important that HbA1c testing and identifying these people are early, you identify them to prevent ASCVD and mortality. You can see the ASCVD increment with more risk factors. However, without risk factors, it is an important tool. And you need to take all of this into the equation. You look at the Kaplan-Meier curves, obviously with 3 or more risk factors, the HbA1c gets merged. You look at the first column, this is the total population. The second column is 0 risk factors, and the third column is basically 3 risk factors. If you look at the right-hand column, with 3 risk factors, the HbA1c, which is of between 5 to 5.6, is merged in amidst all those curves. If you go on to the left-hand side, you can see a clear divergence, and that means you need to be starting early. And again, meta-analyses looking at all of this also, says the same thing. So if you're looking at cardiovascular mortality, this starts pretty early between 5.6 to 6. So it is important to identify this factor. And this is not just cardiovascular disease, but this is also cardiovascular mortality. So 5 to 6 is this cardiovascular sweet spot for non-diabetics. And 5.5 to 5.9 sits at the upper edge of this optimal window. So clearly A1C 5.6 is definitely the new 6.5 if you were to look at this. Now, what about subclinical atherosclerosis? So this is important. The vascular remodeling actually happens not suddenly. It is not basically there after someone's basically got diabetes. It starts very, very early. And this is underway even at an HbA1c of 5.5 to 5.6. And the macrovascular events basically, we see needs to be looked at from a subclinical point of view. That means we need to look at the plaques, and we need to look at the plaques as to how they progress. And this PISA study, which is the progression of early subclinical atherosclerosis, looked at this prevalence of generalized and subclinical atherosclerosis, whether it's focal, discrete, or it was uniform, by the HbA1c band. And what it showed was a HbA1c of 5.5 to 5.6 had 11.5% increase with generalized plaques. So that means there's a 44% relative increase in plaque burden from HbA1c of less than 5 to 5.5 to 5.6. So even more reason why we need to draw this down a little bit further and not be conservative. You can see here, this is basically looking at the focal, the intermediate, or the generalized atherosclerosis. If you focus on this particular slide and look at basically between HbA1cs and 5.6 to 6, you will see what I mean. You will see that the risk is basically incremental at this point, and this cannot be ignored, and this has to be addressed. And again, if you were to look at this in terms of, using multiple scores, so if you were to say, okay, this person's got HbA1c of 5.6 or 5.7 and is basically, let's say having hypertension, yes, the risk would go up. And you add that on to, overweight, yes, the risk would go up. You add that on with dyslipidemia, that would go up. But even without those traditional risk factors, you find that this basically is high. And that is important to understand. If you look at the carotid arteries, if you look at the infrarenal aorta, if you look at the iliac and femoral arteries, and if you look at the coronary artery calcium scoring again, you see that this basically is pretty high with HbA1cs of around 5.5 and 5.6. As I said, the sweet spot is between 5.6 to 6. So this means there's a window of opportunity for preventing macrovascular disease, especially when the plaque is subclinical, and especially at the time the HbA1c is 5.5 to 6. So if we don't, look at that point, you're missing the window, and you're trying to reverse established atherosclerosis. And that's what, the ACCORD trial, the VAD trial, the ADVANCE trial, all of these actually tried later on. They actually tried to address this when the HbA1c was already high, when there were so many years duration of diabetes, and clearly that would not be of any benefit. So the subclinical cardiovascular disease, looking at a surrogate marker, you could look at, intima media thickness. And again here, the carotid intima media thickness and the internal, in terms of the media thickness was pretty high, especially with the HbA1c basically at very low levels. So again, stressing the point that the risk starts early from HbA1c of 5.6 rather than, a later HbA1c of 6.5. What about stroke risk at HbA1c 6.5? Now, I found a very interesting article actually from Pakistan, but this is very scientific, so I actually included it. HbA1c of greater than 6 has an 8-fold increased odds of ischemic stroke. And the risk curve suggests that a HbA1c of 5.5 to 5.6 is basically high. Again, all these are markers of subclinical atherosclerosis telling us that we need to start early. So what is the clinical implication? If 6.5 warranted a diagnosis a decade ago, then 5.6 today, with the current evidence we now possess, deserves the same clinical attention and action. I'm not saying change the goalposts. I'm not saying treat them aggressively. I'm not saying give them insulin. I'm not saying give them metformin. I'm not saying give them a GLP and a GIP. But you could start simply with some strict lifestyle and diet measures, and that's what really I'm coming to. So HbA1c 5.6 is not a disease. It's a risk state demanding action. 6.5 was chosen for retinopathy, not CVD. Diagnostic thresholds must not be confused with preventive medicine. The significant future annual incidence of future diabetes starts early from 5.6. There's a 17% extra ASCVD risk at 5.5 to 5.9, and this is a definite signal to act. ACCORD failed, not because glycemia failed, but it waited too long. So act early before the vessels are scarred. So basically 5.6 is telling you that there is a problem. Treating 5.6 means lifestyle changes, monitoring, and treating CVD risks. As I said, this is not insulin, this is not putting them on an injection, this is prevention and not overtreatment. And HbA1c definitely, should be acted as the new 6.5. So I rest my case and basically thank you very much and look forward to what Dr. Amey has to say.
Thank you, Anand. I think you made the strong case for recognizing the risk that increases at 5.6, and to refute that, now we have Dr. Amey coming and talking against the motion.
Yeah. Good evening, ladies and gentlemen. It's a pleasure to be here amongst all of you. And I thank the organizers for having me here. I must say that Dr. Anand, I always appreciate. First time I met him was in Trendo, and he got his own cheerleader that time. He got the same cheerleader this time. So I also got my cheerleaders. I'll show them to you. But more than that, I realized that how much we agree upon. And you will realize in my talk that most of the times I am agreeing with him only to tell you that how my perspective is correct. And as I said, I absolutely admire him. So first of all, when this invitation came, I thought let us settle the scores very, very peacefully. The doctor-patient ratio in Tamil Nadu is more, doctor-patient ratio in Mumbai is less. We are too overworked, so for us, let it be 6.5. For Tamil Nadu, let it be 5.6. Both of us win. But then, this is how the world is going on, next year we will see Donald Trump promising all endocrinologists to vote for him, saying that he will declare HbA1c as 5.6, and not only all endos, but all the pharma company employees, save Eli Lilly having a big presence in US, will vote for it. And yeah, I promised my cheerleaders. So Rajni Bhai is from Maharashtra, you know, Gayakwad, Marathi man. So he'll defend me over a course of time. But then, before that, let me start by my defense by saying, I mean, I don't know how many of you watched this famous movie of Amitabh Bachchan and Rajesh Khanna. Anand Babu, idu sari illai. That's not correct. And let me put in the perspective that 5.6 is relevant, very relevant. And Dr. Anand said the same thing, remember. 5.6 is relevant. Relevant because lifestyle modification has to start. He didn't say that medicine has to start there. He said lifestyle modification has to start. I also say the same thing. 5.6 is relevant because that is where risk of diabetes begins. Risk of diabetes and diabetes are two different things. Confusing and definitely at times blabbering, but lowering the diagnostic cutoff does not make the biology disappear. Remember, when you label a person diabetic, the monitoring totally changes. When you label a person diabetic, a stigma comes. When you label a person diabetic, insurance premium increases. And all of that, let it happen at 6.5, let it not happen at 5.6, because 5.6 to 6.5 is the level where you know where the person will become diabetic and microvascular disease will start. The only argument I know all of you have agreed to counter now is the macrovascular risk, which I will counter in next few slides. But then the first quote from Rajni Bhai is, diabetes is not a trailer, it's a full movie. And let us not subject our patients to all that harassment stigma at 5.6. Remember, majority will be diabetic in that. And then let us see what Krishna says. Krishna Sheshadri sir also gives a lot of wisdom, but this is Bhagwan Krishna. Nasato vidyate bhavo, nabhavo vidyate sataha. What is unreal has no true existence. So the disease begins at 6.5. Hyperglycemic complications begin at 6.5. Remember, hyperglycemic complications, and the next thing that I want to tell you is CVD is not a hyperglycemic complication. It is insulin resistant complication, it is obesity complication, it is dyslipidemia complication, it is hypertension complication, but it's not a hyperglycemic complication, at least in 5.6 to 6.5 range. That is because we all know, and even the cardiologists endorse, that the cardiovascular disease, other factors matter more. ASCVD risk score we all are using. No mention of diabetes in ASCVD risk score. And let us try to see when the cutoffs were lowered. And the ADA also did not look at ASCVD risk for diagnosing the cutoffs for the macrovascular disease. They looked at emergence of retinopathy. They looked at the steep rise in retinopathy beyond a level X, and even they got the retinopathy at level of 100, the fasting glucose between 100 to 126 where retinopathy was mild and the incidence rates were not very high, they chose to be labeled as pre-diabetic, meaning caution warranted, disease not to be diagnosed here, stigma not to be given here. 2010 was the time where ADA gave the HbA1c a sanctity to be used, because they said first time we have reasonable number of good analyzers. We all know that India is an anemic country. Imagine what happens when your hemoglobins are low, HbA1cs are falsely high. That's my another strong counter, that only HbA1c not correct as the marker for diagnosis of diabetes. You can be fooled by at many times. And 6.5 is a good cutoff. It is not arbitrary, because it also showed the similar studies in 1994 that gave fasting of 100, studies in 2000 to 2010 gave a HbA1c cutoff of 6.5 for the emergence of retinopathy. all biological variables are continuous. We know that salt is a poison, we know that glucose is a poison, but it's also essential. You don't have glucose, you don't have salt, you are again in a disease. You have glucose more, you have salt more, you are again in a disease. A delicate balance of these and many more factors determine the thread of life for all of us. And as I said, I totally respect 5.6. It's a risk marker. It tells how many will become diabetic. It has to stay because it's a pre-diabetes risk marker. It's not diabetes. It tells that you will become diabetic. You will become diabetic, then you will develop complications. But it does not mean that you are at a stage where complications are coming, where your premiums are increasing of insurance and your stigmas are going. Imagine how many people will face this stigma. Risk is not the disease, man, and that's what Rajni Bhai is also trying to tell you. And this is what I was alluding to. The cutoff of 6.5 in 2010, the mark, you read this article of diabetes care, it cautions against using HbA1c, but regards it because at many points in the world, people do not come fasting. HbA1c is done, it's diagnosed, and it's dusted that at least you get a label and treatment. So, coming to the core point, are there any other complications beyond retinopathy? Because retinopathy lowered the cutoff. I told you that retinopathy 5.6, no reason to make it. The world has endorsed that 6.5 is the correct level. Does nephropathy increase? No. This study clearly shows retinopathy cutoffs match with the nephropathy cutoffs. Does neuropathy increase? Maybe yes. Some of them can have mild neuropathy, particularly tall, thin individuals, but lifestyle interventions when done resulted in improvement in the neuropathy at this stage, and that was independent of change in the HbA1c. So then HbA1c had no relation with the development of neuropathy. So we don't know whether it is insulin resistance, whether it is dysmetabolism, which is the culprit. We all now are in a conference where obesity is the theme, diabetes the next theme, and that's what you have been listening from the morning. So we all need to endorse and encourage the fact that obesity is bad. We all need to encourage the fact that hypertension needs to be more aggressively treated. But then, should you lower the cutoff of HbA1c? I think risk and disease have to be totally kept separated. And then lastly, about the macrovascular disease. Remember, we acknowledge that prediabetes can be one of the accompaniments to the recipe of macrovascular disease, but more important players are hypertension, dyslipidemia, family history, smoking, so on and so forth. And adjusting for these risk factors, even if you get some notional increase, there has not been any reason to prove that treating this, and that's what Dr. Anand also said, that treating this is not mandatory that you should be giving drugs. Treating this actually can be harmful, and if you give 5.6 a cutoff, trust me, people will say low resource care setting, diagnosis of diabetes, give sulfonylurea, they did this here, they gave nataclynide, we end up having more mortality. Remember, even at 6.5, we exercise caution. We tell patients with macrovascular disease, don't get it to 6.5. If you are on medication causing hypoglycemia, you will land up in trouble. And moment you make it 5.6, you are opening a recipe for disaster with more hypoglycemias, more aggressive treatment, and maybe increase in the mortality for no rhyme or reason. Because diabetes is a population phenomena. Primary care center, okay, I have only glibenclamide, giving glibenclamide at 5.6 and it's a disaster. HbA1c, we all know, the age increases, the HbA1c becomes less sensitive, less specific. 6.5 can end up missing or overdiagnosing people and at various spectrums of age. So HbA1c is something that is fallacious. That apart, I don't favor lowering the HbA1c because you will see almost double, if not triple, the number of people existing living with diabetes currently just by lowering the threshold of cutoffs. You will see a mass getting stigmatized. You will see a mass getting treated inappropriately. You will see a mortality going increased in at least a subset of people who will be subjected to medications causing hypoglycemia. And so I say, and me and Dr. Anand agreed on that, and he told me that 5.6 is where you should be doing risk stratification, risk reduction measures, but not the stigma of diabetes. Biologically, no sufficient evidence, psychologically agony, socially disaster. 5.6 is error mode, 6.5 system ready. So what should we do? To all our patients, increase your practice obesity, treat all the risk factors, yukta ahara viharasya, yukta cheshtasya karmasu. Treat and preach balance in food, activity, work and rest. Elevate the suffering of people, but do not stigmatize. Remember, warning is not the verdict. I rest my case over here. Thank you.
Any rebuttal to Ameya or?
Ma'am, you're the judge.
So I think really in Tamil we say Sriyana Poti. That means very evenly matched. I think both of you argued your case very well. So I wanted to ask a different type of a question. Dr. Ameya, you were mentioning that obviously we are not going to label people diabetes and put them on agents potentially with harmful side effects at a 5.6. I don't think we're talking about that. So my question really is, nowadays we do have safe agents that help to reduce weight, help to reduce HbA1c without causing hypoglycemia, which are being used even in the non-diabetic population. So let's say GLP-1 analog, which we're going to use for weight reduction, or metformin, some people may do well. I'm saying even with a metformin and say a DPP-4 inhibitor combination, we are seeing people who get their HbA1cs down to 6. So my question really is, someone on a medication like this, what happens when they reach a HbA1c below, I'm going to ask both of you to answer that, when they reach a HbA1c below 6.5, what do you do with those medications? When do you think about cutting back? When do you think about stopping medications when they reach that level? Because they have reached, I'm not talking about initiating, I'm talking about people doing the reverse. When they reach that, when do you start thinking about cutting back, and do you wait till it drops below 5.8 or 5.6, or do you start doing it at 6.4 itself?
So answering your question, ma'am, so it's a very, very nice question. So first of all, I think Amey also basically mentioned that, stating that with the lower HbA1cs, what we need to be cautious about is the glycemic variability and the hypoglycemia. So if you're on agents which would actually, promote that, that would cause, more glycemic variability and also hypoglycemia, obviously, you would start cutting back on those drugs at that point. Now, having said that, with the newer agents, as you mentioned, with the GLPs and the GLP-GIPs now in vogue, now we are having increasingly people of less than 5.7 as a target. Most of the RCTs, at least the phase 3 trials, are actually showing us that actually, you do get HbA1cs of less than 5.7 and people are pretty safe. And, the counter argument also to what Dr. May was saying was basically in terms of, when you bring these people down, let's say obese people who are the so-called normal non-diabetics, you sometimes get less than 5.7, 5.5, 5, and they still do well. So because, so obviously this means this is a continuum. So my take on this is, if they are on drugs which would cause potential hypoglycemia or glycemic variability, when you reach that particular area, you start cutting down and also stopping those drugs. So that would include obviously sulfonylurea on top of the list. DPP-4 inhibitors and metformin, in terms of safety, I would cut down the DPP-4 inhibitors next, and metformin. Whereas metformin, SGLT2 inhibitors, you could use SGLT2 inhibitors and metformin also in people without diabetes. So technically, you could continue with those. The GLP-GIPs also, you could continue with those, because we're not just looking at a HbA1c as a marker. You're looking at other issues. We're talking about subclinical atherosclerosis. We're talking about dyslipidemia. We're talking about waist hip circumference reduction. We're talking about a conglomerate of a composite which looks at a lot of things which are risk factors for CVD, and it's not just being centric with the HbA1c.
Yeah, I think I agree on that. That what we have to do is an approach that is not centered on HbA1c but focused on the person with obesity and dysregulated metabolism. I hope all of you learned this from today morning, and I will also share what changes we are doing in our day-to-day practice. When a person with obesity comes, don't be focused only on, okay, whether you are diabetic or not, okay, then you do this, then you do that. identify that obesity is a disease, look at all the risk factors, the hypertension there, dyslipidemia. Remember, an obese person with an HbA1c of 5.2 with uncontrolled hypertension, with dyslipidemia and a raised NT-proBNP is a candidate for SGLT2 inhibitor and DPP4, SGLT2 inhibitor and GLP-1 receptor agonist, and you will see a meaningful risk reduction and prevention of the disease occurring in that particular patient. Coming to the second part of madam's question is about when do you stop treating these people. Yeah. And remember, underline this, in these people, obesity and insulin resistance is the name of the disease. There are various arrows that come, diabetes, hypertension, dyslipidemia. The core pathophysiology is, we have always learned this in retrospect. 7 years ago, we had SGLT2 inhibitors as the main sponsors and we recognized heart failure as the disease. Now we have GLP-1 receptor agonists as the main sponsor and we have recognized obesity of a disease. Sometimes research happens and knowledge disseminates for good of humanity. Remember, investigate every obese patient. If the person has gained weight despite best of the efforts, always tell them, okay, these are the medications for you. What do you do with a person who has achieved remission of diabetes? You tell that person, okay, you are not on any medication, your HbA1c is so and so, I would like to follow you up, don't go back. We all know that remission will result in again reverse coming back in diabetes. Similar is for obesity. You have achieved a BMI of 24, 25, patient no longer keen on medication, you have down titrated, tell the patient that your biology was of weight gain, which happened to an extent maybe because of some things that you did not follow, but to a great extent because of the things that are there in your genes. And I would like to follow you up and see, and that's what the approach we should be having.
So, neither of you answered my question. I said, at what level of HbA1c will you start cutting back GLP-1s?
We answered your question, madam. We will not look
at
HbA1c.
Is it 6.5 or 5.8? Okay,
yeah.
Fine. Okay, in a
we'll
person.
treat it as an anti-obesity medication and not an anti-diabetic.
Okay, so you're not going to look at the
Yeah,
HbA1c.
so that would mean even if we are going down to 4.8 or 4.7, we would not bother about it.
Yeah.
So, okay, fine. So you're not looking at the HbA1c at all. That is the.
If an obese patient with altered. In an obese patient with hypertension, dyslipidemia, raised NT-proBNP, a risk profile that is metabolically bad, I would not look at HbA1c as a reason for tapering down GLP-1.
Thank you. I just wanted that point to be brought out.
That clear now.
Yeah. Thank you. Any questions? Any points from the audience that anybody has regarding this? Since we have a little bit of time left, what is the lowest HbA1c both of you have seen with the GLP-1 analogs?
I've seen 4.2.
Yeah, I mean 4.5 something that I have seen.
And what was the starting? Is this in a person with diabetes or?
No, this is someone with the HbA1c of 5.7. It's dropped to 4.2.
I have seen this happen because now we have almost 9 to 10 months of experience with people with diabetes being treated with GLP-1s, which are very effective. So I mean, at least to a good number of people who are obese with diabetes presenting to you for the first time with diabetes, I have encouraged to tell them that start this medication. Probably it will not only help you protect your heart and kidneys. You might see, basically the principle of reversal and remission of diabetes was 8 to 10% loss of weight, which was achieved by curtailing the calories and improving the exercise. Now, some of the patients who are super responders to GLP-1 receptor agonists, and I have families, I don't know why, but a family where there are 2 to 3 people on GLP-1 probably do better because they have that family tendency to change the diet, change the exercise. And I have people now, 9 months down the line, who at presentation, first time diagnosis, HbA1c was 8.2. Now weight has came down from 120 to 92, 93, and HbA1cs are like 4.5 kind of.
Yeah. Thank you. I think we'll close up. I think both the debaters deserve a round of applause. I think Anand very clearly brought out the fact that a HbA1c of 5.6, we have to start thinking about other aspects of insulin resistance and metabolic syndrome. I think that is what we don't label it a disease, but understand that this person has already started on the metabolic journey and understand and look for that, because even to this day we still have people coming and telling us that HbA1c of 7, my doctor said it's just very mild and you don't need to do anything. So understanding that even 5.6 the risk is starting, I actually got very depressed, but anyway, thank you Anand for that. And I think Ameya very clearly pointed out that we should not be labeling these people, adding to the distress, and of course there are other legal implications. You know, you were talking about insurance, and definitely I don't think any of us are talking about that. But just to recognize that the lower we get the HbA1c, it's more a marker. Like Dr. Ameya said, it's not just about the HbA1c, it's about looking at all of the other insulin resistance parameters. What is their uric acid? What is their fatty liver? What is their triglyceride, their HDL? And overall fitness. I think, as Krishna was saying, it's not about the goal, it's about the journey. The fact that they're on a fitness journey and on a health journey is what is the most important thing that's going to help them. So thank you very much, and I think we had I learned a lot. Thank you to both the debaters for a very enlightening session. Thank you.
Thank you, Madam. I thank symposium. May I invite the chairpersons, Dr. Bharat Bhushan Kukraja and Dr. Manatosh Sutradhar for taking the session ahead, and the speaker will be Dr. D. Prabhakar. Over to the chairpersons to take the session.
Good evening, distinguished colleague. Welcome to the scientific session on the heterogeneity of beta blockers. Means, are all beta blockers same? We are honored to have Dr. Prabhakar D, Senior Consultant Cardiologist from Apollo First Med Hospitals, Chennai, who will be deliver lecture. We will look forward to your insights, sir.
Thank you, sir. Thank you for the kind words. And I shall be keeping you a little occupied over the next about 15 minutes on something interesting. And this is something about a perspective, and the previous speaker finished with this quote. So I thought, let me start with a quote, but with a different looking quote. This is our famous Dr. Swami, who is very famous for his off-key stories. This is what he said. If the USA saw what is going on in the USA would invade the USA to free the USA from the USA. This is what our Swami Nityananda said. And I shall be giving a talk which I hope is not as confusing as this. Now, this is the gentleman who gave me the inspiration, and this man said, I wish I had my beta blockers handy when he got the Nobel Prize for Medicine. This gentleman is a gentleman who identified and first synthesized beta blockers, James Black. What I shall be doing is the beta blocker that he founded is not the same as the other beta blockers, and each beta blocker is different. And we should all understand the only constant in medical science is change. So the change is most important, and the change has happened over several years. And the change that you see here is starting from 1900 to 1950 nearly, the beta blockers or the beta receptors were found out. Then the first thing that came in was the propranolol. Then subsequent molecules started coming in, the metoprolol, the atenolol, the metoprolol succinate, then the carbidiol, and subsequently the last one to be approved by the US FDA as late as 2007, 2008 was the nebivolol. Now, how these beta blockers evolved why did they find out so many beta blockers? Why didn't they just have one? It's not that different companies did one. The same company, the ICI, came up with both propranolol and the atenolol. Why? Because the first ones were non-selective beta blockers. That is the propranolol. Then subsequently, there's selective beta blockers. So what do you mean by the selectivity? Basically, we all know there are three beta receptors, the beta 1, beta 2, and the beta 3. We'll ditch the beta 3 at this point. The beta 1 acts in the heart and the kidney. The beta 2 is the one that acts in the lungs. The beta 2 agonists or the salbutamol that we see, we all know. So one that is very selective to the beta 1 are the selective beta blockers. That is when the atenolol, metoprolol, and bisoprolol came. Subsequently, the non-selective beta blockers, which are vasodilating. So they thought that vasodilatory property is going to be more beneficial. So vasodilatory beta blocker. Then subsequently, the selective beta blocker vasodilatory came. So we have multiple varieties. You have a basket of beta blockers. How can they all be the same? Obviously, they're going to be different. And in this, there is some other additional classification. Then they said they could have this intrinsic sympathomimetic activity that could happen. I think what is gone? I think it's the presentation is gone. Give me 1 second, please. Sorry. Okay. Works? Yeah. So this subsequently came changed as patients who had beta blockers which had intrinsic sympathomimetic activity and without intrinsic sympathomimetic activity. That again into selective, non-selective, and then came the alpha blocking activity. Alpha blockers came in together, the carvedilol, labetalol. In all this, there is one beta blocker which doesn't fit into any particular category, which is the beta blocker that is selective and a vasodilator, that is nebivolol. So what we shall be doing is talking a little bit more about these beta blockers. There are a whole lot of indications for beta blockers. I'm sure all of you have used this in most of these indications, but I shall focus on just 2 indications because 15 minutes I can just do this. One on hypertension and 2 on heart failure. All of us have used it in hypertension, heart failure. There are classified drugs, but I shall look at it differently. We all know the class effect of beta blockers is going to be reduction in heart rate and contractility. Then you have the blood pressure reduction, myocardial oxygen demand, all these are known. Then you have the selectivity of the alpha and the beta, and then you have the nitric oxide effect which can produce vasodilatation. Then there are these additional benefits which we will be looking at. Now there are 2 kinds of beta blockers in clinical practice, the conventional beta blockers and the vasodilatory beta blockers. Now the vasodilatory beta blockers, once they do a vasodilatation, are going to drop the blood pressure. So obviously they should be more beneficial and they increase the peripheral blood flow and reduce the blood pressure. Now this is going to be interesting because there are 3 ways in which you can produce vasodilatation. One is if you increase this sympathomimetic activity. The blockers, instead of doing that, be a partial agonist, there is going to be there. But unfortunately, all the trials were negative when they started using intrinsic sympathomimetic activity, so that is out of the question. So next, the alpha blocking effects of carvedilol and labetalol came in, and carvedilol vasodilates, but it still reduces the heart rate, basically meaning that the alpha effect is there with a little bit of vasodilatation, but still the beta blocker effect is predominant to the reduction, but not much. Then came the newer modality called the nitric oxide mediated one, which is actually through beta 3 agonism. It's not antagonism, it's agonism, wherein there is an increase in the nitric oxide production. I'll talk about it in heart failure a little bit. So that is going to be nebivolol. Now how does nebivolol and the vasodilatory beta blocker differ? Mainly, the biggest problem with beta blockers in most of the trials has been that we have said that the central aortic pressure rises or it does not fall in beta blockers, stroke increases. These vasodilatory beta blockers block that. So what happens is the central aortic pressure actually comes down when you start using these vasodilatory beta blockers. That's the primary difference between these 2. Now what is the evidence for nebivolol? I told you I'm going to give you a little bit of gist on nebivolol. So the evidence, there has been one large study which has actually shown 20 by 10 millimeter reduction in the blood pressure over a period of about 12 weeks. Now what about the other parameters? This is very interesting. 13 millimeter fall in the blood glucose. HbA1c came down by 0.25, okay, fine. The total cholesterol came down by 16, LDL came down by 13, HDL actually went up by 2, triglycerides by 24. So you have a lot of additional benefits which are generally not seen with a beta blocker. Then what about the microalbuminuria? We say that microalbuminuria is there, these beta blockers have no effect. There is this particular data which has clearly shown that with a BP reduction of about 20 millimeter, you're going to have a significant reduction, not only in the systolic and diastolic blood pressure, the albumin creatinine ratio also significantly starts coming down. Now there are additional benefits apart from this. Interestingly, in a patient who's on a dialysis, beta blockers, we always keep telling carvedilol is non-dialysable. Actually, it is the least dialysable. The non-dialysable one is actually the nebivolol, which is less often spoken of. So what you can do is either you use a bisoprolol, carvedilol, or a nebivolol. Actually, the best one seems to be nebivolol because most of the hypertensive patients develop, CKD patients have hypertension. If you want to use a BP reduction drug also, nebivolol seems to be the drug, and it is not going to bother you. Some of these patients develop tachycardia during their dialysis. Probably you can give dialysis. Before the dialysis, you can give nebivolol. It is not going to create a problem. Another interesting fact I found out was that nebivolol given to patients who are having a little bit of a slight elevation of creatinine compared to metoprolol, contrast-induced nephropathy also comes down.
So to summarize all that we have seen about nebivolol, it seems to be a wonderful drug. It seems to be having a lot of value-added services. Today we don't talk about buying a car. You say, what are you going to give me in addition? So as a beta blocker, the additional things is, one is the dual mechanism of action, wherein there's nitric oxide that is going to be stimulated and producing vasodilatation. Then you have metabolic neutrality. What happens is the glucose level seems to be better. It also actually reduces the insulin levels. Tolerance seems to be much better, because even compared to a bisoprolol, this drug in a large randomized study was shown that compared to bisoprolol, this drug was superior. I'll show you one bit of that study later. Erectile function advantage, it does not produce erectile dysfunction. It actually improves because of the vasodilatory effect. Hemodynamic profile, the afterload reduction seems to be slightly increasing the heart rate, but that is offset by the beta blocker action. So ultimately there is a slow reduction in the heart rate also. Endothelial function, because it acts on the nitric oxide levels, improves. So you have a beta blocker that is more or less complete. This is a beta blocker which should ideally be used in a patient with metabolic syndrome and diabetes. So in a diabetic with a slightly increased heart rate, or even at the same heart rate, you have all the beneficial effects that you should be having. Probably this should be used as much as or next to an ARB or an ACE inhibitor in these group of patients. What do the guidelines say? The guidelines recommended that beta blockers can be used at any stage whenever you find the indication right, and the vasodilatory beta blockers have specifically been recommended in the diabetic persons also. Now, the most common drug, the industry is gaga over only one particular drug recently, which is the bisoprolol. Everybody says use bisoprolol, bisoprolol, bisoprolol. So what is there? Is there a comparison with betaprolol? Yes, there is a direct comparison called the NEBIS study between nebivolol and bisoprolol. Look at the BP reduction with nebivolol and bisoprolol. Nebivolol is 15, 16, 15.7 and 16, no difference. Responder rate marginally better. What is responder? You get a systolic BP less than 140 or at least 10 millimeter reduction in blood pressure, slightly better with nebivolol. What about adverse effects? Significantly lower amount of adverse effects with nebivolol compared to bisoprolol, clearly showing that this drug is equal, if not superior. But what about other beta blockers and vasodilatory beta blockers? Yes, there is one big meta-analysis, or it's rather a retrospective cohort analysis of about 5,000 patients, which compared vasodilatory beta blockers and non-vasodilatory beta blocker. Vasodilatory that was compared was nebivolol. Clearly, it showed a 17% reduction with the compared to the non-vasodilatory beta blockers. This is about cardiovascular events. Now look at the subgroup of patients. It seems to be working in all subgroups of myocardial infarction, stroke, heart failure, angina, revascular. Everywhere it seems to be better. And compared to metoprolol, it was 24% better. All these were statistically significant, clearly showing that as a vasodilatory beta blocker, the nebivolol seems to be the best. So how do you compare the four commonly available beta blockers? The metoprolol, bisoprolol, carvedilol, nebivolol. Selectivity, very high with both bisoprolol and nebivolol. Vasodilatation is good with carvedilol and nebivolol. BP effect, good with the last two again. Very high heart rate reduction only with bisoprolol, agreed. But metabolic effect is better with nebivolol. Look at COPD, asthma, both biso and nebi can be used. What about central aortic pressure reduction? Only nebivolol. Look at which drug has got more greens. So which beta blocker should you use for hypertension? Clearly nebivolol. So nebivolol should be the drug that should be spoken. Don't go by what non-science says. Clearly nebivolol has got the evidence, and that should be the drug of choice in hypertension and when you want to use a beta blocker. What about nebivolol in heart failure? It is not recommended in heart failure most of the times. Why? Because of it, there is a trial, but it's still not recommended because of certain interesting factors. Beta blockers in heart failure, clearly they reduce the heart rate, increase the pathophysiology, sympathetic activity is reduced, and by reducing the heart rate and myocardial oxygen demand, this drug has been shown to be effective in in reducing the complications and mortality in heart failure. Yes, clear. But there are a few interesting limitations in that. What are the limitations? Older patients are generally not studied. Individuals with chronic kidney disease, not used. Beta blockers are not there in the 4 guideline-directed medical therapy for heart failure with preserved ejection fraction. In fact, when you start giving a good dose of beta blockers, patients complain of fatigue, bradycardia, reduced exercise tolerance. So traditional beta blockers can actually exacerbate the metabolic parameters, and they actually reduce the tolerability of these drugs. So where does this lead us to? This leads us to endothelial dysfunction again, and what happens is when you start stimulating the beta-3, the eNOS or the endothelial nitric oxide synthase starts producing nitric oxide. Normally this is produced. In an acute beta adrenergic stimulation, nitric oxide is synthesized. So there is a vasodilatation. But in chronic stimulation, this pathway is lost because of the oxygen free radicals that come in, there is uncoupling of the enos and there is endothelial dysfunction. So how do you reverse this? So the way to reverse this is giving nebivolol. So what happens when you give nebivolol? There are two kinds of nebivolol, the D-nebivolol and the L-nebivolol. D-nebivolol is responsible for the selectivity. It varies selectivity about 300 times selectivity, and the selectivity is retained. Normally when you use a higher dose of a drug, the selectivity is lost, but up to 10 milligram, which is a therapeutic dose, the selectivity is retained with beta-1. When you use nebivolol, that acts on the heart and produces the beta effects, like all the beta blockers. But the L isomer, that is going to work on the beta-3 agonism, that has significant vasodilatory effects. It improves the endothelial function, and the whole picture of the heart failure with endothelial dysfunction and blood pressure, entire thing starts improving. Now, is there any specific improvement or advantage with this drug? The half-life of this drug is 12 to 19 hours, clearly making it once-a-day preparation. And the results are very favorable because the afterload is reduced. There is also a reduction in central aortic pressure and use in special populations, because the major trial in this, the seniors trial, is actually in elderly patients where it is useful. There are additional antioxidant, anti-inflammatory properties that have clearly been documented, anti-apoptotic properties which are very useful, especially in the diabetic and CKD patients, is also there. Now, the key clinical trials in heart failure, there are plenty of trials. The ENICA, seniors, ELAND, all these showed that there is an improvement in the exercise tolerance. There was a reduction in the cardiovascular mortality in the seniors trial, about which I'll give you one more slide. And there is the reduction in the central aortic pressure. There are two sub-studies of the seniors trial also, and there is the Carnaby Intensic and Renaissance trial. All trials showed, in fact, the Renaissance registry showed all beta blockers are the same, including nebivolol, everything was pretty much the same. Now, in the seniors trial, which is a trial of heart failure patients in the elderly, the mean age of 76 years, mind you, 76 years, so elderly patient getting a beta blocker. All-cause mortality or cardiovascular hospitalization was reduced significantly. Look at the p-value 0.039, number needed to treat 24, which is excellent. Key interpretation is that it was mainly driven by heart failure hospitalization, which is what you want ultimately for these patients. Merit of this trial, this is the only trial with very large amount of elderly patients. Demerit is that it did not reduce the patients with mortality in this group of patients. Now, there is a sub-study of this with an ejection fraction less than 35 and more than 35, clearly showing that the trends are pretty much the same. The numbers were not significant enough to achieve a p-value significance, but the trends were same between 35 and 45. So possibly this is the only beta blocker with some amount of data that can be used in heart failure with preserved ejection fraction when there is a specific indication, like you have a patient with ischemic heart disease. So finally, I looked at all these things, and as usual, what I did, I went to the artificial intelligence. So I put it on different AI platforms and asked in hypertension, which antihypertensive drug will you choose for hypertension? Now, this is what it came up with. Hypertension with heart failure, it says carvedilol is better than bisoprolol and metoprolol. It still doesn't use nebivolol because nebivolol is not in the guidelines, but there is enough evidence. The article I quoted and showed you just now is from 2026, Journal of Vascular Biology. It is probably coming up in future. Hypertension with diabetes, nebivolol. Hypertension with COPD, again nebivolol. Hypertension with erectile dysfunction, nebivolol. Look at hypertension with orthostatic hypertension. Probably you have to avoid carvedilol. You can use any other drug. Hypertension in the elderly, data is on nebivolol. Hypertension with stable angina, where you want a heart rate reduction, maybe bisoprolol scores. Hypertension with obesity and metabolic syndrome, nebivolol. So finally, ladies and gentlemen, what we are looking at is that all beta blockers are not the same. Nebivolol seems to be a distinctive beta blocker. BP reduction, vasodilatory action, which is quite different because of nitric oxide, improvement in the oxidative stress and inflammation, anti-ischemic effect, reduced wall stress. It's a non-dialyzable molecule, metabolically neutral, improves lipid profile, improves erectile dysfunction, does not exacerbate asthma. I have tried to combine too many things and hold the sun in my hands. Hopefully, I have done some justice to what I wanted to say. Thank you very much for the patient listening. Hypertension with depression. Beta blockers generally are not very good drugs. But if you have anxiety state, you can give the beta blockers. There, generally, they say use the non-selective beta blocker like propranolol is supposedly better.
We'll take question later on, sir. Please take your seat. So, next speaker regarding very nice talk, sir. Very nice talk. Positioning T3 in clinical care. We are privileged to have Dr. Ameya Joshi, consultant endocrinologist from Borivali, Mumbai, to deliver this lecture. Dr. Romiyo Joshi, please.
Thank you, chairpersons, for the kind introduction, and it's privilege to be here again within a span of half an hour. I would just start by saying that there was a speaker who asked a mixed audience, a lot of people sitting and from different fields and strata. And he asked a question which was a little curious. He said, tell me something in your life which is permanent and something that comes and goes. Finally, one obese man came up, woke up, he said, sir, weight is permanent, weight loss comes and goes. Then a young man got up, he said, sir, wife is permanent, girlfriend comes and goes. Then finally a poor endocrinologist treating thyroid patients got a chance to speak. He said, sir, T4 is permanent, T3 comes and goes. It was in market for some brands. We are actually, when it is not available, we used to search for T3 because we used to get a right patient for T3, like a myxedema coma or somebody whom you have to make fit for surgery, and it used to be not available. And when it is available, we never found that patient. And finally now we have a consistently available T3 from a good multinational reputed company. I hope they continue giving it, and I am privileged to talk on that. But ladies and gentlemen, you know, a lot of patients who see a doctor with hypothyroidism may not always be an endocrinologist, because hypothyroidism is 10 to 15% in the general population, are actually having a normal T3, T4, TSH. They want their dose to be changed or some miracle to be done, and most of the times what they get, you know, is a multivitamin and a B12 level that is about 2000 and a weight that is not reducing and the brain that is thinking and thinking and thinking. And you will typically find those with either a slightly high TSH or a little normal TSH, and we tell them, okay, let us look beyond hypothyroidism. You know, hypothyroidism mein kya hai, ho gaya, it's I mean, let us look beyond, it's normal. And she actually needs, our patient, a prototype here, needs a treatment that will satisfy her. And a good number of these patients with hypothyroidism who are treated with T4 remain unsatisfied and do better with T3. I'll tell you the reason why. But then before that, let us look at two more cases. The second is a 45-year-old lady due for cholecystectomy, known hypothyroid, thyroxine 50 micrograms she was taking. Suddenly a thyroid function test is done. TSH is 72. She says that, okay, I have to travel after some time. I would need a little early surgery. What to do? T4 will take at least 4 to 6 weeks. And then there is a 68-year-old gentleman who is an executive working in a high-profile job, actually down with a papillary thyroid cancer, and we tell him that, okay, sir, we have to withdraw your thyroxine for, say, 4 weeks. And then he says that, okay, but my job involves very high level of intelligence, you know. So tell me what I can do. Do I have an option? So what you need in case 2 is a medication that is fast acting, and in case 3, a medication that has a short half-life. So withdrawal should result in a rapid rise in the TSH with a rapid clearance of the hormone, and that's T3 for you. T3 is something that is more active, at least in certain group of cells and tissues, and in hypothyroid patients, you will have around 20-25%, while T3 is actually not getting adequately formed. You will need a thyroid hormone that will bring down euthyroidism rapidly in certain cases like myxedema coma or say due for surgery or severely affected quality of life. And you will also need rare indications. I told about the elderly man due for radiation therapy. Beyond that, there is a state called as consumptive hypothyroidism, where all the T4 is converted to reverse T3 and you need T3 to take care, and that's very, very rare, 1 in few millions, and endo will see once in a lifetime or little less than that. So why are our patients still unhappy? Unhappy because thyroid gland produces 2 hormones, T3 and T4. We treat them with T4 and we expect that the T4 will be converted to T3. to an extent that we only do free T4 and TSH, at times only TSH in follow-up of patients with hypothyroidism. And we rely that in the T4 that we are giving will be converted to T3 by an enzyme called as deiodinase. However, what happens is that in 10 to 15% of people with hypothyroidism, the deiodinase is less active. And you will typically find a thyroid profile where T3 remains low, normal, little low, T4 is normal, TSH is normal, we pass it everything normal, and the person still has effects of hypothyroidism like brain fog, a lipid profile that shows little high LDL, and the dissatisfaction is there, and we call this as tissue hypothyroidism. Some people have mutations, some people have the autoimmune process which makes the deiodinase less active, but it leaves room for a lot of people to be improved. Because even if you treat 20% of hypothyroid people with T3 and they feel better, they achieve a better quality of life, the number is in millions. But let us understand that even your thyroid gland produces 15% of its output as active T3, and 85% is T4, which is again converted to T3 at the tissue level. Imagine when you are giving plain T4, you are starting with 15% deficit. When your deiodinase is less active, the deficit is more profound, and you have a good number of people who are symptomatic. Symptomatic because they are deprived of more potent, faster acting and short half-life hormone, that's T3. Now, let me explain you in a minute how to kill a medication. That was the first treatment for hypothyroidism. T4 and T3 given in one arm, T4 given in another arm. Those who were given T4 and T3 combination were given 80 microgram T4 and 20 microgram T3, which is equal to 125 to 150 microgram equivalent of T4, 2 to 3 times in a day. Deliberately overdose the patient, then declare that you have found that the overdose is causing a problem like palpitations, and then junk the medication. That's what was done to T3 long back in 1970, and it's 55 years down the line that T3 is still, not got that sanctity back which it deserves. And as a result, we end up seeing patients with hypothyroidism, loading them with vitamins or just giving them some placebos to tide over the crisis. And first time in this meta-analysis in 2021, a large meta-analysis of more than 1500 patients proved that more number of patients who are given T3 actually feel better and more satisfied with their treatment. Now, an evidence of that has started accumulating, and I will quote 2 randomized crossover studies done in small number of patients. Randomized crossover study meaning one group receives T4, another group receives T4, T3 combination, then you change over, and the same patients who received T4 now receive combination, same group that received combination now receives only T4, and then they were given ThyPro questionnaire to look at physical, mental and social domains, and they realized that those who took T3 reported much better outcomes in the ThyPro questionnaire. Same person given both the treatments will prefer combination of T4 and T3, and the same things or similar study was done by Selly, but they also gave objective marker of benefits of T3, that is better weight loss and a dip in the LDL cholesterol. So if you have hypothyroids which are not reducing onto weight, a small amount of extra weight loss can be achieved by T3, substituting T4 some of it, and then LDL cholesterol can be lowered. ETA in 2012, remember 42 years after that 1970 paper that junked T3, endorsed T3. European guidelines endorsed T3 in 2012. American Thyroid Association first time in 2022 said that you may consider in select group of patients, and these were the different guidelines across the globe. Now this is a paper which is written in thyroid research and clinical practice by Indian Thyroid Society led by Dr. Krishna Seshadri sir, which gives clear indications of T3. Unhappy, refractory, severe hypothyroidism, symptomatic hypothyroidism, or states where you want rapid redressal of symptoms, or there is insufficient control with doses of T4. So if your dose of T4 is going beyond 1.8 microgram per kg, patient is not under control, do not go on increasing the dose. Maybe addition of little T3 will help. Ensure compliance, rule out malabsorption. That's what this paper tells you in between the lines. But if you are convinced that a patient is taking a good quality preparation properly, there is no malabsorption, be bold enough to add little T3 that might control your TSH better. So how much T3 to give exactly? What should be the ratio of T4 and T3? And the suggested ratio is 13 to 20 is to 1. And if a person is having a normal TSH, it is better to reduce the dose slightly. I'll tell you, if you are reducing the dose of T4 by 12.5, add 5 micrograms of T3. How does T3 differ? T3 is ideally given 2 to 3 times a day, but you can even begin by giving it once a day and make it twice or thrice, because it has a smaller half-life. And always tell the patient, I am giving you this medication after monitoring certain baseline parameters like heart rate and bone health, and let us reassess after 3 months. If you are comfortable, happy, we'll continue it. If not, be open to say that I stand corrected, but I did all the safety checks to know that I am doing the right thing for you. So imagine that a patient is taking 100 micrograms of T4, you have to add little T3. So reduce 12.5 as I said, add 5 micrograms of T3. So the ratio becomes almost 17:1. That's a typical 100 kg, patients with a weight between 50 to 70 who need 100 to 125 dose. This should be the correct kind of thing, like 88 to 100 of T4, 5 to 10 of T3, and most of them you will find do better, like our patient did better. Remember that hypersensitivity is rare. The main thing that you need to monitor is cardiovascular health. Be very careful in giving it in patients with impaired cardiovascular health, because it can increase heart rate, and it's not approved in pregnancy. It does not cross the placenta. Refrain from prescribing in children and pregnant ladies T3. Give it to your adults. What to do before giving? Baseline ECG, screen for osteoporosis in those who need screening, and thyroid function. Remember, you can't do a random thyroid function. It's better to give a 12 hours gap after the dose of thyroxine and then test for it. Otherwise, you might get little funny level with the T3 going high. The aim is still to normalize the TSH, but the correct time to do is 8 to 12 hours after the dose. T3 has a narrow therapeutic index, so be very careful in up titrating. T3 is very tempting, you know. Even when I wanted, it was not available in the pharmacy. The gym people used to get it very easily, because it gives you a lean look, causes fat burning. And don't prescribe to gym people, because they are abusing it, not using it. And the reassuring part is the long-term data is comprehensive and safe, but short-term erratic use is bad. A long-term use in this particular study, comprising hundreds of patients who took it for 17 years, has been reassuring, with no additional risk of atrial fibrillation, cardiovascular disease or fractures. The bottom line is very important. If you know how to give T3, give T3. If you don't know how to give T3, identify the person who needs T3 and refer to an endocrinologist, because this is a medication that has a narrow therapeutic margin. It will improve your patient, it will give benefit. You have a patient with hypothyroidism not satisfied, there could be two reasons. Other conditions than hypothyroidism that are coexisting, like autoimmune causes, so on and so forth, or the person may be a candidate for T3. If you are capable of handling it well and good, if not, refer to an endocrinologist. T3 combination with T4 is ideal. It helps a good number of patients. It has to be given on case-to-case basis. It has to be given under supervision, but it helps you satisfy the patients who are not satisfied, control who are not controlled, give a rapid control, and help in withdrawal in certain succinct situation. And remember, patients with hypothyroidism who are not satisfied with the treatment, think of T3 as one of the treatment options that can improve their satisfaction. Thank you one and all for your patient listening.
Thank you, Dr. Yossi. Please join me here. It's my privilege now to invite Dr. Vimal MV
He's going to tell us about the glargine biosimilars, optimizing glycemic control and the role of different biosimilars. Over to you, Dr. Vijay.
Good evening. At the outset, I'm extremely grateful to the debate team for having me here to discuss something about a topic. In the era of GLP-1 as well as dual agonists, I am feeling a little bit tense and afraid to talk about this basal insulin and everything. But still, topic of discussion today is optimizing glycemic control, evidence with interchangeable insulin glargine. So I have put an MCQ here. As per ADA standards of care in 2026, the first injectable therapy to be considered in most patients with type 2 diabetes mellitus is, you can scan and answer. Which among the following is the CV outcome trial of glargine? I think it's coming. Okay. So I have been supported by Eris Life Sciences for this talk. My journey with diabetes, I will just start with a patient who is a diabetic for the past 10 years. She has been taking oral medications from the start of the disease. She was initially on metformin, and then she was started on glimepiride as well as sitagliptin. So we can see that her BMI is 25 and she consumes around 1500 calories per day, and her HbA1c is high, it's 9.1 with fasting of 182 as well as PPBS of 244. So what will you do for this patient? Will you add insulin or will you add with some other drug? That is a question that we are going to answer now. So definitely we know that as per even the landmark trial has showed that adding a fourth oral anti-diabetic drug may not fetch results. Probably this patient might be a good candidate for starting insulin, and adding another OAD may not be that much suitable for this sort of a patient. So what are the compelling indication for starting a patient with type 2 diabetes mellitus on insulin? When there is a combination of non-insulin antihypertensive medications are unable to bring the patient to glycemic targets, and when non-insulin medications are associated with unacceptable adverse effects, or if there is advanced liver or kidney disease, or in pregnancy as well as in hospital settings and presence of severe hypoglycemia, probably you may have to go ahead with starting insulin in this sort of patients who have poor glycemic control on oral anti-diabetic drugs. And it's also pretty clear, I think this has been discussed in detail in the past also. Early and intensive initiation of insulin is the need of the day. And we have seen that the AAC guidelines have clearly told that initially you can consider GLP-1 receptor agonists, which may not be suitable for many patients. But if the HbA1c target is high, you definitely think of starting a basal insulin to start with. So for this patient, Mrs. Srimati, which is the insulin that you will start for this lady, probably you can think of starting her on basal insulin. Why basal insulin? Because fasting sugars are high. So when the fasting sugars are high and PP sugars are not very high, not disproportionately high, probably this sort of people, they will respond very well to starting of basal insulin. And we can start with 0.1 to 0.2 units per kilogram, and based on the body weight as well as based on the initial HbA1c, you can think of titrate the dose of basal insulin and you can achieve targets. And also if you go to the and it's very clear that we should bring down the HbA1c, because bringing down each point of HbA1c can lead to improvement death. Diabetes-related deaths can be improving by around 21%. So it's very clear that we can achieve, bring down the HbA1c with this sort of molecule and can bring down mortality associated with diabetes mellitus also. So which is the best insulin in this patient? I think there will not be any doubt here, because the fasting is high. It is around 190, PPB is around 240, the difference is only 50. So when there is a difference between fasting and PPB is very less, it's less than 50 milligram per deciliter, probably you can think of starting a basal insulin in this particular patient. So across the globe, if you travel from US to Canada to UK or to wherever place, Australia, wherever you go, the guideline for starting an insulin will be probably trending towards starting a basal insulin. So even Indian guidelines, RSD guidelines says that to start insulin, you can think of three types of initiation. One, either it is basal insulin or a co-formulation or a premixed insulin. So these are the three ways of initiating insulin therapy as per the RSD recommendations. So these are the three types of insulin which you can consider for starting a patient with uncontrolled diabetes mellitus. It can be either basal, premix, or a co-formulation. So there is a concept of fasting in range. So if in the higher HbA1c, it's predominantly HbA1c is being contributed by the fasting glucose, as is evident by Monier et al. Data, and it's very important that we bring down fasting glucose into target, because fasting getting controlled, even the PP sugars will get controlled, and treat fasting first, bring fasting down first so that even the PP sugars are controlled. I think fasting in range is one of the concepts which has come up, and we see that the glucotoxins associated with will be coming down with the fasting coming to range. So addressing fasting glucose can initially lower fasting levels and even improve postprandial glycemic excursion by bringing down the glucotoxicity, or you can even modulate the diet and even modulate other oral antidiabetic drugs to bring down the PP glycemic drugs levels to target. And even according to ADA 2026, the question that I put is, which is the first injectable recommended in a patient with diabetes mellitus? Any comments? It is either a GLP-1 receptor agonist or GLP-1 GAP co-formulation, which is the recommended one. But the statement goes like this: if injectable therapy is needed, you can consider GLP-1 receptor agonist or dual GLP GAP agonist. If the sugars are not getting controlled, you may have to start insulin, and then the insulin of choice is, it is basal insulin. So consideration for adding basal insulin is definitely there as a second option as per the recent ADA guidelines. And for majority of the patients in India, probably they may not be affording injectable GLP-1 receptor agonist in patients with type 2 diabetes mellitus. And definitely we consider basal insulin as the initial insulin for patients with diabetes mellitus, especially in India. And even as per guidelines, the first choice of insulin as such is basal insulin. There is no doubt. And it's also pretty clear that glargine has stood the test of time. So if you ask me which is the insulin which I might have prescribed very commonly, most frequently in the past 5 or 10 years, probably it is glargine. And the basal insulin and cardiovascular and other outcomes in dysglycemia, that is the origin trial, has shown that glargine is CV neutral. There is no detrimental effects for the heart or CV outcomes with the use of glargine. It is one of the longest duration trial, around 6.2 years duration, with a very large number of patients, around 12,000 number of patients have shown that, and across the globe, around more than 40 countries, it has shown that this molecule is very safe for the heart, and all the CV outcomes, for all the CV outcomes, this molecule is neutral. There is no increasing CV risk associated with this molecule, and insulin glargine has a neutral effect on CV outcomes and cancers. We always talk about CV benefit for any molecule getting released post rosiglitazone era. So it's very clear that the origin trial, which is involving very large number of patients, have shown that this molecule is CV neutral. And there are so many sub-studies after origin trial was released. It is one is origin GRACE trial. It is a subset analysis which showed that carotid intima media thickness will come down significantly, non-significantly with the use of this molecule, and it delays the progression of the carotid atherosclerosis. And original study has the post, just like UKPD's follow-up trial, this a follow-up of origin trial has shown that they are not at all having any detrimental effect on CV outcomes as well as cancers. And now, nowadays we are having co-formulations with which this molecule is getting compared. So comparable efficacy of basal insulin has been demonstrated with the IDA-GASP, which is the co-formulation. One of the articles, an RCT, global RCT showed that they are almost equally efficacious as far as the number of people achieving glycemic targets are concerned. And even with premixed insulin analogs, there is a comparison study known as Galapagos trial. I think you might have come across this trial, you might have read this trial. We showed that they are almost, the proportion of patients achieving glycemic targets are similar between basal insulin as well as once or twice daily premixed insulin analogs being given together. But at the same time, there is an advantage that this molecule produces less hypoglycemia. And even hypoglycemic risk is less if you are giving this molecule, as per one of the studies which has shown that this molecule might be producing less of hypoglycemia when compared to giving co-formulation. There is a statistically significant less instance of hypoglycemia with glargine 100 as compared to IDA-GASP. And also, another important point, I think most of the patients, most of the doctors or most of the physicians might be favoring use of premixed insulin analogs. It's very clear that premixed insulins have significantly increasing the number of hypoglycemia, and even the Galapagos study have shown that there is significantly increased incidence of nocturnal hypoglycemia, about which we are worried about, because nocturnal hypoglycemia can lead to silent coronary events, cardiac arrhythmias, and even sometimes it may be one of the reasons for development of dementia, especially in elderly people. And also, if you compare the cost of glargine, even even innovator glargine, which has come under price control also, and even the biosimilar glargine, you can see that the annual cost of therapy, which is very important in Indian context, is coming down significantly with the use of basal insulin or even basal insulin biosimilars. Around nearly 66% of the cost reduction can be expected with the use of basal insulin or even biosimilars. So, is hypoglycemia with insulin glargine, actually we always feel that the second generation basal insulin might be having significantly less number of hypoglycemic episodes. Whether there is adequate proof for that, actually not much evidence to say that they might be having, the second generation basal insulin might be having significantly better profile regarding hypoglycemias. If you see the type of hypoglycemia, glargine 100 and degludec comparison, you can see that the number of hypoglycemic episodes, the benefit is slightly better for degludec when compared to glargine. It's not at all very much significant. You can see the number. You can see here the nocturnal hypoglycemia may be around 0.46 episodes per patient year in glargine. At the same time, 0.27 episodes per patient year for degludec may not be, it may be statistically significant, but the episodes as such, numerically it is very, very less. And the severe hypoglycemia also not very significant. Overall hypoglycemia is also not very significant as per this meta-analysis. So it's very clear that it is an overhyped improvement in hypoglycemic risk for the second generation basal insulin when compared to glargine, and there is a huge wall of evidence for glargine and around 925 clinical trials, 822 RCTs for glargine, and even the Surpass trial, Surpass 4 trial, where even tirzepatide has been compared to glargine. So whatever study you take across the globe, whatever study you take, whatever molecule is getting released will be compared with glargine. That is the level of evidence which is in favor of glargine, and around 89 million patient years have been put on glargine since its launch. And I think it's one of the breakthroughs as far as the type 2 diabetes mellitus treatment armamentarium is concerned. And factors determining insulin initiation, again, compared to co-formulation, it has got similar efficacy, better safety, because hypoglycemia might be less, and cost-wise efficiency also there when compared to co-formulation or even premix analogs. And all the bioequivalences in efficacy and safety between reference basal insulin and interchangeable glargine 100 are all biosimilars interchangeable? No, interchangeability is something different. So what is interchangeable insulin? It's a biosimilar product. That means additional requirements outlined by the biologic price. So they should be interchangeable. So one glargine can be given, then this molecule, this interchangeable can be given, and then again they can be switched back to glargine. So the interchangeability should be proven. So there are studies which have shown that they are interchangeable, and the use of this sort of biosimilar insulin, there are studies like for Basilog, there are studies. One is INSTIDE 1 in type 1 diabetic patients, for INSTIDE 2 in type 2 diabetic patients, and it was seen that they are comparable regarding their efficacy as well as their hypoglycemia risk. Efficacy profiles were similar regardless of previous insulin exposure. INSTIDE 3 is the trial which showed that they are interchangeable. So that means, just like the previous speaker told, the switching sequence, the molecule has been initially biosimilar insulin was tried, then they were changed to Lantus, then they were again changed to biosimilar insulin, and they were studied. It was seen that throughout the study period, and they were compared to the reference product, and throughout the study period, the HbA1c remained normal, stable, without any risk of any immunogenicity and without any risk of any sort of adverse events. So one of the concerns that we might be having, that they may be having some sort of immunogenicity that is disproven by the study of the INSTIDE 3 trial, and this is one of the molecule which has been approved by FDA as an interchangeable basal insulin. So interchangeable basal insulin biosimilar product means it can be substituted for the reference product without the intervention of the prescriber. The doctor need not prescribe, even at the pharmacist level, the drug can be substituted for the biosimilar one. So to summarize, early insulin initiation provides better glycemic control and reduces the risk of development of complications in long run. So there is no doubt about that. Efficacy, safety and cost determines the type of insulin to be initiated in a patient. Use of basal insulin will reduce the out-of-pocket expenditure by up to 60%. And there is no additional risk related to switching, and they are interchangeable. And even India specific study have shown that similar results are as global trial has been reported. So to conclude, interchangeable glargine has similar efficacy and better safety profile as compared to co-formulation of premixed insulin, in addition to significant cost reduction. So the question answers, as per AD standards of care, the first injectable therapy to be considered is a GLP-1 receptor agonist or GLP dual agonist. Which among the following is the CV outcome trial of glargine? It is Origin trial. So thank you so much for your patient listening. Thank you.
Thank you. Thank you, Dr. Vimal. Please come and join us. Because of paucity of time, we don't have much time to discuss any. Yeah.
So I have one question for the thing. When we use beta blockers for a long time, mainly metoprolol thing, you do get something like a sick sinus syndrome. Many of them do have the thing, hypotension after some time. I don't see that with nebivolol. Is it because its heart rate lowering is much lesser, or is it because it acts differently?
Actually, both the points that you said are correct. It's not because of the metoprolol. It is because there has to be an underlying substrate on which this problem happens. Sometimes you notice that these patients go in for a complete heart block also. Unless there is a substrate for going in for complete heart block, it never produces complete heart block. Subsequently, they will definitely go in for a complete heart block requiring a pacemaker. So most of these patients, if you withdraw it, it will improve, but it will create a problem. What you're saying, the other point is true. The heart rate reduction is much less with nebivolol because it's offset by the vasodilatory effects, which produces tachycardia. That's correct.
Sir, Dr. Prohagar, nice dynamic talk. So regarding hypertension guideline, so we first block the as a rest blocker or a C inhibitor, just to decrease the production of aldosterone, just to prevent stroke. Second line drug is a calcium channel blocker. Do you place nebivolol as a beta-3 agonism like vasodilatory property as well as decreasing the central aortic root pressure? So up position it just instead of calcium channel blocker, because lot of patient having HFpEF, epicardial fat or fat around coronary, so patient couldn't understand he is having HFpEF sort of issues. So do you people opposition this sort of beta drugs?
So I'll answer this question a little differently. If you look at the guidelines, the best response to that question comes in the European Society of Cardiology, European Society of Hypertension guideline. Everybody sees that you give any of the 4 or 5 classes of drugs, anything as a first line of drug. But the point above that nobody has read, because it says ultimately BP control is paramount. You get the BP down, that is most important. It doesn't matter how you bring the blood pressure down, bring it down. Beta blockers today can be positioned anywhere. That is all the guidelines I've said. You can use it even as a first line drug, provided your patient. See, you have a young man with tachycardia, sympathetic activity, you want to reduce the heart rate and reduce the blood pressure. The blood pressure is going to come down only with the vasodilatory beta blocker. You give bisoprolol, it is not going to be enough. It will only reduce the tachycardia, the blood pressure will still be high, then you'll end up adding the ARBs. Single drug, if you want to use it, use a vasodilatory beta blocker, because the recommendation clearly is that use a vasodilatory beta blocker. Bisoprolol, no doubt, is the best one in reducing the heart rate. But reduction of blood pressure, it is going to be vasodilatory. The other vasodilatory beta blocker is the carvedilol, which we don't use much. Basically because the dose at which it starts acting as an antihypertensive is 12.5 twice a day, which none of us are going to be using in clinical practice. Using an ARB first, and second as the calcium channel blocker. Okay, the basic thing came from the Accord trial. That's how it said. It said comparing benazepril with a diuretic or a benazepril with this thing, with the calcium channel blocker, there is going to be a difference. It's better to use a calcium channel blocker. That is the basis on which that algorithm was developed. But now clearly it is said beta blocker can be used at any point. 2 points are mentioned here. One, anybody with a heart rate more than 80 use a beta blocker. That is important. You have to reduce the heart rate. Second thing is, I call it the happy indication. Heart failure, angina, patients with atrial fibrillation, patients planning post-myocardial infarction, and why is the young woman planning pregnancy? This is the definitive indication for a beta blocker. The others, depending on the patient, on a case-to-case basis, I think you use your clinical decision. But I think ultimately we should understand one thing. Reducing the blood pressure is the most important thing. Another thing about hypertension, for all the people who are here, is people use a diuretic very often. They use 6.25 milligrams of chlorthalidone, which is superior to 12.5 milligrams of hydrochlorothiazide. I don't want to go to that. But what happens if that doesn't work? They go to 12.5. Please don't use a higher dose of diuretic. At a higher dose, these diuretics actually stimulate the RAS system. It is counterproductive. Use a smaller dose of diuretic because the mechanism of action is different. So you use a smaller dose of diuretic and don't increase the diuretic also.
Just as an endocrinologist, I just want to make a comment. So one of the indications that I've used this molecule very commonly is thyrotoxicose with asthma. So those patients, I found that there is no worsening of asthma, obviously as you said, and the patients are getting very good control of heart rate with the use of this molecule. And I commonly use this molecule for thyrotoxicose with asthma because it's very common actually. Having some sort of bronchospasm is common, and there is I think
as well as beta-1 selectivity.
Yeah. So other molecules, even metoprolol, I think may produce some. I don't know, but bisoprolol. Yeah. I think I use very commonly for that sort of patient.
A quick question to Dr. Omeo. So basically, T3 by these days is a quick acting because short half-life, only 24 hours. So recently diagnosed hypothyroidism, significant hypothyroidism, patient is on surgery, or you said patient need to put on radioactive iodine. Apart from this, do you think in case of brain death patient, just going for organ donation, particularly for vascular instability, as well as cardiac transplant patient, as it is a short-acting drug, we used to put T4, just crush it and through nasogastric tube. T3 is better there.
Honestly, sir, there is no clear evidence to say this, number one. Secondly, you have to be little guarded because these are the patients where the underlying cardiac condition is unstable. And so giving a medication that has positive inotropic effect can trigger arrhythmias and cause more trouble. So I think that's a use with caution, preferably avoid kind of a situation. It's better to be used in situation where it has wider applicability in our common practice. There have been studies in patients where T3 has been used in a guarded manner post CABG, and it did give some indication towards using in a guarded manner improved ejection fraction a little. But then that's a small group of patients. I always prefer one thing, in our practice, pick our battles very carefully and fight where you can, but don't go out of indication where you can, where you should not. It has to be used. But remember, it's very tempting to give a very high dose of T3, but that's not correct. Because you need to saturate the thyroxine binding sites, and so you need to give T4 a good dose in the background and on top of that T3, so that T3 is left free to act and improve. That's a very good indication.
Yes, sir. You have a question, sir. I think after this we'll close. Monotherapy. Can it be used as monotherapy?
Last part of the question, can it be used as monotherapy? Yes, it can be used. But I don't think there is a separate D and the L isomer separately available in the market to start using it separately. Whatever answer I'm going to give to you is a guess. So I don't want to guess and give you. Science doesn't give an answer to your question. No, sir. No, sir. No, sir.
Only esmolol can be indicated?
Spironolactone also no. Malignant hypertension is an emergency. Yeah. In that case, you give parenteral antihypertensive drugs and bring down the blood pressure acutely.
In cases of that, sir, only esmolol can be used. It is IV, as sir said. 0.5 milligram per kg body weight doses can be that dose. You can go for a infusion, 1 hour infusion. Only esmolol can be used in hypertensive emergency BP more than 180 by 110.
I think, can we conclude, sir?
Yeah, I thank all the three speakers. These are the three subjects which are our clinical, all clinicians have this dilemma. Beta blockers, Nebivolol now has so many good things, but then the myth was there that all beta blockers lower heart rate, they are same. It's not true. Dr. Joshiji, you remember there was initially in our country we had a combination of thyroid extract available once upon a time. So, it's still available? Okay, but that was very long time ago. Something very good we know, when we know that if we are using T3, we got to be very vigilant. And you have covered very well your subject. With this, I profusely thank all my panel, all my speakers, and on behalf of my co-chair, thank you for your kind attention. I close this session. Thank you.
So thank you so much, all the chairpersons and the speakers. So with this, we'll move on to the next session. It is Therapy Symposia, and may I call upon Dr. N.K. Narayanan. Dr. N.K. Narayanan is a senior consultant endocrinologist, and he's going to talk about applicability of premix insulin in type 2 diabetes. A case-based discussion. Over to you, sir. The next 15 minutes is yours. Thank you.
Thank you for the introduction. Good evening, delegates. Can I have the slides?
ஸ்லைட போடுங்க. NK நாராயணன்.
It's at the top.
மேல இருக்கு, மேல இருக்கு, மேல மேல. அதான்.
Super. So, I think my previous speaker was also talking about insulin. Insulin, we know that it's been there for a long time. It's gone through a lot of changes from animal to human insulin to analog insulins. Compared to all the other molecules which we use to treat type 2 diabetes, the biggest advantages of insulin is that it has got no contraindication. There is no disease where you cannot use insulin. There is no upper limit of dosing, unlike your oral molecules or injectable GLP-1s and other things. There is no upper limit of a dosing. There is no real side effect to the molecule itself. It's dose dependent. Hypoglycemia is a side effect, but it is dose dependent. It's not due to the molecule itself. So there are distinct advantages of using insulin. We can blindfoldedly use it in any situation with any doses. You can go to 100 units, 200 units, depends on how much the patient is needing. All we need to understand is the pharmacokinetics of the insulin so that we know to use which insulin in which place, whether it's a prandial or a basal bolus or a premix insulins. In India, we all know that the common insulins that are being used are basal insulins and the premix insulins. Premix insulins, obviously, when the fasting, postprandial, everything is high, then premix insulins are preferred. Twice a day dosing, much preferred compared to basal alone, unless the patient is ready to up-titrate it from basal to basal bolus insulin. So, as long as we know where to use this insulin, insulins have a distinct advantage in that regard. I probably straight away slip some of the slides for the sake of timing. Now, the unique properties of an Asian population. We all know about the dietary impact of on the glycemia itself. The high carbohydrate diet is going to have a high glycemic excursion, especially the postprandial glycemic excursion is very high, and therefore the Indian population needs probably a different type of insulin, and that's where you also see, I think our previous speaker was also telling this, that if you look at all the European guideline, ADA guideline, Australian guideline, where the carbohydrate intake is not high, the first preferred insulin is often the basal insulin. The premix does not even come into the picture there. But the RSSDA guideline, our own Indian guideline, has got both. If you want basal or if you want premix, you can use either of these depending on the patient in front of you and depending on the glycemic profile that we see. So the high carbohydrate diet, the high plasma glucose excursion, or all these things are factors which tells us that we may need to use premix insulin in certain situations. Therefore, patients with high PPG level, premix is preferred. It reduces the number of insulin injections. Obviously, if you are starting with the basal and adding bolus insulin twice a day, that means 3 injections. Therefore, it reduces the number of injections. If you want to up-titrate the insulin, also you can do so with premix, as in increasing to once a day to BD to TDS, 3 times a day also. There are a number of studies which have shown this. Now, I'm going to use 2 case studies as a backbone to discuss the case and present the evidence as to what are the types of premix insulin that we use. We all know that there are mix 25, mix 30, mix 50, whether one has got a distinct advantage over the other. I'm sure in India, my experience is that mix 50s often work much better compared to the mix 25 or 30 because of the high carbohydrate load. The glycemic postprandial excursion is often better controlled, especially in the morning time. So there are situations where we use a mix 50 in the morning and a mix 30 or a mix 25 at night time, so that the fasting is controlled with your mix 25 and the postprandial excursion is controlled with your mix 50 insulin. Now, this is a type 2 diabetes patient of 60 years age, 8 years duration, inconsistent with follow-up, a high BMI at 25.8. Both the fasting and the postprandial plasma glucose are elevated, and HbA1c is 9.3, normal renal function. Not an atypical patient that we come across in our clinic. The reason he comes is he's got an uncontrolled blood glucose. He knows that he's inconsistent, but now he's come to terms thinking that, yes, I need to take something more. He's already on 3 agents, metformin, sitagliptin, and dapagliflozin. His father had hypertension and type 2 diabetes. He's got a predictable diet. With regards to diet, he's okay. He takes a heavy breakfast and a heavy dinner. His lunch is little. Now, where do we use premix in compared to the basal? Whenever there is a difference of more than 55, this magic number of 55 comes again and again when we are talking about insulin. magic number 55, when the difference between your fasting plasma glucose and the postprandial plasma glucose is more than 55, then you can prefer a premix insulin. When your bedtime blood sugar, that is, let's say a 2-hour post-dinner bedtime blood glucose value compared against your fasting plasma glucose, the difference is more than 55. There also your premix insulin will work much better in terms of controlling your fasting plasma glucose. So situations where it needs that the insulin has to be up titrated with a single insulin, there also premix insulins are preferred. The basal is preferred if the patient wants only a single dose or only the fasting plasma glucose is elevated, but not the postprandial plasma glucose. And if the patient is in future, if there is a need, the patient is willing to up titrate the insulin to basal bolus insulin or a basal plus insulin. In those situations, basal insulin is preferred. If the patient has got a habit of taking a large carbohydrate meal, like our patient what we discussed here, then a premix insulin will be better. And even there, the mix 50 works much better than the mix 25. And definitely they need to have a predictable lifestyle. On premix insulins, what the patient cannot do is they can't have a morning, evening premix and skip their lunch, because still the intermediate acting is going to be acting and they are at risk of hypoglycemia. Therefore, they need to have 3 times a meal, they need to have a reasonably predictable lifestyle, then you can prefer a premix insulin in those situations. What is the evidence? This was a study called Durable Trial, which was comparing basal insulin versus Humalog mix 25. This was a randomized multi-center study conducted at 242 centers across 11 countries, 2,000 patients study population, and they compared mix 25 10 units BD versus Glargine 10 units once a day, and the primary objective was to compare the duration, the durability of this, and hence the name was Durable Trial, the duration of maintaining the HbA1c goal between the two groups, how long they can maintain the HbA1c. And this was what the outcome. The change in HbA1c was not too different between Glargine and mix 25. It's 1.7 versus 1.8, almost nearly the same. But if you look at the percentage of patients maintaining the HbA1c in the long run, obviously mix 25 does better. It's very understandable because the basal will control only your fasting plasma glucose, whereas the combined insulin, the mixed insulin, is going to control both your fasting and your postprandial plasma glucose. Again, a table just for us to understand as to in which situation you would prefer a basal, in which situation a mixed insulin would be better. When it comes to a hypoglycemia risk, obviously basal insulin is much better. As I told you, on mixed insulin, the patient has to got a reasonably decent lifestyle, a reasonably decent diet plan with 3 times a day meal. They can't afford to miss it, whereas with basal insulin, that's not the case. When it comes to convenience of initiation and up titration with the same insulin, like a situation where people may get confused with 2 different types of insulin. And again, this might have happened in our clinical practice where the patient starts taking the basal insulin 3 times a day and the bolus insulin once a day. So all these sort of confusions can happen. So in those sort of situations, if the patient wants to uptitrate with a single insulin, and if you need to control both the fasting and postprandial plasma glucose, in those sort of situations, then definitely mixed insulin will be much better. So this patient, he was started on mix 25 10 units before breakfast. The dose was up titrated. It did not control it. He had to have twice a day mix 25, and finally the HbA1c at 3 months came down to 7.5%. The second insulin is what we call as a high mix or a mix 50, which was the one which I was talking about earlier. So 51-year-old male, type 2 diabetes, being treated for diabetes for 10 years. Again, a high carbohydrate load, high BMI at 28.1. HbA1c is 9%, both fasting and postprandial plasma glucose is elevated, creatinine is normal. So he's got an uncontrolled type 2 diabetes. Father has got hypertension, mother has diabetes at 55 years of age. He's on glimepiride, vildagliptin, metformin, and he prefers processed food, high calorie snacks, so everything to increase the postprandial plasma glucose. That's his 7-point reading, which again shows that the pre-meal, before breakfast, before lunch, before dinner, it's less than 200, 166. Although not normal, it is not unreasonably high, but the post-meal, every single meal, the plasma glucose excursion is very high across the board, which is what is driving the HbA1c here. And this is the initial graph. And the traditional Indian diets are carbohydrate rich, almost compared to the Caucasian diet, which is about 50% carbohydrate. Ours is about 70 to 80%. and therefore the greater prandial glycemic excursion, and therefore the high lipemia, the triglycerides which are associated with this. So the evidence we are looking at for mix 50 in type 2 diabetes with uncontrolled diabetes on multiple OADs, comparing mix 25 versus mix 50 over a 26 weeks time duration. And these patients were randomized at the baseline around 200 in both the arms. So at 26 weeks, the LM50, that is the mix 50, had a significantly more subject who achieved a HbA1c target of less than 7%, primarily because it was able to control the postprandial excursion in much better way compared to the mix 25. And as time passed, the postprandial excursions came down, and this was titrated to 12 units before breakfast and further titration to twice a day, increasing at 2 units per day to achieve the target. And this was it after some time where the postprandial plasma glucose excursion started coming down. And this is a graph. After 6 weeks, the pre-breakfast dose used by the patient was about 15, and pre-dinner it was about 10 units. And it started settling down as expected. So the postprandial plasma glucose excursions was controlled with the mix 50. So 4 weeks later, this was a dose requirement, and at 3 months, the HbA1c came down to 7.3%. So to conclude, as I said earlier, when I started, insulin is insulin. Whichever insulin we want, we can use depending on the patient profile. No contraindications, no fixed dose or upper limit of dosing. As long as we understand the pharmacokinetics, you can apply it in appropriate places. Where the postprandial plasma glucose excursion is high, you probably prefer a mix 50. Where you want to control the fasting plasma glucose, the bedtime sugar is a little bit high, then the mix 25 would be preferred. And achieving a the HbA1c of less than 7%, needless to say, you want to control both fasting and the postprandial plasma glucose, for which a mixed insulin would be preferred. The disadvantage being that they need to have a reasonably strict diet lifestyle pattern. Otherwise, the risk of hypoglycemia is higher compared to your basal insulin. I conclude there and hand over to my next speaker. Dr. Jayashree Gopal.
Yeah, good evening. I'm here to talk about, I don't know how many of you are aware that inhaled insulin has entered the market. Do you know? So it is available in India now. It entered the Indian market about 10 days to 2 weeks back. So I'm here to talk about it, and hopefully the ability to use insulin will go out a little bit when we start using the inhaled insulin more. So Narayanan gave a very nice talk about the pre-mixed insulins, and the fact remains that in spite of the fact that we know that insulin is the best treatment for diabetes, we have so much more newer agents, we still continue to use insulin. A significant majority, people who need to be on it refuse to take it because of various factors, including this the pain, the needle phobia, and public embarrassment. Quite often when we tell people they need to take a basal bolus insulin, they don't want to take it when they go to the office. And of course, the rapid-acting insulins in general would require administration minimum at least 20 minutes to 30 minutes before the meals. And if you mistime it, then you'll end up getting a hypo and a hyper. It doesn't control the blood sugars. And of course, the tail of the injectable insulin duration, because it works for about 6 hours, 8 hours, it often, sometimes it causes stacking and late postprandial hypoglycemia. All of these means that there is less adherence to multiple daily doses of insulin, and therefore leading to poorer outcomes in diabetes. There has been always, for the last almost ever since insulin was discovered, trying to find out ways in which you can deliver insulin in a painless manner without the need for injections. And of course, we know that oral insulin has been tried, it continues to be tried, and maybe there will come a day, we now have oral GLP-1 analogs, maybe we'll have another oral peptide in a pill, but currently we don't yet have a type of insulin which can be taken orally. It was thought for a long time that lungs were not really a viable route for insulin delivery, in spite of the fact that the lungs have a massive absorption area. There are 500 million alveoli roughly, and obviously, I think there is some, they cover a football field or 6 football, I can't remember the exact numbers, but it's huge when you lay out the alveoli. And the epithelium is very, very thin, ultra thin epithelium, 0.1 to 0.2 micrometers when you go down to the smallest part of the lungs, with a very high vascularization. So I would say it's actually a very ideal situation or an ideal way to deliver any type of medication. The inhaled insulin that I'm going to talk about today is it's a recombinant human insulin. It's regular insulin, which is absorbed into these microparticles. I'll tell you the name in the next slide. It's fumarate something microparticle. And this particular microparticle was used because this will ensure that the particles enter the deeper alveoli. If you use too big a thing, they get deposited in the upper airways. If you use too small, it won't go down. So you need that correct size. And this size was achieved by absorbing that human insulin onto these microparticles so that it gets into the deep alveolar space, and there it dissolves, releasing the regular insulin. Now, inhaled insulin has had a checkered history so far. Even back 100 years ago, soon after insulin was discovered, inhaled insulin first started getting trialed and investigated. 2006, type of insulin called Exubera was developed by Pfizer, but it was withdrawn a year later. Whereas this insulin, which is now in the Indian market, it's called Afrezza. It's also called Technosphere insulin. Afrezza insulin was actually US FDA approved in 2014. It was developed by Mankind. Mankind should not be mistaken for the Indian Mankind, which is spelt with one N. This is a US-based company. And in fact, it's been on the US market from 2014. It occupies some amount of the market, something like about 5 to 10% of the people use this on a regular basis, and it continues to be used to this day. It has not been withdrawn. And this is the insulin which Cipla collaborated with Mankind to license and commercialize back in 2018. And actually in 2024, Cipla received approval. I'm not sure why, but nearly about a year and a half later, finally it has entered the market, and we have inhaled insulin available. And there hasn't been much of a buzz about it. I haven't seen any media articles, but I have had patients come and tell me, doctor, I saw something outside about an inhaled insulin. Is it available? So definitely people are going to be coming and asking us more about it as people become more aware about it, and we need to know about it and where to use it. So like I said, Afrezza is a Technosphere insulin. That is the name. When I go through the studies, anytime you see the word TI, TI stands for this Technosphere insulin. It's just those particles to which the regular insulin has been absorbed. It is a rapid-acting inhaled insulin. And currently the DCGI indication is for improving glycemic control in adult patients with diabetes, both type 1 and type 2. Like I said, it was approved by the US FDA more than 12 years back and has been in use since then. And the insulin, the regular insulin, is adsorbed onto the carrier particles, and this is the name of that carrier particle, fumarate diketopiperazine and a polysorbate. This is what the device looks like. I'll show the device at the very end. You can see this is what people will carry around. And the insulin is available in cartridges. There are only fixed these cartridges, 4 unit, 8 unit, and 12 unit, and they are color coded, as you can see. This device, you have to place it in its mouth and take an inhalation. So it enters our system through oral inhalation. We recently came up with a paper dispelling myths and presenting clinical evidence for it's available online. It's available. It's a open access journal, and you can go look at it. We went through certain myths looking at inhaled insulin and came up with some guidelines for use in India. So these are the microparticles, human regular insulin. This is how it is kept in the mouth, and you take a deep breath. The inhaled particles, as soon as it reaches the periphery of the lungs, the particles dissociate and they are absorbed separately and they enter the bloodstream. So I think so far we are clear about what it is, regular insulin. Another myth around insulin is that we think that maybe this way of giving insulin will not be as effective as injectable insulin because we are so used to using injectable insulin. But it's actually got a faster onset of action. and a faster offset of action as compared to subcutaneous insulin. So within a minute it actually appears in the blood, and the clearance rate is also very high. It returns back to baseline. The insulin is cleared within 3 hours. So it matches our meal digestion. The fast in, fast out profile prevents the lingering tail that sometimes happens with subcutaneous injections of insulin causing hypoglycemia. And these are the actual studies that were done looking at the pharmacokinetics. So you can see that the yellow or the orange bar is with the Afrezza, the inhaled insulin compared to Lispro. And you can see the sort of graph that I showed earlier. This data here, going through this, is very interesting. Look at the endogenous insulin in healthy humans. Once it is secreted, it takes about 10 minutes to see its action. Afrezza takes about 12 minutes to show its, to come up with the action. Subcutaneous takes about 15 to 30 minutes for the action to be seen. Time to peak effect is about 45 minutes for endogenous insulin, very similar in Afrezza. And for subcutaneous, the time to peak action is about 90 to 120 minutes. Time for the effect to return to baseline of a single insulin sort of surge is roughly about a little over 3 hours. Afrezza similarly 3 hours. Subcutaneous, like I said, sometimes it has a longer tail, so sometimes it takes about 4 to 5 hours for the action, even for the analog insulin, for the action to wear off. So the pharmacokinetics of this insulin are very similar to the endogenous insulin. How about the actual clinical studies? And there have been studies done, like I said, now it's been on the market for about 12 to 15 years. This is a study which was the Affinity 2 studies in type 2 diabetes patients, about 350 patients. They were uncontrolled on at least one oral anti-hyperglycemic agent, and they were randomized either to the Technosphere insulin or just the Technosphere placebo. So it was just the particle which was given without the insulin added. And you can see that in the purple bar, the reduction in HbA1c was about 0.82% versus the placebo where the reduction was about 0.4. The postprandial excursions came down significantly. You can see the dotted line is the baseline, and you can see that after the usage, you can see that the levels came down significantly. So very, very, I think, useful for the patients in whom we are struggling to control their postprandial blood sugars. Just a single puff of this and the postprandial seems to come down. Hypoglycemic event rates are obviously higher with the Technosphere insulin compared to placebo, which I think it also says that definitely the insulin is entering the circulation, but it is something we need to be aware of, that there is a risk of hypoglycemia as with any insulin that is administered. This was a study which was done in type 1 diabetes patients. So here obviously it was compared not to placebo but to insulin aspart, and you can see that the extent of reduction of HbA1c was not as much as we saw in the type 2, but still a decent reduction in HbA1c to show that it was the same, that it reached the non-inferiority margin, but much lower risk of hypoglycemia as compared to subcutaneous insulin. So this is basically the data from the type 1 and type 2 diabetes that I presented earlier, non-inferior to injected aspart insulin and type 1s with a significantly lower hypoglycemia event rate. So in the group on Afrezza, they had 9.8 events per month. In the subcutaneous, they had 14 events per month. In the type 2 diabetes patient, again, compared to aspart insulin, good reduction in HbA1c with lesser weight gain. In fact, the Afrezza insulin people lost a little bit of weight versus the subcutaneous insulin gained a little bit of weight. So I think this is another interesting aspect of the usage of inhaled insulin that we need to keep in mind, that it really doesn't cause weight gain, may help a little bit with weight reduction. This was a study that was done in India. It was a phase 3 study, and it was presented at the ADA last year. And you can see that there is, this was done in type 2 diabetes patients. 200 patients were uncontrolled on at least 2 oral anti-hyperglycemic agents. And you can see in the purple bar again, decent reduction in HbA1c. Up to 0.62, it came down, the HbA1c as compared to the placebo. And percentage of patients with hypoglycemia, again slightly more in the group that was given, obviously, the Technosphere insulin compared to the placebo. Similar cough incidence, 9% with the Technosphere insulin, 8.4 with the Technosphere placebo, and no difference in FEV1. I'll be talking about this in a minute. So no difference in FEV1 was observed between the two arms at the end of this roughly 6-month study. Please keep in mind that inhaled insulin is only a short acting. It's useful in places where you need the prandial precision. It does not eliminate the need for completely for all insulin injections. You still need your basal insulin, but the people who have, let's say, a very good fasting and where you're only worried about the postprandial spikes, rather than giving them a short-acting injection, you can give them this, or in the ones where they are still struggling with a postprandial spike or do not want to take injections, you can substitute a prandial insulin with the inhaled insulin. So it can replace your rapid-acting injections, but it will not replace your basal insulins. Obviously, in type 1 diabetes, it has to be always used with a long-acting basal. And in type 2, you can think about it as an add-on when the PPG targets are missed. If you don't want to give even a basal, you just want to get the postprandials under control, you can use this. You can think about using this. And you don't have, like I said, the risk for hypos. What were the adverse reactions? The most common adverse reaction is just really cough and throat pain or irritation. As you can imagine, something that you're going to inhale in your throat, you're going to have a little bit of irritation. So that's about 25%. And other things are fairly similar between the placebo group and the Technosphere insulin. The thing to keep in mind about the cough is that the cough is the highest in the first 1 week after initiation. In this trial, 10% of patients had it, but you can see as people continue to use it, it tails off. So the number of people who continue to have the cough tails off, but cough was the most common reason for discontinuation in clinical trials. The cough is generally mild, dry, occurred within 10 minutes of the oral inhalation, was transient and declined with continuous use. What about the effect on lung function? In fact, that initial insulin Exubera was removed because it showed a reduction in lung function. In this group also, in Afrezza, there is a little bit of a decline in the FEV1 from baseline, small decline, but it was not sustained. After you stopped using it, the FEV1 came back to normal. And this was even at the end of about 6 months of use, and there have been longer trials which have shown that there is no change in lung function, even when people continue to use it for years. Or that little bit of a reduction changes is reversible once you stop it. This is the extent of reduction in the FEV1. So you can see that most people have about a 0 to 5% reduction in the FEV1. Some people, in fact, have an improvement in the lung function, an improvement in the FEV1, and some people have a further reduction. So one thing before using it is you will need to check an FEV1. But overall, the pulmonary safety is that cough is a common adverse effect. It declines over time. The small initial decline in FEV1 is non-progressive, does not worsen, and it is reversible. But before initiating Afrezza, it is important to perform a detailed medical history and assess the FEV1. So the company is giving out a spirometer. I'm going to take another 2 minutes. We'll give out a spirometer for everybody to assess an FEV1. If the FEV1 is less than 70%, we should not be using this inhaled insulin. So this is important, and we have to know how to use it properly. We need to be aware about how to use that machine properly. So assess the FEV1. And you have to assess it at baseline after the first 6 months of therapy and annually thereafter, even in the absence of pulmonary symptoms. If the FEV1 declines by more than 20% of baseline, consider discontinuing the inhaled insulin. These are the current guidelines regarding the usage of inhaled insulin. Who are the people in whom we can use it? All adults with type 1 and type 2 diabetes, any age above the age of 18 years, there is no difference. We can use it even in the elderly population. It should not be used in people with a history of asthma and COPD, in current smokers or those who quit less than 6 months ago, because they may have ongoing changes in their lung function. So these are the absolute indications and contraindications. It is not approved for use in pregnancy and lactation, and not approved for use in children, pediatric less than 18 years. An FDA review is pending for the ages of 4 to 17 years, but currently it is not to be used in this population. Like I said, get a mandatory FEV1 test. Do not prescribe if it's less than 70%. Reassess every 6 months and annually, and stop if it declines by more than 20%. So this is the way the thing is used. This is the device. I don't know how many of you can see this, but basically you open it up like this, you put in the little cartridge in this place and you close it. Once you close it, it gets activated. You remove this cover, put it in your mouth and you take a deep breath and it goes and that's it. And then this device is supposed to be changed every 2 weeks. As with any other insulin, make sure that it's at room temperature before you use it. So let it sit at room temperature. Obviously, the colder it is, the higher the chances of bronchospasm. Once you open one blister, because once you open that one thing, there are 3 little the cartridges inside it. If it's unopened, that whole thing is good until the expiration date. Once you open it, you have to use it, I think within 48 hours, I believe. And this inhaler device, which I showed you, has to be replaced every 2 weeks, like what I said. So to conclude, inhaled insulin is now available on the market. It is the only insulin that mimics the natural first phase release of insulin, shown to be very effective, non-inferior to injections, eliminates the needle barrier, potentially improving adherence, has been approved for 10 years, available and recently approved in India. Make sure you screen patients thoroughly, educate them and then prescribe. I think that is my last slide. Yeah, I'll stop here and happy to answer any questions. I would not use it Yeah, so I'd be very careful in that situation because, like I said, already there is a little bit of a decline in the FEV1 that occurs. So, COPD and asthma are absolute contraindications. In somebody with ILD, I would say, like what they said, measure the FEV1 after 6 months. I would do an FEV1 every month. And after discussing in great detail, and I'm not sure how much the effectiveness will also be because you need good amount of the alveoli to absorb the insulin. So if you already have fibrosed alveoli, I'm not quite sure whether it is going to be very effective, but it's something that you can, I would do it with extreme caution.
Madam, if you are giving 4 units,
yes,
how much will get absorbed into the bloodstream? How much percentage of the 4 units or 8 units?
So pretty much almost 100% of that gets absorbed because it's very well vascularized, the alveoli. I don't think I showed the chart. So basically, why did I not show that? Sorry. No,
but I think the problem, why was Exubera, the Pfizer insulin?
Because Exubera showed significant changes in the lung function. So they had to stop that. That's why there's a lot of studies with this, and it's been used in the US, like I said, for about 12 years, and they haven't shown any continuous decline. While you're on the medication, there is a little bit like a 5 to 10% decline in FEV1. Once you stop, it comes back. So there is no reversible change in the lung function, it looks like.
So you would say 100% gets absorbed and bioavailable?
Yeah. And it's only available as 4, 8, and 12. So depending on, when you're initiating it in treatment naive patients, they say start with 4 units with every meal or 1 meal or 2 meals, whichever one.
The studies showed they're using 12 units of Afreeza.
Yeah.
Subcutaneous, they're giving only 8 units of Lispro. Why did they study like that?
Yeah, I know, I saw that. I think to bring out the difference. I think initially maybe they didn't know. I'm not quite sure why the study was set up like that. Yeah, you're right. Okay. Pediatric, it is not approved for use. Yeah. I know, only above the age of 18 years. It is not approved for use in the pediatric population. Nowhere in the world. It's only used in above 18 years. We do not know how a developing lung will be on the long term. It is not approved. When I said type 1, it's only for adults with type 1.
Sorry, sir, we're running short of time. We can have the discussion directly with ma'am. Before calling Dr. Vijay Kumar, sir, I have a small announcement. There is a special talk on temple architecture by 7:45. So kindly stay with us, and dinner is there after the talk. It is very specific topic. நம்ம வித்தியாசமா இருக்கும். சிற்பம், கட்டடக்கலை அதை பத்தி சவுத் இந்தியால இருக்கக்கூடியதை பத்தி Chitra Madhavan அப்படின ஒரு ஸ்பீக்கர் வந்து பேச போறாங்க. Now I glad to invite Dr. Vijay Kumar sir to talk about disease modifying outcomes.
Can I have the first slide? Yeah, thank you. Good evening to everybody.
have very interesting talks both on insulin and as well as on the two insulins rather, the inhaled insulin as well as that subcutaneous insulin. I'm just going for a very basic talk on how we need to bring down the blood glucose levels and what are the benefits that we get on particular combination which I'm going to discuss. Now, if you look into that nowadays in the combination therapy, now we are always talking about CRM, cardio-renal metabolic era, where it is not just enough if you reduce the HbA1c and blood sugar levels, but you need to address the reduction in CVD, the way you bring down the blood glucose, and the other thing is that the way you select the molecules, it should have a benefit on the CVD, reduction in NAFLD, and it also should improve the CKD if at all it is there, and prevent CKD, at the same time weight reduction without any hypoglycemia. These are the things that we also look into that. Now, there is the philosophy of treatment, what you call as paradigm shift, what we call. The philosophy of treatment is totally changed. From a glucocentric approach towards a disease-modifying approach, it has evolved over last 25 years or so. It has evolved so much that you can see that nowadays we don't reduce the blood sugar. Rather, we address the pathophysiological factors that cause blood sugar, high blood sugar. This is what we're trying to do that. So ultimately, it should have a holistic approach. Apart from HbA1c reduction, it should also reduce inflammation. It also improve the CV and renal outcomes as a class effect. This is what we need to look into that. Now, the Diffranzo has already, before GLP-1 receptor analogs have come in, he used to say that, before SGLT inhibitors came in, he used to say that about 25 years ago, he used to say that it is GLP-1 receptor analog, pioglitazone, metformin is a combination, the best for that. And later on, he formed the ominous octet. Now, he says that SGLT inhibitors and pioglitazone is also a very important molecule that resurfacing now in many aspects. So this is an article which Diffranzo has written. He said that by adding pioglitazone, it might be an ideal agent to combine with SGLT inhibitor. Suppose you are using a SGLT inhibitor with metformin and you are not able to under good control. There is an option before going for insulin or anything like that. You can have an option to add a pioglitazone, which might be an ideal agent to combine with SGLT inhibitor to reduce, look at this, to reduce the cardiovascular events in patients with high-risk diabetes. In reducing the cardiovascular events in patients with high-risk diabetes. This is what's important that we need to look into that. Now, we can see that there is one study done by Eris Pharma, actually today's sponsor of this talk. They have taken about 92 patients, total 180 patients, and what they have done is that those who had a monotherapy and not under control with metformin, a minimum of 1000 milligrams and more per day, and then HbA1c should be between 7.5 and 10. And then there are two options that they have taken, two arms. One is FDC, fixed drug combination of 10 milligrams of dapagliflozin with 15 milligrams of pioglitazone, FDC. And then they have compared with the originators such as the dapagliflozin AstraZeneca along with pioglitazone from Sun Pharma. So, in fact, pioglitazone is not a originator from Sun Pharma, but they are the earliest one to come. So they have, it's a 12-week study, total number is 184, and you could see that compared to the reference product that is giving separately, AstraZeneca product and Sun Pharma, when they have the FDC of DAPA with pioglitazone, you could see that there is an equal reduction of HbA1c, minus 8.6 and minus 8.1. Fasting blood glucose easily come down in both the groups, and then postprandial also is minus 50 and minus 53. So Now it has been concluded that FDC of DAPA and pioglitazone offers good glycemic control also with no risk of hypoglycemia and in type 2 diabetes inadequately controlled with metformin. So it's also said that FDC is non-inferior to the products when they are giving in a separate app. Now, how is it combining? Is it going to be very beneficial? Let us look into the metabolic effects of what you are going to talk. HbA1c reduction, we know that DAPA reduces by 1.5, pioglitazone by 1.2, so that the enhanced HbA1c reduction is a possibility when you use this FDC. And then dapagliflozin improves the beta cell function basically indirectly. That is, it reduces the lipotoxicity of the beta cells and improves the beta cell function. Whereas pioglitazone has got a different way. It not only directly reduces the lipotoxicity by reducing the diacylglycerol content in the beta cells, and apart from that, it has got a capacity to convert the stem cells in the pancreatic duct into beta cells. So these are the two things that have been there. So you can have a sustained preservation of beta cells, so it can revive the beta cells, and beta cell apoptosis will be reduced by combination. So now you can look at the insulin sensitivity. We know pretty well that pioglitazone is one of the best insulin sensitizers, especially in the skeletal muscle. Metformin is mostly in liver, and whereas pioglitazone is less in the liver and more in the skeletal muscle. So it improves the insulin sensitivity predominantly in skeletal muscle, peripheral tissues compared to, it's got effect also on the liver. In fact, it is off late we are able to see that more and more benefit on the liver as well. Dapagliflozin as an SGLT inhibitor is a class effect. You can see that it reduces the waist circumference, it reduces the visceral adiposity, and so that free fat acid efflux will come down. And in that case, whenever there is an insulin resistance, it's a free fat acid is the main idea, and so that it reduces it, so that indirectly it reduces the insulin sensitivity as well. Now the only problem what we used to have with pioglitazone, weight gain and fluid retention, that is the usual side effects in spite of such a good molecule with a cardiovascular benefit. Now by adding a SGLT inhibitor such as dapagliflozin, you can see that the diuretic effect of DAPA and also it will mitigate, and it is counterbalance whatever the weight gain and water retention has been there with pio, it will be counteracted so that it can be balanced. So there may be no weight gain as well. Now, so what happens is that in this combination there is a reduction in fluid retention, pioglitazone increases, so they are neutralized. Body weight, pioglitazone increases, DAPA reduces, so it is neutralized. Blood pressure, both will bring down the blood pressure. And apart from that, if you look into the durability of reduction HbA1c, you can see that glitazones are the best. Even at the end of 5 years, the sustainability of the effect of pioglitazone is something extraordinary which doesn't happen with other molecules. You take that that is Tosca, and so many other studies have shown. Now, we always talk about metabolic memory, right? So initially when you got a high blood glucose levels, it will have a metabolic memory. It may develop into micro and macrovascular disease. But initially aggressive treatment of blood glucose levels in the beginning itself, if you have a good metabolic control, so later on the developing complications are also less. This is what is called as a metabolic legacy effect. That's called as a legacy effect. By using SGLT inhibitors initially, in spite of not having a good glycemic control, this legacy effect is attenuated. Look at this, attenuated. That is, bad legacy effect is attenuated. Similarly, pioglitazone is also does that, reverses the bad legacy effect. So it becomes good legacy effect, it becomes. And this is an interesting study by these people have shown that if you take the mean HbA1c of 7.1 and 8 and more than 8, and then those people who had a very good glycemic control less than 7 at the end of 3 years, and in spite of those people who did not have less than 7 for the end of 3 years, they are supposed to have a bad legacy. But when they found that those people who had SGLT inhibitor, in spite of not having a good glycemic control, the legacy effect has been seen there. That is, good legacy effect has been there. So this is interesting point that they were able to find it. Now, does this combination has got a benefit on cardiovascular disease, NAFLD, and how about the stroke? Now, if you look into that, if you look into the secondary prevention of a stroke, the only molecule which helps is pioglitazone. No other molecule. Secondary prevention. Primary prevention may not be there. Now, pioglitazone, what happens is that, for example, let us look into first cardiac remodeling. Pioglitazone reduces the hypertrophy, reduces inflammation, proliferation, and fibrosis. We know that dapagliflozin is such a cardio-friendly drug. Both are cardio-friendly actually. Rather, it improves the cardiac function as well and reduces the morbidity as well. Reduces preload and afterload, reduces oxidative stress, reduces hypertrophy and inflammation. We got several CVOTs. Because of paucity of time, I am not going to look into that, but there are positively pioglitazone in several CVOTs has shown the benefit in reduction in stroke and as well as primary endpoint of myocardial infarction. We know that DAPA, how benefit it is both cardio and renal benefits, and even in the liver benefits also, we know that. And then, this is a very interesting meta-analysis. What they have found is that those people who had a combination of pioglitazone and SGLT inhibitor, look at this information. This is very interesting, where it is amongst the patients who have been there, 15,000 plus patients who are on this combination, they found that compared to the other combinations, the MACE risk was reduced by 24%, MI risk by 19%, stroke by 28%, CV death by 11%, and heart failure by 33%. This is fantastic. Just a two-drug combination. Now, how does it happen? You know, as I said that it has got a neutral effect, pioglitazone. DAPA and pioglitazone reduces the MI. CV death reduce extremely well with dapagliflozin to some extent in pioglitazone. Heart failure is reduced, but pioglitazone, because of fluid retention, may increase, but it is mitigated. The two effects that, because it reduces and it increases, and that is the reason if you could see that there is a heart failure reduction of 33% even with this combination. So renal disease, both have got a beneficial effect. Now look into the NAFLD. I'll just finish in 2 minutes. NAFLD, before going into compensated cirrhosis or decompensated cirrhosis, from F0 to F3, you could see that the pioglitazone is the only drug which causes great benefits, even ballooning, prevention of fibrosis, and reversibility of changes also can happen. Pioglitazone is number one drug, and of course GLP-1 receptor analogs, and even actually you can see that even SGLT inhibitors have got a benefit, definitely, if not as good as pioglitazone. The list, if you take in the pioglitazone, is the best. Next comes GLP-1 receptor analogs, then comes SGLT inhibitors, then comes metformin. This is a hierarchy of what you can see that the effect on the NAFLD. So when we combine these two drugs, there is a decrease in visceral fat area and the increase in adiponectin level, and contribute to the improvement in NAFLD in patients with type 2 diabetes. So the combination effect is not only reduction in the fat content, also inflammation also is come down. So friends, this combination, if you got a chance, please do not hesitate to use this combination, because it reduces the stroke, myocardial infarction, cardiovascular death, heart failure, and whatnot, everything, the benefit. The only thing is that fluid retention and probable heart failure are mitigated by the SGLT inhibitor that we are using. Thank you for your patient hearing. Any questions? I'll be too happy to answer, because no time. Okay. Yeah, that is one thing, sir. How often are we seeing? It's been over-exaggerated, I feel, actually. It's not that commonly that we see that, actually. Very, very rare, actually. Sir, in that case, even DAPA, we are using it. So, DAPA also can cause bladder problem. But that is the only thing is that, in my practice, I am not seeing any of such things, actually. In the long-term usage, and if you see that the caution that has been given is that only when you use high doses of glitazone, there is a possibility. And we are not going the supernatural doses, we are not going to do that. if you can see that in even prescribing information, we see that 15 milligrams is the minimum effective dose, and in the West they use only 30 and 45. They don't use in 15, but here we use even 7.5. Isn't pioglitazone? We can use it. Yeah, why not? We can use it.
So how do you compare saroglitazar with pioglitazone? Which would you prefer?
Pioglitazone has done more studies, sir, actually. That's one thing. Saroglitazar is a very good drug, no doubt. Both triglyceride and as well as the reduction in the enzymes. There is some tissue, that biopsies have been done. But comparing pio with saroglitazar, pioglitazone scores over saroglitazar, and the number of studies that we have to done. In fact, I am using saroglitazar in plenty, and because not only triglyceride, it reduces the fatty liver, and so that even blood sugars also will come down. Though they have said it's 0.2 reduction in HbA1c, I'm seeing more than that, up to 1 to 1.2. It's a very good molecule to use. But as far as the NAFLD is concerned, there is more evidence that has been available with pioglitazone. It is superior. Especially, we are not very sure whether it is useful in the ballooning and fibrosis level, but pioglitazone has got a benefit in that way.
Thank you, GVK sir. For the next session, I would like to invite Dr. Nandita Arun to talk about a powerhouse approach to type 2 diabetes.
Thank you. Very good evening to everyone. So the next couple of minutes, I'm going to be discussing a little detail about what the title here reads, the powerhouse approach to the management of type 2 diabetes. And the molecule that we are referring to is nothing but imeglimin, which is a newer molecule that has been launched pretty recently in the management of type 2 diabetes. And the reason why it's called the powerhouse, I will discuss briefly. So imeglimin has been launched recently, as I mentioned. It was first launched in Japan in around 2020. Is the pointer? Sorry, I don't know which one the pointer is. Yeah, in around 2020, and around 2020, and then in India in around September 2022. So a couple of years ago, and I think we all as clinicians have been using the molecule quite effectively, working in our patients as well. But how do these drugs, how does this molecule actually work, and when and where to use it appropriately is the question that we will address today. DCGI approved imeglimin in India for the treatment of type 2 diabetes in late 2022, September. So as the title read earlier, it's called the powerhouse. And the reason for that being that the mechanism of action of this particular agent is through the mitochondrial cellular level. And this is very interesting because I don't know how many of y'all have recently seen, there's a lot of light on longevity. If we see the recent trials, the recent studies are all focusing on improving outcomes in patients in terms of longevity, not just in people with diabetes, but overall the world is moving towards longevity and the so-called anti-aging. There's a constant quest for anti-aging. And one of the molecules which has been indicated, which is now being used, being endorsed by a lot of celebrities. I don't know how many of you all are seeing Samantha, the actress, has been also talking a lot about NAD. And that is the approach to so-called anti-aging in recent times. So interestingly, imeglimin actually has a similar action. What it actually does is acts at the molecular level, at the mitochondrial level. I'm hoping this is the pointer. Yeah, at the mitochondrial level, by inhibiting the complex 1, restoring complex 3. So basically increasing ATP generation and working at the cellular metabolic level and increasing the NAD as well. So this in turn is improving our insulin sensitivity and improving at the liver and the muscle level and improving beta cell function. There is also an explanation, this is also the explanation behind the fact that it also may preserve the beta cells when used over a period of time. But of course, we have limited data to actually prove that as yet. So this is the basic mechanism of action of imeglerin. What is the evidence that we've had so far? Mainly the global data that is available is the Japanese trials, because it was approved first in Japan, and it was initially the molecule was worked on in Europe and then taken over and initially marketed, and the work that was done, the phase 3 trials were all done in Japanese population. So you have the trials which are called the times 1, 2 and 3. Times 1 has been done in treatment in treatment-naive patients with type 2, just looking at HbA1c reduction, and showed a HbA1c reduction of around 0.8%. The times 3 trial is in patients with pre-existing on oral agents who were uncontrolled and added on. So added on to a background of oral agents. And the HbA1c reduction when added on with DPP-4 was around 0.9, 0.8, with metformin was 0.6, and SGLT2 inhibitors was 0.5. So over and above these agents. And the times 3 trial was in patients in a background of insulin, where 1000 mg BD resulted in a reduction of around 0.6 from baseline. So what about an Indian patient? Those 3 trials that I showed you were in Japanese population. When it comes to the Indian context, there is what is called the Indy times. And we were part of this trial. There were 190, almost close to 200 sites all over India. This was recently published. More than 8,000 patients were randomized, and it was a large-scale study all over India, in which around 8,300 subjects were prescribed above the age of 18 with a HbA1c between 7 to 9, received 1000 milligrams BD, that is 2000 mg per day. This was a pan-India study, 3-month duration with a baseline HbA1c of 7 to 9%. And at the end of the trial, the analysis showed a significant HbA1c reduction of, quite a powerful reduction of around 1.1% from baseline, which was 7 to 9, a fasting and a postprandial reduction of 29 and 62 milligrams respectively. So 45% of the patients were able to achieve a HbA1c of less than 7% at the end of the trial. Furthermore, so it is not just a reduction in the HbA1c or the overall blood glucose, but there is also some Japanese data again showing us that there is improvement in the overall glycemic variability. And that is what we are seeing over here, where we are seeing that before and after imeglemin, this was a very short observational study in which what they've actually shown is that there is improvement in the time in range from around 66% to around 67 to around 79%. So you see the green bar actually increasing in size when added on imeglemin. So what about the cardiovascular safety? Now, because this drug is marketed only in Asia, they do not have a dedicated CVOT, but what they have done is compared it to the other molecules like moxifloxacin, and shown that even at supraphysiological doses, or supratherapeutic rather doses, you do not have QT prolongation, so it is supposedly cardiovascular safe. Also in patients with heart failure, this particular study showed that there was significant improvement in HbA1c and did not appear to be pretty stable in patients with heart failure as well. What about, of course, this is the most important question. This is a drug that works mainly on insulin resistance. So can we use it in patients with kidney disease? And here again, you have Japanese data that we are looking at called the Twinkle trial, a 52-week, quite a long trial, in which patients on CKD, who were put on imeglemin, and they found that it was pretty safe with lower risk of hypoglycemia as well. And the key findings was that there was a HbA1c reduction, improvement in lipid profile, improvement in liver parameters as well, the liver enzymes, and no adverse effects were found. But most importantly, this is the point that I think our biggest fear with the insulin sensitizers with metformin is that there is a risk of the lactic acidosis, and that risk is almost minimal with imeglemin. That being said, I don't know whether it is really worth discussing the so-called lactic acidosis even with metformin, because I'm pretty sure if I ask for a raise of hands here, how many of us have actually seen that often cases of lactic ulcer, unless a patient goes into sepsis and there is some other underlying cause, where quite often we would anyway withdraw the metformin. Another study called the PRISM trial. Now this is a subset of people in whom imeglimin would actually be useful because these are people who were intolerant to metformin that were started on imeglimin, and the results, this was a 6-month trial in which they found that people with type 2 diabetes who were intolerant to metformin when started on imeglimin, there was a significant HbA1c reduction, you can see from the green to the blue bars, and the drug actually worked pretty well. So now actually coming to where the drug actually fits into our Indian scenario, and this is the consensus guideline by Krishna sir himself, the Indian consensus, in which the recommendation is basically that it can be used even as monotherapy in treatment naive patients, newly detected patients, especially in patients who are metformin intolerant. Number 2, can be used as second line therapy, added on to any of the other oral agents, considering the fact that it has a completely new, unique mechanism of action, which is completely different from any of the other agents like the SGLT2s or the sulfonylureas or your DPP4 inhibitors. So it can be considered to combine with a second line as well, can be considered to treat both postprandial as well as fasting. Yes, and this is the point that I was talking to, and of course can also be added on to insulin. So I think to summarize what we're trying to say here, the recommendations is that we now have another tool, because we quite often do find that our patients are struggling to reduce the fasting and the postprandial, and quite often we are sort of searching to look. So then when we do add on an imeglimin, we do find that there is definitely an improvement in the labs, and that being said, the drug is also pretty well tolerated. Sometimes we do find some patients, very sensitive patients, who do say that they are having some GI side effects like bloating, but otherwise generally very, very well tolerated, and the risk of hypoglycemia, for obvious reasons, because its mechanism of action completely independent of the beta cells, the risk of hypoglycemia is nil. The one point that I forgot to mention in terms of the renal dosing is that it is excreted through the renal pathway. So the dosing is up to an eGFR of 45, it can be used in full dose. 15 to 45, we would use a dose of 500 mg once daily. And less than 15 eGFR, it should not be initiated. So the take-home message would be that imeglimin is definitely a molecule that is worth trying. It is something that adds an extra dimension to our management of type 2 diabetes, with a mechanism of action completely different, as I mentioned, than the other agents that we've had so far. Can be used even as monotherapy in people, especially for those who are intolerant to metformin. It is a useful drug. The other indication would be to add on even as second-line therapy to the pre-existing agents, which like either the sulfonylureas, the DPP4 or SGLT2, even with insulin, it can be combined. Pretty well tolerated. The GI side effects do exist, but not as severe as you would probably see with the GLP-1 or since we have been seeing patients with nausea and GI side effects with GLP-1, that would be the yardstick to compare to. But in summary, it is essentially very well tolerated. The HbA1c reduction, as I showed you, there's data to show HbA1c reduction up to even 1%, 0.8 to 1% in the Indian data that we looked at. But in clinical practice, from what anecdotal, I think you probably see a HbA1c, fair to say around 0.6 to 0.8 would probably be the HbA1c reduction that you would see. Thank you.
Thank you, Dr. Nandita, for the wonderful talk. I think we can take the questions at the end of the session if time permits. Already we are running short of time. So let's move on to the next topic. For this, I invite Dr. Usha Madam. She's a senior consultant endocrinologist. She's going to talk about vision of managing type 2 diabetes with CKD. Over to you, Madam.
Hi, everyone. No, Zydus team, don't leave and then leave the seats empty. Please, you can listen to this talk as well. Sorry. So, look, this is obviously a sponsored session. I'm speaking here on behalf of BI, so that's my disclaimers. This isn't new data, but it's important data, and periodically it's worth reiterating it because CKD impacts nearly 10% of our Indian population, and it has doubled in the last 2 or 3 decades. So since I've been studying medicine and practicing, the incidence of CKD has doubled. Diabetes is still the most common cause of CKD in India. And CKD isn't just CKD, it is a cardiovascular risk marker, and the risk of cardiovascular death increases anything from 70 to 820-fold, with the risk of hospitalization increasing 30% to 380%. We always look at CKD as creatinine, but we need to move away from that. We need to understand that GFR is a good marker. We do need to measure albuminuria, but we need to be aware that an increase in albuminuria is not always a given in patients with CKD. Unfortunately, in India, CKD is still one of those neglected entities where people present at a late stage to nephrologists. The cost of renal replacement therapy is disabling to most families, and the first diagnosis of CKD may well be end-stage CKD before anything is caught. So being aware, having an antenna out to look for this is really important. So then how do we look for it? This is the outline, and I'm going to take you through one by one all of these 6 points. Is it essential to assess albuminuria as well as eGFR, not just creatinine in all settings? It is the short answer, because, do I have a pointer? Hang on. Good. So at any given level of eGFR, so let's take an eGFR of, let's say 90 to 104. You might say that that is a normal urine albumin excretion, but as the urine albumin excretion goes up, you can see that your cardiovascular mortality goes up. So at any given level of GFR, whether it is 105 plus or less than 15, a proportionate increase in urine albumin excretion increases your risk of cardiovascular mortality, increases your risk of renal replacement therapy, increases your risk of heart failure, and increases your risk of hospitalization. So irrespective of your eGFR, if your urine albumin excretion is increasing, the outcomes are worse. And you'll never figure this out without actually checking your urine albumin. How often do we start? In type 1 diabetes, start 5 years after diagnosis. In type 2 diabetes, it is at diagnosis and yearly thereafter. You need to do a spot urine albumin creatinine ratio as well as an eGFR, which you can calculate on most calculators on your smartphones. If you have a positive result, please repeat it and confirm it with a gap of about 6 to 12 weeks, and make sure that you ruled out other causes of a decrease in eGFR or an increase in urine albumin before pegging it only to diabetes. Now, how do we diagnose CKD? You need and, right? Any one of these is enough. A persistent urine albumin excretion more than 30, a persistent eGFR under 60, or any other evidence of kidney damage. So don't rely on a creatinine alone. I keep coming back to this message. Now, we need to look at the overall picture, because the guidelines actually recommend looking at and screening for kidney disease using GFR calculated by the CKD EPI equation and urine albumin excretion, because there are implications for CV risk reduction. If a lab urine ACR is not available where you practice, you can have point of care tests, but together with an eGFR, it stratifies your patient into low, moderate, or high risk and allows you to put in appropriate preventive therapy. So if we look at the kind of case that we see day in and day out in clinic, you might say 50-year-old diabetic for 1 year, hypertension and dyslipidemia for 10 years. Thank you. with a BMI of 27, moderately controlled, blood pressure anemic already with an A1C of 7.9, poorly controlled, lipid profile LDL and triglyceride both outside ideal, and a urine ACR of 90 with symptoms of myocardial ischemia on exertion. This treatment, I would say metformin, telmisartan, amlodipine is not bad, but clearly nor is it adequate given the lipid profile, the blood pressure and the glycemia. Where does this patient fall? And it's really important to put these patients into this KDGIO algorithms, because it gives us on this side a EGFR category. So he's a 3A, 45 to 59 with a GFR of 55, and an A2, which puts him at a moderate risk in terms of cardiovascular risk, not just progression of DKD. I've shown you progression of DKD, heart and heart failure. So all of these above. So what are the possible trajectories when you have somebody like this? Number one, you can actually, this is how most kidney failure goes. The albumin excretion stays stable, slowly increasing, and then suddenly they fall off a cliff and the GFR goes down. Number two, you can actually with the right therapies cause the urine albumin excretion to regress. Number three is a sudden decrease, and number four, you do see non-proteinuric. Your GFR continues to decline, but your urine albumin is more or less within the normal limit. This is a subset of patients that we should be aware of and watch out for. And then there is this blind spot, but potentially the most important spot, because at this stage you can actually put in therapies to prevent progression. So how do you manage this? You need to assess your risk factors. You need to assess, I mean by risk factors, glycemia, BMI, hypertension, dyslipidemia, all of these. Bring them down to target, regular assessment of renal function, and protect your organs and continue your lifestyle modification. Obesity is a very reversible factor for DKD. We've had lots of evidence starting from about a decade ago with Credence and then Fidello and Figaro, DAPA-CKD, EMPA-Kidney, and now latest the flow semaglutide trial, which published about 18 months or so ago. The reason these are important is none or single therapy, that is your trajectory. And that is just blood pressure control. But as you add in RAS inhibition, as you add in SGLT2 inhibition, as you add in MRAs, you can actually modify the time and the slope of decrease in kidney function. So stacking therapy, multifactorial therapy gives you benefits in terms of outcomes. You can be conservative and wait till you actually have findings or kidney function deteriorates going into CKD before you initiate pharmacological treatment, or you can actually be active, preventive, and start screening for CKD and case finding at the low risk spectrum and start pharmacology with all of the agents we've just discussed as early as possible to make sure that you change the trajectory of kidney failure. So if I say as early as possible, where is the optimum point for intervention with SGLT2 inhibitors? You can see that there is a risk reduction at every stage, both overall and in Asians, and you can see the forest plot, everything is to the left of unity. There's a 39% risk reduction of incident or worsening nephropathy, new onset or worsening, progression to macroalbuminuria 38%, and doubling of serum creatinine, initiation of renal replacement therapy or renal death, also a 46% risk reduction. So frankly, it is never too early or too late to initiate these treatments. And there is a 68% reduction of decline in EGFR across all stages of GFR and all stages of albuminuria. It is better than placebo. So it is never too early, it is never too late, as long as the patient can tolerate it. There is a 43% regression to normal albuminuria with empagliflozin, and there's an 82% increase in likelihood that even prior macroalbuminuria, so microalbuminuria can regress, but macroalbuminuria also has a chance to regress with empagliflozin, as you can see. Now, we know that EMPA is not the only drug. We have other drugs, and it is not just all kidney oriented. We have major cardiovascular events, CV death, all-cause mortality, hospitalization for heart failure, and chronic kidney outcomes with empagliflozin, canagliflozin, dapagliflozin, and the ertugliflozin. But you will see that in terms of CV death and all-cause mortality, EMPA is the only drug that has data. In terms of hospitalization for heart failure, well, they're more or less comparable. And in terms of kidney outcomes also, DAPA and EMPA are comparable, but the only molecule that has other data, including CV death and all-cause mortality, is EMPA. We also know that with empagliflozin, the incidence of clinical events, there is a new improvement in CV death or hospitalization for heart failure and ESCKD. And CV death, all-cause mortality, MI or stroke are comparable when you compare it with a GLP-1 receptor agonist, which is the other drug that we use very frequently for CKD and cardiovascular benefits. So it's better for CV death, hospitalization for heart failure, and progression to ESCKD, comparable for the rest of the parameters. And in terms of the patient population included in this study, it's most representative of what we see in clinic because it includes a spectrum of moderate to severely decreased GFR and a spectrum of albuminuria from moderately increased to severely increased, whereas Credence and the DAPA-CKD are at this end of the spectrum in terms of their patient population. So certainly more representative of the kind of patients we see in clinic. EMPA kidney is nearly 7,000 patients with type 2 diabetes and without type 2 diabetes. So about half the population did not have type 2 diabetes. About 73% had prior CV disease, and the average, 35% of patients had a GFR under 30, and they had kidney reported biopsies, and patients without RAS use at randomization with a urine albumin less, about 50-50 for less than 300 and more than 300. So the spectrum again that you would see in clinic, you have a GFR that is low as well as adequate, you have a urine albumin that is low as well as more than 300. Now in these patients with and without diabetes, you can see that DAPA-CKD and EMPA kidney, both studied patients with and without diabetes. Credence only had patients with diabetes. About 3,000 patients to 4,000 patients. GFR less than 30 was maximum in EMPA kidney, so about 38% of the patients. And you can see the split between each of the urine albumin levels, with about 48% of the patients having a high urine albumin excretion, but about a fifth of the patients having a normal urine albumin excretion. And you can see that the primary diagnosis that was looked at was varied, including cardiovascular and renovascular outcomes. So you will see that in this clinical trial, there is an improvement, 33% risk reduction of progression to ESKD with empagliflozin, and end-stage kidney disease or death reduced by about 27% risk reduction. Now, it isn't just risk reduction. The gradual slope of GFR decline that you see with diabetes and with age is actually flattened with empagliflozin. So the blue is EMPA and the hashed is the comparator or placebo. And EMPA-REG outcome, EMPEROR program, and the EMPA kidney, you can see that the slope is flattened and that there is a slowing of the decline in GFR with these drugs. At any given GFR level, empagliflozin use can delay ESKD onset, and the earlier you start, the more preserve the eGFR at the start, the more you can prevent CKD, and years gained can vary from 9 years to anything up to nearly 27 years. So again, I come back to the point, it's never too early or too late. You can still put 9 years on somebody's life, but start early and you can put 27 years on their life. So how do we optimize SGLT2 use? We know that initially there is a little dip in GFR with SGLT2 inhibitors. Let us not panic about this. Even a more than 30% dip, if you've ruled out other factors and you're carefully monitoring, may recover, and dips are typical. On the other hand, if it isn't recovering, please look for other factors. You may not need to stop the SGLT2 immediately, depending on what you find otherwise. A few more slides. This is the most common question we get asked: what happens if they get an infection? It is not contraindicated if you have a history of genitourinary infections or asymptomatic bacteriuria. If you have recurrent GU infections, look for a cause, eliminate the cause and start the drug. You counsel your patients extensively on genital hygiene and what to look for and when to stop the drug and report to you. A single lower urinary tract infection or genitourinary infection does not require discontinuation. You can in fact continue, and if you have preventable causes, treat and reintroduce. And if you are going to stop an SGLT2 inhibitor for any of these conditions, please reintroduce as early as possible. As for other drugs, when you're looking at elective surgery, and I'll show you the timelines, please do stop along with all the rest of the stuff, you know, the diuretics, the metformin, the NSAIDs that you would stop prior to surgery, go ahead and stop before you reintroduce. Do not use in these conditions. This is not licensed for these conditions. So what have the guidelines told us now? Back to the same patient. So apart from lifestyle intervention, you will use SGLT2 inhibitors as first-line drug therapy in this kind of a patient until patient requires dialysis or transplant, and you manage as per the KDIGO guidelines. You aim for a blood pressure under 120 with the SGLT2s plus or minus RAS inhibition. Remember, he was already on telmisartan, and you need to put in a statin because of his multiple risk factors and the poorly controlled. His atorvastatin 20 is simply not enough. He will need multiple therapies. If just putting in a RAS inhibitor is not enough, then you would look at a non-mineralocorticoid, non-steroidal MRA, which would be fenderanone in this condition, and you would adjust accordingly. But the ideal is to get all these patients to target. So if you're going to withdraw SGLT2s at fasting or surgery or critical illness, please have a written plan, a plan that the patient is aware of as to when to safely restart. So discontinue 2 to 3 days prior to surgery, but restart soon after in concurrence with the clinical condition of the patient. And you do not need frequent monitoring of renal parameters when they're on an SGLT2 inhibitor. I'm going to stop here, say thank you, and I'll stay for questions at the end.
Thank you. Yes, madam. If time permits at the end.
I'll wait.
Yeah.
Thank you.
Thank you. So, thank you, madam, once again. So, let's move on to the next speaker. May I call upon Dr. Geeta Lakshmi, Senior Consultant Endocrinologist, to talk on glimepiride, impact of glimepiride on glycemic control.
So, good evening, everyone. Thank you, Debate. Thank you, organizers, for giving me this wonderful opportunity today. So, without further delay, we'll directly move on to our topic today. That is the metabolic memory that matters and glimepiride's enduring impact on glycemic control over the last decade or so. So, we are all very familiar about the pathophysiology of diabetes, and we have come a very, very long way in the history and pathophysiology of diabetes, because so many things have changed right from when we identified that insulin is the culprit behind this disease. Right from insulin deficiency to resistance, we have come across so many pathophysiological factors these days. So even ominous octet is not enough these days. We are somewhere in the group of 15 to 18 pathophysiological factors that can contribute to the etiology of diabetes. And we are also very, very familiar with the changing landscape of diabetes in India over the last decade or so. I think all of us practicing clinicians right now these days, we come across a lot of population coming on to us with so much young onset diabetes. So much so that even people in their 18s and 20s, we tend to think about type 2 diabetes as the first diagnosis rather than giving credentials to type 1 or something rare that as MODY. So, and we have a younger onset population, and we also have an earlier onset of cardiovascular complications. And as we all know, the potential causes that are pointed towards this earlier onset being insufficient beta cell mass as a genetic ethnic population, and also we have a lot of beta cell functional defects to target with. And because of this multiple pathophysiological factors, early onset of cardiovascular complications, we are also targeted towards more and more of early combination therapy. That is, a verified trial has opened our eyes towards a new landscape, and now we are targeting towards early combination therapy at the start. And to come on to the therapy specifics, we are more and more going on to drugs with complementary mechanisms to have a holistic approach and to go on to a person-centered precision medicine approach. So, whatever said and done, though the guidelines have undergone a remarkable transitional change, we still know that tight glycemic control is the essence of everything, because as our famous proverb goes, "Siru thuli peruvellam," small difference in blood sugars, that tight glycemic control by means of 1% reduction of HbA1c, we know that it causes a big impact in terms of micro and macrovascular complications, because there's almost a reduction of 30 to 40% in terms of diabetes-related mortality and morbidity. And when coming on to the prescribing patterns of drugs for diabetes management, our country is, I won't even accept this numbers, we are in terms of 60 to 70% OADs and only 20 to 30% injectables. We are still in that landscape. And sulfonylureas have been there almost more than 100 years now. When you read into the history of these drugs, it's very interesting because it dates back to the Second World War era, when people identified the hypoglycemic effects of sulfonamide antibiotics which were used commonly those days, and finally went on to discover sulfonylureas for the management of diabetes. So ever since, it has been the undisputed leader of management of diabetes, especially in developing countries like ours, where cost constraint is one of the biggest factors in management of diabetes, and it was the first available drug for oral glucose lowering therapy. And though the first generation sulfonylureas like chlorpropamide, tolbutamide, followed by glibenclamide, had a multiple of side effects and were talked about in an ill-effective manner, the modern sulfonylureas like glimepiride, glycoside possess a lot of unique characteristics because they are having an effective glycemic control. They are also proven to be the cardiovascular safe molecules by the recent Carolina trials, and they are at the forefront of precision medicine as well. So, coming on to the place of sulfonylureas in type 2 diabetes management. So, whenever we go on to management of diabetes, a patient-centric approach is the first thing which is advised. You consider age of the patient, duration of diabetes, comorbidities, the lifestyle of the patient, so the polypharmacy of the patient. So many things are being considered, and also the cost and benefit risk ratio is also to be consideration when we are initiating oral anti-diabetic agents. So a careful choice, a judicious choice among sulfonylureas should be considered, since the clinical concerns are mainly associated with first generation sulfonylureas. And second generation SUs like glimepiride can be preferred because of their relatively safe side effect profile, and they are tolerable as well as cost effective. And not only that, they can be covered across the entire spectrum of type 2 diabetes, and especially when used as an initial therapy of diabetes management along with combination with metformin, especially if the A1C reduction is required going to be more than 1.5 to 2%. And modern sulfonylureas can be effectively combined with metformin and other oral anti-diabetic agents as well. Only thing where you're going to use insulin, you have to use little caution, and if you're going to use other analogs like glinides, then you're going to exercise little caution. And all sulfonylureas are very effective in the early stages of diabetes, because we know that whenever in the early stages of diabetes, patient presents with an initial very high HbA1c levels, there is a very high amount of leukotoxicity, which when overcome, the medications can be very well down titrated, and patients can be kept on a bare minimum of medications once it is overcome. So at this scenario, I think sulfonylureas are very, very effective, and only the problem during fasting periods during festivals like Ramadan and Navratri, we should be using it very, very cautiously. And in patients with elderly and renal and hepatic impairment, it should be used judiciously at the lowest possible dose, and we should know when and where to stop these medications in patients with these criteria. And there's an evidence of 60 years of clinical research to support this, and there's a very, very good efficacy, because whenever we talk about anti-diabetic agent, we always talk about the golden rule of 1% HbA1c reduction and many newer molecules, because we know that the last 20 years or so has seen the birth of so many novel agents for management of diabetes, and there is so much hype and excitement surrounding these modern agents. And just because of these modern agents, sometimes there are some unflattering biased comments towards agents like sulfonylurea, but sulfonylurea is very simply, it's old as gold, and it has traditionally stood the test of time. And because of its good efficacy and the benchmark A1C reduction of more than 1%, which can be achieved by this molecule. And also about the glycemic durability, so many trials have shown it has a good glycemic durability, especially in patients with early onset new diabetes, and there's not much of excessive weight gain and a favorable ratio of cost, with also proven cardiovascular safety as well. So the main concerns here is sulfonylurea related to severe hypoglycemic effects, and glimepiride differs from traditional sulfonylureas as it is associated with equivalent metabolic control and lower stimulation of insulin secretion. So when you compare to molecules like glibenclamide, the hypoglycemia incidence is definitely 1/4 of the older molecules. So going on to a case, this is about Mr. John, a 39-year-old, which is a garden variety diabetic patient which we see in our OPDs, who comes to us with high blood sugar levels during his annual examination with an A1C of 9 with osmotic symptoms, and he's concerned about his high sugar levels, whereas a strong family history of diabetes including both parents and no known history of cardiovascular disease. So these are the parameters: fasting of 150, PP of 215, and body mass index of 25. His lipid profile, renal functions were within normal limits. So based on the guidelines in our country, this patient was initiated on a combination of a low dose glimepiride plus metformin twice daily, and this is what his follow-up at 3 months showed: an A1C level of 7.3%, where there is a good control, and a lipid profile wherein it has remained within the normal range. Additionally, he was also advised to attend educational sessions to enhance his understanding of diabetes and nutritional management. So this is what I would like to emphasize here. So whenever we are using sulfonylureas, use it at the lowest possible dose, and when the target HbA1c is achieved, it is always better to down titrate to medications which have proven cardiovascular safety, which have a negligible hypoglycemic effects as well. So we have the added advantage of starting these molecules to hit early and hard, followed by down titration to the lowest possible dosage and switch over to other agents if necessary. So after 6 months, this patient showed substantial improvement in energy levels and weight stabilization, and there's an improved glycemic control and reduction in FPG by 24% and PPG by 26%. And early combination therapy preserves the beta cells which are intact, reduces complications of uptitration, and we attain target levels swiftly with cell-mediated and non-glucose-mediated actions as well, which is given by the newer generation sulfonylureas. So these are some of the studies. So compared to metformin uptitration, if we add sulfonylureas with metformin? So this is a Korean study of 200 patients where the patients were achieved for A1C reduction over 24 weeks. As you can see, the graphs on the left show a glimepiride metformin combination where the A1C reduction is good with good amount of fasting and postprandial reduction. And these are the various guidelines right from RSSDI to global recommendations. Our RSSDI very beautifully recommends early initiation of combination therapy when monotherapy is unlikely to achieve glycemic goals, and it often recommends sulfonylurea as the second line agent because of its cost and benefit risk ratio. The same holds on with other societies as well. And coming on to the ICMR algorithm, though this is little outdated, I think still in our population, in our daily OPDs, whenever we see a patient with A1C more than 1.5% above baseline, that is 7.5 plus 1.5, anything more than 9, we tend to start over sulfonylureas along with metformin, and based on the cardiac risk, we tend to choose SGLT2 inhibitors or GLP-1s based on the cost-benefit ratio. So this is another study called GREAT study where the prescription pattern of commonly used glucose-lowering medications were assessed. Glargine, insulin, glimepiride, liraglutide and sitagliptin was assessed, and the cardiovascular safety was also assessed. So in contrast to the very much controversy surrounding the cardiovascular adverse effects surrounding sulfonylureas, this study showed that incidence of death from CV causes was similar among all these group of agents. And high dose glimepiride was associated with lesser CV mortality compared to low dose and lesser number of hospitalizations and heart failure visits. So coming on to the legacy effect, whatever said and done, even with the advent of novel agents, we still stick on to the concept of legacy effect and metabolic memory, which has been told time and again over the last 50 years by our DCCT study and UKPDS study. Long-term protection holds on good by the early intensive glycemic control because it translates to certain epigenetic changes at the cellular level, which leads on to benefits at long-term and prevention of complications in terms of both micro and macrovascular complications. So to summarize, modern sulfonylureas improve beta cell functions. Both metformin and sulfonylurea reduce hepatic neoglucogenesis, and sulfonylurea's entire spectrum of diabetes you can fit these molecules, and you can use even add on to basal insulin as well. And early combination therapy is mandatory in our patients to extend the time to treatment failure, and sulfonylureas are the first line agents in our country for non-obese patients, especially in situations where financial constraint is a primary concern. To reap the benefits of metabolic memory, I would recommend sulfonylureas as one of the big agents. So I think sulfonylurea's presence is like a salt. It's unique, its presence is not felt, but its absence makes diabetes management in doldrums. Thank you very much.
Lakshmi. I don't know, something about these lights bother me, but importantly, thanks everyone for staying back, because for the past few years, we've been feeling that, at the end of the day, you don't want to leave with sulfonylureas and metformin and thing, but we need to have something that grounds us. We could of course do a cinema music round, and maybe more people will like that. But we thought Primer as an organization, and I must thank my partner Arvind, I felt that we should give something back to our culture and roots, and the best way to do that is to make sure that we expose physicians who generally don't have time to enjoy and appreciate it, and a window into our past that we are not really, while we practice quote unquote allopathic or Western medicine, we have not forgotten where we come from, our great traditions, the geometry with which they designed, the mathematical traditions that we've had. The reason we discovered the Fibonacci sequence much before Fibonacci stole it from us, that the Madhava school of mathematics did more work before everybody else, that the Surya Siddhanta calculated the distance from the sun much better, and even today a much better this thing than any other way it is done. And of course, the best 1 by pi formula is from a guy who had dreams of Namagiri telling him what the formulae were. So in that, and thanks to Arvind, that he said, look, I'm willing to give you the money to do this program. And therefore we started a history session last time. And we had a fantastic, those of you, many of you in the audience were there, we had this fantastic session on the Ranganathas. It is, in Tamil it is called Arangan Ula. So T.S. Krishnan adapted it and we had a fantastic talk. And we felt, you know, who else to fill that thing than Dr. Chitra Madhavan? Somebody, I would like to talk, Dr. Chitra, if when you speak, hopefully you also tell us about your mentor, because I've heard stories about your own mentor who inspired you to get into history. But Chitra Madhavan is arguably one of the finest historians and experts on temple architecture in South India in this point of time. And we're really honored to have her. I contacted her and then she readily agreed. Her most important area of expertise is temple history and architecture, sculpture and iconography. I'm going to invite my colleague and partner Arvind Susali to come on stage, Sanjay Reddy, and I'm also going to ask Vishnu and Lakshmi to come up. And Dr. Chitra Madhavan, can you also come up on stage, please? Where's ma'am? Come.
Yeah. I think it's a great day for us, and day one always ends well, and I'm sure it's going to end with something different that we all are going to learn. Before we head to have our dinner, thanks to Dr. Chitra Madhavan, who's agreed to actually come and then do the honors of speaking about the temple architecture of India. And now I request Dr. Vishnu and Dr. Lakshmi to honor her with a small memento and then to also garland her.
Excuse me, so this is till 8:30?
Huh?
Till 8:30 or can I extend it a little?
யாரும் உங்களை நிறுத்த மாட்டாங்க.
இல்லை இருப்பானா யாரா
எல்லாரும் இங்கே தான் இருப்பாங்க. Everybody here for me.
Okay, I'll just take this. Excuse me, technical. இது ஒரே நிமிஷம் எடுத்துக்கோங்க. இதை சரி பண்ணிவிட்டு அதை தூக்கி கொடுங்க.
ஸ்க்ரீன் கொடுக்க மாட்டாங்க. ஓப்பன் பண்ணுங்க.
ஓகே. அங்கே
வராது.
Namaste and a very good evening to all of you. I'm delighted to be here with this gathering, and I would like to thank all the organizers for inviting me, in particular Dr. Krishna Seshadri, who has been contacting me from a very long time back.
the topic of today's lecture is temple architecture of South India. Those of you who live here, those of you who may be visiting South India from other places, know that entire South India, especially Tamil Nadu, is a land of temples. Everywhere we go, there are temples. Very big ones. We know of the Chidambaram and the Meenakshi temple. We know of Tirupati. We know of Guruvayur. These are all big temples, so to speak. But most of us don't know how these temples actually came to be what they are today. And I would like to start at the very beginning, many centuries back, more than 1000 years ago, and to tell you how temples actually were and how they came to be what they are today, what we are looking at today, and what is making tourists come to South India mostly. So on the screen, you're looking at a cave temple, this one. This is in a place called Badami, which is in Karnataka, and the ancient name of which was Vatapi. This was the capital of the mighty empire of the Chalukyas. You may have all heard of the Pallavas. We are in Pallava land. Where we are standing today was part of the Pallava kingdom. And to the north, they had their arch enemies, Janmashatru, so to speak, the Chalukyas. And the Chalukyas in South India, especially in Karnataka, started the tradition of making temples like this. You're not going to believe me when I say that this is a temple, or rather was a temple. It's not in worship now. I'll go back a little more. What you're looking at is a 6th century cave temple. But before the 6th century, in most parts of South India, of course you had temples, but they were made of brick, or they were made of other perishable material, metal, etc., wood, etc. So the Chalukyas started the tradition of making temples out of stone. And instead of building, putting one block of stone upon the other, which came at a later time, they started digging into hard rock. Literally, they must have had a hammer, they must have had a sharp pointed metal instrument, whatever it was, we don't know. And right now I'll tell you, we don't know how many people worked here, with what kind of implements they worked, for how long they worked. We have no idea whatsoever. They put their hammer to some sort of metal implement and banged against the rock with a great deal of expertise. And then they made these cave temples. Once we go inside, you will understand what kind of master sculptors and architects we have had in this country, in our own front yard. There's no need for us to go beyond and look at other places. We can, but we have to appreciate what we have. So this cave temple that I just showed you is cave 1 in Badami, and it is a Shiva cave temple. And what you're looking at is a lovely image of Nataraja. Now most tourists, when they come to Badami cave 1, will just look at this and go away. But we are not supposed to do that. We must stand and stare, because the sculptor wanted us to do that. This anonymous sculptor, who has not left his name behind, didn't chisel his name anywhere, wanted us to see one thing. Before explaining the sculpture, I would like to say that in any cave temple across India, whether it's Ajanta or Badami or in our own Pallava country, these sculptures are made directly on the wall. They are not made elsewhere and then fixed on the wall. See, if you make it somewhere else, suppose all of you have given me this podium as a block of stone, and you want me to change this into a Ganesha, and while I'm chiseling, I make a mistake. I can just discard this piece of stone, get another rock, and make your Ganesha for you. But in this case, they were sculpting directly on the rock, and they could not afford to make any mistake. If they had made a mistake, the whole project, that cave temple project, would have to be abandoned, and you and I will be standing today and saying, look, this poor sculptor made a mistake. But no error, no mistake happened. I want you to look at this. Do you see the gap here? And there's a gap here, and there's a gap here. So he has made this kind of sculpture, a 3D thing, actually protruding from the wall. And this must be some very, very great sculptor, because you have to understand this, he must have visualized this in his mind. I want to put a Nataraja on this wall. I want to make the arms of the Nataraja come out. There was no paper, no pencil, no computer screen for him to have worked on. Directly hammer to wall, some sharp instrument, chisel something to the wall, and then he has created this. Actually, if you go there, you can easily put your hand into this, you can slip your hand into Nataraja's hand. The gap is there. This is actually amazing work. Very few sculptures like this will you see. I am taking you to cave 3 in Badami. This is a Vishnu cave. This is the largest and the deepest cave. So you can see these many pillars in front. Now, if you happen to stand behind any one of these front pillars, you can't see the pillars in front of you. Similarly, if you stand here, suppose you stand here, look at how many pillars there are at the back, at least 3 rows, you can't see those pillars in front of you, which means the alignment is so perfect. And we also need to understand that when the sculptor and architect came here, this was what they saw right through, this rock over here, right through. And that design, how many pillars they should be in front, how many rows of pillars they should be at the back, all of this was only in their minds. They could not have drawn it anywhere. So, and then they set about their work, and to make each pillar, what you have to do is, you have to remove all the rock around it. That's how you make a pillar, not by putting stone upon stone. That's not this kind of pillar. That came later. So imagine removing all the rock, all that empty space that you have here is rock removed. And yet the alignment is so perfect. Now look at the second row of pillars. They're completely different from the first. And then between the first and second row of pillars, you can see there's one beautiful Mahavishnu seated here. This kind of Mahavishnu cannot be seen anywhere else in India. He's sitting as though, a king is seated on his throne. Perhaps that's where the sculptor got the idea of making this Vishnu from. He must have seen the Chalukyan king Pulakeshin II very majestically seated on the throne, perhaps, and he decided to make Vishnu like this. Full hood, all the hoods of Adisesha above him. This is Garuda, waiting to do whatever Vishnu wants him to. And then this is how the pillars look. They didn't expect people with cameras, with zoom lens and all coming there in the 6th century. High up there, they made all these things. For whom to see? Nobody. But this is their dedicated work, absolute dedicated work. This band of flowers that you see here will not be more than 1.5 or 2 inches in height. And this is the kind of meticulous detailing that they have done. Can you see the ribs of the pillar? Today we are saying handmade, this handmade. How was this made? All handmade only, completely and totally handmade. This is like a full-blown lotus going around the entire pillar. And if you happen to look up, you'll see all kinds of things looking down on you. So this is a Nagaraja. And I have said this many times, and I will continue to say this. In India, we don't value our heritage. So somebody made this Nagaraja on the ceiling of the cave temple so many centuries ago. It's as though he is actually hanging down. His hand must have been in blessing, as though blessing all of us from above. And somebody has gone up there and broken both his hands. So this is like a fully coiled, you can even see the scales of the snake here. No detail has been left out, nothing at all. And then as you move into the interior of the cave, you will see this as well. And look at again the painstaking attention to detail. There is a square, and then a circle of fish, and a full-blown lotus. What is the meaning or significance behind this? Nothing. There is no significance. This is a work of art by an immensely talented artist high up on the ceiling of a cave temple. How he did it, we wouldn't know. Some scaffolding would have been there. He would have been lying down on his back and then sculpting. Can you imagine the amount of dust and stone and everything that would have fallen on his face, and no kind of protective equipment like we have today? And despite all this, these beautiful things have been done. And this Incidentally, this has become the logo of the Indira Gandhi National Center for the Arts. People who see that logo on the podium of their hall will not know that this is high up on one cave temple in Badami. This is like a maze, swastika. Again, requires a lot of skill to do. I am now, we are going to go all over South India today. So I am now coming to Tamil Nadu. And shortly after the cave temples of Badami were completed, there was a king here, a Pallava king in the 7th century called Mahendravarman Pallava. It's a famous name. And those of you who have read Kalki's Sivagami and Shabadam will know what a great king he was. Now, not to be outdone by his arch rivals, the Chalukyas, Mahendravarman also decided to make cave temples in North Tamil Nadu, which was the Pallava area. But the problem here is that we have only granite in Tamil Nadu. And this granite rock is very difficult to carve into, very difficult. It's a tough rock. But this Mahendravarman was a genius. We don't know how great a warrior he was. He was a good administrator. He was a great Sanskrit scholar. He wrote 2 plays. He wrote poems. The poems have been etched on the walls. He was a great patron of temple architecture and sculpture. He was a painter. He wrote a treatise on painting called Dakshina Chitra. That's the name, the painting of the south. In this little cave temple, which is in a place called Mandakapattu, near Vilupuram. It's a small village, nobody even goes there except some archaeologists and historians. There is an inscription in this cave temple, and I'd like to quote it for you. It's in Sanskrit, small one. I won't bore you for too long, but it's a landmark inscription, so I want to quote it. It says, Etad anishtikam adhrumam aloham ashudam vichitra chittena nirmapitam nripena Brahmeshwara Vishnu Lakshita Yatanam. Oh, Greek and Latin. So, Brahmeshwara Vishnu, Brahma, Ishvara, Vishnu. This temple was made for 3 gods, by whom Vichitra Chittena Nirmapitam. Vichitra Chitta was one of the titles of Mahendravarman. Chitta means mind, Vichitra means unique. He says, I am a unique-minded. He gave himself one title, unique-minded man. And what is he? The first line is most important for us. He's saying, Etad, this, anishtikam. Ishta in Sanskrit is brick. Anishtikam without brick. Adhruma, dhruma is wood. Adhruma without wood. Loha, metal. Loha without metal. Shuddha, not shuddha. Shuddha is plaster, like sudai we say in Tamil, the chunnamba, the plastering that we do. Ashuddha without that. So without metal, without brick, without wood, without plaster, Vichitra Chittena Nirmapitam, this temple was done by him. Now, then a few other things, doesn't matter. Now, why should a man say, without, I'm making this temple? He could so easily have said, I'm making it out of shila, I'm making it out of stone. But 2 things, very significant here. One is Mahendravarman was a poet, and poets don't speak straight. They kind of, we've studied poetry in school. So, second thing is, this without makes a lot of sense, because temples before Mahendravarman's time were made of brick or wood or metal or Shuddha. All these 4, he's saying, no, not anymore, because all those 4 are perishable. If you make a temple out of wood, for how long will it stand? 200 years, 300 years, 500 maximum, and then it will go away. And then what about brick? Those brick temples also will not withstand nature's fury. So he says, I'm making out of stone for the first time. That is in his territory. The Chalukyas had done that before. And the study of temple architecture is very fascinating. It's a study by itself. So if you look at when you go into a temple, you see the Dwarapalakas, the door guardians standing on either side of the entrance. Just by studying the Dwarapalakas, you can understand which century or which dynasty that thing belongs to, that temple. So this is a Mahendravarman time Dwarapalaka. Most of you who live in Tamil Nadu know this place. This is Malakotta or Rock Fort. This is in Tiruchirappalli. And most people who go here will go straight up to that Pulliyar temple and then come down again. It's quite a climb. But if people are interested in history. On the way to the Pulliyar temple, all these ladies are walking straight up. They are not even looking at this board. If you look at this board, which is half in blue and half in white, if there is a board outside any place, it means it is a protected monument of national importance by the Archaeological Survey of India. National importance. So what is this little thing? Why is it of national importance? This is a 7th century Mahendravarman cave temple, and once you go inside, this is a Shiva temple, but in Mahendravarman's time, in a Shiva temple, you need not necessarily have a Shivalinga. Instead of that, this man made a beautiful murti of Shiva, the like of which we have never seen afterwards. Now, which form of Shiva is this? It's not Nataraja, it's not Dakshinamurti, it's not any of the forms of Shiva that you and I come across in temples. This is a rare form called Gangadhara Murti. We all know, I think, that Shiva held the Ganga on his head. So this, unfortunately, very badly damaged. This is goddess Ganga. She was a river that flowed in the heavens and then had to come down to the earth because a king called Bhagiratha, Rama's ancestor, prayed to her and asked her to come. But the earth would never be able to bear the fall of Ganga, so Bhagiratha prayed to Shiva and said, please hold her. And Shiva let out one strand of his matted locks, and Ganga came and landed there, and then drop by little drop, Shiva put her gently on planet Earth, and there she flows. So this is Shiva here holding Ganga. That's of interest. Also of interest, can you see an inscription over here? So that is a Sanskrit inscription. And the author, the poet who wrote it, it's a poem actually. Some of it is on this side, the other left, the other is on this side. This is the inscription. And this is by Mahendravarman Pallava. He wrote it. And this man was quite a genius. In this he says that, as though Parvati is somewhat putting words into Shiva's mouth. She says, I know you are Nadi Priya. I know you are fond of rivers because Ganga is there already. Now I don't want you to go coveting this river Kaveri which is flowing by the side of this mountain because she already belongs to Mahendravarman. So what he is trying to say is Mahendravarman already owns this entire area. That is the information that he wants to give us. Because he is a poet, he didn't want to say, I am the lord of this entire Kaveri river. He is putting the words into Parvati's mouth and saying, Mahendravarman already owns the Kaveri, so, oh, Nadipriya, Shiva, don't go looking at her. That's what he is trying to say. So this is in a script called Grantha, and the language is Sanskrit. So we go to our very own Mahabalipuram, just down the road, 45 minutes away. And you can see how the cave temples now become so much more beautiful. I'll just show you these pillars. Look at these pillars. And within a very short time, in the reign of Mahendravarman's son and successor, Narasimhavarman Pallava, Mamalla, that's how this town got its name, Mamallapuram. Mamalla's Puram. The British changed it to Mahabalipuram, and we faithfully continue in the colonial mindset. It should be Mamallapuram. It's Mamalla's town. And here you can see the pillars become very beautiful, and these are the kind of sculptures that you have. The Pallava sculptures are mind-blowing. I'll just explain the sculpture to you, and we can understand how great this sculptor was. This is Trivikrama, Vamana, who measured the earth. One leg on the ground, one leg going up space. He's covered the space. The third leg, you will all know, he kept on the head of King Mahabali. That's the story. Beyond the story, if we go into the actual carving, I want you to see, he has represented this Trivikrama with 4 arms on this side and 4 arms on the other. I want you to see that the sculptor has carved the 4 arms in front of the leg. He would have been wondering whether to put the leg in front or the hands in front. Then he put the hands in front. So how to show the leg? He showed it in 4 segments. 1 bit, 2nd bit, 3rd bit and 4th bit. That much imagination and that much thought had gone into it. Once again, this is carved directly on the wall. One little slip of the hammer, whole project gone, this entire temple would have to be abandoned. Okay? So then over here you see, this sword that he's holding goes like this behind this arm. Now they want you to understand where that leg of Mahavishnu went. In 1 second it was on the ground. The next nanosecond it had gone up somewhere. And in Hinduism it is believed that the highest point in the world is called Brahma Loka, and this is Brahma sitting there. How do you represent where Brahma Loka is? So he is showing you here Surya. This is the sun god. He is showing you here Chandra. It has gone above the moon, it's gone above the sun. It's gone somewhere, that leg. That's what he is trying to show you. And then here, there's some person who's like hanging there. Now why show someone hanging in midair? What significance does it have? So, in all likelihood, this is a person called Trishanku. There are some variations of opinion, but most likely it is a person called Trishanku who was an ancestor of Rama and who was so handsome that he wanted to ascend to the heavens in his own body. The Devas would not allow it, they pushed him down. And a sage called Vishwamitra said, no problem, you can't go to the heavens in your own body, but I'll create a separate heaven for you, and that is called Trishanku Swarga. And it is not on earth, it is not in the heavens, it's somewhere in between. And to show that the leg had gone somewhere there, this Trishanku Swarga is shown somewhere there. So much more is there. Can we look at one other small thing? Look at this figure over here. If we ignore him, it's wrong. Yes, it's Jambavan. It's Jambavan the bear, the very famous bear in the Ramayana. We know that he helped the monkeys and all that, but remember that is Ramavatara. That is when Rama was there, Hanuman was there, Jambavan, the big bear, was also there. But if you look at Hindu tradition, this avatara of Vishnu comes much before the Rama avatara. Okay, so then what is Jambavan doing in the Vamana avatara when Rama avatara was much later? Because Jambavan was a Chiranjeevi, he is supposed to have lived for a very still alive, so to speak. And this is Jambavan, in the Valmiki Ramayana, he tells his monkey friends, Hanuman and all of them, that when this Vishnu became Vamana, I was there at that time. And when he became that colossal celestial figure, I became so happy that I went round and round him beating on a drum. So this Pallava sculptor knew that, and it's there. There are many other things, but I don't have time, so I'll go on. This is Lakshmi, goddess Lakshmi. You and I will buy a gold coin in a shop, or we'll buy a picture of Lakshmi, Gajalakshmi. She's supposed to bring all prosperity. That Gajalakshmi will be shown with 2 elephants on top. Both the elephants will look equally poised, equal. The trunks will be pouring water on Lakshmi, etc. Look at this one. This elephant has a pot. He's pouring water directly on Lakshmi. Abhishekam he's doing. Now this elephant has his trunk down. He's not posing just like that elephant. This one has a trunk down, wrapping his trunk around another pot held by another lady. Okay. Now, what this Pallava sculptor was trying to tell you to see is this movement. He is telling you, when this elephant finishes pouring that pot of water on Lakshmi, this elephant is going to take his trunk up and do Abhishekam. By which time he will bring his trunk down and take this pot of water and take it and do Abhishekam. So you can see that circular movement. Why both elephants pour water at the same time? One will do it and then another will do it. So that was what the Pallava sculptor was trying to say. And these 4 ladies represent 4 river goddesses who are bringing their sacred waters for the Abhishekam of Lakshmi. This, look, it's all damaged, don't worry about it. This is goddess Durga. And the one reason I'm showing this to you is because I want you to see this man. He is actually doing something very gruesome. He is cutting off his own head. And this man is actually cutting off his hand. This is called Navakhanda, cutting off different parts of your body to offer to the goddess. We find this in the literature of the period and in later times as well, but this is shown to us in graphic, this thing in here. Very fast I'll pass through Pallava art. This is goddess Durga fighting with the buffalo demon, Mahisha. Just give me 1 second. As is my wont, I have brought too many slides. This is the center part of Mamalapuram, where you have what are called, many of you have been there, it's called the Pancha Pandava Ratha. which is a very, very wrong name to give. It has nothing to do with the Panchapandavas, nothing at all. And these are not rathas, these are not chariots at all. These are 4 separate temples, 1, 2, 3, 4, and this one 5, each made of a single piece of rock. Each is made of a single piece of rock, which is called a monolith. Now, unfortunately, not even one is complete. This looks like a hut. So where they saw a hut made of thatched roof, they have made it out of stone. Permanent record of what was there. And that this is for Durga, we know. There's a sculpture of Durga inside, and Durga's Vahana is the lion. So they put a lion here. Now tell me, this lion should face Durga. Why is this lion facing another direction? That's not correct, no. But then the Pallava sculptors had one rule. They actually found the stone there and they cut that stone into a temple. Then they found another stone in front. That stone was this way and they cut it into a lion. They could not remove the stone and turn it. That was not the law. Wherever they found stone, they did it. So this lion, but imagine if this had been completed, all this would have been cut out and the lion would have looked as though it was standing on 4 legs. The second one is a temple for Shiva, meant to be, but it was not completed. And we know that because there is a beautiful Shiva Vahana there, the bull is there. Third one was meant for Anantashayi Vishnu, Vishnu lying down. That's also not completed. And this fourth one, this is a fantastic monument. You know, again, people who go to Mamallapuram don't realize the significance of this one. All these monolithic, that is one piece of stone buildings, were carved from top to bottom, not from bottom to top. Okay? So there were people sitting somewhere here cutting, but still notice the dimensions and proportions are perfect. Now, since they were cutting from top to bottom, the top part is all complete. There is one room here, I don't know whether you can see it, and people could actually do a pradakshina over here. There is space here. From the first floor to the middle floor, there are steps, even today. And they could worship here and go around pradakshina. There is space also. What they were planning to do is to put steps to the ground floor, put another sanctum here, put a Shiva here, and put a pradakshina around. That is the place to go around. If they had done that, what you would have had is 3 stories, one on top of the other, all 3 having a pradakshina passage, all 3 connected by a flight of stairs, and everything inside one piece of stone. The whole thing is one piece of stone. So this is what they wanted to do, almost finished. They almost did it, but for some reason work stopped. So this is a fantastic, absolutely fantastic monument, and it has lots of sculptures around it. You have Shiva, you have Vishnu, Brahma, etc., etc. And then you come across this sculpture. So people walk by, they don't even care to see it. This is very important because we always talk about sponsors and all that. This was a sponsor of Mamallapuram. This is His Majesty Sri Narasimhavarman Pallava. He was the one who, how do you know he's not a god? Only 2 arms. And look at this crown, the very typical Pallava crown, and his title is written on top, not name, but title is there. Finally, you have this 4th, 5th of the monoliths, very, very ordinary looking from the front, but if you go to the back, it looks somewhat different. And this is rounded at the back. It's not round, it's oval. It's a technical term, it's called apsidal. In Sanskritam, it's called Gaja Prishta. Gaja means elephant, Prishta means back. So the Pallava genius sculptor wanted us to know that this is like the back of an elephant. How better could he express it than put an elephant with its back next to it? So they had, thought so hard. They wanted 2 rocks next to each other, one a big rock, one a small rock, turn the big rock into a Gaja Prishta temple, turn the small rock into a Gaja with its Prishta in the same direction, and then you will know it is Gaja Prishta. But even if we didn't know anything like that, we just see the elephant. It's a fantastic piece of art. Once again, incomplete. If it had been completed, all this would have gone. 2 big tusks would have been in place, and you would have had that. So now we have seen cave temple cut into hard rock. We have seen temples made of one piece of stone. Next step is to put stone upon stone upon stone and build a temple. So that is the famous Shore temple in Mamalapuram, one of the first earliest temples in India where you have actually put one stone upon the other and built something. But unfortunately, since it has been so close to the sea from the 8th century onwards, this is also Pallava and built in the reign of a king called Rajasimha, which takes us to a fantastic temple called the Kailasanatha temple in Kanchipuram. This is very fantastic because it was built by the Pallavas out of a stone called sandstone. Sandstone is not seen in Tamil Nadu, only granite, mostly granite only. So where did they get the tons and tons of sandstone to build this temple? Where did it come from? Scholars couldn't understand, historians and archaeologists didn't understand where did it come from till they discovered that it is beneath the ground. So in the 8th century, they knew enough geology to understand that there was so much sandstone underneath the ground, and they quarried it and brought it up. And even then it was not ready to be built, so they let it dry, then they cut it, and then this temple happened. So this is how this temple, now I am showing you how temples are slowly becoming bigger and bigger, grander and grander. These are all the sculptures that you see in the Kailasanatha temple. This is Narsimha fighting with Hiranyakashipu. Can you see some traces of paint on the face of Narsimha? This is 7th century Pallava organic paint. Now, why red? Because Narsimha was angry at that point of time. He had come out of the pillar in a rage and he wanted to kill Hiranyakashipu. All the sculptures were painted. This was one of the grandest Natarajas ever. So beautiful. And as I always say, you're looking at a 1300-year smile. He's been smiling like that. This is another Nataraja with leg gone up fully. Traces of paintings from the Pallava times. The temples were becoming more and more ornate. We go back to Karnataka in a place called Aihole, Chalukya times. You are seeing one more Gajaprishta temple. Look at, have you ever seen it? So now more and more designs are happening. Temples are becoming bigger and bigger. Look at this. Why should they put all these stone long things like logs of wood? They were trying to imitate logs of wood. Temples were made of wood initially. Now they are saying we'll make stone temples, but let us try to put some designs on them. Not only designs. See, suppose water leaks through these gaps. So to prevent that leakage also, they have put a stone bar there. And then there is a place called Pattadakkal. It's a fantastic place. All these temples I am showing you are most of them from the 8th century. What is really amazing about Pattadakkal is some temples are of the North Indian style of architecture. You can't find anything like this in South India. This is typical Orissa or Gujarat, etc. North Indian style temples came to be built side by side with South Indian type temples in Pattadakkal. It was a period of experimentation. This is South Indian. I'm just going through, look at this sculpture. Look at the genius who made this sculpture. It was on one side of a pillar. The pillar itself is only about 1.5 feet. This is Ravana lifting Mount Kailash. Okay? So they have put Kailash like this, Shiva and Parvati on top. He could not, you're actually looking at, because Ravana has 10 heads, you don't know which direction he's looking, basically. So all heads are all round like that. We are looking at the back side of Ravana, and this is his back. And his legs are buckling. He couldn't hold Kailash because Shiva had pressed that mountain down to teach him his lesson. 1 foot has gone in, this leg is absolutely buckling. So that's what you see. Completely North Indian style temple architecture in Pattadakkal. We come back to Tamil Nadu. The temples now have become very big over here. Slowly over time, bigger and bigger. This is the famous Tanjavur Brihadishwara temple in the time of Rajaraja Chola in the 11th century. So instead of one Gopuram entrance, Rajaraja says, let's have 2 Gopuram entrances. And then you go into the main temple, and this is the tallest Vimanam, meaning place of worship, the structure above that, tallest in the world, going up to approximately 61 meters. Grand temple, it is called Devalaya Chakravarti, the Chakravarti, the emperor of all temples. So it was built in 1010 exactly And in 2010, we had a grand event with commemorative coins and stamps and first day covers and notes, etc. But then, not many people realize that what we see as a solid piece of stone is not, that it is totally empty inside. That's how these people have made, what kind of architects we have had. The entire weight of the structure called the Vimanam falls on 4 walls. And between the 2 walls, there is a passage where you can do a pradakshina. Only royalty could do it then, only VVVIPs can do it now. So here. And this inner pradakshina passage is divided into 2 sections. One ground level, one upper level. You know, this temple is simply amazing. So the ground level, I'll show it to you later, but I'm showing you this diagram now. This ground level has paintings. The upper level, it says here, Karana Gallery. I'll show you what that is. And to tell you, there are some, the internet, social media, books written by people who have no knowledge of history and archaeology will tell you that this is one piece of stone sitting up there. That's what we've all been led to believe. There was a scaffolding for 25 kilometers, some will exaggerate and say 50 kilometers, and then one big ball of stone was rolled up and put over there. No, don't believe all that, please. It's not one piece of stone. It's several pieces of stone placed there and fitted together, which is even more difficult than rolling one ball of stone up there, because the height is 61 meters. The second thing they'll tell you is that the shadow doesn't fall. It falls, definitely. Go at 3 in the evening, a long shadow. Everybody will be standing in that shadow and saying, see, the shadow doesn't fall at all. we are gullible. We'll listen to anything. So this is how it looks inside. And the Nandi, the Vahana here, is of a much later date. This temple has been contributed to not only by the Cholas, by the Pandyas, Vijayanagar, Nayak, many dynasties, and the number of inscriptions is also growing. This temple has more than 100 inscriptions. This is ancient Tamil. And I showed you the painting gallery on the ground floor. What I'm showing you are 1,000-year-old paintings. This is from Rajaraja's time. All these. I want to show you something fantastic about this painting. Yeah? Can you dispel this? This is not Karur Deva, this is Ishanashwar, right? So, that also we are not sure of. There is, I'll explain one thing immediately. So, these paintings were done in the time of Rajaraja Chola in the 11th century. For many years, this temple was in worship, and then slowly, when the capital moved off to Gangaikonda Cholapuram, the greatness of this temple also fell. But worship was there. In the 16th century, another dynasty called the Nayaks took over this temple. And though the Nayaks preserved India's culture, etc., they did lots of very good things for Tamil Nadu. One wretched thing that they did, I'm using a strong word, was that they painted on top of the Chola paintings throughout. I don't know why they did that. And it was only in the 1950s, by chance, one history professor from Annamalai University noticed that there is one set of older paintings behind the Nayak ones, and since then a lot of effort has been done to remove the Nayak paintings, the newer paintings, without damaging them, and to expose the Chola paintings without damaging them. So initially, these two people were thought of to be Rajaraja Chola and his guru, Karuvur Devar. That's because, and I'm quoting great archaeologists who have done work on this. This is not my own work, especially Dr. Sriraman, who has done fantastic work on these paintings in the Tanjavur temple. What happened was initially, only this bit was removed, was exposed. So they thought this was Rajaraja and his guru. Later, much more has been removed. So it is highly doubtful whether it is the king and his guru, or it could be somebody else also. So this is about debated opinion. And here, again I'm quoting a very great scholar called Dr. Kudavail Balasubramaniam. This is a form of Shiva that many of us don't know. He holds a bow in his hand, and there's a quiver full of arrows over here. He is called Tripurantaka, meaning he defeated 3 Asuras with the help of just one arrow. And he is said to have been in a very angry mood when he did that. But in the Tamil tradition, we've heard of the Nayanmars, the great devotees. One particular Nayanmar or Appar says, with his laughter he destroyed the 3 asuras. Attahasam, where he laughed. So if you cover this mouth, just look at his eyes. Look only at his eyes. It's blazing away. He's angry. Now just look at the lips. He's smiling. Now how an artist has brought an expression of anger and a beautiful smile on the lips in one painting is again fantastic. And in just one stroke, he has made the bow over there. So later period paintings are also there in this temple. They are there. We are going to, so now the Cholas have started building big temples, small temples across the land. They have started building. So when Rajaraja had built a temple as grand as the Rajarajeshwaram, the original name was Rajarajeshwaram, his son Rajendra Chola, who conquered far more lands than his father, also built a beautiful temple in his new found capital, and he named this temple Gangai Konda Cholishwaram after his title Gangai Konda Chola, because he had sent his army all the way to the Ganga in the north and brought the waters to this new city. Now this temple is actually not a clone of that Tanjavur temple. People think they built it just like that. It's not. So again, I am quoting from other scholars, the base is square, just like the big temple. In the center, it's octagonal. And as you go to the top, it's round. This is also very difficult to build, but he has done that. And unfortunately, what happened was when the British were here, they needed granite for building a dam across the river Kollidam, the Kollaroon which is nearby. And unlike Rajaraja and Rajendra, they could not be bothered to go miles and miles and bring stone from some other hill. So they just basically blew up this temple, and that is why it became like this. And the whole Gopuram had, outer Gopuram totally collapsed, and the Archaeological Survey of India has managed to put it together somehow. So one Gopuram gone, one Gopuram is there. Look at that intricate work, high up on the Vimanam. It's there. Not too old Nandi. The old Nandi is gone. The sculptures here are amazing. This is the best of Chola stone sculpture. It's Chandesha Anugraha Murti, where Shiva blesses his devotee Chandesha with a garland of flowers. You can see that. He's blessing him because as a young boy, he showed his devotion, and I'm not going into the details, just to tell you who the Cholas were. I'm just zooming in on this. We can, like you say, take a selfie in front of Chandesha Anugrahamurti and post it on Insta. That's one way of looking at it. The other way is to do this. So you see, he is wearing a beautiful necklace over there. And the sculptor wants to put more and more ornaments on him. So the chain comes in front of that. So he has made, you can't just chip off a part of the necklace and put another chain on top. This much of detailing has gone in there. And that sublime expression, only the Cholas could bring this expression. The tender expression on Shiva's face when he is the entire concentration is on blessing his devotee, so much so that he's even turned his back to Parvati. That, we have to look at that. Shiva is so fond of Parvati, they always sit next to each other. Here he's completely immersed in the blessing. So Parvati's face also somewhat is showing the... So we have inscriptions also over here, some inscriptions, and this is Saraswati. And look at her, completely sublime. Now we are used to seeing Saraswati with a veena, and that is Ravi Varma's doing. That's correct only, but before Ravi Varma, hardly did we see Saraswati with a veena in her hand. She is Pustaka Dharini. She is supposed to hold a palm leaf manuscript in this hand, and I want you to see this Yajñopavita, that's a thread, thin thread, so it twists and turns and twists and turns. I don't have too much time, otherwise I could explain some more sculptures. We are going to a temple called Dharasuram, about just 5 kilometers from Kumbakonam, another Chola temple, 13th century, where the entire mandapa looks like a chariot. Now you see, you've all seen that Konark Sun temple. It's a beautiful temple and it's a chariot, only temple that's built like a chariot. No, no. The temples built by chariots were in Tamil Nadu first. I don't mean to be parochial. I'm a historian. I'm just giving it to you. In the Chola period, they made some temples look like chariots. And a Chola princess called Rajasundari got married to a prince of Orissa. And she went there. And with her went the idea of making a temple like a chariot, and there was born that fantastic Surya Mandir in Orissa. So the origin of making a temple look like a chariot is Tamil Nadu. Look at this, the hub and the spokes and the wheel and all of that. And inside, you're looking at a mantapa, granite, where every inch has been carved. Every inch, minutest detail. This is the ceiling, and this is granite. So Konark, I just wanted to show you for a minute, all these wheels and all, very beautiful. Very quickly, I'm taking you to Karnataka, where again, because of the stone, you have a completely different style of architecture. This stone is soft stone. It's called chloritic schist. With this kind of stone, they could not hope to build a Brihadishwara temple or a Gangaikonda Cholapuram. The stone would not stand. So they built these smaller temples. There would have been a Vimanam on top, but that went off. But instead of that, they were going to concentrate on minute sculptures. Look at this kind of detailing. You can't see this anywhere else in India. Only the Hoysalas could do it. There are a row of 1,200 elephants over here. Each elephant is different from the other. And then you have a Mahabharata war also. Clearly the Mahabharata. So you can ask me, why can't this be Rama? Why can't this be Rama? Can anyone tell me? It can't, how do you know it's Mahabharata? I may be lying. There is a clue here. There is a clue. Chariots, it could be some other war also. Perfect. So there is Hanuman here. So Hanuman was on the flag of Arjuna. So if this is Arjuna, then this has to be Krishna. All right? So that's how each of the warriors in the Mahabharata had a different emblem on the flag. So when they were coming from far itself, you knew, oh, this is Duryodhana, this is Karna, this is Krishna, this is Arjuna, etc. So that is that flag. And look at the arrows flying thin and fast. So this kind of architecture completely changes in the Karnataka region in the Hoysala times, 12th century, 13th century, were miniature sculptures. What I showed you was in the Hoysaleshwara temple in Halebid, place near Hassan. This is the Chennakeshava temple in Belur. Just look at this temple. Amazing beauty. Flat. It's like this. Look at this. Each window here is made of one piece of stone. Okay, so they went into decorative elements. Again, 600 elephants, each different from the other. Would you believe this is stone? This is not wood, this is stone, Hoysala. And inside the temple, when you go, between the pillar and the ceiling, at an angle of 45 degrees, you have all these ladies. And each of them is a dancer, musician, etc. They are called the Madanikas. Look at this pillar. So they had learnt this art of polishing. You can virtually see your shadow over here. And these pillars were what we call lathe turned, turned with a lathe machine. And the ceilings look like this. They go inside 6 feet, 8 feet, etc. And these are the Madanikas. Quickly take you to a temple in a place called Somanathapura, very close to Mysore, 13th century. Perfect specimen of Hoysala architecture. This is called, in technical terms, Trikutachala. Achala means a mountain with 3 peaks, 1, 2, 3. And 3 forms of Vishnu are enshrined inside. The whole thing is star-shaped. If you send a drone on top, you will see the entire thing is like a star. You can see in and out and in and out. Now just look here where I am pointing. This is where it juts out. If you follow this arrow, the whole thing up to the top is protruding. If you come down, the whole thing over here is in a recess. It goes in like this. The whole temple is made like this. And these are the miniature, attention to minute detail. Go into the temple, Mantapa, and look up. This is what you see. And the paint is still there. I just passed through a little quickly. Kerala, completely different architecture. But why? Because the climatic conditions are very different in Kerala. It rains so much, you have lots of wood, jackfruit, rosewood, teak wood, and they made use of it for their temples. So here it's completely the tile and timber tradition. Lots of wood, lots of tiles, completely different, very, very beautiful is the Kerala temple tradition, where you also have separate mantapams for the music, ritual music and dance, the Kootambalam as it is called. Separate mantapams where the Ramayana and other scriptures are read. This is the Namaskara mantapam, the top of a Kerala temple, very nicely done in wood. Then we cross a river called the Tungabhadra in Karnataka, and we step into something extremely beautiful. There is this land called Hampi, which was the capital of the Vijayanagara Empire. And as a historian, I wish to place this on record that if not for the Vijayanagara Empire coming in the 14th century, South India will not be what it is. The traditions and the practices and the temples and the sculptures and inscriptions you see would not have been there because enemies would have run us down. And they stood and they protected us. Hampi is very bumpy, it's like completely full of rocks and very, very rocky place. And there, standing tall in the middle of Hampi, is a temple called the Virupaksha temple. The Vijayanagara rulers made this Virupaksha their Kula Deivam, a family deity, and they bestowed so much on this temple. But not many know that originally this was a small temple on the banks of the river Tungabhadra. The Tungabhadra's original name was Pampa. And so this god Shiva was called Pampapati. We already know Shiva is fond of rivers. So this is Pampapati, the lord of rivers. And then the name changed to Virupaksha. And this is how the Virupaksha temple looks, right next to the Tungabhadra. And then Vijayanagara architecture goes off at another level altogether. They were following the Tamil Nadu style of architecture in Karnataka, the Dravidian style of architecture. This temple is a Rama temple, today called the Hazara Rama, but originally called Ramachandra. Entire Ramayana has been sculpted. Entire Ramayana is there on the walls, which is why it is called Hazara Rama, 1000 Ramas. And this is the scene of Rama stringing the bow to win the hand of Sita. And Sita's father Janaka is here and Lakshmana is here. So many more sculptures are there. I'm not going into it. The compound wall of this temple, have you ever seen anything like this? Each sculpture here is like a photograph from 15th century Hampi. These are not just horses. These are Arabian horses. There's a lot of history in these sculptures. These men who are pulling and pushing and dragging these horses were Portuguese, who bought the horses in Arabia and transported them to India and sold them to the Vijayanagara emperors. Elephants, of course, are homegrown elephants only. So then, these are the kind of Kolatam dancers that you had. And all these, this is a famous Vitala temple that was burned down in 1565 in the invasion. This is a very, very famous stone chariot, the like of which is not there anywhere else in India. This was a sanctum for Garuda and the musical pillars. This is a very Vijayanagara tradition. How you could find pillars made of resin and stone, quarry it, carry it, put it up there in a temple, sculpt it so beautifully that even if you didn't know that you could get the Sarigama Padani, Saptaswara, yet it looks very beautiful. Look at that gap between the main pillar and the smaller pillars over here. That much beauty. And where they found boulders, each boulder they turned it into a god. This is 4.5 meters high Ganesha. This is a 2.5 meter high Ganesha. 7 feet, more than 7 meter high Narsimha, very badly broken. And this step tank that they have. Everything very, very unique about Vijayanagara architecture. I'll just go now to some temples that I need to show you because we are now going, till now I have been able to tell you about temples that I have been able to date, Chalukya, Pallava, Chola, Vijayanagara, etc. Now we are going to temples that have grown over many centuries. This is an evolution of temple architecture. This is the world's biggest living temple. This is Srirangam, the Ranganatha Swami temple on the island of Srirangam, taking approximately 156 acres altogether. It has 7 prakarams. It is called the Uttamottama type of temple architecture. It has 21 gopurams, never seen in any temple. 7 prakarams, as I said, about 60 odd shrines inside. Now, how did this temple happen to become so big? Not in a day or a year or in 1,000 years. Literally, we have historical evidence of this temple being 2,000 years old. There is a Tamil work called the Ahana Nuru, which mentions a particular festival in this temple. From that humble origin, when the temple would have been very small, every dynasty of South India literally has contributed to this temple. Not only Tamil Nadu, Pallava, Pandya, Chola, Vijayanagara, Hoysala, Kakatiya, and it has become this big. And this is the grandest of the gopurams. This is the 100-pillared hall. This is the 1,000-pillared hall. Everything is there in the Srirangam temple. And this, I'm taking you to another temple in Tamil Nadu called Mannargudi, which has the world's biggest temple tank. It's 35 acres of water space alone. Now let's not think it is a religious body. The temple tank is used for utsavams, it is part of the temple, but our ancients had this wonderful concept of water harvesting, which we are talking about so much today. This is to do with a lot of water harvesting also. And then we go to the Meenakshi temple, which again over years and years, and the Ranganatha temple and the Meenakshi temple have been subject to many invasions and ravages, bounced back in the time of the Nayaks, and this is how the Meenakshi temple looks today. 14 wonderful gopurams with lovely prakarams. Can you believe this whole thing is just one pillar? Whole thing is a pillar with the portrait sculptures of Nayak kings and their wives. This is also part of a pillar. When you see Ganesha, you don't see the pillar. Okay, this is part of a pillar. And you go to Tiruvannamalai, again, grown over centuries and centuries. Chidambaram, many centuries of evolution. Do you think this grew up in the time of any one king? No, many kings. And the east and the west gopurams belong to the Chola period, and they have 108 dance movements called the Karanas. Each is a dance movement, and above each dance movement is an inscription. This is taken straight from a book called the Natya Shastra of Bharata. So what that great author, sage Bharata Muni has said, they have written down here, and they have put the corresponding movement underneath. This is a phenomenal amount of research that they have done. Last few slides are this Gopuram. Do any of you know which Gopuram this is? Tamil Nadu's emblem, Srivilliputturu. Okay, so if you had given this answer, Srivilliputturu temple is the emblem of the state government of Tamil Nadu, you will pass your UPSC. That is correct. But I also thought the same thing. Not that I ever wanted to go for civil services, but every one of us kind of knows that the Srivilliputturu Gopuram is the emblem of the state government of Tamil Nadu. This is totally wrong. Totally wrong. I mentioned this in a lecture, and one young man got up after the lecture and told me, Madam, nice lecture, but you made a big blunder. So I said, what was that blunder? He said, the state emblem is not Srivilliputturu Gopuram, it's the Madurai West Gopuram. So I said, how do you know all this? And he said, my grandfather actually drew that emblem. He lived in Madurai, very close to the West Gopuram. When he was commissioned to draw the state government emblem, he chose his favorite Gopuram and he drew it. So I asked him, how come we think it's Srivilliputturu? He said, you see, ma'am, the contours of the West Gopuram of the Meenakshi temple resemble the design of the Srivilliputturu temple. And since this is a far more famous Gopuram, people have come to think that it is the Srivilliputturu Gopuram. But whatever, the stately Gopuram standing with the Western Ghats as the background is the culmination of the temple architecture of South India. It soars above, very stately, those gentle curves and all that, very Nayak style of architecture. I know I have exceeded my time, but I just want to conclude by saying that you know, we need to be very, very proud of the traditions that we have been given. We are not just looking at things in stone and brick and whatever. These are architects who had learned the science of rock, who had learned the science of sculpting, building. None of these temples have ever fallen, will not fall unless made to fall. They cannot. The design and the construction, there's an interlocking process. It's a profound science that they had involved themselves in, and they have given it all to us. Each little minute sculpture would have taken ages and ages to carve, but they have not left their names behind, 90% of them. So this is a huge tradition that has been handed down to us, and I think each one of us needs to strive to preserve it and to hand it down to future generations. So thank you very much.
Ma'am, will you take a couple of questions? Any questions? Yes. 2 or 3 questions alone.
Even Darasaram and many of the other temples with different stones just as a musical thing. How was that?
So in Daras...
Lepakshi has the thing under which muslin cloth.
Yes, I brought it, but I didn't have enough time.
Andhra, the thing that Lepakshi is at the end of Andhra.
Yeah.
Like, and that was much earlier, much later temple. So who was taking care of that side and who?
Okay, so the answer to your first question as to how come Darasuram has the musical steps, I understand the Vijayanagara pillars, musical pillars are the first. But before that in Darasuram, not the steps, but the sides of the steps give the Saptaswara. Now these are particular stones. The traditional architects and sculptors know geology. They know how to study stone. Any random stone is not picked up to make the images of the gods and goddesses. There are what are called male stones, female stones, etc. Similarly, there are stones which are resonant in nature. They know how to find them, and then they bring them, and then they make all these musical pillars, etc. Lepakshi, what he was talking about is a temple in a place called Lepakshi in Andhra Pradesh, about 3 hours from Bangalore, this side. And it has a very famous 16th century Vijayanagara period temple for Shiva. And there they have made some pillars where actually it was, the pillar would not touch the ground. And then some person is said to have dabbled with it, and therefore one end touches the ground. The whole thing is a hanging pillar where you can.
Don't you see this also in Gangaikonda Cholapuram, the second level, a similar pillar?
Not this type.
Okay, because I remember in the second level of Gangaikonda Cholapuram, they're showing me this particular thing. That's why I'm asking.
Putting I am not. That's not very well known.
In the Atmalingam space.
I understand, the second level. So this is something again fantastic. They could make a mantapa where only one pillar wouldn't touch the ground.
Vidya?
Great work.
Okay. Fantastic talk, ma'am. This question I'm just asking you because my daughter's asked me, why is there so much nudity?
How much?
So much nudity?
Yeah.
Because
all the dancers, kings and queens, and they have
very
barely
simple
any clothes,
answer.
and why is it like that?
Very simple. That was a tradition of those times. So they did not wear an upper cloth. It very simple. That was a custom of those times, and that is faithfully represented in sculpture. We cannot compare one era with another, nor one culture with another. For example, there are so many erotic sculptures on the walls of temples, and people ask, why so much eroticism? But you see, the mind of the Indian was very different from people of other countries. The temple is supposed to be, I use a technical term, a microcosm of the macrocosm. It's a small world in itself. The god is in the center, demigods all around. Everything in the world is depicted. A woman giving birth to a child, an elephant giving birth to a calf. Why are we hiding all these things? Everything, this is the entire world. You have birds, flowers, reptiles, animals, reproduction, everything is there. That was the vastness of the ancient Indian mind. If we cannot appreciate it today, the fault is not theirs, the fault is ours.
Last question.
Yeah, just a comment. A very nice talk, ma'am. And in fact, as you see, தமிழ்ல நம்ம ஒரு கவிஞர் வாழ்ந்தப்ப அவருடைய கவிதைகள்லாம் அந்த காலத்தினுடைய மக்களுடைய கலாச்சாரத்தை டெபிக்ட் பண்ண மாதிரி, as you said, all these sculptures, as you said, what was actually the prevailing culture, prevailing the dress habits, everything depicted. And you told about Vijayanagara and Krishnadevaraya, definitely, really, really amazing. And we are happy to say that we are all part and descendants of Krishnadevaraya. So very happy that the culture, what we embedded in the South India, we are partly responsible. Thank you, ma'am.
I'm going to have one last question.
Yes, please.
The Chandrabhaga stone in Ganga Ichonda, I hear this all the time, but how did they source that kind of a stone?
We don't know exactly where the stone came from, this huge one piece of stone. It is said that there is a huge arc starting from Trichy and going up to Pudukkottai. These are low range hills. And much of the stone came from there. So I am not at all surprised seeing that stone, because this is what they could do so easily.
Just to add, Vichitra Chitta probably wrote the first humorous, the first comedy in Indian history, literature, isn't it?
So Mahendra Varman, who had the title Vichitra Chitta, wrote 2 outstanding dramas. One was called Matta Vilasa Prahasana. Prahasana is like a farce, to make you laugh. And literally, even now when it's enacted, you will feel like laughing. He makes fun of his own people. He says, in my courts, there is lots of all bad things going on, In Kanchipuram, the courts were not at all very correct in what they were doing. He makes fun of the Shaivites, he makes fun of the Buddhists, he makes fun of everybody in his own kingdom. And in the last line, he says, I am Mahendra Vikrama, son of Simha Vishnu, writing this. He's a fantastic man.
Absolutely. And remember that he was a Jain who converted back to Sanatana. Yes. So with that, I think we've had the best lecture of the day.
Thank you so much.
Please give her a standing ovation. Thank you very much. And ma'am, please, maybe in a cycle we'll get you back here again into this meeting.
Anytime.
And in fact, I was telling our colleagues in the back who are endocrinologists that you actually do a fantastic Mylapore Madavidi tour. And we should take that. Thank you so much. Dinner is served. And ma'am, thank you so much again.
My
thank
pleasure.
You. Irrespective of how late we went, we meet here tomorrow at 9 o'clock.